Good morning, everyone. This is State Senator Gustavo Rivera from 33rd District in the Bronx, Chair of the Health Committee in the New York State Senate. And I want to welcome all of you to these hearings, which will begin a series of hearings this week and next week on the impact of COVID-19 in different aspects of our state. And today we're talking about nursing homes and home care settings. And I will be very brief in my introductory remarks and just say that this hearing is both about accountability as well as determining what happened so that we can make sure that going forward, it does not happen again. I want to make sure that we save lives, and by changing policy, we might be able to do that. And that is what these hearings are about. We are joined by many of my colleagues. I will recognize all of the Senate members now and then pass it to the Assembly. We are joined by my co-chairs, Rachel May, who is the chair of Aging, as well as Senator James Skoufis, who is the chair of Investigations. We are also joined by majority members David Carlucci, John Liu, Andrew Renardis, Kevin Thomas, Alessandra Biaggi, Toby Stavisky, Monica Martinez, Brad Hoylman, Jen Metzger, Luis Sepulveda, and Todd Kaminsky. And we're joined by Minority Health Ranker Patrick Gallivan, Aging Ranker Senator Sue Serino, Investigations Ranker Senator Tom O'Mara, as well as Senators Pam Helming, Jim Tedisco, Patty Ritchie, Betty Little, and George Borrello from the minority. And now to my co-chair in the Assembly, Assemblymember Richard Godfrey.
Chairman Andrew Lanza here as well.
Oh, thank you, Senator Lanza.
And Jim Gorin here.
Gorin and Lanza.
Okay, before I do go through some procedures, Harry Bronson, chair of our Aging Committee, will announce all the Assembly members who are here on both sides.
Thank you, Chair Gottfried. I will announce Assembly members from both sides. The order is basically what I'm seeing on the participant screen, so bear with me. But first we have Ranker of Health, Kevin Byrne, the Ranker of Aging, Jake Ashby, and the Ranker of Oversight, Brian Mactolo. Other members, Assembly Member Edward Bronstein is with us, Assembly Member Marjorie Burns, Kevin Cahill, Stephen Simberwitz, Joe DiStefano, Charles Fall, Assembly Member Fernandez, Assembly Member Galiff, Andrew Garbarino, Eileen Gunther, Ellen Jaffe, Assembly Member Mark Johns, Assembly Member Jones, Assembly Member Ron Kim, Assembly Member Nicole Maliatakis, Assembly Member Dave McDonough, Assembly Member Missy Miller, Mike Montesano, Assembly Member Amy Paulin, Michael Riley, Assembly Member Linda Rosenthal, Assembly Member Doug Smith, Assembly Member Salajas, Assembly Member Taylor, and I believe I've caught all Assembly members who are with us today.
Okay, thank you. Okay, I'm just going to run through some procedural points. This will be a very long hearing, and so every 3 hours or so, we will take a 10-minute break for what the Health Committee calls ambulation and toileting. Opening remarks will be limited to our committee chairs and ranking members and limited to 2 minutes each. People should feel free to take a pass on opening remarks. Witness testimony will be limited to 5 minutes each, a limit that will not apply to the health commissioner. Question and answer time will be limited to 5 minutes per panel for committee chairs and rankers, and 3 minutes for other committee members. Committee members may also submit written questions to to us, which will be forwarded to the appropriate witness, asking that the witness respond within 3 weeks. Each witness will be asked to swear or affirm that the testimony he or she is about to give is true. But since the notice for the swearing in was not included in the hearing notice for this hearing, if a witness declines to swear or affirm, the witness may testify anyway, and we will note that for the record. That's it.
Thank you, Assemblymember Gottfried. And now for some brief introductory remarks, Senator James Skoufis, Chair of Investigations. Can't hear you, James.
Someone has to
That
unmute.
was bound to happen to someone. And,
Yes.
But thank you, Mr. Chairman. And good morning, everyone. And as you noted, welcome everyone to the first of 2 legislative hearings on the state's response to the COVID-19 public health crisis in residential care facilities. Partnering with the Health and Aging Committees, the Senate Investigations and Government Operations Committee looks forward to engaging with today's witnesses. The past 4 months have tested the very fiber of our state's being. And in so many regards, New York and New Yorkers rose to the occasion, sacrificing our livelihoods to save our and our neighbors' lives. Families didn't leave their homes for months on end. The entire economy shut down, and spending time with loved ones was replaced with painful physical separation. As we all know too well, however, death was prevalent and harrowing, and no place more so than in our state's nursing homes. Over 6,000 residents have perished so far from COVID-19, a previously unimaginable figure, and a number that we know is an undercount. Governor Cuomo has rightfully described the virus ripping through nursing homes as a, quote, fire through dry grass, unquote. It's now up to the legislature to determine who lit the match and understand how and why the fire fanned out. To that end, let me make something crystal clear to all of our participants here at the onset. Check your politics at the door. Over 6,000 of our most vulnerable neighbors died in nursing homes. Tens of thousands of additional New Yorkers were taken from us. Attempts to score cheap political points disgraces those lives lost and distracts from our genuine effort to understand what happened. Our loyalty today must be to the truth and nothing but the truth. I look forward to today's testimony. Thank you.
Thank you, Senator Skoufis. Now for our Senate Chair on Aging, Senator Rachel May.
Thank you, Chair Rivera, and greetings from the 53rd Senate District in Syracuse and Central New York. I am grateful to my colleagues in the Senate and Assembly leadership and staff for making these hearings possible. As chair of the Committee on Aging, I began pushing for hearings back in May, as did the majority leader, and I'm very glad they are happening. On March 2nd, the legislature voted to give extraordinary powers to the executive to respond to the pandemic. Like nearly all my Democratic and Republican colleagues, I voted for that because we were already anticipating the need for rapid and decisive action. And I believe the executive has used those powers appropriately in most cases, but it's also necessary that we maintain an oversight role and hold the administration accountable for its actions. I see these hearings as having 2 main goals. First, to get answers for those who have lost loved ones about the decision-making process and the precautions that were or were not taken to prevent the loss of life. This, I believe, will be the focus of my colleagues in the Investigations Committee in particular. The second goal, and the one that I will focus on, is to make sure that we have the right policies and protocols in place now to protect the lives and well-being of residents and staff at nursing homes moving forward. Thank you to all who have agreed to testify. I look forward to learning from what you have to say.
Thank you, Senator May. Now on to the Assembly. Assemblymember Gottfried.
Well, I've already done my opening remarks. I guess we can go to Harry Bronson.
Thank you, Chair Gottfried, and thank you all for being here today. The impact of COVID-19 has been unprecedented for our families. It's affected every aspect of their lives, especially in the area of health and in their ability to provide for their families because of the downturn in the economy. These are difficult times, but I'm confident we will get through this together, supporting and caring for each other. That said, we must rely on the science and the medical understanding as we develop policy to keep our loved ones safe, including the residents and employees in our nursing homes. Today, I look forward to hearing from stakeholders about what has happened to date and what measures we might take as we prepare for the possible onslaught of a second wave of COVID. Thank you again for participating today, and thank you all for moving us forward together. We will get through this if we care and support each other, but we have to do that by developing policies that are based in science and based in medicine. Today's hearing is about getting that information, and I look forward to hearing from each and every one of the witnesses. Thank you.
Anyone else in the Assembly, Assemblymember Gottfried?
John, do you want to make opening remarks? John?
Very briefly, good morning, everybody. Thanks to everybody for their participation today. We know that COVID-19 is a hopefully once in a lifetime experience, although much preparation has always been in place over the years. It's when you actually take those plans and put them to action that we have an opportunity to see where we were successful and where we can build upon. I look forward today to having a constructive conversation on what's worked and where we can do better. And I thank my colleagues and the panelists today for their participation.
On the Senate side, briefly, our Senate ranker on health, Senator Patrick Gallivan.
Thank you, Mr. Chairman, and good morning to everybody. We know that COVID-19 has had a devastating impact on the health and safety of New Yorkers, and one of the hardest hit communities has been nursing homes across the state, and it just shouldn't have been that way. I believe many of my colleagues feel the same. On May 5th, I called for hearings. I'm grateful that the chair of the Health Committee in the Senate, Senator Rivera, and the other chairs have put this together, and I thank you for it. On May 6th, the Senate Republicans called for independent hearings, and to Senator Skoufis's point about the checking the politics at the door, I think we need to get to the bottom of what took place in nursing homes. It's inexcusable to make sure that it doesn't happen again. And I'm certainly hoping that the administration is cooperative in respecting the legislature and its role as an independent body, and really really works to care about what goes on in nursing homes and fix this, because it is problematic. Why were certain orders followed? Why is there still seemingly a lack of transparency? And why hasn't the state provided sufficient help in ensuring that nursing homes were prepared for this? Once we find those things out, of course, we turn to the future to make sure that it doesn't happen so that we can be fully prepared. Thank you.
All right, last on the Senate side, aging ranker, Senator Tom O'Mara. I'm sorry, investigations ranker, Senator Tom O'Mara.
Thank you, Senator Rivera. Gave me time to get my mic on. So I thank you for the opportunity to have these hearings today. You know, since the first cases in the United States in the state of Washington appeared in nursing homes, we knew how sensitive nursing homes were. In fact, as was stated earlier, Governor Cuomo said nursing homes and getting COVID in a nursing home would be like throwing a match on dry grass. And that's exactly what we experienced, not just here in New York, but across the country in our nursing homes, and what we saw even before cases came to the United States from elder care facilities across the world. I do want to note at the outset, well, I look forward to getting as much information as we can out of these hearings today. The minority conferences on both sides of the aisle, both conferences, were not allowed the opportunity to call witnesses today. We were not afforded the opportunity to subpoena any witnesses today. We will be following up on that for our next hearing on August 10th. We hopefully will get some accurate and real information today on what went on with these decision-making processes from when visitors were first stopped from going into nursing homes, when nursing homes were required to take COVID positive patients, and why nursing home staff was allowed to continue to work while testing positive in these matters. Hopefully, we get some good information on that today. But I would note that every witness testifying here today, to my understanding, is here voluntarily. No one has been subpoenaed to be here. And I think if we're truly going to have an investigation into this, that authority to subpoena witnesses and request witnesses should come from the minority as well as the majority. Thank you very much.
Thank you, Senator O'Mara. Assemblymember Bronson, anybody else in the Assembly?
Senator?
We have the ranker members. Kevin Byrne.
Thank you, Chairman Bronson. I want to first thank all the chairs on the Assembly side specifically for agreeing to host this hearing. Like my Senate ranking colleagues mentioned, many of us across the political spectrum have been calling for hearings as early as late April, May, and many of the chairs made public comments supporting the sentiment for having public hearings. And I firmly believe in this because this is part of our job as state legislators. Certainly we debate policy, we debate all sorts of things, but it was noted earlier, the governor and the administration has an incredible amount of power during declared disasters. And if we want oversight, it is not fair to simply rely on the Department of Health and the Attorney General's office to do an investigation into this matter. The legislature has an obligation to also chime in and to be a proper check for our system of government. And I think this is extremely important. So I want to thank them for agreeing to have this hearing. I will note that I was pleased to see that the health commissioner was on this list, even though the subpoena power wasn't used. The fact that he's going to participate is something that I do appreciate. And I know we have lots of questions to ask, and we're going to hopefully dig deep into some of the details here, but that's because we want to get to the truth. That's because we want to learn from any mistakes that were made. Should a second wave come, losing over 30,000 lives in this state, more than any other state, is not something that we want to be known for. And we want to make sure that we're just prepared. So again, I want to thank the chairs and my colleagues for having this hearing, and I look forward just to getting down to business. Thank you.
On the Senate side, it was my mistake. I believe that Senator Sue Serino is now on the line as the ranking member in Aging for a brief statement.
Good morning, Mr. Chairman. And I'm sorry, I had not hit the button to raise my hand. I had lost connection. But I'm very happy that we are doing this today. I was one of the first legislators to call for this hearing, and New Yorkers deserve answers. I want to make it perfectly clear that this is not about placing blame. It's about getting to the bottom of this highly gross death toll and ensuring that the state does a much better job of going forward, if any of this were to happen again, of protecting our very vulnerable New Yorkers and the people that have been taking care of them too. Facilities have kind of been an afterthought since day one, and it's time for them to be a priority. So I thank you, Mr. Chairman, for holding this hearing today, and I look forward to the questions and answers. Thank you very much.
Thank you, Senator Serino. Assemblymember Bronson.
Yes, I believe we have ranker of Aging, Jake Ashby, to say a few words.
Thank you, Mr. Chairman. I want to express my gratitude to all of my colleagues on both sides of the aisle and both in the Assembly and the Senate for holding these hearings. I think it's imperative that we as legislators get out there and get these questions answered, but more so, for us and our ability to shape policy, and also for the families out there that have been affected by this. I think there are many, many of my constituents in particular, and I know many across the state, that are searching for answers. So I'm grateful for the opportunity to participate in this hearing today and get some answers for these people, and I'm hopeful that we can continue this process. Thank you.
May I speak?
And lastly, we have Ranker of Oversight, Brian Magnolo.
Thank you, Mr. Chairman, and thank you everyone for allowing us to have this meeting today. It's great to be here and great to hopefully get an understanding of really what happened. As leaders, we need to make decisions moving forward. We can look at the past. We can't change the past, but we can look at it. And I think it's imperative that we do look at the past, making sure as we move forward as a state, as legislators, as a governor's office, that we do things the right way or possibly changing things that didn't work quite so well. We do owe this to those families and those loved ones that lost family members in those nursing homes. And I'm just looking forward to the testimony and asking a few questions, helping us to better understand what went wrong and where we look to go here in the future if we do have a second wave for sure. I thank you for allowing me to be here, and let's get on with this. Thank you.
All right, thank you for that. We're going to move on to our first panel. We are joined by the Commissioner for New York State Department of Health, Howard Zucker, and the Deputy Superintendent and Special Counsel for the Department of Financial Services, Garrett Rhodes. And I believe that there will be a presentation that they will be doing. If so, you can share your screen and we can begin that.
Just a second.
Okay, we can see the Zoom screen, but we can't see your present. There you go.
There you go. Good morning, members of the New York State Senate and Assembly committees.
And if you could get, I'm sorry, oh, okay, you're in a setting. Please make sure that you get close to your mic because we couldn't hear you too well when you spoke there. Go ahead.
Can you hear it now? Is that good? So, all right, let's see what we can do here. We're working on that. Give us a second.
But keep it rolling so that we can, while we fix the mic situation, keep it rolling.
Good morning, members of the New York State Senate and Assembly committees on health, aging, Senate investigation and government operations, and the Assembly oversight, analysis, and investigations. I'm Dr. Howard Zucker, New York State's Health Commissioner, and thank you for the opportunity to speak before you today. When I last spoke to you on January 29th to discuss the executive budget, I spoke of an evolving public health threat called a novel coronavirus. It was a name that hadn't even been named yet. It was 1 month later that our Wadsworth laboratory confirmed New York's first case of COVID-19, but we now know that it was already here. Within 2 weeks from that moment, we had implemented a series of aggressive actions to protect our most vulnerable populations. And those practices continue today and will serve as a foundation as we prepare these facilities for a second wave and beyond. COVID-19 has caused more deaths in New York than we could have imagined.
Can I interrupt you for a second?
More loss than we can bear.
Commissioner, I don't know if you can hear me. Can I interrupt you for a second? I neglected ask whether you swear or affirm that the testimony you're about to give is true.
I affirm that, yes.
Thank you. Sorry.
COVID-19 has caused more deaths in New York than we could have imagined and more loss of life than we can bear. We feel the losses in these nursing homes as a community, and we grieve with those who've lost loved ones during this pandemic and during this time of disruption and fear and unrelenting stress. For all those who've been touched personally by this terrible loss and this terrible virus, my heart goes out to you. Today is an opportunity for a thoughtful dialogue on what we've learned based on the science and how we can apply those best practices moving forward. First, some quick background. COVID has significantly changed how we live, not just in New York, but around the world. This pandemic has rapidly and dramatically altered our everyday lives, introducing social distancing, face mask wearing, remote learning, business closures, and restrictions on visiting nursing homes and hospitals. Congregate settings such as the 613 nursing homes we have here in New York are particularly vulnerable to infectious diseases such as COVID. This has been a challenge nationwide since February 2020, when the first known case of COVID was identified in a nursing home resident in Kirkland, Washington. Now, I stress the phrase known case because, as we'll discuss this morning, COVID had a hold on New York State and its nursing homes much sooner than anybody knew. For context, the federal government issued a travel ban from China on February 2nd, but the virus didn't come to New York from China, it came from Europe, and 3 million people flew from Europe to New York City. The CDC has acknowledged that their European travel ban, which was on March 13th, was too late. The virus had already reached community spread here in New York State. Now, we may never actually have the full picture of the impact of COVID in nursing homes nationally, or an accurate snapshot of how it's been reported in other states. And when looking back at data from March and April, the CDC Director, Dr. Robert Redfield, said on June 25th that the cause of 27% of all deaths in the United States, 1 in 4, was recorded as pneumonia. And he went on to say, and I quote, it's up there, a lot of those pneumonias that were dying were actually COVID-infected individuals that were the elderly, nursing home, and individuals with comorbidities. So we now know that despite our best efforts, COVID continued to spread in nursing homes nationwide. And here in New York State, we restricted nursing home visitors. We ordered workers to be temperature checked every day. We implemented specific isolation and quarantine procedures for exposed and ill staff and residents. We built unprecedented systems for facilities to report real-time data to us. And to the extent practical, despite the fact that, as they say, we were building the plane as we were flying it, we made that data available to the press and to the public on a daily basis. We launched the most aggressive nursing home testing program in the country, testing residents in the 613 nursing homes and directing the testing of all nursing home staff, which has led to more than 1 million tests and identified several thousand positive cases. We conducted 1,300 on-site inspections. Every single nursing home and adult care facility in the state was inspected at least once to ensure that the infection control practices were in place. And we supported these facilities by providing 14 million pieces of PPE, connecting them to a staffing portal of more than 96,000 volunteers, and helping facilities transfer residents to other homes as needed. But when we saw the rise in nursing home deaths, like so many other states, I kept asking myself, what happened? What happened? And the why matters. The why matters for New Yorkers, it matters for the nation, it matters to prevent it from happening again, and it matters to bring closure to all those families who lost somebody. So we looked at the admissions to nursing homes between March 25th and May 8th. And there were 6,326 COVID positive patients that were admitted to nursing homes from hospitals during the time when COVID hospitalizations were rising. And what did we find? So a few key facts I want to show you. The peak in nursing home fatalities was on April 8th. The peak in admissions to COVID positive hospital patients occurred on April 14th. So the question would be, which was essentially a week later, why does that matter? Well, if the March 25th guidance was the major driver in deaths, which some claim it to be, then the peak of admissions would precede the peak in deaths. It's just the mathematics, the statistics of it all. However, it occurred the other way around. The peak in deaths occurred before the peak in admissions. In fact, when you look at the curve, as the admissions of residents was increasing, the deaths were decreasing. So one would say, why is this so important? Well, it contradicts this false narrative that's been circulating about regarding the March 25th guidance document. The false narrative is that COVID positive residents boarded into the nursing homes from the hospitals. But we have to be objective here, and the data does not support that. The facts show that 310 nursing homes admitted COVID positive patients from hospitals. And of those 310, 304 already had COVID in their facility. It is unfortunate, it is sad, but it is true. 98% of nursing homes already had COVID in their nursing homes. And those are the facts. Now, it causes me great pain as a physician and as the health commissioner in the state to see the total number of COVID cases in Florida, in Texas, in California, as they each surpassed New York. From May through July, COVID-related deaths in nursing homes more than doubled in Florida, they nearly doubled in California, and they tripled in Texas. You know, and I sympathize with my public health colleagues and my peers in those states who are experiencing the feelings of helplessness that we felt in March and April. As Governor Cuomo has said many times, healthcare workers are the heroes of this pandemic. Nursing home staff are incredibly hardworking professionals, all of them. They are dedicated to the residents that they care for. Mary McHugh, the Secretary of the Florida Agency for Healthcare Administration, recently confirmed for Politico that it was asymptomatic health workers themselves that were carrying the virus and transmitting it to their own patients. And a Florida nursing home administrator echoed that point by saying, and I'm quoting, "What we're finding is staff is coming in contact without even knowing it. Our community are truly a microcosm of the larger community."
Commissioner, if I may, is there any way, because I've gotten a couple of texts from some of my colleagues that are finding it really difficult to hear you. Is there any way that you could get closer to the microphone, please?
Let's see what we can do here. All right, let me see what we can do. I'm sorry. And I'll speak louder.
Okay, I did not, Commissioner, are you still there? I did not.
I'm right here. I'm right here.
Okay, because the presentation went away.
I know they're working on trying to get the mic.
I mean, and now the audio is going away.
Stand by. They're troubleshooting.
Okay. Hoping that doesn't count against our time, sir.
At your discretion, Mr. Chairman.
Now I'm talking to the commissioner because he's the one that, want to make sure that we get some time to ask some questions.
That better?
Say a couple more words so that we can determine, but in any event,
all right,
we're just gonna have to put up with that audio because we don't want to, we don't want to kill more time. Keep going, sir.
All right, let's see if the PowerPoint comes back up.
That's a little bit better actually in the audio. Please continue.
All right, great, thank you. After all, staff are one of the links between the community and the facilities. And when we looked at the data in New York, we asked nursing home administrators to tell us the first date staff experienced symptoms typical of COVID or received a positive test result. We also asked them to quantify how many staff either tested positive or experienced symptoms of COVID. So what does the data show? A retrospective analysis shows that the earliest recorded staff illness with symptoms similar to COVID was actually at the end of February 24th to be exact. So let's think about that for a moment. The period of time from infection, when the virus is in the body, to symptoms is 2 to 14 days. And if you count backwards, this could in many cases bring us back to mid-February when the exposure likely occurred. The question is that possible? Well, Mount Sinai recently published the results of their antibody study, which showed that COVID was in New York as early as February 1st. But back then, we could not test for it. CDC was the only place a specimen could be evaluated then, and for a long time afterwards. In fact, our own Wadsworth laboratory developed the first test for COVID outside the CDC, and that was on February 29th. Back then, we were not even screening for symptoms yet. And as I mentioned, the CDC itself recently released a report acknowledging that the European travel ban, which came on March 13th, right, was too late, and it was already spreading in New York. 3,000 flights from Europe had already landed in New York State by mid-March. So mid-March, For the largest number of nursing homes, the first instance of staff reporting a COVID-related illness was on March 16th, as one sees on this image, which is the blue peak there. Right? So one may ask, why does that matter? So let me explain. Because as I said earlier, nursing home resident fatalities peaked on April 8th, as one can see here with the yellow peak. So April 8th is 23 days after the peak in nursing homes' first known infections among staff. And one may say, well, why does that matter? What's so important about 23 days? Because multiple publications out of the Imperial College of London and many other prestigious research institutions have shown that among people in the general population who died from COVID, the average span of time from infection to death is 18 to 25 days. So I want to be clear on this. This is not to place blame on the nursing home staff for resident fatalities, not at all. But we need to look at this from that moment in time, not from an analysis using knowledge that we have subsequently gained in the months since that time, right? So let's stand at that moment in time. What was the landscape then? Many of the COVID positive nursing home staff were actually asymptomatic. Testing was not available then. But let's just for argument's sake say that there was testing and that they knew that they had it, but they did not have symptoms. The extent to which asymptomatic individuals could transmit disease was just not fully known back in March. Now, more on the nursing home staff, because as I mentioned, they were hit hard by COVID. By mid-May, nursing homes had reported approximately 37,000 affected staff. In fact, when I learned about this point, I actually said to them, you mean 3,700? And they said, no, 37,000. I was just shocked by that number. Because we have 158,000 people who work in nursing homes. So that means approximately 1 in 4 workers were affected. And interestingly, independent antibody testing done by the BioReference Lab in May showed that 29% of the 3,500 nursing home employees that they looked at had COVID antibodies. And this is very consistent with our findings. So extrapolating that data to the whole nursing home workforce means that approximately 1 in 3 nursing home workers had COVID at some point in time. So let's clarify this a little about the guidance. I'd like to spend a little more time about the March 25th guidance, which we have talked about many times, but it deserves repeating.
And if I may, Commissioner, just an inquiry. So you do want to spend some time on that. We want to give you time to do that, but how much longer in your presentation? Only because we have quite a list of questioners.
One more page. So
go ahead, sir.
A minute. Okay. The document mirroring CMS guidance released March 13th simply said that no resident shall be denied admission solely based on COVID positive status. It did not say you must admit residents with COVID. Now, I know this seems like semantics and just words, but words matter, and it's not semantics. No resident shall be denied does not equal must accept. A nursing home could not accept a COVID positive person unless the nursing home could provide, and I quote, proper isolation protective procedures and provide adequate care. And Title 10 of the New York State Code of Rules and Regulations, Section 415-26, clearly states that a nursing home shall accept and retain only those nursing home residents for whom it can provide adequate care. And in this case, adequate care means properly cohorting patients, ensuring proper levels of PPE, screening staff, and other infection control measures that we communicate to the nursing homes at several different junctions. So in conclusion, what caused nursing home residents to get COVID? The tragic truth is that COVID-19 is a new disease. It's in its name, 19, referring to 2019. Early on, we did not know how widespread it already was within our communities. And because no one knew the virus was able to enter the facilities that house our most frail and vulnerable citizens. And looking back, the data shows that the virus came into nursing homes through staff and presumably through visitors and was passed on to the residents. And with their health already compromised by age and other conditions, They died in number that, again, are just too high to bear. Still, we looked at the facts, and we will continue to do so. And as we learn more about COVID-19, we will have more facts, and we will be able to refine how we respond. But we will always, always make our decisions based on the best scientific data available at that time. Thank you very much.
All right, thank you so much, Mr. Commissioner. We are going to start it off by the Senate. Senator James Skoufis.
Thank you, Mr. Chairman, and thank you for your participation today, Commissioner and Mr. Rhodes. As we in the legislature make judgments on the past 5 months, I think you both agree that it's critical that we first have the full, unadulterated facts. And so to that end, I'd like to ask you about your administration's definition of a nursing home death. As it stands, someone who's in a nursing home as a resident gets infected in their nursing home, but loses their life in a hospital or elsewhere is not counted as a COVID nursing home death. So first, how many other states similarly do not count the aforementioned as a nursing home death?
I can't give you the answer on the number of states. I know that the data that's coming in to the CDC, and I've spoken to the CDC many times, is quite fragmented regarding different states. Some reported.
So if I can ask then, are you aware of any other states that count these deaths as we do?
I know that there are other states. I can't give you other states that specifically say that it's coming from nursing homes versus hospitals, but I can get back to you about which states are doing what.
Please do. My investigative team wasn't able to identify a single other state that counts nursing home deaths as we do. Regardless, and respectfully, it's my opinion that your administration's definition truly misrepresents the true scale of this crisis in our nursing home as a result. So let's try and get the full picture here and now. How many of New York's nursing home residents died in hospitals?
So I know that you want that number, and I wish I could give you the number today, but I need to be sure it's absolutely accurate. And let me explain a little bit as to why I'm saying that, because numbers, when we ask the nursing homes information, they provide information, sometimes it's dated all the way back to December 2019, obviously before coronavirus was here as we understand it. They also sometimes provide nursing home data that was on a day, but it wasn't accurate to that specific day. And I'm not placing any blame on the nursing homes. The nursing homes provide data, but I personally need to also be sure that that information is accurate and correct. And we have in the middle.
If I may, because my time is limited, you don't have a ballpark that you can give? I mean, so the total official number is about 6,500. Are we talking with the hospital deaths, 8,000, 10,000, 15,000? What are we looking at?
I think this is a serious issue of making sure when it comes to the deaths of individuals in nursing homes, and I'm not prepared to give you a specific number. We are in the middle of the pandemic, obviously. We always forget about that sometimes. We are looking at all the numbers. We are looking at data. When the data comes in and I have an opportunity to tease through that, then I will be happy to provide that data to you and to the other members of the committee.
So I respectfully, I don't understand why many other states, including very large states like California, both large in population and large in terms of the scale of this crisis, are able to collect this information and we are not. It perplexes me that in an administration that has prided itself, and rightfully so, over these past 5 months for making data-driven decisions, that you don't have this fundamental information. You do have, based on your report that came out last month, data that speaks to nursing home residents that were recovered from hospital stays and discharged back to hospitals, but you're not able to, it seems, track how many nursing home residents didn't recover. If I may move on, your definition of a nursing home death is fundamental to that report I just referenced. Our committee's investigative team solicited testimony from a Dr. Dennis Nash, an epidemiologist at CUNY, who wrote the department's report, quote, didn't set up the design well from an epidemiological standpoint, and goes on to write that hospital-based deaths of nursing home residents are central to understanding whether there is any causal link between state nursing home policy and increased COVID transmission. Do you agree or disagree with Dr. Nash that a full accounting of hospital-based deaths is central to understanding the effect of the state's policies on nursing home infections?
I don't agree with him. I think that we have looked at the report. Obviously, I issued the report and anything that I'm going to issue, I obviously stand behind. We've looked at that data, and it does, as I just showed you in this PowerPoint slide, it does show you the relationship regarding residents and, well, I should say staff who got ill and deaths, and we can talk a little bit more about that. We had an incredible team of epidemiologists who also work on this information and look at the data as we put information out. And regarding, I was just thinking about this also, that 11 states don't even report anything. I remember that number popped back in my head. Yeah. Right, 11, and we report, New York State also reports presumed cases. Now, granted, we are at a place now where we have the ability to test. We're testing, obviously, 80,000 a day. But
one second. The clock is not up, but you have 30 seconds left.
Thank you. My last question. I think we can all agree that it's of utmost importance that we learn from the past 5 months so we're best prepared for the next public health crisis. In hindsight, do you have any specific nursing home regrets that you would like to share with our committees? And Mr. Rhodes, I'd like you to answer this question, please.
Your question is, do we have any specific nursing home regrets?
Yes.
I think we're still in the middle of a global pandemic, and like everything, there's always going to be lessons learned. And I know that's what today's hearing is about as well. And I think once there is the amount of data, the amount of facts, once there is a full picture on the table, hopefully once this crisis is over, I think there'll be many lessons learned that we can look back from and learn from.
Thank you, Mr. Rhodes. Thank you, Mr. Thank you, Senator Skoufis. Actually, your time is up, Senator Skoufis. I'm going to ask for the technical team to please make sure that I'm going to stop everything for a second. Make sure that the clock is up on the screen so that every person after us can do it. So if anybody who's out there in the technical team could take a second to put that clock up. I'm doing some rough timekeeping over here, but I don't want to be accused of doing it unfairly. So something that everyone can see would be preferable.
We recommend that everyone uses the gallery view. The clock should stay there in the gallery view of Zoom.
It's still, is it on there?
It should be.
It is on mine.
Okay.
Chairman, can I just remind you that Mr. Rhodes was not sworn in as Mr. Zucker was?
Okay, I pass it to the assembly.
Fair point. Mr. Rhodes, if you're asked further questions, do you swear or affirm that the testimony you're about to give is true?
I affirm.
Thank you.
Assembly. Go ahead, Mr. Bronson.
Yes, Ron Kim has his hands up.
Assemblymember Kim, you're up.
Okay, can you hear me?
Yes.
Thank you. Commissioner Zucker, was there any thought to have an independent third-party agency or organization evaluate the policy of the New York State Department of Health to send hospital patients, irrespective of their COVID positive status, so that any concerns of conflict of interest may be addressed?
So I think I will echo what Gareth just mentioned, that this pandemic is not over yet. And New York has made an aggressive response regarding the pandemic. And I think that we need to work through the pandemic first, and hopefully we get through this without other deaths, and we can tackle that at another point in time. But I want to say that the efforts that we have made in the state, I hope we didn't lose you. Can you still hear me?
Okay, so that's fine. Thank you, Commissioner. So for argument's sake, then let us assume that the conclusions of the report are correct, namely that the admission of COVID positive patients to nursing homes had a negligible effect on the spread of the coronavirus disease there. If this is true, then what explains the impetus for the reversal of the March 25th directive in early May to prohibit nursing homes from accepting COVID positive patients?
So this goes back to that statement I made earlier in my opening remarks about there's a false narrative out there. And this is where I have to correct these statements that are being made. There was no reversal. The March 25th memo is still in place. We still say, based on the guidance of CMS and CDC, that a nursing home cannot accept a patient without being able to care for it. That's part one. The May 10th guidance that you just referenced was about the ability to test people who are leaving the hospital. And again, as I also mentioned in my opening remarks, we have to look at this in each moment in time. In May 10th, we were able to test. On March 25th, we were not able to test, and what we were asking back at that point is to make sure that no one is discriminated against, and we still feel that way. No one should be discriminated against based on their COVID status.
Okay, so if there's no statistical correlation between the unconditional admission of COVID positive residents to nursing homes and the rate of infection in them, then why would there have been a need to establish specialized facilities for the isolation and care of COVID positive residents?
So let's also think about this at that moment in time. We were sitting with projections of suggesting that 140,000 people were going to be admitted to the hospital with coronavirus. We have a 53,000 beds, and that's across the state, 26,000 downstate, which is where most of these cases were initially, obviously. And we were planning for what we would need to do in case there was a surge of even more cases. We had to look at this with projecting going forward. We could sit here now, 6 months later, 4 months later, 3 months later, and be able to sort of say, well, these are the facts that we have. But as I said in the presentation, it is important to stand there at that moment in time and say, what should we be doing? Governor Cuomo, I remember the meetings, and there are many meetings saying we need to project. If there's a surge of 140,000 potential cases, we need to plan for that. And that's what we were doing, planning for what could happen. And that's what one of the things was to move forward on that. Sorry.
Thank you, Commissioner. Thank you, Assemblymember Kim. Senator May, please.
Thank you. So I want to go back to the issue of staffing, because you talked about staff a lot. Last year, we passed a bill requiring the Department of Health to submit a report detailing safe staffing levels, in part to improve patient safety in nursing homes. It was due at the end of last year. When can we expect to see that report?
I promise you I give you an answer to that on August 14th. I will have the report. I wanted to be sure that we also looked at this in the context of what has been happening. Remember, December to now, the world has changed, and we are now in the middle of obviously a public health crisis, but August 14th.
We wanted that report before in December. I don't think you can use that excuse. So in your report, you stated that employee transmission was the largest correlation to nursing home fatalities. We know that many long-term care workers work multiple jobs. They lack benefits like sick leave that might make them less likely to get sick or to be unwitting vectors of disease. I also wrote to you back in May about the need for more PPE for nursing home staff. What are you doing now to assure that the state invests in these heroic workers so they have the support they need to protect themselves and their patients moving forward?
So I think this goes to the bigger question of what are we doing to protect not just the nursing home staff, because they are part of a community, right? And I think it's the issues of how to protect those who work in the nursing homes is really protecting the community. So maybe I could talk a little bit about that, of what we're doing looking forward and how to prevent the spread of this disease. And that, I think, will answer the question about how we're protecting the staff as well. So let's look at this from two parts. Let's look at this from the standpoint of prevention and treatment, because I think this is a really important issue. With regards to prevention, we are making sure that there is equipment available for those in the nursing homes and for elsewhere. We put out 14 million pieces of PPE. We are aggressive to make sure that if any nursing home needs more supplies, we provide that to them as the state. We have also worked to make sure that there's testing available. We had 1 million tests, or more than 1 million tests done on nursing home staff. We provided the test kits to those individuals as well. We've tested, obviously, the residents in the 613 nursing homes. So it's a whole issue of testing. We have moved forward to make sure there's testing available for the nursing home staff if they weren't to get it just there. But let's say they wanted to get it elsewhere in the state. We have 776 different places they can get testing on that. We're working with the nursing home staff, again, about the community regarding contact tracing. So if one of them gets sick, we want to be sure that we can look at that individual in the nursing home and to be able to track not just those who they're exposed to in the nursing home, but to their relatives as well. Because as I said, this is part of the community. So we have contact tracing set up, which has been an aggressive effort on our part with Bloomberg Philanthropies and with Vital Strategies. And I can tell you, there are tens of thousands of tests done. And I hear about, because I get reports about every time there's a positive and what we have done in every hotspot there is, and we go after that. So that's one issue. Then there's obviously all the education. We can go into that at another point that we're doing, but also the issue of vaccines. And I think this is something worth mentioning as well, because we're looking down the road. The department is looking down the road. The entire state of New York has always been very progressive on this issue, but looking down the road, what happens when a vaccine becomes available? How do we decide how to get this out? And we've already dusted off the plan for the H1N1, which was a 2009 influenza infection. What were our plans then? How did we move forward then? What can we do? How can we apply it? I've been speaking with the pharmacies, the CEOs about pharmacies about this. I've been speaking to the hospital leadership about this, the nursing home leadership, everyone about this. Like, what's the plan to make sure people get vaccinated on this issue? And we have PPE rates as well. I can go on. I would like to at some point.
I'm going to interrupt you though, because I also want to talk about the issue of nursing home staff and home care staff are so underpaid that we don't have enough people working in the nursing homes. And I want to urge you to be proactive in supporting this whole sector so that we can avoid the dire outcomes we've been seeing. I have one other question, which is about social isolation, which is a huge problem that's reducing the quality of life and even the life expectancy for some seniors in nursing homes. New York's prisons are set to resume visitation, but nursing homes have an incredibly high bar of 28 days without a positive test before people are allowed to visit. Have you considered models like Massachusetts allowing outdoor visitation and encouraging outdoor visitation? The latest estimate I've seen is about 10% of New York nursing homes are doing this.
So we, a couple things on that. First, one other thing, we have 60-day supply requirements on PPE in the nursing homes, 90 days in the hospitals, but we can get back to that. Visitation. Yes, we recognize this as a challenge. We have 28 days based on the CMS guidelines. There's a reason for that. This is based on guidance of 2 incubation periods. We really want to have 2 incubation periods. It's not we want, this is the science behind it. I recognize there's some discussions about outside visitation. We are looking at all options out there, but the last thing I want to do is create a situation where we have a surge in the number of cases here. And I also recognize, I really am very sympathetic to the situation of the fact that people are lonely. And what we're doing is we've actually tried to figure out how we should have more connections using technology. And we put $1 million into a program to be sure that can move forward. And I know your time's up, and I'm trying to be respectful.
Thank you, Commissioner. Assembly.
Yes, my apologies. I went out of order. I should have called Chairperson Dick Gottfried. You're up, Dick.
Okay, thank you. Commissioner, how many people contracted COVID-19 in a nursing home and then went to a hospital and died? If a handful of salmonella cases showed up, I think we would know pretty quickly that they came from a nursing home and which one, and we'd be on that case. I don't know why we can't do that with COVID-19, but it seemed, I would have assumed that the data on what nursing home patient in a hospital came from would be in that patient's Sparks record, and which is the hospital data system the state has had since 1979. And that if you needed that information on a real-time basis, the system could be jiggered so that that information would be available to you on a real-time basis. From our conversations, it sounds like what I've thought Sparks would be able to do, maybe it currently can't do. So here's my question. I'd like to talk to the top people that run the Sparks system and get from them a fairly detailed picture of what's in the Sparks system, what isn't, how quickly it can spit out information when needed, and what we would need to do to improve that. So my question is, right after this hearing, would you email me the name and mobile phone number and email address of the 2 or 3 people that run the Sparks system and tell them it's fine for them to talk to me at length?
I will do that. I wrote it down. And just so you know, the Spark system data is for hospitals, not for nursing homes. There are other ways, there are other systems in place for the reporting of nosocomial infections or other infections, but we could talk about that and my team could happily discuss that.
Okay, and yes, I know Sparks doesn't cover nursing homes, but the data ought to say where the patient came from. And did they come from a nursing home? And if so, which one? Another question, Medicaid is the payer for about 80% of nursing home residents. At the moment, it might even be higher than that. That a COVID patient in a nursing home or caring for patients in a time of COVID, it's a whole lot more expensive, a whole lot more staff time, a lot more staff who are absent and need more expensive replacements. Patients need more care. Patients need, it's labor intensive to separate patients and treat them separately. I think that if you look at home care, there are probably very similar issues. As far as I know, the amount that Medicaid pays to nursing homes and for home care, those terms and those amounts have not changed. And my question is, are we going to do something about that? How can we expect providers to provide quality care when their costs are skyrocketing and their payment rates from the state are not?
Well, we're going to look at everything on this issue, obviously, but I will turn back to the issues of the federal government when it comes to Medicaid, because this is one of these big challenges, and we would hope that our federal partners help provide some of the support to this, financial support to the states on this issue, and obviously then it will go to the people in the state of New York who are recipients of such programs.
Well,
so I recognize your question, and we will look at all these issues.
When the federal government was in the mood to be passing multi-billion-dollar or trillion-dollar pieces of legislation, maybe we should have put this on their agenda back then, meaning a couple of months ago.
Thank you. Some member, your time is actually up. Sorry
Okay.
about that. Senator Biaggi.
I can't, for some reason, click off or show my video. There we go.
We can hear you.
Okay,
There
very
you
good.
are.
Thank you very much, Commissioner. I'm going to ask that you just answer yes or no because of my time. How long have you served as the New York State Health Commissioner?
6 years.
Okay, great.
1 year as acting, 5 years as the firm.
to yes or no. As health commissioner for 6 years, how many budgets have you worked on?
All of them since the beginning.
Great. In accordance with your responsibility to uphold the health and safety of all New Yorkers as Department of Health Commissioner, do you read the health section of each year's budget?
I do read the budget when it's done. But I will tell you, do I remember every detail? No, I don't remember every detail.
Okay, great. Did you read this year's health budget language?
It depends on what you're asking me specifically about that.
Did you read Alpha Part GGG, which is the provision of the budget that gives immunity to healthcare professionals, healthcare facilities, and any other treatment that are given to individuals who are seeking treatment from those doctors or professionals?
No, I will not say that I can remember those details on that, but I have a team of unbelievable number of lawyers who usually provide me with information along with my legislative team on that. Okay. There's something specific that's in there. Yeah.
Okay. Just to be clear, the most important provision of the health budget this year, one of the most important and provocative and frankly controversial, was you did not read that provision. Okay, so I will then just jump to the point. So that provision was written by the Greater New York Hospital Association. I can confirm that from a press release that was issued on April 2nd, which they later deleted, unfortunately, that basically said, quote, they drafted and aggressively advocated for the immunity provision. So since you are not aware of that provision, I'm going to tell you that the broad implications of that provision were that immunity was not only granted to COVID-related treatments and diagnoses, et cetera, but it also was granted to non-COVID related treatment, diagnosis of care for any single New Yorker, which means that if you were a New Yorker that went to the doctor from March 7th to April 3rd, on April 3rd, when the budget was passed, your rights were retroactively taken away from you. And today, who are visiting their doctors still do not have those rights. So are you now aware of these implications?
The Greater New York did not draft that, as I understand that. I know what you're talking about. I know where you're going on this issue. I lost your voice. I lost the audio for you.
I actually have that language, and I have the press release that they sent out on my computer right now. I'm happy to send it to you.
I think the issue here you're going to is about immunity.
I'm reclaiming. Right? So now that you're aware of this provision, in the state of New York, Black women are still 2 to 3 times more likely to die in childbirth than white women. After the findings of the New York State Task Force on Maternal Mortality and Disparate Racial Outcomes, which I'm hoping that you remember since you co-chaired it.
Of course I do.
That childbirth should be a joyous time for families, unblemished by fear and implicit racial bias. So for women of color who are already receiving a lower standard of care during childbirth in the state of New York, how does immunity for their doctors protect them?
The issue here about, there are a couple things. One is the issues here about immunity. No one is saying that we are allowing bad actors to act on in the community, doctors or anyone else. And believe me, as a physician, I'm well aware of that. So that's number one. Number two, we were in unprecedented times. We wanted to be sure, and we still are, wanted to be sure that there could be care provided. And we will look at everything about that. Regarding the budget, I will just throw back to you the fact that this is actually a negotiated budget. So you're part of this. You know, the legislature is part of this. So I'm just—
Thank you, Senator. Thank you, Senator, and thank you, Commissioner.
So you actually know better since you have been involved in 6 budgets in the past. Thank you very much.
Thank you, Senator. Assembly, please. Is that Member Bronson?
Yep, I had some problems with my mute button. So I'll be next in asking questions to the Commissioner. Commissioner, thank you for being here today. I do appreciate it. My first line of questioning has to do with what many have reached out to my office and voiced a concern of a lack of transparency of what's happening in the nursing homes, a lack of communication or poor communication with family members. Certainly in the early days, family members who didn't know that their loved one had tested positive, and indeed some who had passed away with delayed notice of that. Most importantly is the fact that the Ombudsman program had been halted, which is a direct liaison system between the nursing homes and the family and the loved ones, as well as helping residents to marshal their way through changes that were impacting them. And I guess my first question relates to how many inspections are you doing and were you doing in the early days of this to assure that nursing homes in particular were providing staff instruction, following protocols, and making sure that staff had the appropriate PPE?
Sure. So we did 1,300 inspections. We continue to do them. We've been in every nursing home across the state multiple times, sometimes in the middle of the night, unannounced. We are, if there's anything that is not being done appropriately, and if there's any danger to any resident in that nursing home, we will go in there and be aggressive and make sure it's changed. Separately from what the department and obviously our branch of government, the Attorney General also has their own investigations that are being done, and I won't speak to that, but I just raised that as well for you. So we have been in there, and we will continue to be in there.
Thank you. Of the 1,300 inspections that your agency conducted, do you have a breakdown of the number of nursing homes that had to take, and I'll use the word substantial, I'm not sure if that's a good qualifier, but had to take substantial measures to correct their procedures or other aspects of whether it's staffing, PPE, and things of that nature?
I'd have to get back to you about a specific number on that, and which ones.
Okay, if you would please, and in getting back to us on that, if you would outline the violations that were found and what corrective steps were taken and things of that nature. I just heard from a local nursing home who's concerned about the 28-day rule in connection with no test positives. Can you tell me the scientific basis of coming up with that 28
Sure.
day?
Sure. It's about 2 incubation periods. And this is not just about COVID-19. If you remember last year, it seems like a century ago, but last year when we had the measles outbreak and everyone's saying, well, when will New York State be considered cleared? And I kept saying that we need 2 incubation periods because someone could, in that first incubation period, someone could actually end up positive. So you want to be sure you have coverage 2 incubation periods before you can say there's no risk. This is just so dangerous and is so deadly that we need to be really cautious about this. And I am extremely empathetic to the issue of these individuals who are residents in the nursing home and their relatives who want to see them. I get it. Believe me, I have a mom who is home, not in nursing, but home alone. I have seen her 4 times, once through a glass window in the lobby of the building, and is so upsetting because people don't have many friends when you get to that age that are left. A lot of people have died, which is very sad. And I can feel exactly that situation for someone in a nursing home. And the fact is that their relative or their best friend can't see them, and it's psychologically challenging to them as well. We've tried to move this forward with regards to using technology. I feel them, but I don't want to do something which is not in the best interest of public health.
And I would add this is consistent with CMS guidance, which says 28 days as well.
Okay, thank you for that. One follow-up question in that regard, and it's similar to what Senator May asked, and that's we're very sensitive to also isolation, which really impacts the elderly. Are there plans to develop creative ways to get around that isolation issue?
Right, and so that goes to use of technology and trying to move forward. The best thing I hope is that we get through this and this pandemic is over and that we are able to have vaccines or some kind of antiviral therapy, monoclonal antibodies, something out there that can help people to make sure that it decrease the period of when they're ill. This is all in the works. I have spoken to, I just will share, I know time's up, but I just want to share the fact that I have spoken to so many scientists. I have spoken to, obviously, Tony Fauci on a regular basis and been in contact since the beginning of this, 2 former FDA commissioners, 3 former assistant secretaries for public health preparedness, 2 former CDC director. I've also spoken on a weekly basis to the person who used to run the National
Thank you,
Yeah,
Commissioner.
that's good for that. And there's just a lot of people and scientists on this issue
You
as well.
talked to a
So
lot
we're
of
looking-
folks, but a lot of
I
our
do,
folks want to talk
all
to
the
you.
time.
Gotcha.
Okay,
A lot of our
fine,
folks
got
want
it.
to talk to you. Next,
No problem.
Senator Jen Metzger.
All right. Thank you, Mr. Chairman, and thank you, Commissioner, for joining us today. I represent Hudson Valley communities in Orange, Ulster, and Sullivan counties with nursing homes that were hit very hard and saw a tragic loss of life. Our state has an obligation to these families and to nursing home residents and their families and staff to analyze and assess the policies, procedures, and conditions that may have contributed to those deaths. This is important, not just for reasons of transparency and accountability, but to make sure we don't repeat past mistakes, to make sure that we are putting in place the best possible policies and protocols in case we face another surge. I felt that the Department of Health report did not do this. It did not examine the practices, procedures, and conditions that contributed to or protected against fatalities. For example, I think it would be very valuable to undertake a comparative study of nursing homes that fared well in highly impacted regions compared to those that did not, so that we can understand what was effective and what wasn't. Do you have any plans to really examine what happened so that we can learn from the experience and be prepared for a future surge?
Sure, thank you, Senator. We always are looking at information and data. So let's go back to the data and the facts on this, because this is really important because of different areas of the state. This virus came in to New York, and particularly in the downstate region, in the beginning of the year, probably in February of this year. We know from the data, from the antibody data, that it was probably in the community early on in February. We do know from what the governor asked us to go out there and to test the essential workers. We found out that there are some parts, some zip codes in the downstate area with 50% antibodies. So what this says is that within the community, this virus was spreading. We did not know about it. It had affected a lot of people. And so those people in the community who also work in these nursing homes, it spread that way. It went into the nursing homes. There are other regions where the antibody levels were much lower. And the testing, the levels, the positive rates were much lower. So the community probably had lower amount of coronavirus. And since the community and the nursing homes are obviously linked together so closely, it's probably less likely to spread. And I can tell you that in some areas, look at Florida. Look what's happening in Florida. These numbers are skyrocketing now. The disease has gone up in the community. It's gone up in the nursing homes.
I'm going to run out of time, but there are differences within my district. I have a facility that had no COVID positive patients, and others where we had many deaths. And I think that is worth investigating. You know, why do you have such disparate outcomes? So I agree
with you. I agree it's important to investigate this, and I will tell you we are doing this, but we're still in the middle of this pandemic, and the more information we get, the better it is, and we will respond to it appropriately.
Okay.
Thank you, Commissioner. Thank you, Senator.
All right, thank you.
Assembly.
Yes, next we will have Chair McDonald.
Can't hear you, bro. Can't hear you.
There you go. That's better. Dr. Zucker, thank you. Let's start off with a reverse question first. The March 25th policy, and you've done a good job of explaining the data elements, but you know, the average Joe on the street asks the same question time and time again. So I'm going to ask you this. You know, why were nursing home residents not actually discharged to a step-down facility, or why were they not? And the same would apply for those in developmentally disabled population as well. Why were they not discharged to the Javits Center or the USS Comfort? That's something I think people want to know the answer to, and I'd like your thoughts.
Sure. So I think that, again, two parts to this. One is that the issue of what was the purpose of Javits and the Comfort. And I know this has come up a lot, and I've heard it from many people. The fact is that we have to look at this in the context of the clinical picture. The Javits was not designed for the physical ailments of people in nursing homes or the cognitive issues. Let's think about this from the perspective of somebody who unfortunately has dementia, and you have somebody in a facility where they're not in their room, they have to get out of, the next thing you know, they're getting out of the bed in their cubicle, they're starting to walk somewhere, the bathroom is not right there. You have to look at this from the clinical perspective. Also, just moving someone from the nursing home to another facility, there's something called transfer trauma, where you actually disrupt them. So if you can keep them in the facility, you can provide the care that's needed in the facility, we will do that. If there was a reason to move them, if there was a need to move them, we would have moved them if they came to me and they asked. Nobody asked me about that. Back to the Comfort and the Javits for a second. Originally, they were not designed even for COVID patients, and I know what you're saying about the non-COVID patients. It was Governor Cuomo who actually asked the president and to change these to a COVID positive facility. So we did move forward on that as well. But the nursing homes are their home. I think people forget that this is their home. This is their environment. If they could be provided here, that we should do that. Back to the March 25th for 1 second. I do want to, because people keep bringing this memo up, it was to make sure that we did not discriminate against COVID positive patients. And I will mention to you that years ago, when I was in training, this issue came up with HIV/AIDS. And exactly what happened was people, and if you go back in the literature, both the medical literature and the lay public literature, you will find there was big concern that people were not allowing individuals who had HIV/AIDS into nursing homes. Go back history. We sometimes should look at history and see what it showed. This is a really important point. I'm respectful of your time. So
let me jump onto something else. Let's jump forward to today. We have many residents throughout the state wanting to visit their family members in the facilities. You mentioned earlier that the visitation period, the 28-day period, is based on CDC recommendations. Is that recommendations in regards to no positives with residents or no positives with staff or both?
No, it's CMS guidance and it's both. It should.
I'll quote.
You have a
quote.
yeah.
There have been no new nursing home onset COVID-19 cases in the nursing home during that period.
All right. Isolation, big concern. As you know, I'm a practitioner. I hear it from my colleagues. I hear it from family members. Are we measuring the psychotropic use of medications? Are we seeing an uptick? Because many people are saying they're not dying of their illness. They're dying of depression and isolation.
And I look at this and
also medication use is up dramatically.
Right. And as one who is in the pharmacy world and as an anesthesiologist, when it comes to medications, I'm very sensitive to being sure what are we giving and what has been happening. Yes, we have seen an uptick on this, but it's not just in nursing homes. We've heard a little bit about what you're suggesting about nursing homes, but it's across the board in society. There's a 27% increase in the use of Zoloft and some of the other agents for managing depression in the community. So I recognize this, and we are looking at the effect, the psychological effects of this on the entire community, not just the aging population, although I recognize they are a vulnerable population, but all across the board.
Another question. We are requiring nursing home staff to be tested. I'm hearing from throughout the state that the results are coming back 8-9 days after they've been tested. The tests are weekly. I think that needs to be reviewed in one way or the other. We need to review how they're going to continue to be able to afford this if we keep this type of process. And the other thing that I'm hearing from the nursing home community, which I really like to have reconsidered, the daily reporting of PPE. It's important to have PPE, and I know we're making provisions. But can we move that to weekly reporting versus daily? Just one less thing that these long-term care providers have to deal with.
We'll look into that. And with regards to testing in the state, our numbers are 2 to 3 days turnover. Some of the commercial labs are a little bit longer, but Gareth probably can answer this specific.
Very quickly, Mr. Rhodes, the time is up, but very quickly, please.
The biggest issue is the large commercial labs. To the extent we can move testing from those labs here in the state with shorter turnaround times, we're actively working on that.
Thank you.
All right. Thank you, Senator Susurino. Recognized for 5 minutes.
Hello, everyone, and hello, Chairman. Thank you for being here today. And I'll be quick. Throughout the pandemic, when it came to making decisions for nursing homes and assisted living facilities, do you feel that your department was wholly independent of the executive branch? And this is really just a yes or a no for my first question.
So, well, we are, the department's part of the entire, executive branch, right? And so we work together. This is such a complex pandemic. Sorry, it's not a yes or no answer because the issue is that we are all working together. There's so many parts to this that we must do this as a collaborative effort. Otherwise, we wouldn't have the success that we have today in New York State versus the rest of the nation.
And that's good because it was a team. So of the team that you had that were making the decisions, how many people left?
How many left the team? We have an enormous team. Are you talking about within my department, or I have over 1,500 people working on this issue, and so I have so many individuals that I couldn't even name them. The other day I was on the phone call with my entire department, thanking them for all their efforts.
Okay, I'll go on to the next one, Commissioner. So who made the final call when it came to the wording of the March 25th order, the wording, and who made the final call on that?
This is a department. What happens with any guidance, we did 124 guidances so far. It's like any other department guidance. It goes through the process. It goes over to chamber like any other guidance goes forward.
Okay, and then I know you touched on staffing before, but the state recruited thousands of healthcare volunteers. Can you tell me how the process worked to get them where they were needed? Because from what I heard from administrators, they were not able to access them. And worse, many of their own qualified employees were getting incentivized to go to New York City. This was my question.
So
sorry. We can answer that.
So we had 96,000 volunteers. We still have in the system. If a nursing home needs it, we will provide. They can go into a portal, and if there's any challenge, they can call us. We had an entire operation set up right here in this room where I am right now to address any of the challenges that anyone needed when it came to support. And to this day, if someone needs someone, just call and go into the portal. And if they don't get the answers in the portal, let us know, and we will make sure it happens.
Because that was an extreme area of frustration for people. And I had put forward a proposal to recruit and train staff and to recruit volunteers with experience in this field. But why wasn't that done? And will you make that a top priority going forward?
Well, I'm not sure what you're asking that it wasn't done. It was we had that information and we provided it to everybody. So I'm unclear. If there's a problem, we're happy to fix any glitches that are in the system.
Okay, and then on April 23rd, I sent a letter to both you and the governor regarding specialty care centers. And in the letter, I make it clear that many nursing home administrators explained to me that even though the governor claimed any facility that didn't have the ability to care for these patients could deny them admission because of the wording of the March 25th order, they felt that was really not an option. I suggested that the state look into creating regionalized specialty care centers where you could designate certain facilities across the state as COVID nursing homes, but provide those facilities with direct support and resources needed to ensure they can provide quality care. Shortly after sending the letter, my conference had a call with the governor's team and I asked for a response to this idea, but to date I have yet to receive one.
We'll look into that and get back to you on that.
Okay, and then one last thing. On the testing for the nursing home and assisted care facility staff, it's taken too long for the test results to come back. Is there any work being done on that we could have a quicker turnaround?
So we will move forward. Gareth will mention that. Let me just mention that there are other facilities that are out there that we have in place right now for individuals who can go there, including I can go through the specific areas on that. And let me see if I have it on my paper, but while Gareth answers, I'll look for that for you.
Absolutely. So when we, in May, when we started this, we required nursing homes to do weekly testing of their staff. We connected every nursing home that asked in the state with a laboratory who could do the test. Over that, now in the weeks and months since, you've had some of the larger national laboratories, the overwhelming demand from Arizona, from Florida, from Texas, which has led to much longer lag times than we were seeing there. We've been actively working to move that volume from these national labs to more local labs. New York State built the entire network of local labs. And this is, you read the governor's op-ed in the New York Times a couple of days ago, setting specific requests of the federal government and what other states can do to help reduce the demand of these big national labs.
And so
very quickly.
Yeah, the answer is quick. Buffalo Avenue, there's one in Staten Island, and one's upstate in SUNY, New York, in SUNY, New York, and there's one other one that I have also, but we'll get to you.
Thank you, Commissioner. Thank you, Senator. Assembly?
Yes, next up we have Ranker Assembly Member Kevin Byrne.
Thank you, Mr. Chair, and thank you, Mr. Commissioner, for being here. Before I get really started, I do want to thank you from earlier on at the onset of the outbreak. Commissioner met with conferences, both Republican and Democrat, to brief us on the virus earlier in the year. So I do appreciate that. So I want to say something nice before I really got into the weeds here. And I'm glad you came prepared to discuss the March 25th order as well as the DOH report. So let me start out by asking who actually developed this report from the Department of Health that seems to defend the March 25th order?
The report, the nursing home report was developed by the team within the department. I have, as I mentioned, a lot of epidemiologists. I have physicians and others, and have been working on this since day one. And they worked through the report, looked at the numbers, and as I mentioned earlier, that I stand by all the data in that report because I know there's expert individuals who do it.
Understood. And I do think there's some opinions from my colleagues, like speaking for myself, that it is incomplete in certain instances. The counting of fatalities from nursing homes is an issue. If the department felt it could do a report, I'm actually glad you did. We put forth an amendment in the assembly at one point to ask the department to do a report. So it's good. I just feel it's missing information, specifically a total complete count. I also had a question about the number. It seems to be heavily reliant on the timeline, and I understand that the two different peaks, but the number 23, the 23 days basically from infection to fatality. My question is, when we're dealing with the elderly and those with the most severe underlying conditions, is it not reasonable to believe that that period would be sped up, that they are not going to have the same time period from rate of infection to fatality as the general public?
I've asked some scientists about that, and it doesn't, so far it has not panned out on that. If the individuals are severely immunocompromised, somebody who has had, is on chemotherapy, their white count's 3 and their platelet count's 20,000, all these other medical problems I go through, then the virus may hang around a little longer. That's something, but it's a very small percentage of the population. Back to the
Mr.
report for
Commissioner,
1 second.
I want to ask, but we just have a limited amount of time, so I'm sorry to interrupt. But sure. I just want to point that out. That's a concern, and I know there's anecdotal evidence of people that have succumbed to this virus fairly quickly. So there's obviously highs and lows to this. Going back to the actual March 25th order, I'm glad you said that words have meaning, and that's important. I think we believe that as policymakers and as lawmakers. And you cited the New York State Codes of Rules and Regulations 415.26. I know the governor has mentioned this. I'm not sure if you have the March 25th order, but can you point to where in the order it actually cites CDC guidance or the New York State Codes of Rules and Regulations in the order?
So two things. One is, I don't have it sitting right in front of me, but two things. One is, on the report, just so you know, it has been reviewed by outside experts as well. So it's sort of peer reviewed as well. So that's part number one. Number two, these codes and these statutes, 415-26, that has been around since 1992. They know, these nursing homes, everyone knows that you have to provide the necessary and adequate care. So this is just a basic underlying understanding of the nursing homes, and for that matter, all other facilities, Article 28 facilities. So I think that,
Commissioner, I'm sorry, we're just running low on time, but I understand that, and I thank you for your answer. But as we craft policies in the state legislature and other orders and directives are disseminated, I mean, we are dealing with this pandemic where the governor has had to, in many cases, rightfully suspend certain state laws. So I think this is a very, high pressure time. We pass laws and policies where we always say things like, not always, but oftentimes, not to conflict with state or federal law. I didn't see that anywhere in the order. I also saw, we use the term advisory or guidance, and I know the report mentioned some of the CDC guidance, but this uses words like must and shall Do you think that if you had to do this over again, it's still a standing order, although I can't, or standing document, although I can't find it on the Department of Health website, would you consider revising it or rewording it if you had to do this over again?
The guidance was put out there in the effort to make sure we did not discriminate against those who are COVID positive. That was the purpose of the guidance. And at a time when our numbers were going up dramatically and we could not predict what was going to ultimately happen with projections at 140,000 cases, that's where we were at a time when, remember, we didn't have the testing capacity of 80,000 individuals. So we have to always remember where we are. The guidance is still in place and it's still there. We have other things that we now can do, including testing at the capacity, as I mentioned. And so we can provide.
Thank you, Commissioner.
I know, why isn't it on the website?
Thank you, Assembly Member. Thank you. Your time is up. I recognize myself for 5 minutes. Mr. Commissioner, I want to go back to the beginning. Let's talk about the definition of nursing home deaths. I've been trying to, I've obviously read the report. I heard the conversation that you had with my colleague, Senator Skoufis. Other folks have asked you about it. I have to admit to you, it does not, I'm confused. And I'll just pose the question, and the rest will be for you to kind of convince me that this is the right way to do it. If I'm not mistaken, please correct me if I'm wrong. At the beginning of the pandemic, reports that were being put out included data related to people who were nursing home patients who then were admitted to hospitals and died there. Is that incorrect?
At the beginning of the pandemic, when somebody died, we assumed that what was going to happen was people who got sick ended up going to a hospital, and we were reporting the data from the hospital as someone unfortunately died. Ultimately, as we move forward.
Sir, just.
Yeah, sorry, yeah.
This is the question. This is the question, because I have a few very specific questions. This is the first one. Is it correct or incorrect that at the beginning of the pandemic, before I believe the 731, I'm trying to look for the exact report, but that there was at a point at the beginning of the pandemic, patients who were nursing home patients who were admitted to hospitals who died were counted towards the deaths of that nursing home. And then at one point you stopped doing that. Is that correct or incorrect?
The issue here is that someone comes in and the worry is that you will end up counting them twice. You'll count them as nursing home, you'll count them at a hospital. So you have to, this is the issue.
So I will ask you one more time. I'm sorry. I'm asking one more, please just answer this. This is the question. The question is it correct or incorrect that you at one time reported it one way and now are choosing to report it another? Because this is the crux to me. I
get it. Yeah.
Okay. I'm gonna give you 30 seconds. Go ahead.
No, I'm gonna say we reported in as someone who's died in the hospital. If someone came from the nursing home, they went to the hospital and they died in the hospital, we reported as they came from the hospital. We then started to ask and trying to get information about who died in the nursing homes, and we started reporting that and getting information from the nursing homes. And we do not want, as I mentioned before, we don't want to double count and say this person died here and also died there.
But it's as my colleague Senator Skoufis pointed out, no other state keeps the numbers like this. This is the concern that we have, sir. I understand that we were all hold on. Everybody's like, is that incorrect?
The issue here is there was a lot of confusion up front because this was an evolving process. This is what I was sort of trying to say in my presentation, that you have to go back to that point in time when we had information coming in and we assumed one thing, and then we found out that there was another problem there, or that the numbers were going up, or the numbers we were going to predict.
Right. This is the concern. This is the concern.
Yes.
I'm going to tell you what the concern is. I'm going to tell you what the concern is. There is, because I know that you went like this when I said there was no other state that's doing it like this. And then you kind of, went back and said, we have to look at that time. I get it. And none of us is trying to castigate y'all here for the very difficult work that had to be done. But it seems to me that patting ourselves on the back for victories is a little bit far-fetched, considering that we have still more deaths than anybody else in the country, both in nursing homes and in overall deaths. And the concern here, sir, is that it seems that definition, you have to admit that maybe you never will, but the definition, the fact that the definition was changed, that the report before a certain date included those numbers and then afterwards did not, it seems that what y'all are doing is just trying to minimize And nobody says that you went into these nursing homes and threw people off a flight of stairs. But we are saying that to be able to, moving forward, if we want to get clear information, we need to get clear information so that we can make better policy. And it seems to me that if the definition that you're insisting on keeping on the books is one that no other state utilizes and that it makes you look better than what y'all did when y'all actually did, that's a problem, bro.
Yeah, but you know what, Senator? There are 14 states in the United States that don't even report nursing homes, don't even report
I'm
their
not
data.
talking about those 14, but okay, but then what about the other 36 or what have you?
And some of them don't report for Zoom. We are transparent. All I'm saying, Senator, is that we have been incredibly transparent on information. But the one thing that we also is that we have been, Senator, and we have also the one thing you know me. I will not provide information unless I'm sure it's absolutely accurate and out there. And I've done that on so many other things that you and I have worked on.
The only thing, and I want to respect the time as I'm respecting it for everybody else. I will do it for myself as well, and I will cut myself off before saying it seems, sir, that in this case you are choosing to define it differently so that you can look better, and that is a problem. I'm sorry. My time is up. Assembly.
Thank you. Next, we have Ranking Member Brian Mankdalo, and you have 5 minutes.
All right, thank you, Chair. Commissioner, just a quick question for you. Do you remember meeting with us on March 2nd with the minorities for the Senate and the Assembly?
I do remember a meeting because this was when we were discussing the $40 million appropriation that was being put forth. Yes, I do remember.
Well, thank you. And that evening, I think it was around 7 o'clock or 7:30 that evening. And I know one of the things that you said was you really need to be very conscious of the 60, 70, and 80-year-old people as this pandemic moves into New York State. And do you remember that as well?
Well, I'm very concerned about the elderly people, so I'm sure that I mentioned, I do actually sort of remember that.
Sure.
I mentioned that, and I also mentioned those who are young, yes. And at that point, we didn't realize that young, we just assumed young people would get sick, and look what happens there. They haven't been infected except for that Kawasaki-like syndrome.
So knowing at that point in time that our seniors, especially if they have something pre-existing, would be compromised quite quickly. On February 25th, on one of your earlier graphs that you showed, you said that the first staff reported in a nursing home of COVID symptoms at that point.
The first staff, we had a staff that was reported with COVID on March, a nursing home staff on March 5th. And then on March 11th, in another nursing home, there was staff that were reported positive. And subsequent to that, obviously, but it was March 5th.
Let me rephrase. I apologize. Maybe I said it wrong. On February 25th, you said one of the nursing home staff members reported the first symptom-like COVID symptoms of a patient at that point.
Yes, but you know what? That was right. So you're asking me at that point, but I didn't know it at that point. This was when we did a retrospective analysis, looking back at this data. When we went back, this is how the March 5th and the March 11th, I know because that was prospectively at that moment in time. Then we went back looking to try to find out. This is when we were trying to figure out how 37,000 individuals in the nursing homes, the nursing home staff were positive. So we went back asking everyone, can you please tell us when the first person in your nursing home was staff person was positive? And that's where the February 25th, because February 25th, I want to mention a little bit about February 25th, because that's a very critical day, at least in this response. And so I want to be respectful of your time, but when you have a second, I would like to bring that up.
All right, well, yeah, okay, I got one other quick question then. So at that point, knowing how compromised our nursing homes could be, having to have that $40 million that we voted on to approve, why was there such a time lag getting the PPE equipment out to our nursing homes? It seems like at this point, if they're our most vulnerable people that we have in New York State, why would they have not been the priority at that point?
We did, so let's talk a little bit about PPE and supplies, because we did provide to the counties who then provide both to the hospitals and nursing homes PPE. We did not have enough PPE. The governor was he was asking everyone to try to figure out how we can get more PPE. We were looking across the country. We were looking across the world for that matter. The irony here a little bit is that the virus originated in China right from the beginning. That's where it started, right? Went to Europe, came to the US, and the actual answer that the protection from the virus, the PPE, was being manufactured in China as well, and we were trying to get it from there. It's a little bit of an ironic situation there on that, but and we did get it out. And if they didn't, we did not have, then we were quick to try to do whatever we could to help them out.
All right, because that was the number one complaint, one of the number one complaints from our nursing homes and our senior living places, that they could not get PPE equipment to their staff members fast enough. And it just seems like with all the information that we had, the data, the scientific proof of what was coming, it just seems like they would have been a priority and we would have got that equipment out to them sooner. I think that's one of the downfalls of what had happened. And I hope we move forward and look at something to make sure that doesn't happen again, especially moving forward. I only have like 30 seconds left, so I'll go ahead.
Now, I just want to talk about that last week of February for a second, because I think it's an important week of what we did and what was happening on a national level. Because on February 25th, and I recognize the time, give me an extra 15 seconds. On February 25th, I was in Washington. I was with all my other state health commissioners from around the nation, annual meeting. We were invited to the White House to sit down with all of them and to listen to HHS and to listen to the leadership there and the leadership at the White House to tell us about this coronavirus. And what they said was that we are going to leave this to the states. New York was already leading. The Governor Cuomo, was already taking steps to address this issue. As I had mentioned, that we had a $40 million appropriation put forth, which I thank the legislature
I gave you 20. I gave you 20.
Let me just finish. I'll even stay 1 minute longer on this, okay? Thank you. Thanks. All right. I promise you. And what happened was I told the White House after they said we leave it to the states, I said to them that this needs to be a federal response. And New York will lead, but that this needs to be a federal response. That same week.
Thank you, Commissioner.
All right, that same week, Wadsworth Lab came out with our lab, and then we had our two cases.
We have to move on. Senator, Ranking Member for Investigations, Senator O'Mara. Recognized for 5 minutes.
Yes, thank you, Chairman. Thank you, Commissioner and Mr. Rhodes, for being with us today. Were you cognizant of the fact the numbers of nursing home deaths that occurred in hospitals would be an important topic of interest for us today?
Yes, I was. Yes, I was.
Yet you come with no information to give us any idea of how many of those deaths there were.
Because as I said earlier, that I will not provide information that I have not am sure it's absolutely accurate. This is too big an issue and it's too serious an issue with deaths and numbers to be able to provide. I will get you that number as I promised you that I would.
Commissioner, when were you aware that this hearing was going to happen today?
A couple of weeks ago, I heard about this, but I have to tell you that within that period of time, these last couple of weeks.
Commissioner, this is my time. And were you further aware that the CDC guidelines with regards to admissions in the nursing homes would have been an important topic for us to be talking about today, yet you didn't got the CDC guideline with you today?
You broke up, Senator, on that, so I didn't hear you.
Did you not understand that the CDC guidelines relative to nursing home admissions would be an important topic of interest to us today, yet you did not bring that CDC language with you?
We have it there. Yes, we have it.
Well, earlier you said you didn't have it and you couldn't answer a question about what specifically was in there regarding requiring nursing homes to take COVID positive patients.
Yeah. We'll get it.
You can see this in multiple pieces of guidance. Which one?
I don't know which one you want.
This particular.
Well, I forget what the specific question was from a member before, but I thought it odd that you said you didn't have that language then.
Yeah. No, I didn't have our March 25th memo with me. That's what I was saying. I didn't have the memo with me.
Yeah.
Okay. Are either of you familiar with a March 26th statement by the Society for Long-Term Care Medicine and the AMDA in response to
No,
the
I'm not.
order.
I'm not.
Neither of you have seen the March 26th statement from AMDA, the Society for Post-Acute and Long-Term Care Medicine.
I have not, no.
It was stated to us earlier in some meetings we were having, a representative from the AMDA, the Society for Post-Acute and Long-Term Care Medicine, which represents healthcare providers in the nursing home industry across the country, that this March 26th statement was sent directly to both the governor and you, Commissioner Zucker, on March 26th. And that statement said that the AMDA finds that the New York State advisory to be overreaching, not consistent with science, unenforceable, and beyond all, not in the least consistent with patient safety principles. Now, this statement has been reported in the media extensively. Neither of you have seen or read this statement.
There's a lot of things that have come across my desk, as you can imagine, and I'm happy to go back and look at that and see what memos or letters that came through on this. We'll find this.
The Society for Long-Term Care further went on in their response to your directive. Rather than bullying nursing facilities and medical providers to make unsafe decisions, the state of New York would be wise to direct its energies at ensuring adequate personal protective equipment is available to all healthcare providers, ramping up capabilities, shortening test turnarounds, developing a long-neglected healthcare workforce, and identifying and standing up alternative care sites. What alternative care sites for nursing homes were set up outside of the New York City metropolitan region?
So a couple things. Number one, we have a 60-day supply for PPE. I take issue with the statement that we were not providing excellent care to the individuals in the nursing homes. We always are looking out for the best interests of those individuals. The residents in those nursing homes, if there was a concern, the nursing home administration was happy to reach out to us. They say that they felt that they could not do that. That's not a true fact. I have spoken with many of the nursing home administrators and owners about their issues, and they're always, I'm always receptive to that. So that's issue. Your last point that you were asking is like, what are we doing moving forward on this? Is that what your concern is?
No, what did you do since March 25th to set up alternative
Oh, yes. So outside of New York City,
rather than sending them back into the nursing home?
So a couple things. Let's go through this. First of all, there are other facilities that are out there that we have set up. But I think there's a point here that this goes back to the science, that people keep believing that, I know time's up, I'll be very fast on this. People keep believing that the individuals going to the nursing home with coronavirus, that doesn't fit the science when you recognize, you talk about CDC, after 9 days, 0 infectivity in the median infectivity. I can go through this, but I'm respectful of the time. I can go through why the science doesn't add up to what people are saying. Sorry.
Gotcha. Thank you. Assembly.
Yes, the next person to ask questions, Assemblymember Tom Abenati. Tom? All right.
If he's not there, I'll take it.
Okay.
Oh, I'm here.
Okay, Tom, you have 3 minutes.
While to get the mechanics to work. First of all, thank you, Commissioner, for joining us this morning. I'd like to first go to the issue of families visiting at nursing homes. Do you have any evidence of any family transmission at nursing homes?
This goes back to the issue of visitation in general, and I believe, based on what we found.
No, I'm not asking you visitation in general. I'm asking you've said the problem of transmission of COVID with nursing homes was staff. If it's not visitors, why are you keeping visitors out and allowing staff to continue to go?
No, what I said is that the data we have shows the 37,000 positive staff, but that because we didn't test visits, but the presumption is, and I would tell you, the presumption is that the visitors also brought it in. I don't want to, like I said, I don't want to blame anyone,
Why is
but
there
the reality,
if you're going on the basis?
because the
What's the
nursing home
basis for
staff,
presumption?
because the nursing home staff are someone that we can go ask and that we want to get tested. And it's, a little bit different to walk up to someone and just say, you came to visit your relative.
Commissioner, it seems to me, I'm directing the question about family, not about staff. Families are complaining that they are not able to supervise on a day-to-day basis, so there are no outside eyes to see what's going on, that their family members are deteriorating very significantly, that they cannot use technology because they're much older people.
I agree. I understand.
The same thing is being face-to-face. So what is the basis for excluding family completely? If you don't know, why can't you set up a protocol for every nursing home where the family members are tested? It seems to me, as somebody previously said, that the staff work in various places, they go home to their own families, they take public transit, while it's the families that are going to be the most careful because they don't want to infect their family members who are in the nursing home. What can we do to allow families in nursing homes today?
I am extremely, like I said before, empathetic to those who have relatives that they don't see and they need to see them. I get that. I really recognize that. The reason I say also visitors is because everyone lives in the community. The people who work in the nursing homes live in the community. People who visit live in the community because the person who is in that area is also in the community. We do know from our testing of antibodies that we do know that that some of the visitors in that community were positive. We do know from the zip codes with a 50% positive and some zip codes 25%.
Why can't you set up? Let me just finish my question. Why can't you set up a protocol where you actually test the visitors? Most of the visitors, from what I can understand, are staying home, socially distanced, unlike the nursing home staff working several jobs. I would like to see you set up a process as soon as possible to test the visitors, to give them the questionnaire, check their temperature before they come in.
Thank you so much.
I got one thing. 117, yes, 117 nursing homes already have visitation programs that we have put into place. We have 209 that have policies that are put forth. We want to move forward. I really do want to move this forward. I want to help, but I also do not want it to spread. The reason that goes back to the visitors issues, they live in the community, they work in the community, right? And I just don't want this to spread. I recognize it. I am really, really empathetic about it, but I am trying to tell you, I'm trying to balance two things. We will set up, we are working on this. All right.
Thank you, Commissioner. Senator Salazar recognized for 3 minutes.
Thank you. I'm unable to, there we go, to start my video. So I actually want to follow up about the impact of the blanket legal immunity that was granted not only to nursing homes, but also to healthcare facilities like hospitals. Nearly 70% of the nation's COVID-19 deaths came from states such as New York and New Jersey that handed out early blanket legal immunity. And while the legislature has since narrowed the scope of that immunity, there remains a period of time longer than 3 months for which the previous blanket immunity still applies. Senator Biaggi referenced the egregious racial disparity in maternal morbidity in New York. During what I'll call the blanket immunity period, from April through part of July, a Black woman named Shasia Washington died at Woodhull Hospital in my district. And just because that case received national attention, Commissioner, are you familiar with Shasia Washington's case?
I'm not familiar with it specifically, although I've read a lot about different cases, so it is possible that I am, and I don't recognize the name. I've read all about these different cases out there.
Certainly. So just briefly, Shasia wasn't treated for COVID, but she was treated at, because of where she was treated and because she died on July 2nd, the medical providers involved in her death, her anesthesiologist, for example, who administered the epidural before she died in childbirth with an otherwise completely healthy pregnancy. Her care team still has blanket legal immunity. It is, in your opinion, is it acceptable that her care team has blanket legal immunity in this case, and that her family, for example, doesn't have any recourse? because of
So I-
the previous.
Right. So I'm here wearing my doctor hat, public health hat. I'm not wearing my lawyer hat today, and I would not but I will comment a little bit as a lawyer. I will not comment on a case that I don't even know all the facts to. So I recognize, I feel for individuals, but I want to go back to what you're mentioning about this immunity. Two things. One is this was not a Greater New York Hospital Association proposal or whatever. So that I think is an inaccurate statement. But the second point is that no one, not the department or anyone, will allow any kind of egregious behavior to happen, whether it's in a hospital, nursing home, or anywhere. That is the premise long before coronavirus. It will be long after coronavirus is gone. And the bottom line is that the objective here was to make sure that those who are working, they would be able to provide the care while we were in the upsurge of an absolutely unbelievable pandemic, which is, as I say, still going on. I am still worried every day. I am working every day on this issue. And the reality is that I don't want it coming back to New York. And many of the questions that have been raised my answers are to make sure this doesn't come back to New York, or it doesn't uptick in New York.
Sure. I realize that I just ran out of time. I have one more question, if I may ask it.
10 seconds, really quickly, please.
Thank you. So we know that higher staff-to-patient ratios in nursing homes are directly related to quality of care. 37 states have a higher average hours of direct care than New York does. New York is one of only 12 states that has no minimum standard for hours of care per staff in nursing homes specifically. Do you think it's acceptable that New York, by that metric, has among the lowest standards of care in nursing homes?
Well, number one, I will get back to you about the details, because I want you provided me one piece of information, asked me to respond to it, and I actually like to have all the facts and the data before I answer a question like that.
Thank you.
All right. Thank you, Senator. Assembly.
Yes, next questioner we have is Assembly Member Billy Jones. Assembly Member, you have 3 minutes.
Yes. Okay. Thank you. Thank you, Mr. Commissioner, for being here. I'm going to go back to the visitations to our nursing homes. Can you tell me the percentage of nursing homes that meet the threshold for the July 10th criteria that from the guidelines that you put down? What is the percentage of nursing homes that are able to meet that threshold right now?
I have to get back to you. 117 have put that we have opened up some form of visitation to. 209. I probably have it in my papers. Keep asking your questions, and I'll take a look. All right.
Okay. Well, the percentage that we had originally a couple of weeks ago was 12%. 12% of our nursing homes could meet that criteria. That's not a very high number or a high percentage of nursing homes that can meet this. My issue with this is that, obviously, like many of my colleagues here on this hearing, we're hearing from the family members over and over and over again that they cannot get visitation to these facilities. They can't get that human interaction. It's been mentioned by several of my colleagues. People are literally dying of depression, lonesome. Their families are feeling, they're suffering through this. I hear heartbreaking stories every single day. We need to get a policy in place and some guidelines in place, obviously in a safe manner, to let these family members interact with their loved ones. We have mentioned other things through technology and what have you, and it's been mentioned by my colleagues, and I think you would agree. A lot of our elderly residents are not that great with the technology, so we have our hiccups there as well. We need to do this. I have another question. Who provides the guidance? Do you provide the guidance for docs for their visitation, which will be going into effect this week?
Two things. One is my report says what I have here is 34%, so that's higher than what you have. We are going to look at the issues of technology, and we have been, and that's where that $1 million for the program to develop technology to help those in nursing homes connect with relatives. We'll move forward. I'm a big fan of technology, and I will figure out a way to adapt whatever is necessary to help those in the nursing homes. And with regards to docs, I have to check the answer on that.
Do you provide, does DOH provide the guidance to docs?
Well, I have to check whether we provide assistance to docs, and we've been working with them. We've done testing in the correction facilities as well, and the guidance, a lot of guidance has come out by the Department of Health that goes around to other agencies as well. But then those also issue their own guidances. But
Okay, I guess my
my
point here is, you know, long before COVID hit and going through this, for many of our family members that have loved ones in nursing homes, they feel like the forgotten ones, and they feel like the death toll that's happened in these nursing homes and the carnage really that's happened, they're being punished now through these visitation processes or policies that they can't see their loved ones. At the same time, where we could put out guidance for docs to do this, we should be able to do this for our loved ones in our nursing homes and for their family.
Thank you, Assembly Member. Moving on to the Senate Ranking Member in Health, Senator Gallivan, recognized for 5 minutes.
Thank you, Chairman. Commissioner, on June 25th, there was a New York Post article where you were quoted in responding to a letter that 22 members of the majority had sent to you regarding a number of their recommendations regarding nursing homes. When did you first become aware of the letter that was sent to you?
I'd have to go back on that. I really would. There's so many letters that come in. So June 25th, even though it's only 2 months ago or whatever it is, 6 weeks ago, it feels like a century ago to me. So I'd have to find out when it was.
Would it be fair to say that you likely received it near that time, and your comments came about as a result of the receipt of it?
Well, it depends on, I mean, if it was sent by email, you know, it comes through and then it gets processed. And if it was sent by regular mail, there's another whole process to it. But I'd have to go back. I don't want to comment because I don't want to tell you something that, yes, I got it the next day or so. I just don't remember.
Understood. Well, back on March 20th, the governor announced Matilda's Law, and that in particular established rules for vulnerable populations, such as seniors. And I think at the time, that law classified seniors as the population over 70 years old. And of course, it shows a recognition of the severe impact the virus could have on a population like that. But it doesn't seem at all that Matilda's Law applied to nursing homes, all of whom fit the definition of that vulnerable population. Can you explain how Matilda's Law came to be and why it did not include provisions regarding nursing homes?
I can't speak. I can tell you it came to be because Matilda's Law is named after the governor's mom, and he has recognized what many of us recognize, some of the challenges for those who are older, and to make sure that their needs are met. I'd have to go back and go through the details of Matilda's Law, but I could tell you that the governor's commitment to the nursing homes like my own and the rest of the department of all of us is paramount.
So Matilda's Law did not deal with nursing homes.
Matilda's Law, I will go back and listen, but it required that there be, you know, masks available for to be sure that if you're with somebody that you are wearing those masks to make sure that if there's any face-to-face interaction to make sure that you're not exposing someone to this virus. And there are other components of it as well. Do you have it?
So in early March, the focus from the executive branch was on the hospital system and hospital system being prepared, including providing for necessary PPE and staff. But it didn't appear that the same measures were being taken at the same time for nursing homes and assisted living facilities. Why not?
I should jump in here. Well, I'll read from the Department of Health March 13th health advisory: COVID-19 cases in nursing homes, suspended all visitors, health and temperature checks required for everyone who enters the building, face masks required for working with residents, the cohorting of residents with COVID-19 with dedicated healthcare professionals and other direct care providers. This is March 13th. The morning of March 13th, New York State had not reported a single death yet. At the time, there was just several hundred cases when the Department of Health put out this guidance. So to suggest that there wasn't activity and action being happened is not true.
After the issuance of the March 25th guidance regarding nursing homes were directed to contact the Department of Health in the event they could not provide adequate care for a patient. And they were told that the Department of Health would be helpful. If I understood you correctly, you said that, Commissioner, that nobody contacted you. But on April 9th, the Cobble Hill Health Center in Brooklyn, a nursing home there, reported that they had asked state officials if COVID-19 patients could be transferred elsewhere, and they were denied. How come?
People, if someone needs to be transferred to another facility, we would make that happen. The reality is that the issues, if someone called us and said, I would like someone to move to another place where they needed PPE, or they needed other assistance, or they needed staff, we were there to provide that to them. So, everyone keeps saying that they wanted to move someone, but sometimes people think about it, but they didn't reach out to do it. Whether they thought that they could not reach out is just a fallacy. We were available for anything that needed to come forward.
I would just say, if I could follow up on that, not with a question, but just to that point, that it was reported in the New York Post.
Senator Gallivan, I'm sorry, your time is up. Your time is up.
Oh,
I'm
okay,
sorry.
Chairman, thank you.
Assembly.
Just the thing, the Cobble Hill issue was about staffing, if that's what you're.
All right, moving on.
And it was addressed.
Let's move on to Assembly Member, Ranking Member Jake Ashby. My apologies, I took you out of order, but you're up now and you have 5 minutes.
Thank you, Mr. Chairman. Thank you, Commissioner. Considering the massive undertaking of contact tracing and all of the efforts that have been put into this, it seems kind of strange to me that we are going about this in really a great way for everybody across the state. Shouldn't that extend to our nursing home residents that went to the hospital? I mean, if we're able to track people all over the state and make sure that, they haven't come in contact with this person, or if they went to this party and they tested positive and we have a positive location on them, how is it that we don't have a real-time number in nursing home deaths for people who were discharged from a nursing home and went to a hospital?
Well, there's two parts to this, right? One is about the contact tracing. What's the objective here? The objective is to prevent the spread of this disease into the community, right?
Commissioner, with all due respect, I understand the intent of it, but the basic principles of it is tracing people, right? You're following people, and the same principle can be applied to nursing home residents that were discharged from their facility and then admitted to a hospital. And I understand that it may be difficult to track that down, whether it wasn't through the admissions department through a hospital, but even going through, as you mentioned, the 613 nursing homes that we have around the state, they would have a record of whether or not that person were discharged from their facility or not, right?
Right, and what I'm saying is that information, I want to be sure that we are not double counting individuals, that someone didn't die for a different reason, so that's what we're trying to do. If someone goes into the hospital from a nursing home and then they die, and they're sick in the hospital, and someone says, well, they died because of COVID. Well, maybe they died because of something else. I mean, this is something which I mentioned earlier about pneumonia, right? The presumption by CDC was that they died, the 27% of people dying in those 2 months was because of pneumonia. And as the director of the CDC said, presumed to be coronavirus, right? But what I want to know is exactly when someone dies in the hospital, what did they die from? Were they counted there? I understand.
Commissioner.
I
understand the reluctance to say whether or not they died from COVID or not. Do we have a number or a figure as to how many people were discharged from nursing homes and sent to a hospital?
And that's the information that has to come, nursing homes report information. I want to see what that is.
We don't even have that.
Essentially, when we put out data, we put out more data than any other state. We're one of 9 states that reports presumed and confirmed deaths. Multiple states do not report anything to do with nursing homes. There's 3 parts to this. It's collecting the data, validating the data and reporting the data. We do not release data that we're not 100% sure is accurate. We've had reports of deaths come in from nursing homes that say someone died of COVID in December. Now, maybe COVID was spreading wildly in December that we didn't know about. There's a lot we don't know about.
With all due respect, that wasn't my question. My question was, do we have a figure of how many were discharged from a nursing home and sent to the hospital, regardless of diagnosis, but during that time? If we were tracking that, or they were suspected or being treated for COVID, because we're looking at that right now as well.
We collect a lot of different data, but the key is to be able to make sure that it is accurate. And we would not give ballparks, we would not give ranges, we're not going to give estimates, we're going to give the actual data. We'll continue to collect it. We'll continue to go back to the nursing homes, call them and validate this data, and release it on a rolling basis.
Okay. And all right. My second question is, if the March 25th guidance is still standing, why is it not up on the Department of Health's website anymore?
So I will check to see what's where. It's an active guidance. There's a lot of guidances that are out there.
I printed it out this morning, so it was up on there.
I mean, I don't understand if we're making the clarification that this is still standing guidance from the Department of Health, and I'm not sure why it was removed in the first place. If it was still standing, why is it not back up?
Well, there's an updated guidance that is online. If Gareth said he just printed out this morning, then it must be there.
All right. Regarding the transference of nursing home patients, on May 12th, the media reported a resident of the Grand Rehabilitation Nursing Center in New York, which is in my district, had been transferred to a facility in South Point without notifying the family. Were nursing homes permitted to move residents without notifying families? And is the Department of Health notified of residents who were moved?
No, but this is an ongoing pandemic, as I've said, and people need to notify their relatives. And if something happened where a relative was not notified, then we will look into that specific case or any other case of that nature. A relative should be contacted, and I'll find out what.
And I understand that.
As a member, I'm sorry, your time is done.
Thank you.
We're moving on to the Senate, recognizing Senator Helming for 3 minutes.
Thank you, Senator Rivera. Commissioner, thank you for your testimony today. For about the past 2+ hours now, I've listened, Commissioner, as you responded to various questions. I've heard statements that you've made, such as, let's get through this pandemic, and we will make decisions as the information becomes available. I have to say, as someone who's worked my way through college as a direct care provider at a nursing home, and later in life, I served as a director of a senior living facility, that I find these responses extremely troubling. The issues surrounding the quality of care in our nursing homes are not only complex, as we all know, but they are longstanding. They've been around for a number of years. It is unacceptable, it's frustrating, and it's heartbreaking for many New Yorkers, including my family, who lost a loved one living in a nursing home during this pandemic. It's just so unbelievable that the great state of New York was not better prepared to protect our citizens. We've all heard of all the issues, like I said, that have been around forever, issues like infection control lapses. I've heard stories about the lack of PPE, nursing home care providers wearing garbage bags or used gowns, the lack of testing protocols and test services, inadequate and underpaid staffing, lack of collaboration, no exchange between the state and our nursing home representatives, and the lack of communication that I also experienced between nursing homes and residents and their residents' families. Again, these are issues that have been around forever, and the pandemic is shining a light on how significant and how prevalent these shortcomings really and truly are. So, Commissioner, you mentioned that there were 1,300 nursing home inspections that were done. And yet, in spite of that, in spite of all these things you're talking about that are being done, we lost somewhere between 6,500 and 12,000 nursing home residents. And it just it leads me to ask you, without pointing the finger at the federal government, what resources does the DOH, what resources do you need to do a better job of protecting our senior citizens? More financial resources, more staffing. And the other question I want to ask, are the inspection reports that have been done, are those available to the public? FOIL requests that have been submitted, we have gotten generic responses to, so I'd like to know if those reports are available.
So I think I hear what you're saying. However, I will tell you this state and the Department of Health has been incredibly aggressive on this issue. We have provided, and I need to reiterate this, we have provided 14 million pieces of PPE. We offered 96,000 volunteers.
Dr. Zucker, I'm sorry, I have to interrupt, but I had numerous calls to your office about the lack of PPE in our rural upstate New York areas. And the fact that you said earlier that PPE was given to the counties to distribute, I can tell you, I have the timelines, the dates and everything, that did not happen in a timely fashion. And in some cases, it didn't happen until it was much too late.
What I'm telling you is that when information came to us and we need to provide, we provided it out to the community. This is an ongoing pandemic. Obviously, I bring you back to the PPE issue because at the beginning of this pandemic, when this was already in the community and in the nursing homes and in our lives, to say the least, the fact was that we were looking for more PPE and we got it out to the community. Senator Rivera is signaling me.
And I'll just say really quickly, in Seneca County, we had no test kits.
Your time is up. We got to squeeze in a couple more. Assembly.
Yes, the next questioner will be Assembly Member Linda Rosenthal, and you have 3 minutes.
Okay, thank you. Thank you, Commissioner. I have a facility in my district that is, okay, sorry. I have a facility in my district that is an assisted living center as well as a rent stabilized building. So when we called up DOH to find out if there were any rules and regulations governing the assisted living, which has a very elderly population, we were told that's not our purview. Whose purview is that? And you could just answer, we don't have one, or it's someone else's.
I will get you the details of where this falls within the agencies out there on this.
Okay, because that was very troubling. I have another rehab and nursing facility where there were at least 44 confirmed and 17 suspected deaths. At a certain point, they lost key workers, for example, social workers. So they consolidated all of the COVID patients on one floor. A constituent I've worked with for years was never told. He didn't know where his mother was. And I wonder, did the DOH reach out to any of these nursing homes to tell them what the protocol was if they were lacking staff?
Constantly, we constantly reached out to the nursing homes, and as we talk about these guidances, there are guidance documents that have gone out, 124 different guidance documents that came out of the department.
Can you give me an example? How often was each one called?
On a regular basis, they were called. I can't tell you exactly, but I do know that I personally have called one nursing home probably a couple weeks ago, 5 or 6 times during that week, and been in contact with them constantly when there was a concern. And that's just one, and I could tell you others. And while managing this pandemic, when I hear something that was of concern, not only did my team address it, but I also picked up the phone and called them. So to say that we are not aggressive on this is just not true.
I just asked who called, how often did they call? And you told me he called. Okay. My next question.
But I will tell you others did as well. If there's a specific one, I'll make sure we'll find out.
Okay. And when I called around to facilities in my district, they said they had no idea how to get PPE. And as a result, many did not have PPE for the longest time. When did DOH contact them to tell them that there was PPE available? And did you ship it to them? How did you deal with supplying homes that did not have access to PPE with PPE? What did you tell them to do in the absence of their having PPE?
So we worked with, first, I want to add one more thing about this, because you keep saying whether the department reached out to the nursing homes. The nursing homes are also part of an association, and we worked with the leadership within the association, and they also came to us and said, this is what we need. So if there was something needed, I can get you the details of a specific group of those PPE, then I will let you know exactly what was done for that group. We also told people about cohorting. We talked about social distance. Sorry, thank you.
Thank you, Commissioner, because I know your time is limited. We're moving on to the Senate. Thank you, Assemblymember. Senator Thomas, recognized for 3 minutes.
Hi, Commissioner. How are you?
I'm all right.
Good.
How are you?
Glad that you can hear me. All right. So my question, I have a number of questions. I'm going to start with Article 81 guardianship. Hopefully you're familiar with that. So COVID-19 has had a significant impact on Article 81 guardianship cases. As you probably know, if I'm going to refresh some of your memory here, guardianship is a legal arrangement where a court gives a person the legal right to make decisions for an incapacitated person. So for the duration of COVID-19, Article 81 cases have been unable to move forward because court evaluators and attorneys have been unable to meet with their clients in nursing homes. You know, in June, nursing homes were allowed family members to visit. This is a yes or no answer. Are non-relative visitors currently allowed in nursing homes?
Among the nursing homes where I mentioned there was visitation, they are allowed in there. Visitors are allowed. Regarding the specific article that you're referring to, I'd have to find out how they can have them go in. But there are opportunities for them to reach out to them through telehealth. So I'm not sure why they haven't been able to be contacted with those to address some of their concerns.
I mean, given your responses, I'm pretty sure you're not familiar with how this works. So, you know, are there any steps how the Department of Health is taking to carve out some sort of like rule for court evaluators and attorneys so that incapacitated persons in the care of nursing homes can complete the guardianship process? Is there any?
So, I mean, but I don't know if there's specific rules, and it may be in a different part of one of the other agencies about this. If it's within my department, I'll find out from the lawyers. I will tell you that there is the opportunity, as I said before, to do FaceTime with the nursing homes, but you're saying that that's not possible. I'm not sure why you're saying that.
It's not about it not being possible. It takes a little bit more than a Zoom conference to get things like this done. But I'll go away from the Article 81. Let's talk about nursing homes and what they went through to.
Doesn't this fall within the Office of the Court Administration? I think this may be a legal thing, right?
Yes, it is a legal thing. It is a legal
right.
thing.
So it may fall in the Office of the Court, the OCA, the Office of the Court Administration.
Okay, so during the whole COVID-19 crisis, we're still going through it with nursing homes. You talked about how, you know, masks and other equipment were sent to nursing homes. Now, were there any ventilators that were sent to nursing homes?
Well, if someone is ill, this goes back to a very important point, and I see the time is clear, is that when someone is ill in a nursing home, they're going to be transferred to a hospital where they're going to provide the care. You need to provide the care, tailor the care to where it's needed. And I think this is a really important point, because many of those who are in nursing homes who are frail, they will sit there for a couple of days, because often when someone realizes someone's sick, they may not realize that they have coronavirus. Ultimately, they get transferred to the hospital because they're critically ill or ill.
Has the Department of Health or the governor's office ever sent ventilators down to nursing homes?
They don't go to nursing home. If you're that sick, you need to go to a hospital.
Okay.
Nobody's going to be able to manage someone that's sick in a nursing home. And I would not ever want someone to be cared for that ill where they need to be on a ventilator in an ICU in a nursing home. That it just wouldn't be the appropriate medical care.
Thank you, Senator. Thank you, Senator. Your time is up. Thank you, Senator. Assembly?
Yes, we recognize Assembly Member Aileen Gunther. You have 3 minutes.
And one announcement I would like to make. This is the last speaker. The commissioner has to leave after the speaker. A lot of people will be angry. That is the reality as we are right now. So, Ms. Gunther, you're recognized for 3 minutes.
Gunther?
7-member? Going once? Going twice?
I'll speak again.
7-member Bronson, if you have somebody else available immediately to ask for 3 minutes, if not, we have to stop.
Yes, let's go to the next Assembly member, Ed Bronstein. You have 3 minutes.
All right. Thank you. You're recognized for 3 minutes.
Hold on one second. Okay, I just snuck in. I didn't think I was going to get a question. I think starting right at the beginning of the hearing, Senator Smith has brought up what I think a lot of people have concerns about is the definition of nursing home deaths. And I think part of with the conclusion of the report is that we're using a definition of nursing home deaths that other states aren't using. So I guess I have 2 questions. One is, in the future, we do anticipate having the data of how many people came from a nursing home and died in a hospital. Do we anticipate amending the report to reflect that new data? And if in the commissioner's estimation, will that new data change the conclusions of the report, or do we believe that the conclusions of the report will remain the same if we were to enter that new data?
I think the conclusion of the report will remain the same on that.
Do we anticipate getting that data and amending the report to reflect that data?
The data, like I said, that I know that you, at the beginning, I said that I know you want a number, and I wish I could give it to you at this point, but I will get you a number, yes. But I want to be sure that that data, that we've looked at everything and made sure that they weren't double counted.
I think a lot of us maybe want to reserve judgment about the conclusions of the report until we have an accurate view of all the data. And we're missing a significant amount of people who contracted COVID in a nursing home and then later died in a hospital. And I just think it would bolster the conclusions of the report if at some point in the future, when you do have that data, maybe you can, add it into the report just to, make sure that this report is accurate.
I am confident about the data. I hear what you're saying. I will also say that in that report, you'll see that there is a curve that shows the deaths in the nursing homes and deaths in the community, and they line up. And I suspect that, I know that this will be the same.
Yeah, I would just add, when we're updating this report down the road, we should include what the experience of other states has been since this report came out. I quote the Mary Mayhew, the Florida Agency for Healthcare Administration. We've done a lot to guard the door to keep that virus from getting to our facilities. Our staff are human beings who have lives outside of these facilities. Nursing home operator in Florida, the overwhelming majority of our staff members were testing positive or asymptomatic. Indigenous virus is very difficult to detect absent the testing. So it's happening in other states. I think if you're looking at
I believe with that new data, the conclusions of the report may in fact be the same. It's just until we get that data, I think we have to reserve judgment. So thank you for your time, Commissioner.
May I add that, in one of the slides I showed at the beginning about Florida, California, and Texas, this situation about nursing homes is across the country. You go back to some issues about different memos, but the reality is other states may not have issued that memos, but they are seeing the exact same thing that we saw in March about this. And I think it's important to make a note of that.
All right. Thank you, Mr. Commissioner. That concludes the first panel of this hearing. We will now be taking, as was stated earlier by my co-chair, Dick Godfrey, we'll be taking a 10-minute break for water and toiletries, and then we will be back. Thank you, Mr. Commissioner. We'll be back in 10 minutes. Welcome back, everyone. Thank you for that break. Everything should be, we're going to go through this. Oh, see, that's the exact 10-minute timer, right? Going off right there. Next panel, panel number 2, will be Neil Heyman, President of the Southern New York Association, and Michael Balboni, Executive Director, Greater New York Healthcare Facilities Association. If witnesses are both present, I believe that they are.
And do you each swear or affirm that the testimony you're about to give is true?
I do.
All right, may begin, I guess, Mr. Balboni, or is Mr. Heyman? Is Mr. Heyman here? All right, Mr. Balboni, you may continue, you may.
He is here. He is trying to unmute.
Oh, he is trying to unmute. All right.
While he's doing that, Mr. Balboni, do you swear or affirm that the testimony you're about to give is true?
Successfully unmute?
I do, Mr. Chairman.
Okay.
Did I successfully unmute, sir?
You did.
Okay.
And do you swear or affirm that the testimony you're about to give is true?
I affirm.
Okay.
Okay.
Fire away.
Thank you very much. I appreciate the opportunity to give testimony today. My name is Neil Heyman. I am the CEO of the Southern New York Association, whose members include 60 residential healthcare facilities in New York City, Long Island, and Westchester. I know this has been said before, but I'd like to emphasize at the outset that we are in the middle of fighting a pandemic. We are all on the same side. Our foe is the virus. We are facing a situation unprecedented in living memory, and the crisis is continuing. Everyone involved faced a steep learning curve as we all figured out the hard way what worked and what didn't. Our task now, as I see it, particularly my role, is not to cast blame or point fingers, but to continue moving forward using the information we've learned and then meeting and resolving the challenges as they arise. As we all know, and it's been said before, residential healthcare facilities were uniquely vulnerable, not just in New York, as has been said, in the country, but the entire world. These folks are elderly, medically fragile people. In these congregate facilities, they live, eat, and socialize in close communal settings. Staff provide such close hands-on care, which includes intimate activities such as dressing, bathing, transferring, and even toileting. Nevertheless, our home's dedicated staff have worked and continue to work round the clock to provide the residents with the care they need. Now, working closely with the governor, the state health department, local health and emergency management authorities, New York's residential healthcare facilities helped begin to show that the virus can be contained. Now our facilities' resiliency and ability to react to the fast-moving crisis can help the state prepare to respond for the continuing pandemic and the looming risk of new wave of cases from other states and regions. Now, some of the key takeaways that we have learned thus far, which will help us going forward, are as follows. Facilities must be able to assure that their staff, residents, and any visitors have access to reliable, high-quality PPE, even as New York is increasingly in competition with other states. Right now, actually, facilities are having some difficulty finding some N95 masks. Regular testing of residents and staff is valuable if the test results are available within a reasonably prompt timeframe. Proper infection control procedures can successfully contain the virus. Adapting and enhancing infection control protocols for influenza help the nursing facilities to control the spread of COVID-19. COVID-only units within facilities, as well as dedicated COVID-only facilities, can and should be used and put together immediately as the caseloads require them. It is critical that facilities have resources available to them that will make it possible to locate, recruit, and retain adequate qualified staff. This is particularly important if there is a surge in the COVID-19 cases. There are many facilities that have empty units, and those units can be activated immediately if there's enough staff to take care of the residents in those units. Residential healthcare facilities must be integrated into the state's overall healthcare response so that their space, equipment, and staff can take part in a coordinated solution. Sufficient funding is needed for residential healthcare facilities to both continue to operate and meet the high costs of the necessary pandemic response. Over the years, Medicaid reimbursement rates have been cut by millions of dollars, reaching significantly below the cost of providing care. This year, even before the pandemic, New York made further across-the-board cuts to nursing homes. The nursing homes have coped with these reimbursement cuts and with the to-date unreimbursed costs of mass COVID testing, PPE, and increased staffing levels needed to cover staff that's out sick or in quarantine. However, without federal or state financial assistance, facilities will not be able to sustain the effort to combat the virus. If you combine a low census and increased costs, it could spell disaster. Focused statistical data is invaluable in developing an effective healthcare response, but time compiling data is time away from residents. So the state should identify and communicate the key data sets and reporting intervals it needs in advance as much as possible. With the experience that they have gained and the procedures and protocols they have put in place, nursing facilities are prepared to care safely for new residents admitted from the hospitals and the community up to their pre-pandemic census levels, both for COVID as well as non-COVID patients. Residential healthcare facilities have the experience, dedication, resiliency, and adaptability to play an important role in New York's ongoing pandemic response. We look forward to building an effective collaboration with the state and other healthcare participants. Thank you very much.
Perfect timing, Mr. Heyman. Senator former Balboni.
Good, and thank you very much, the chairman of this very important hearing. Thanks for doing this. I can only imagine what it's like for all of you in the legislature to have to respond to your constituents in this incredible time of loss and stress virtually. Because I know many of you, and I know that you're hands-on and you like to talk to people directly. I know that's very difficult in this time. So let's get down to the questions here. One of the things that I think many of you may have known, but some do not, is that not only am I the executive director of a nursing home association, but I'm also involved with the 1199 Greater New York Health Fund. It's a benefit and pension fund. And I also do collective bargaining negotiations with the 1199 union. So I get a chance to do regular interface with the union. And so the labor workforce, not only within the metropolitan area, but frankly, throughout the state is a chief concern for me. In addition to which, I do have a background that I think plays into this role as a former Homeland Security advisor under two governors. And that reminds me of how similar where we are today it was in the days following 9/11. You know, back then we had never thought a terrorist attack would come and hit our local police forces. Yeah, sure, we trained and designed to try to get at the root of crime and prevent that, but not counterterrorism. Well, the same thing here. We have a global pandemic that has come and visited at the doorsteps of our hospitals and our nursing homes. And though, sure, contamination control is in fact something that we practice every single day at our healthcare facilities, we never thought we'd have to do it in this context. And so what also followed 9/11 was this federal, state, local dynamic of, well, who should provide the funding? Where is the guidance? What are the steps we need to take to prepare? As a matter of fact, you know, the crisis and response for this pandemic actually started 20 years ago when Secretary of Health and Human Services, Mike Leavitt, came out and said, you know, we ought to prepare for the anthrax attacks to be doing these types of things. And yet every administration has come out with plans, but the funding has not been there from the federal government. Likewise at the state, you know, you are so busy doing so many things that it relates to public health that to be able to sit there and say, we need to prepare at this time for this eventuality, when there's so many of the things we have to do, is very incredibly difficult. Now, part of my world now is that I do tabletop exercise for enterprises such as, you know, top 100 Fortune facilities, and also for enterprises such as municipalities. If I had said to the people back in February, you know, we're going to imagine a scenario where every single nursing home is going to go to 2, 3, 4 times X their personal protective equipment, everyone would have said, you're an alarmist. You know, it's one of these things. Actually, Mike Leavitt said this. He said, you know, when you go out early before a pandemic and you say you ought to protect yourselves this way, you're called Chicken Little. And then after the pandemic, you're called, well, you've been frankly irresponsible and not preparing more. So that's the lens through which we must see all of the responses going forward. We have to imagine not a COVID-free environment, but rather an environment that has less opportunities for the transmission of disease. And so we must think, reimagine healthcare. Examples, you know, telehealth, things that we could do remotely. Even thinking beyond that about robotics. You know, is there a place for robotics in the healthcare industry? These are the questions that previous to this really didn't get much traction. Now I think it's imperative for all of us to do it. You know, and the other thing is to understand what the dynamic is at a nursing home. I'll tell you this, there is no normal day in a pandemic. Absolutely none. All the assumptions you make are wrong. The information you receive on a daily basis could be incomplete, could be inconsistent, could be contradictory, or could be wrong. And so an industry that is this regulated, the constant communication back and forth, that communication changes. Look at what is happening with disease. We are still studying this disease, and I predict that we are not going to fully understand the breadth of the impact of this disease for years to come, because it still keeps on changing. And imagine trying to run a nursing home with that type of background of information. So we have a lot of things to do. We can talk to funding, we can talk to personal protective equipment. You've already taken a step to do that in passing a law this year that requires 60 days of PPE. We're going to seek to work with the governor's office to make sure that we have the right amount of PPE at the right time. But we also need to recognize that there's more work to be done in terms of the whole healthcare continuum. Thank you, Mr. Chairman.
Thank you, Mr. Balboni. I recognize the Assembly for a first round of questions.
I would ask my co-chairs and rankers if you want to speak, if you would raise your hand, but not seeing anyone at this point. Chair Godfrey, would you like an opportunity at this point?
Yes, thank you. Yeah, I was about to go raise my hand. Couple of questions about staffing. You know, when we talk about the safe staffing legislation over the years, we are often told that there's really no evidence that enhancing staffing is, you know, increasing staffing levels makes any difference, which I've never understood. Are we learning in this pandemic that staffing levels have made a difference and that increasing staffing levels would make a difference?
If I might, I think that my view of that, Assemblyman Gottfried, is that what happened when the crisis started is that numbers of staff people became ill. So instead of having the number of staff that we were supposed to have had, we had fewer, and that became a problem. We were trying to get back to normal, so to speak, back to where we were, and we played catch up for the first 6 or 8 weeks. So I think that the problem wasn't that we didn't have enough staff in the first place. The problem was, as the pandemic caused the staff to become ill, we didn't have enough staff to proceed forward, and that became a crisis.
Yeah. Chairman Gottfried, as you know, the staffing levels were a problem before the COVID. And so they become even more pronounced, as Neil had said, because a lot of different things came into play. Not only did staff become sick, but there was a fear, a realistic fear of getting sick. You don't have enough PPE to go to work. And so you had families of the staff saying, don't go to work. Don't submit yourself to this. This staffing is also something that we need to really examine. And one of the things that we had looked at and we were pretty successful at was going to colleges, nursing schools, and say, while somebody is training and learning to be a nurse, in these types of surge capabilities, we need to be able to put them into the workplace. The problem is that you can say that you've got a system in place, but you actually have to be able to look at how you put people in the nursing homes. And by the way, just walking in off the street, even if you have some nursing information, is not enough. You got to be integrated into the facility.
Some of your facilities, this is a question, I guess, for both of you, have organized labor in the facility. Mm-hmm. I assume some don't. Does having an organized workforce promote better morale, better stability in the workforce? Is it ultimately beneficial for the facility?
Yeah, Chairman, it is essential to have a motivated workforce that is trained properly and has the right protective equipment. That is, no doubt, the most important thing that you can do. As you know, 80% of a nursing home's costs associated with personnel. And so there's no way you can provide care without good staff who come to work understanding that they have a mission to do and they can do it safely. And this has been a huge challenge. Again, unprecedented health care crisis. We're still learning. Look at how the strategies have changed, Chairman. The strategy initially were, okay, try to take the patients in, try to keep them away from other patients. Now it's specifically testing and cohorting. That's something that is a relatively new strategy given the last couple of months. So these are the things we need to take care of in terms of our staff as well.
My specific question is it beneficial to have a union organized workforce? Does that help support morale and provide stability in your workforce?
Yeah, yes, I think it does. And by the way, virtually all the facilities are in the union. Most of them are at 1199, but there are other unions, so it is a large majority. And yes, and we work closely with the union and the union staff, particularly when this crisis hit. We had conversations with the union leadership because we understood the issues as they surrounded the staff, and we wanted to keep morale up. So overall, yes, working with the union and cooperating with them and then with us does work well. And in this particular crisis, it was very useful.
Thank you.
All right, thank you. Some member on our side, leading off with Senator May, recognized for 5 minutes.
Thank you. And thanks for your testimony. I wanted to ask about staff. I keep talking about staff. So I gather some Canadian provinces have actually taken the step of barring their workers from working at more than one nursing home site at a time as a means of limiting spread. Is that an option that you could envision here? Do you have a sense of how many workers actually work at multiple sites, and what would be needed in the way of support to supplement their income or whatever, so that we could pull something like that off?
Yeah. So Neil, let me just take a quick shot at this. So before the DOH edict about not limiting visitation, a lot of the members in the downstate area decide to do that on their own. As a part of that, they also recognize the fact that there are these journeyman staffers who are working in more than one facility, whether they're actual union employees or they're agency employees. And we recognize kind of early on that without testing, you don't know what someone might be bringing into a facility. You then combine that with not enough PPE, and you really create a situation that is ripe for transmission. So I think you're absolutely right. This is something that we should really try to stop from happening itself. But of course, that works we have to partner with the union on that to make sure that they understand the risks, that we understand the risk, and we can come up with a good protocol for that.
I might add, by the way, if I could, that as the testing becomes more sophisticated, and as we get more involved with the test kits that can actually produce virtually instantaneous results that are accurate, and hopefully that will be the case sometime very soon, if we test people and we know that they're testing negative, that would prevent that spread, even if they went from home or community to the facility or from facility to facility. I think the key to this is knowing whether or not the person has the illness as to whether or not there'd be a danger. And I think we can get to that point sometime in the near future and understand what the dangers are.
Thank you. And then I wanted to ask something that came up a lot in the previous questioning of the commissioner, balancing the just outright saving of lives in the pandemic and the quality of life in the nursing homes, which is often also a determinant of life expectancy and health in its own right. Can you talk about how you are thinking about this balance, like reducing isolation, advocating for more visiting or less visiting? Like, how do you balance that out in your own mind and in your own practice?
So in your statute that you passed, there's got to be a pandemic plan. That was a very good bill, very good law that you passed. And a part of that is a communication strategy. Again, this is something we haven't had to do before. So the inclusion of technology to be able to talk to families during this period of time is one aspect of it. But you're absolutely right. And I really appreciate everybody so far in this hearing challenging the current ideology as it relates to visitation. I've strongly urged the department that they reconsider the opening of visitation. This is absolutely essential because, as you have all talked about, loneliness is a comorbidity. It is what is making people sicker. We need to get people together, and I'm convinced that we can do it safely. That's the other thing. Nursing homes have learned so much about decontamination, about contamination control. In fact, I would argue that in many of the nursing homes in the state of New York right now, it is one of the safest facilities in which to put somebody because they've learned, and now they have the equipment, and now they have staff because they've come back because they're not sick anymore.
I know that we hear about, sorry, we hear about family members who have typically been coming in and bathing or helping with actual care of their loved ones. And I wonder if you can like deputize family members as staff essentially so that they would follow the same protocols as staff or something like that.
As we get more sophisticated in our ability to test and more sophisticated in our ability to appropriately obtain, utilize, wear PPE, that we'll probably move in that direction. I think what's happened now, because we still are in the middle of a pandemic crisis, that everything's moving a little bit more slowly than we would have wanted it to. But I agree 100% that loneliness and being away from family is very difficult. If not, my mother's 94 and she's in a facility. I've been going through this myself. But the fact of the matter is that we want to be careful and do this correctly because we don't want to reintroduce a problem. So it's moving along, and the department's been very cooperative in moving along with us, but moving along slowly and carefully.
Okay. Gustavo, do I have any more time? I have one more question.
Your time is up.
Okay. Well, thank you both.
Thank you. Assembly?
Yes, thank you, Senator. I will go next in asking questions. And the first question is to both gentlemen. Are your member organizations, are they made up of both for-profit and not-for-profit facilities?
Yes.
Yeah, I have some not-for-profits as well as for-profit, but it's predominantly it is predominantly for-profit.
Okay. And are you getting different information or regarding the experience, I guess, if you break it down for-profit versus not-for-profit?
I am not hearing anything different. I don't think, and I'm not trying to be cute, I don't think the virus knows the difference. I mean, I think that it is taken its own route, and it's entered all auspice facilities, whether they be government run, for-profit or not-for-profit, with equal disaster. So I haven't heard anything different at all.
Mr.
I
Belbar?
agree. I don't see the distinction.
Okay. Yeah, certainly I agree with you. The virus doesn't know a difference, but certainly some of the historical information we have on the different organizational setup is different for sure. Looking at some of the issues that you pointed out, the regular testing of residents you indicated is an important aspect, Mr. Heyman. Are you getting test results back in a timely way? Is there any backlog, or is that working smoothly at this point?
Kind of all over the map. I mean, it depends on the lab that's being used. There's a lot of it depends. In some instances, they're coming back I would, by the way, what is a timely manner? Timely is enough so if a staff person in particular is tested on a Monday morning, that we know before Tuesday, the next shift, that they do or don't have the virus. I mean, that would be very useful. Ideally, it'd be wonderful to have it in 15 minutes so that they could go on to their shift or not on that very day. But once you get past a 24 or 23-hour time period, it becomes problematic. And there are still some problems in that vein, and we're not getting the results back as quickly all over as we would like.
Okay. And in connection with that, are you, if you're testing someone that's not exhibiting any symptoms, and that's one scenario, but if someone is exhibiting some symptoms, even if it's a cold or something, are they instructed not to come to work under that scenario?
Yes. Yes.
Yes. If they're exhibiting a fever or a cough, yes.
Okay. And let's talk now regarding the reporting. And I know certainly hearing from some facilities up in my area, in the greater Rochester area, the reporting requirements are burdensome and difficult. What's the experience that you're having with the Department of Health and all, the daily checks that you have to make reporting back? What's your experience in your areas?
That's actually an excellent question, because obviously in the beginning, when everybody was trying to figure out what we needed and how best to do that, there was a lot of requests, and there were a lot of requests that were made with a very short time frame to get the answers in. But as we moved through the actual crisis, it's become a bit more steady and a bit more easy to deal with. And as I mentioned in my remarks, I think that what we want to do going forward is actually work with the Department of Health, figure out in advance of the next wave what we need and when we need it, so that we can tell the facilities, here's what you have to be looking for as this thing morphs into the next phase. And so we can put a little bit of order to it and make it easier to do and a better result if we know exactly what we need up front.
So let me go further. The hospitals don't have to do HERDS reporting every day. Why do the nursing homes? It is the information really doesn't change. So why the constant reporting? This is the part of the administrative oversight burden that has to happen. You say, well, how could reporting be a burden? Well, it can be. But then generally speaking, the reporting, not only in New York, but across the nation has to be more consistent. The numbers that we're seeing, the way it's reported, that's the only way we're really going to be able to find out how we move forward from this. And that really comes also at the federal level. There needs to be a much better standardization of reporting across all areas.
And the last questioning is in line with what some of my colleagues have already brought up, and that is the staffing levels. In your written testimony, you said that you need critical resources, make it possible to locate, recruit, and retain adequate qualified staff. This is worsened because of COVID, but that was a problem prior to COVID, at least it is here in upstate New York. When you say resources, certainly we can think dollars and cents. What other resources might there be? And my time's up, but go ahead and answer as quickly as you can.
Well, quickly, yes, the resource of, obviously it's got to be funded, but I've been training, schools, education, encouraging people to get involved in the healthcare environment early on. This is something which is a long-term kind of project, and making full utilization of volunteers which are out there and full utilization of the various aspects of what New York City and New York State did as far as opening up the various avenues that we could utilize people who aren't currently in the field but had experience in the field. So there are ways to do it in the short run, and there are ways to do it in the long run. And I guess all pieces of that.
Thank you, Mr. Heyman. Thank you, Mr. Heyman. Recognize Senator James Skoufis for 5 minutes.
Thank you, Mr. Chairman, and thanks to you both for your participation. I think we can all imagine your jobs have become exponentially more difficult over these past 5 months. I first want to ask, and I mean this with all seriousness and respect, we're obviously asking you to attest to and to share on the ground problems and issues and how you've reacted in your member nursing homes. You both represent a pretty enormous slice of New York State's nursing homes. Can you just briefly share, that would maybe lend some additional confidence to us, how you've interacted with your member nursing homes over the past 5 months personally? Have you visited? Have you been physically to many of your member nursing homes? Have you spoken to workers in addition to administrators who I'm sure you do engage with frequently? Can you just speak to that a little bit?
Sure. If I can, Neil. We weekly, at one point in time, we had daily board calls as things from the department regulations, directives would change. In 2 weekends, late March, beginning of February, I actually participated through the direction of the department in actually getting PPE out. So I was actually a part of a group that was working out of the Javits Center and out of the Nassau Coliseum, of all places, and actually taking gowns and gloves and putting them on the back of trucks and delivering them out to try to assist in terms of what the network was of finding this very difficult PPE. On that point, everyone was saying to me, we have to compete globally for things like masks and gloves. It's really, really difficult. And they were subject to all sorts of price gouging that they're seeing.
And I'm going to focus my questions on the PPE issue. But just to be clear, so it sounds like you were on the ground personally, handing out equipment, visiting nursing homes, engaging with workers themselves. Is that accurate?
That's correct.
Okay,
Neil, you
great.
too, I assume?
Yeah, yes, and also, by the way, we did make tremendous use of the media, being of Zoom and of doing it this way, because there was an awful lot that we had to impart to our members, infection control. As this was evolving, we were imparting this, and I know that Mike was as well, to our members on a regular basis, having hundreds of people online to hear what we're talking about and to bring the information in. which was very effective.
Right. Okay. So let me jump into my questions quickly. And like I said, I'd like to focus on PPE. The governor made it very clear the challenges associated with getting PPE in those early weeks and months, especially given the federal government's lack of preparedness. But even considering that difficulty, as you heard earlier this morning, up to 1 in 4 of your employees in nursing homes contracted COVID-19, which are significantly higher rates than transit workers, police officers, firefighters, other categories of workers that were tested during the pandemic. How much of that disparity with your workers do you attribute to the lack of adequate PPE in nursing homes? And as you briefly answer, can you also speak to whether you believe the state adequately prioritized PPE for nursing homes from our state supply?
So, the challenge, of course, is when did this virus impact us? That's the thing. I personally felt that because we didn't have the right international, national surveillance capabilities, we didn't know there was already our environment. So when you had, the nature of congregate care is that you're incredibly close to your patients. And, it's not something you can do distance-wise. And so then when this first began to ramp up and people began to get sick, then that is when the PPE was actually at its lowest because the burn rate changed completely.
If I can just jump in, because I do have one other question. Would you say this was the primary driver of that higher infection rate among nursing home employees, or do you believe there was another primary driver?
Yeah, Senator, it's really, it's very difficult to be able to pinpoint the exact reason for transmission. You're in a nursing home in Queens, you send your patients out for dialysis. Was the ambulance properly decontaminated, the dialysis center? In other words, there's so many different reasons that a virus could get into a facility. It's very difficult to pinpoint and say it's because of this only. I think it's really a combination of a lot of factors.
But this is at the top of the list.
We believe this is a part of it because, again, we didn't understand how this.
And what about the state supply? Do you believe that the state was adequately prioritizing nursing homes in our state supply PPE? And I guess this will be my last question.
They focused on the healthcare and the hospitals first. And you could argue that was exactly the right thing to do at that time because they didn't want a collapse of the hospital network system. But again, we would have wished that there could have been a 2-track approach that would really focus on long-term care as well.
And we believe that should be the case going forward.
Really quickly, please. Really quickly. Oh,
that's it. Okay, I'm done.
Oh, okay. Thank you, Senator. Assembly.
Thank you. Next, I recognize Co-Chair McDonald for 5 minutes. Take off, unmute, John.
There you go. That's better. Thank you. So, gentlemen, thank you for being here. And what a trial of time for all of you, particularly those on the front lines. I have a couple questions in regards to environment and approach. Environment, and we have some speakers later on our panels to talk about this. If you talk to people in the engineering industry and they talk about the virus, and this argument can actually be held for the typical influenza virus, relative humidity plays a large role of whether that virus is going to be active or dormant. And relative humidity between 40 and 60%. According to the engineers, the virus is dormant. So this gets into the question of, in your facilities, I know this is broad-based and this is not a gotcha, it's just a question, is humidity tested for on a regular basis? And at the same token, ventilation is seen to be coming up as an issue. Is this an issue that an area where the state should be focusing its energies on helping support the improving the infrastructure of the facilities that are out there?
I would respond by saying that as we move through this crisis and as we sort out from the scientists and from the epidemiologists what works, what doesn't work, what makes sense and doesn't make sense, we would be cooperative and do what makes the most sense to check. I don't have any personal knowledge right now of whether or not humidity testing has occurred yet, but if that is proven to be something that makes sense and can prevent the spread of the disease, there's no question that we would be pleased to do that.
Certainly we're looking at all aspects of this, right? So we're still seeing studies out of South Korea that talks about the HVAC being a large part of the transmission. Obviously there's lots of studies around that talk about airborne transmission. There's we don't really test for humidity within the ventilation systems, but there's all sorts of things we could take a look at, including the introduction of UV light within humidity, within the HVAC systems. So there's a lot of things we really should talk about going forward as innovations in the healthcare system.
Yeah, and I don't think it's lost to any of us. We've gone through a lot of Herculean efforts to get the malls open again, and filtrate and ventilation was a key issue. Gyms still aren't open, but obviously a place where people call home and they're there 24/7. We want to make sure it's the best proper environment. Once again, not a gotcha. It's more about how do we help support them.
So,
The other
so the
aspect-
department does require that the maintenance and vent systems are cleaned religiously. You know, so there is. I don't want to give anyone the impression that there's no regulations
Right.
that they're cleaned. They are.
But they also, are they prescriptive on the type of filters and the levels of filters?
Yeah, HEPA filtration are being looked at right now in terms of what the standard should be. There's currently no standard that matches up to a virus transmission.
Different related topic, infection control. And obviously that's a very loose term. That's very critical in many aspects. I'd like your response. I've had individuals who actually work in the long-term care community who are just as serious as you are say, you know, the approach in long-term care is not the same as infection control in the hospital setting. In the hospital setting, they've got their own department, they got people running around doing tests and training and things like that. Is that an accurate statement, or what would you have a comment to that?
Nursing homes have infection control programs in place, and they've had them in place for years, and that's a part and parcel of how they have to operate. And they're surveyed by the state of New York on a regular basis to make sure their infection control programs and protocols are up to date and accurate. And for the most part, they are, but if there are issues, they get them back up to speed. So I think that they're there at this point in time.
So nursing homes have had to operate under stringent decontamination control, infection control for years. And now, but that's the old normal. There's a new normal that's now emerged, and we look forward to partnering with the department to basically have a regulatory standard that, in fact, can implement these new standards.
Thank you. And the intent of my questions is that we know there's going to be changes coming, and we as a state need to be a partner with you to take care of our most aged and critical. Thank you.
Agreed.
Thank you.
Thank you.
Thank you. So I'll recognize myself for 5 minutes. Gentlemen, thank you for being here. Did you have the opportunity to listen to the commissioner that spoke before you folks?
Sure did.
Yes.
Okay. So there's a couple of things that I wanted to kind of get your perspective on. Number one, let's talk about the definition of deaths. Let's talk about the definition of that. In particular, there is this insistence from the commissioner that this was the right way to do it. So if you could tell us a little bit about the reporting that the nursing homes that you represent did, and the information that they kept available to them as it relates to what you reported to the state when somebody was a nursing home patient and then was admitted and unfortunately passed away. How did those numbers reported to the state?
We followed the guidelines as set forth in the HERDS survey. In other words, the HERDS survey has a number of questions, and we all answered those. All the facilities answered those questions, and so we didn't actually take a look outside and say, well, if it's outside of the HERDS survey, we need to have an addendum on that. Mm-hmm. So, but the challenge, Senator, I don't want to make this any more complex than it already is, but it's determining really cause of death. And when you talk to, remember, medical examiners are not involved in the pronouncement of death. It is the clinician at each of the facilities. And therefore, necessarily, there's a little bit of subjectivity associated with that call. So to be able to, I know a lot of people take a look at the death count and say, this has to be accurate. I'm telling you now that it is not. But I can't tell you if it is undercounted or overcounted. All I can tell you is that there's no way on God's green earth that we can actually pinpoint and say, this is the reason someone died. If they had emphysema for 10 years, they're 85 years old, and now they get COVID and they pass away. What was the cause of death? Same with heart disease. So, because we're still studying the target audience.
So let's talk a little bit about the reporting that you had to do. There were 4 dates. There was a lot of press around this. There were 4 dates in April, between 15th, 16th, 17th, and 18th of April. And that the reason I want to focus on those is because even though you might not recall those exact dates, you probably heard about the series of emergency meetings, emails, calls, and things that the nursing homes that you represent and nursing homes all around the state were required to present within just a few hours. Could you tell us if you recall those times? Because as I understand it, there was like, for example, on the 15th, there was an email at 11:46 in the morning that said, you are required to get on a 1:30 call with the commissioner. And then after that, you have to give us information by the next day. Do you recall this that I'm talking about?
Yeah.
There was some short time frames.
Good. Yeah, I recall it, Senator, very much. And it's incredibly frustrating when you have a change of directive in such a short period of time. But let me just make a statement here. I know that there's a lot of controversy surrounding this. Neil and I both know the Department of Health staff worked day and night to try to get this right. Were the responses and the regulation and oversight always perfect? No, it wasn't. But it's in the middle of a pandemic, an unprecedented time. And we got on calls almost daily, sometimes twice a day, to talk to the staff and try to work things through. And so when they made these changes, we weren't always privy to what was the motivation for the rapid change, but we knew they had everybody's best interest in mind going forward. So, it's hard to take this perfect prism through which we see what the department did, but I know that they worked as hard as they possibly could.
Yeah, if I might also just, Senator Vera, yes, there were short time frames, but interestingly enough and miraculously enough, the nursing homes met the time frames. The department, who was working day and night and weekends, got the data, analyzed it, and got what they needed out of it. So that's why I think.
Last question, because my time is running out. Because I've heard differing stories about people being very frustrated, having very few resources to be able to put the information out. They did it, but it was within a very, very crushed time frame. Do you think that it would help to have some sort of, there's somebody that suggested to me a committee of operators or some way that the state would be able to have a group of operators from different nursing homes be available to them so that when they have suggestions of regulations to put out there, that they're actually considered even for a short period of time as to how they're actually going to be implemented. So then they could actually be implemented to the best of the ability of particular facilities. Quickly, because my time is running out, if you could.
That's a great idea. In fact, doing that in advance of the crisis, as I kind of suggested in my opening remarks, makes a whole lot of sense because we've learned now what we need. We've learned now when we might need it. So I think that putting together a script and utilizing the people who are in the field along with the people in the department makes all the sense in the world.
Thank you.
Senator, the relationship has been ad hoc, doing something more formal, actually kind of creating like a kitchen cabinet for the department as they move forward would be great.
Yeah, so my time right now. Thank you. Assembly.
Thank you. Next we'll recognize Assembly Member Ron Kim for 3 minutes. Assembly Member Kim.
Hi, can you hear me?
Yes.
Thank you. So for years before this pandemic even hit us, we've known about the understaffed and underfunded nursing homes and legislated nonstop to fix these problems. On February 6, 2020, the Center for Medicare and Medicaid Services issued a national memo to all healthcare facilities warning and instructing them how to prepare for COVID-19. The public would like to believe that the state and the facilities took this warning seriously and prepared healthcare facilities. But when I surveyed close to about a dozen or so facilities at the peak of the crisis, every nursing home director told me that the only time they heard from the Department of Health is when they called for fatality numbers. One administrator even told me it was never ending. They called every day to ask how many people died. The state never once asked if we needed PPE, extra staffing, resources. Fast forward to March 23rd, 2020, Governor Cuomo passed an executive order to provide legal protections for frontline medical workers and volunteers. Within days, he pushed a new provision in the budget that broadens this protection to a blanket legal immunity that covers nursing home executives, CEOs, shareholders, board members, and for non-COVID treatments as well. April 2nd, 2020, the Greater New York Hospitals Association immediately sent out a press release as soon as the governor signed the budget, claiming that they drafted and aggressively advocated for this legislation. Despite early warnings by the CMS and the global community, we sleptwalked into this pandemic and found ourselves in full panic mode. And consequently, it was too late to protect the patient rights, so the industry lobbied hard for legal and criminal immunity for healthcare facilities. Just a yes or no question for both panelists. Did you lobby for legal and criminal immunity for nursing homes?
No.
No?
When were you aware of this immunity status, and did you communicate the legal protection status to your members?
We were aware when the budget was passed, Assemblyman, and signed by the governor. And as you know, Article 2B of the executive law kind of sets the table for changing a lot of this as it relates to state law. And much has been made about this, and it's a very fair description. But when you think about the different elements of the care, under New York law, right? Reasonable standard of care is what you must show has been breached. Well, as you know, under a pandemic, that standard of care changes. And the most difficult aspect of this, in case somebody's saying to you that, a case against a nursing home, even without these protections, would be a slam
Mr.
dunk.
Rabboni, I'm sorry to cut you off. My time is up. Just one more question. Do you think we're better prepared to prevent the spread and arrange the care for COVID positives in nursing homes now than before?
Absolutely.
Okay.
Yeah.
Okay.
Absolutely,
Thank
yes.
you. Thank you.
Thank you.
Thank you, sir. Apologies, trying to squeeze my lunch in. Recognize Senator Sue Serino for 5 minutes.
Thank you very much, Chairman. And thank you very much, gentlemen, for being here with us today. So I just have a quick question. If you had to prioritize one thing to change to improve the state's response to this crisis in these facilities to measurably improve health outcomes, what would be at the top of your list?
So they're going to give you three things: surveillance, resources, and communication. Those are the three things we really got to focus on. Dr. Tom Frieden of New York City was talking a long time ago about something called syndromic surveillance. The ability to take a look across the entire community and see when a disease state was impacting a community itself. We should go back and explore this. Back then, Health and Human Services, DHS, all looked at that model. They didn't believe you could have the sensitivity to actually give you any type of notice that would be useful in terms of a disease state. But we should explore that again. Resources, everybody's talking about the funding, everybody's talking about PPE. Yes, of course, those are all, the staffing surge models. We need to look at that. And the last thing is communications. It is so difficult to be able to you can talk to hospital networks, even that's hard, but talking to individually owned, 614 nursing homes, it's really difficult to communicate effectively, real time, with the right information. Those are the things we really got to work forward going forward.
I think if I had to put one up there, I would put the resources and the funding necessary, because most everything will flow from that. I mean, if the facilities have enough resources, they can have enough additional staff. They can cover for staff that are out sick. They can get and pay for the PPEs, and they can afford the testing. So I think the number one priority, and whether it's federal dollars, state dollars, or a combination, is, I would say, our funding. And I think it's critical that the existing rates that the nursing homes have don't get cut any further, because, as I mentioned earlier in my testimony, I believe that if we don't fund them appropriately, it'll be a threat to the health of the people in New York, and certainly a threat to the facility's ability to function.
Well, and thank you both very much. And I agree with you. The resources are very important, and to cover our staffing and everything. And I guess everything else would follow suit, right? The surveillance and the communication, it makes everything a little bit easier. So thank you for everything that you're doing, and thank you for being here today.
Thank you, Senator.
Thank you.
Thank you, Senator. Assembly.
Yes, I next recognize Ranker Kevin Byrne for 5 minutes.
Thank you, Mr. Chairman, and thank you, Mr. Balboni and Hyman.
Just a quick question. I know we've talked a lot about the count of fatalities in nursing facilities and how we're counting it, hospital setting or not. And you spoke to that a little bit earlier. There's also been reports about the increase in vacancy rates at nursing facilities across the state, a significant increase. I don't think that reveals a total amount of fatalities, but it merits probably further consideration and review. Can you share with us how the vacancy rates have changed since the pandemic begun, the outbreak, the onset, and how you view that? Is that possibly an indicator of fatalities?
Well, I think the vacancy rates grew tremendously for several reasons. Yes, fatalities would be a part of that, I suppose. But the fact of the matter is the hospitals were not performing elective surgery. Most of the nursing homes admissions in a normal period of time, which we may never see again, come from the hospital discharges from, hip replacements and whatever kind of elective surgical procedures go on. And there are numerous in the hospitals. Those ceased. Those ended. For a period of months, the hospitals were just treating COVID patients. So the nursing homes didn't have access to the usual kind of admissions. And that now, by the way, can change because the nursing homes have the capacity to take in COVID patients and hospital and community patients equally. But yeah, that was probably the biggest driver for the tremendous downturn in their occupancy rates, some of which were down 40%.
So Assemblyman, you have touched upon the next crisis that's going to hit long-term care. And nobody's talking about this because it involves the economics of a nursing home. If you're below 80% census, means for profit, you're barely making payroll. And right now, the census, because of the way this impacted long-term care residents who were there for 10 years, they're not coming back anytime soon. Yes, the higher reimbursement rate, as you know, is tied to the acuity, right? The amount of services you have to provide. And so rehabilitation has been higher. Ventilation patients have been higher. But right now, nursing homes are in an incredible struggle to keep their doors open. And one of the things that we want to point to is the state actually, because of the reduction in the census, is actually putting out less money towards the payments. If you combine this, because remember, CMS does in fact reimburse us. Our actual amount of money that we're going to be getting from the federal government is actually less as well. But nobody's taking a look at the economics of nursing homes. And then you take on top of it the increased cost of testing. You take on top of it the increased cost of the PPE. These are all things that we needed to do, but is impacting the ability of a nursing home to stay open.
Well, I can certainly understand how those increase costs for business and for you to provide your service. As far as now that we've been slowly opening up elective procedures, have you seen a change in those numbers regarding vacancy rates in the more recent months now that we're past phase 4 or we're still in phase 4? Has that started to trickle back, or are we still in this kind of holding pattern with the vacancy rates significantly higher than normal?
So here's one of the things that's impacting the fact that you can't visit your loved ones. Mm-hmm. People are not willing to send their folks to nursing homes because they can't visit their loved ones. In addition to which, there's this concern that nursing homes are not safe. And so all those things combined are creating an environment for nursing homes that is we've never seen this before. And it is really becoming a crisis across the entire state.
Now, just a question, since we talked about it earlier with the commissioner regarding the March 25th order, and then I know there was a different order that came out later, I believe it was in May. Are you of the understanding that, were you still of the understanding that both orders were still fully in effect, as the commissioner stated, or were you of the understanding that it was revised? I know one of the orders was, the more recent order was more, I think, geared towards hospitals. But if you could just give me your reaction to that, if that was news to you, or is this something that you're just continuing to operate with?
I was aware that the orders were in effect. That was no surprise.
Okay.
Yeah. So there's an irony here in that a COVID patient that has, again, a higher level of service actually has a high reimbursement rate. So now that the nursing homes have the cohorting, have the personal protective equipment, have the staffing, they want these patients. And yet now they're being told, we're not gonna, we're gonna try to restrict those patients from traveling there, so, or being admitted.
Thank you.
Thank you. And there's currently no Senate members that are on the list for speaking. If there are Senate members who are on in this hearing and are interested in speaking, please let me know. For a moment, I'll pass it back to the Assembly.
Thank you. Next, I recognize Assemblymember Tom Abenati for 3 minutes.
There we go. Thank you both for joining us. I'd like to get back to the issue that I was raising with the Health Commissioner before about getting family members back in to see their loved ones. I called as somebody tweeted at me and said they're not visitors, they're actually part of the staff. They're part of the treatment. They're part of the help. And I agree with them on that. How do we do this? Has either of your organizations actually developed a plan that you can present to the state health department? Have you made suggestions? I don't know if you heard me with my conversation with the health commissioner was similar to what other members were saying, that, that the family members are just as concerned about the health of their family members in your residences as the staff are. They're going to try very hard to socially distance. They're going to try very hard to do everything necessary so they don't bring COVID into the nursing home to their loved one. How do we get them in tomorrow? This using technology just doesn't work. What do we do? Do you guys have a plan? Can you come up with something and get the health department on board?
Neil?
Well, actually, the answer to no, I don't have an absolute plan, but what's been going on for the past, I would say, 2 months is the department has had regular meetings with the nursing homes and with other long-term care providers. And they have asked us on a regular basis for input, and we have told them this is a high priority. We want to have visitation. And what they've said is they want to be careful to make sure that it's done appropriately, correctly, safely, and in a way in which they won't increase the problem accidentally. But what they've done, and they've always stuck to this, is when they start to move with us towards opening that up or towards reducing the amount of testing or towards whatever has to be done that we think might make sense, they do it carefully and they do it with us. And they say, let's now wait and see what the numbers look like. So as I understand what the department has said to me, they opened it up, and I know it's a high bar to get over, but now they're looking at the numbers. They're looking to see how this worked thus far. And although there's not a specific plan in place, my understanding of what they're doing now is they're going to evaluate the numbers. They're going to look at the facilities that have opened up, seen how it works, and then probably come back.
That's not the only factor, though.
No, it isn't. It's something you touched upon it. Massachusetts is doing this. The hospitals don't have the same type of thing we do. So families have said that they would test. This social distance outside. There are all the different things. I'm absolutely confident. I understand the commissioner's concerns, but I'm absolutely confident that individually the homes can produce a program that will absolutely limit or eradicate transmission.
Right, because right now, as we open up the rest of the world, nobody's restricting the staff from going out to have dinner outside, to take public transit. So we don't know. So you don't have any numbers, do you, to show that there was transmission by family members?
No.
Okay. Please come up with a plan and let's get the health department moving.
Okay, thank you, Assembly Member. I believe we'll go to the next Assembly Member, Inez Dickens. I recognize you for 3 minutes.
Can you hear me, Mr.
Yes,
Chair?
we can. Yes, we can.
All right. Thank you for your testimony. Some hospitals have considered implementing plans that would, if a person designated with COVID has been infected, would designate one family member or friend, and that person would have to agree and understand the possibilities of visiting the patient. Just one. Has the nursing homes thought about implementing something like that in their plan? That's one. Two, regardless of the cause of death, why did it take so long to notify family members during the pandemic about the passing of their family member? Three, has your plan included the disposal of bodies during the pandemic? Since the hospitals we know have morgues and nursing homes do not, and that was a problem during this last pandemic. We know staffing is short, and as such, prior to the pandemic, it was short. How is that going to be addressed moving forward? If a staff member tests positive, will the entire staff be notified? And PPEs were short in hospitals and seemingly more so in nursing homes. I understand, that you're talking about the economics and the funding. Is that the only way that can be addressed? The first one is about
Right.
of having a family member or friend. For one person, that would address mental health.
Sure. We're confident we could work with the department to come up with this protocol, and even having folks just not show up, but having appointments. So
Yeah, a limit of one person that they would designate.
Right.
Yes.
Good idea.
Yeah, I think it's doable, right, Neil? It's absolutely
All right.
doable.
Very good idea. Very doable.
All right. Then the
Agree with that.
second thing is about the issue of death. Why did it take so long during the pandemic to notify family members that their family person had died? What was the reason for that? And that seems to have been so with the nursing homes.
Assuming it's hard to specifically talk about the entire nursing home industry. I know you probably have individual cases or individual homes and individual families. So some homes did better jobs of reporting than others, and sometimes there was I know of one case where they simply didn't have any administrative staff to make the notifications that the folks were on the floor, doing patient care, and so even though for us death notification is so absolutely crucial within the concept of a pandemic, it's not an excuse, but it might be a reality for some of the homes trying to respond.
And what about the disposal of remains during the pandemic?
That is a huge issue. We lack not only in terms of the individual nursing homes, which you're right, do not really have capacity, but the system, the way it's been set up is that the Office of Emergency Management in the city and in the county health agencies, they're supposed to provide the ability to handle the disposal of remains. And what we found was that, there wasn't enough pickup, but we got that done. In other words, we needed to surge and we got there.
Because that's something that we need to address in anticipation of another pandemic. And what would staff be notified if one staff person or two have been tested COVID positive?
Thank you, Assembly Member. Your time.
All right, thank you.
Sorry. Thank you.
Thank you, Inez. Next up, we have, I recognize Assembly Member Andrew Garbarino for 3 minutes. Andy, you there? There you go. Okay.
Thank you, Harry. Just some quick questions. Thank you, gentlemen, for coming today and answering some questions. I received a call from a local nurse at a local nursing home. She said DOH has been at her nursing home for the last 3 days investigating. Have you heard from other of your members or any of your members that DOH is doing in-depth investigations into nursing homes around the state?
They've been doing that for a while,
Yeah.
right? We've
Yeah,
heard that.
they've been surveying, they surveyed all the homes, and if they found anything, they would come back and resurvey so that, in most homes, as I understand it, there weren't problems, but I suppose where they found issues, they wanted to come back and make sure everything was all right. So that has happened, yes.
Was that, are you getting any information shared from either the DOH about about their investigations, where there are problems, or from your members?
I haven't gotten any specific information, no.
I know that early on, there's been a focus on the number of deaths. That was a principal focus. And then it came to, right now they're doing a survey on the amount of PPE that each of the facilities have in order to create a baseline. And by the way, on that, I really appreciate the way the Department of Health and the Division of Budget has been engaged in this to try to implement the law that you guys put into place about PPE.
Okay. Another question from one of my constituents. She tried to get her mother out of a nursing home in the middle of the pandemic, but the facility, according to her, refused to let her mother leave. Was that a policy that just some nursing homes had, or was that something, in effect, or was it just, you guys don't know anything about it?
I don't know anything.
Probably individual.
I'd have to see what the specific situation was. I don't know anything about that.
Okay. And last, I know Senator Byrne brought it up about the March 25th order, and you both said it's still in effect, and how you couldn't refuse a readmission or admission of a patient based on COVID alone.
but the commissioner today made it sound like if the person had COVID and the nursing home said we didn't want the person because we can't take care of them, that would be good enough. Is this something, how are you answering questions from nursing homes as to whether or not if nursing homes don't want them? I know you said some of them do because of a higher reimbursement rate, but how are you advising members if they don't want them COVID patients back? What are you telling them so they don't have to take them?
That basic concept, by the way, of a nursing home not taking a patient because the facility doesn't feel they can take care of it, goes across the board. It's not just for COVID patients, it's for any patients. And so that if a nursing home feels they can't take a patient for whatever reason, we would help them help them or have the Department of Health help them find a different facility. But
Specifically with COVID, though, what are you saying to them?
Don't
So they don't have to take
they
the
don't
next
feel they can take the patient,
upswing.
they should not. But what's happened now, then you should know this, is that virtually every facility has put protocols in place, learned how to cohort, and has COVID-only units. So although the answer to your question is yes, I would say do what you need to do. I would say a vast majority, if not almost all of them now, have the capacity to take the COVID patient.
Thank you, Assembly Member. I actually have one senator, Senator Biaggi, will be recognized for 3 minutes.
Thank you very much. I'm just trying to undo my video. Someone can just start it for me, please. Thank you very much. Okay, great. So good afternoon. Thank you very much for being here. I just have a question about federal regulation that was put in place in 2016 that required nursing homes to create pandemic crisis plans. I think investigations have shown, and there's a really great article actually talking about it, that only a fraction of nursing homes have actually done so. So I'm wondering if either of your organizations has done an inventory of the nursing homes to see which ones have done the plans or complied with the plans and which ones have not. And then also what you're doing to ensure that every single facility has one moving forward.
Senator, thank you for that question itself. We had not done a survey specific to the federal plans. That's usually done through the State Department of Health. But what we are doing going forward, because of the law you passed, is that we are hosting webinars talking specifically about the acquisition and maintenance of the PPE and the development of the plan itself. And that, remember, as you know, senators, it's not just the plan itself, but you have to exercise it. You've got to make sure that people know how to use it. And so we're urging to create not only the plans itself, but then the templates for exercising those plans.
So can I just to be super clear, so then has the Department of Health not done any outreach to any of your respective nursing homes that you are overseeing or in your organization or part of your organizations with regard to making sure that there's compliance with this federal requirement?
Yeah, Senator, I'll be honest, I before you brought it up, I know that there was actions at the federal level in 2016, but we have never really referred to the pandemic planning as a part of what we need to do pre-COVID. Again, it was one of these things where there were a lot of plans. Remember up to Sandy, everyone had to have a generator, and you had to test that generator. So there have been regulations layered on over the years. I don't believe, in my personal opinion, that the 2016 federal pandemic plan requirement that you're referring to has actually been something that we've been talking about as an industry in New York since that time. Certainly, because of your actions, we are going to be talking about it now.
Sure. Okay. No, I appreciate it. I just want to be very clear with everybody and just be on the record with this, that the federal requirement to create this plan is absolutely something that the Department of Health has oversight and enforcement of, and also has to ensure that there is compliance with. And so it's
Senator, just to get some information from my crack staff listening to me talk. So
Sure.
The plan you're referring to is the federal emergency preparedness mandate, and it is actually all hazards, which means so it's not pandemic specific, but it's
Yes.
actually all hazards.
Yes.
So they're part of their whole planning as well. So I do believe, as a part of their planning in response to the all hazards requirement, that they have plans in place.
Okay, I know my time is up, Senator Rivera. I just want to complete the thought. That makes a lot of sense. And also, because pandemics have already been present in the state of New York, it would have been very prudent for the Department of Health to have made sure that that was planned for. So thank you very much.
Thank you. Assembly?
We recognize next Assemblymember Michael Riley for 3 minutes.
Thank you, Mr. Chair. Thank you to the panel members. I have a question regarding focusing on the downstate area, which the hearing is focusing on. I represent Staten Island, portion of Staten Island. During this, the pandemic, how often has the governor's office or Department of Health held meetings with your organizations to stay on top of the status each period? Can you tell me if there's been a certain amount of meetings and how often they occurred?
During the height of it, Assemblyman?
Yes.
Like several times a day.
And that's weekends and nights.
Right. Weekends, nights. Yeah.
Okay. So before the they started getting into those meetings every day or every weekend, or the frequency of the meetings, during the time of the executive order for the immunity and for the budget discussion, was there any contact with your agencies in regards to the implementation of that legislation and that executive order?
Are you referring specifically to the liability executive order?
Yes.
Okay. No, not that, Neil, I don't recall it. Do you?
No, I mean, there was early, as the process started, there was an explanation of what was out there and what was going on. It was stated to us at some of the meetings that this was in place, but it was just something they announced at a meeting and mentioned as part of what was out there.
So there was no consultation to the organizations and the facilities that it actually implemented, or that it impacted, I should say, from the administration?
Assemblyman, I think it was done more. I can't tell you, what the mindset was of the governor when this was put out there, but I believe it was for the whole healthcare industry, that it wasn't specific to any one sector. And
yeah, no, I understand that, Mr. Maloney. I was actually looking to see if there was any input from those on the ground.
I see.
Before it was implemented. That's
I certainly think it's a good idea. It was told to us that it was happening. I thought it was a good idea. I mean, but there wasn't any input prior to it coming out.
During the regional meetings, or when they had these discussions that were led by the governor's office and Department of Health, did they include the executives from each county or the commissioner from the Department of Health in New York City?
Not with us. Not with our meetings.
Not on a regular basis, but there was interaction between New York State and New York City at the ground level, and at the attempt to try and get the appropriate staffing lined up and to coordinate activities. There were New York City groups doing it and New York State groups, and they invited each other to participate, and that did take place.
So, I mean, we talked a lot about
your time is up, Assemblymember.
It would be great if we included that moving forward, where all.
Thank you, Assemblymember. Your time has expired. Thank you.
Thank you. I next recognize Assemblymember John Selka for 3 minutes.
Hello, can you hear me?
Yes, we can.
Okay, gentlemen, thank you for being here today. This was probably an answer I would have preferred to be gotten from the Department of Health, but I'll just run this by you. Did you get any indication from your members on how many in particular actually requested help from the DOH in when they couldn't accept a patient because of their lack of ability to care properly for the patient?
I don't have any numbers on that. I'm sorry.
Same
Okay.
numbers.
So you haven't had any reflection whatsoever from any of your member organizations that they might have reached out to the Department of Health with an issue regarding inability to provide proper care? You didn't get any input at all from any of the members?
I'm not, but Assemblyman, in full transparency, there were moments during the pandemic, I remember 2 weekends specifically, where we were very concerned that a nursing home would have to evacuate their patients, that for lack of staff, lack of the ability. I mean, it got really close in a couple of situations. That didn't have to do with a specific order or anything else. That was just due to the operation. and lack of staffing. So, again, there is no normal in a pandemic. And this really was a war.
And I understand that. What I'm trying to pinpoint here is that I know that the governor had said that if, in one of his press conferences, that if the nursing homes could not provide adequate care, to reach out to the Department of Health. And we're just trying to put our finger on whether or not that did happen at all. And if it did happen, how quickly that request was expedited so that, of course, the resident got the best care. So I was wondering if you had heard anything at all about that, any reflection from any of your organizations.
No, I had not heard, even anecdotally, none of my members actually told me that they went through that process.
Okay, thank you. Thank you, gentlemen. Thank you for being here.
Thank you.
Thank you.
All right, that is all from the Senate. Do we still have from the Assembly?
That is all for the Assembly as well. Thank you, gentlemen.
All right, thank you, Mr. Hammond and Mr. Balboni.
Thank you very much.
Thank you and we are moving on to panel 3, which will be Judy Farrell, the long-term care ombudsman from the Tri-County Ombudsman Program, and Richard Mollett, please correct me if I'm wrong in that pronunciation, Executive Director for Long-Term Care Community Coalition. Mr. Mollett, is that correct? The correct pronunciation?
Thank you.
Yes.
And just before I swear them in, I just want to observe, it's been an hour and 20 minutes since we returned from our break after the health department. 2 witnesses have testified during that time. We have 30 more on the list. Do you each swear or affirm that the testimony you're about to give is true?
I do.
Yes, I do.
Okay.
Thank you.
Judy, do you want to go first?
Sure. Thank you, Richard. Thank you to the chairs and to the Senate and Assembly for convening this important hearing today and inviting me to submit a statement on the impact of COVID-19 on residential healthcare facilities. My perspective is based on the hundreds of heartbreaking conversations that I've had with families and residents during the peak of the COVID-19 pandemic. The facilities are home to thousands of New York's most vulnerable residents. Many of these residents knew each other, shared meals together, participated in recreational activities, and enjoyed visits with families and friends. No one was prepared for the spread of this horrific virus, the massive death toll, and the inability to spend precious last minutes of life comforted by loved ones. From the beginning, we knew that COVID-19 would take a devastating toll on the elderly, particularly in long-term care facilities. Now we know over 6,000 residents died in a few short months. As the new long-term care ombudsman for Region 4, which covers Westchester, Rockland, and Putnam counties, I soon became aware that we were one of the only offices having direct contact with residents and families during the COVID-19 peak. And as a long-term care ombudsman, I received calls from desperate families to get any information on infections in their loved one's facility. I received calls from family members seeking to arrange end-of-life compassionate care visits. I received calls asking for assistance with getting bodies to be released to funeral homes. While I was able to advocate for residents and connect some with their families via technology or help families safely discharge their loved ones, residents, families, and facilities were overwhelmed by the pandemic and living in fear. Today, months later, families are still not able to visit loved ones due to the continuing number of staff testing positive for COVID-19. It is vital for all of us concerned with the lives of people living in long-term care facilities to find a way
to not only protect our elderly and people with disabilities from future outbreaks, but to solve the devastating problem of isolation and lack of human connection that may also impact the mental health, cognitive capacity, and lives of so many residents and families. Based on all of the fears and concerns I've heard expressed to me since COVID-19 swept through the facilities in my regions, and with over 20 years of experience in healthcare and public health, I offer the following recommendations for your consideration. 1, ensure residents of long-term care facilities are represented during New York's emergency preparedness planning, and that there is public access to emergency preparedness plans. 2, notify families and guardians of long-term care residents immediately of imminent threats to their health and safety. 3, share with residents and families information about all of the assistance available to them through times of public health crises, including the services of the Office of the State Long-Term Care Ombudsman, complaint report hotlines, and the local Department of Health. 4, continue to invest in and support technology that allows residents, families, friends, and representatives to stay connected virtually. 5, bring all stakeholders to the table, planning the future of long-term care in New York, including the representatives of residents. One final thought. It has been said that we as a society will be measured by how we treat the most vulnerable. While we cannot have known and still do not know fully the horrific COVID-19 virus, we must all work to ensure that we are prepared for the next outbreak and that we do everything we can to protect New York's most vulnerable elderly population and people with disabilities. Thank you.
Thanks. Should I just go ahead?
Yes, perfect
Thank
timing.
you. Okay. Thank you for inviting me to provide testimony today. I'm truly grateful both professionally and personally that you're holding these hearings. My name again is Richard Mollett. I'm the Executive Director of the Long-Term Care Community Coalition. We're a nonprofit, nonpartisan organization dedicated to improving care and quality of life for residents in nursing homes and other residential care settings. It is well known, as we've discussed today, that nursing home residents will be particularly vulnerable to the coronavirus well before it hit the United States and our home state of New York, based on how it hit communities in China, Italy, and Spain. In fact, our first knowledge of the virus's entrance into the US was when we witnessed in horror the devastating impact that it had on residents and staff in a nursing home in Washington state. Despite these warnings, far too little was done by nursing homes or state and federal leaders to mitigate the impact of the virus when it came to New York. As a result, we lost thousands of residents to the coronavirus and undoubtedly many thousands more from the persistent reports we have been hearing of abject neglect and substandard care in our facilities. Fundamentally and sadly, there is plenty of blame to go around at every level. Since we are at the beginning of piecing together what happened and where we go from here, I would like to use the remainder of my time to discuss a few points that we believe are critical to any discussion of what happened and how to best move forward. First, a few nursing home basics. Nursing homes are paid and contractually required to provide good care and humane, dignified conditions to every resident that they accept. The State Department of Health is paid and contractually required to ensure that these standards are met for every single resident every day of the year. The industry complains that it does not receive enough money to provide decent care and humane conditions for our elders. When bad things happen, either under normal circumstances or as a result of the pandemic, the industry's inevitable response is that it is not their fault and they need more money. In fact, the industry is increasingly run for profit with growing numbers of chains. The industry, both for and nonprofit, is dominated by sophisticated operators. As the New York Times reported, nursing home operators commonly use related party transactions to hide profits from Medicaid and Medicare services. Nursing homes received a 6.2% boost in Medicaid payment under the Families First Coronavirus Relief Act. They've enjoyed double-digit profits on Medicare patients for close to 20 years. And since October 2019, they've seen a boost in profits as a result of changes to the federal reimbursement system. A few points about what happened leading up to the pandemic. We have long known that staffing is a widespread and persistent problem in our nursing homes. We have also known that poor infection control protocols are longstanding and persistent problems. What we know about what happened so far: residents and their families were and continue to be absolutely devastated, as Judy was saying, by the coronavirus and the abject neglect residents are experiencing in facilities across the state. Our preliminary analysis of the data indicate that New York nursing homes with higher staffing levels had lower rates of death due to COVID. We have also found that ownership makes a difference. For-profit owners have had higher rates of resident deaths than have nonprofit and county-owned facilities. There is growing evidence of nursing homes that avoided deaths, even in hotspots, when they took basic steps to ensure resident and staff safety. Where do we go from here? 1, we must improve oversight and accountability for nursing home care in New York State. Our research of federal data, the New York State Comptroller's audits, even a recent GAO, U.S. Government Accountability Office, GAO report on New York have all indicated that the Department of Health must do more to safeguard the safety and dignity of our residents. The nursing home standards are strong, but they are not self-implementing. They must be enforced. 2, we need to join the majority of states that have minimum staffing standards. 3, we must put in place a medical loss ratio to set reasonable limits on how much money nursing homes can take out in profits or administrative costs before they allocate any funds to resident care, including decent, livable wages for nursing home staff. Nursing homes are increasingly run for profit. Right now, they're getting paid enormous sums for COVID patients, and bonuses of billions of dollars are going to the industry through the stimulus bills. Where is that money going? Where is the accountability? Thank you again for this opportunity to provide testimony.
Thank you, sir. And to lead us off in the Senate will be Senator James Skoufis, recognized for 5 minutes.
Thanks very much. And thanks to both of you for not just your testimony today, but your service. Speaking frankly, and this is something that you didn't touch on, but I'd love to speak at some length about. I'm disturbed by the state's early decision to prohibit ombudsmen and women from performing safe in-person oversight during the pandemic. I tell you, you're our watchdogs, you know what to look for, and your very presence itself oftentimes deters bad behavior. So fundamentally, I guess maybe the most important question on this matter is, in your heart of hearts, do you believe that if you and your peers around the state would have been able to save lives from COVID if able to carry out your duties over the past 5 months in nursing homes?
I think we were able to speak to residents and families through technology, but of course, it would have been more effective to be there in person, but I think that decision was right to not allow us to visit in person because the risk was too great, frankly. And we not only to the ombudsman's staff, but we have volunteers, and many of them are retired seniors. And
so I appreciate that, and I guess I've spoken with ombudsmen with a slightly different opinion, and they felt that they would have liked very much to be able to visit in person. Clearly, there's discrepancy in opinion within your ranks. I wonder, Richard, as an executive director of an organization that represents many members, can you speak to maybe what you've heard on this? Do more ombudsmen and women feel this was the right call, or do they feel differently and wish they would have been able to continue in-person visits?
Well, I think, one, this really came down from the feds, and I think that's important to know that. And it's actually in March that CMS, the Centers for Medicare and Medicaid Services, put that blockade up on visitation. We were against that for both family, in respect to both families and ombudsmen at the time. That was the beginning of March. However, that was before the disaster, frankly, really unfolded, and that's when Judy came in. As Judy knows, she's a new ombudsman. So I think by the time we got to late March or mid-March in New York, it was not an appropriate time for people to be going in. However, and this is something that you guys discussed earlier, I think that there were ways that the visitation could have been mitigated and done appropriately earlier on. if better steps have been put in place to safeguard residents along the way. And certainly, this is something that we have issued guidelines on for reopening visitation right now. I know you guys were interested in that too.
So just to be clear, the state didn't have a choice on this issue?
Correct, but the state does have a choice now in terms of visitation, but it didn't then.
Okay. And, my team and I, we received some testimony from an ombudsman out in Western New York that reads in part, quote, prior to, during the pandemic, and still, when I attempt phone calls to certain facilities, I am refused access, or too often the phone line rings indefinitely, never to be answered. Can you speak to the prevalence of that sort of problem where there is just complete unresponsiveness or outright refusal, both during this pandemic, although certainly the refusal to visit part has been addressed, but even more generally than that?
Judy?
I was able to get through to many facilities, but I did hear from families that they had difficulty getting through to facilities and difficulty getting calls back. I've heard
And
that.
so what do you do at that point?
Then I call. If a family's having difficulty, they've called me. I mean, that's how the ombudsman program is very resident focused, and it's at the request of the resident or their family, that we're able to call the facility directly and connect them with that resident's family so that their loved ones can communicate with them and get information on their status if they're not able to communicate.
So it sounds like you haven't had any problems personally with unresponsiveness to you. I'm wondering if, Richard, what I shared is prevalent among other ombuds members who have, maybe a longer history doing the work.
That's really what we're hearing is unfortunately a mixed bag. And I've been on a number of family calls as well over the past several months, and certainly spoken to a lot of ombudsmen that it's unfortunately, as I said at the start of my testimony, there's blame at every level. And I think really the lack of direction and leaving it up to facilities, some facilities did a great job with reaching out to families and to residents. Some of them, frankly, a lot of them did a really poor job. And that made it really hard to get to people. And we heard, just someone I mentioned previously, but not even hearing about.
We're out of time, so please wrap up. Please wrap up.
Not even hearing about deaths of their families until well after the resident had died, their family members. Excuse me.
Thank you so much. Thank you, Senator. Assembly.
Yes, we recognize Co-Chair Dick Gottfried for 5 minutes.
Thank you. Richard Mullet, in discussing the pandemic, I've been saying several things, and I'm just interested in your take on them. Basically, that for years, long before COVID, our nursing homes were suffering from inadequate staffing, inadequate staffing of the health department's enforcement personnel, and a fairly lax attitude among the enforcement personnel, and a chronic inadequacy of funding, particularly from the Medicaid program, and that all of that long pre-existed COVID has made all of the problems of COVID much worse. Does that square with your vision of things?
Yeah, it does. I mean, we have longstanding problems with staffing in this state, and with infection control. It's a nationwide issue. It's the most cited deficiency last year was failure to provide appropriate infection control protocols. I know you guys discussed that a little bit earlier. It's really, all this stuff is basic. It's hand washing. It's using basic common sense of washing your hands or changing your gloves when you go from caring from one resident to another. It's not brain surgery, but it really comes down, as you're saying, Assemblymember Gottfried, to staffing. Because if you have enough staff and the staff are trained, then they know to do that. They don't have to rush from one resident to another. They can stop and wash their hands. So it's really basic stuff. In terms of funding, I think obviously the Medicare program pays a lot more money than the Medicaid program does. And it's frankly due to a lack of transparency and accountability with where funds go. As I mentioned briefly in my testimony, it's really hard to say how much we need to pay, et cetera. I think that it would make sense to have a payment system that reimbursed appropriately for good care. We all want to see that, but that requires some transparency and accountability as well.
You used you referred to setting up a what you called a medical loss ratio, a term borrowed from the insurance world, to essentially require a facility to demonstrate spending a certain percentage of their revenue, I guess, on patient care and services before they could draw profit. And I'd like to, obviously not right now, talk at much greater length with you about that. Is there legislation like that in place in some other states?
No, not that I'm aware of. In terms of not for nursing homes, there is of course, as you mentioned, in the insurance world.
Yeah.
But it's something that we have become aware of just in the last few years. And as I quickly noted in my testimony, something that we've seen over the last 15 or so years is that the nursing home industry has become increasingly sophisticated. So one way to kind of address that sophistication, hiding assets in LLCs, hiding assets by selling the underlying property to yourself and then paying yourself rent at above market rates, those kind of things, would be to get at a way of accountability. And so we borrowed that. And I didn't come up with this idea. These were actually academic experts. And then we looked into it afterwards. And it made sense to have some kind of structure so that you couldn't pull out, $1.5 million in administrative salaries, for the administrator, for one person per year, and then turn around and say, well, I'm not making enough money to provide a decent staffing for my residents or to pay a livable wage for my staff.
Is this predominantly a problem on the for-profit side, or are there facilities on the not-for-profit side that are doing this sort of thing?
Yes, to both. I think it's more predominant on the for-profit side, but I think that there are facilities in the not-for-profit side that are increasingly sophisticated in their financial structure, and that money is not going necessarily to provide resident care.
Okay.
Your time is up, Assembly Member.
That's fine. Thanks.
Of course, Senator, followed up by Senator Rachel May, recognized for 5 minutes.
Thank you. And thanks for this testimony. Ms. Farrell, I can't believe this. What a time to be new in this job. This must be amazingly difficult. I had a number of questions about the Ombuds program. I want you to know that I fought really hard in the budget before the pandemic exploded for more funding for this program. And this has been on my mind for a long time. So first of all, just a simple question. How well do you think residents and their families know about the Ombuds program?
I think it could be shared more widely. I think, the nursing homes and other long-term care facilities are provided with the information, the contact information. There are posters in every facility. But I really think until there's a crisis, unfortunately, this pandemic is the worst crisis you can imagine, that people, then ask for the number. But I think that it could be shared more widely with families and with the community, frankly, so that people know if they know someone in a nursing home that has an issue, that they can call us. And we're trying to do that, the Ombudsman's office, but we have a very small budget, and I think getting the word out is really important.
Right. I asked repeatedly for the governor to say something about it in his press conferences, just so people would know, but I don't think it worked. So another question was about your access to information. So we heard about problems with infection control plans at different facilities. I know you're working with the residents and their families, but do you have access to that kind of information, like facility-wide information about something like, do they have a plan in place and are they following it?
Well, that's why in my recommendations, I asked that that be considered a recommendation that there be an emergency preparedness plan in place. What I heard from families of residents was that they could not get access to that. They didn't know what the facility's plans were and they wanted to know. And also if representatives of residents can be on the local emergency preparedness teams or have some contact with them, because getting that information is critical to family decisions. I mean, unfortunately, some families would have taken a loved one out and the loved one passed away from COVID-19 because they didn't have information quickly enough. So
Sure.
it's really,
but I was more asking, as an ombudsperson, do you have access even?
no, no, I have what the Department of Health has shared, that information. The information that I received on infections in facilities, I received from resident families who were more in touch with people inside, with staff, and with others. So I sometimes got information even before the Department of Health, maybe when people called, but they were guesstimates. They didn't have exact numbers, but we knew what facilities had quite a few infections.
Right. And this is a big question, and I know you're new, but do you think the ombuds program should be independent of the state, of the executive? Is that something you can comment on?
Well, it is in federal, it's a federal state partnership, and it is an independent program.
Okay, well, but
Although it's
by the state
it
office
does-
for the aging.
It does sit within that office, but we
Yeah.
are supposed to operate independently.
Do you feel that you do?
I'm too new, I think, to really make a judgment.
Probably so. Okay, one more question, because you talked about the virtual visits kind of working in this period. And I've heard a lot about volunteers, that it's hard to recruit new volunteers. And often I'm upstate, they have to travel long distances to get to facilities and they're volunteers. So it takes a lot of time. Do you see virtual visits as something that will continue to be used in the future beyond the pandemic and could be effective, or should the visits be in person?
I think virtual visits are important to maintain as a tool, but I think there's nothing that replaces in-person visits or human connections. I think we can use technology as a tool. And certainly if we can't get in to do a FaceTime with a resident and with their family is helpful, and certainly was helpful during the pandemic and should be a part of planning. But I think, if we can get and recruit volunteers and have more staff to get into the facilities, that's really important, because the residents in the facilities, I haven't, been with the program too long, but I know from our volunteers and other ombudsmen that the residents trust the ombudsman and will share things that they might not share with others. So I think it's really.
Thank you, Ms. Farrell.
Yeah,
Thank you.
Thank you.
Thank you, Senator. Assembly.
Thank you, Senator. I will go next. And my first question is for you, Ms. Farrell, and it's following up on the Ombudsperson program. We really need to change the name of that, by the way, so that it's gender neutral at best. But that being said, so this is a federal and a state program, correct? And if I understood your response to Senator Skoufis, the bar for ombudspersons from going into facilities, that was federally required in the beginning, is that true?
Yes.
Okay, and that requirement no longer exists. So are ombudspersons going in facilities today?
They are not yet going in. I think the department has given approved and given guidance to allow ombudsmen to go in. There are issues around testing and PPE and other issues that really I'm not, at liberty to address what stage they're at, but I know there's guidance being developed actually implement visits going forward, but that's not happening yet.
Okay, so if you know, so we currently have a visitation guideline, 28 days of no test positives, and you're allowed visitations. Would not the ombudsperson fit under that guideline?
Yes.
Okay, so, but as far as you know, for instance, I just had a facility right up the street from my home who had met that requirement, and unfortunately now they've had 2 staff people test positive. So now they're starting the 28 days all over again. Are you not aware of any facility that has met that requirement where an ombudsperson has gone in already?
No, I mean, there are requirements, as you know, for the staff to be tested, but there are also requirements, and this is really a Office of the State Long-Term Care Ombudsman question. Or Richard, if you want to address it, but there are requirements for tests every week, the ombudsman. And how that's going to be implemented is not clear yet.
All right, so just so I understand it correctly, as far as you're aware, ombudspersons are not going into facilities as of this date.
Not in my region. No.
Okay, all right. And Richard, I lost you on the screen. Oh, there you are. Richard, are you aware of ombudspersons going into facilities in any locations?
Not in New York State.
Okay.
But just to clarify, very quickly, there's a difference between allowing a plan for allowing facilities to have visitors and a plan to allow ombudsman in. Okay. So there's a distinction there. So what DOH did was a plan to allow visitors and open it up, and they did mention the ombudsman, but then that really has to come from the long-term care ombudsman program, as Judy was saying, the state office of the ombudsman program.
And do we know where those discussions are on developing that plan?
As Judy said, I believe that they're being developed, but that would really be a question for the state ombudsman.
Okay, all right. Are either of you aware, has the Office for the Aging reached out to you in connection with this program? I mean, they're the agency in charge of oversight of this program. Have they reached out? Have they had conversations with either of you, or are you aware of conversations or communications of any nature from that agency about this program and how to fit it into the current COVID-19 in a safe and healthy way?
If I may answer that, as Judy said, the long-term care ombudsman program is housed within the State Office for the Aging, but it's required under federal rules to be run as an independent program. So it's the long-term care ombudsman, her name is Claudette Royal, would be the beginning and the end of responsibility for how the ombudsman program is run, again, under federal rules. We get a significant amount of federal money to have an ombudsman program.
I understand that, but the Office for the Aging is still responsible for the program. Is that not true?
The Office of the Aging houses the program, but the Office for the Aging does not have substantive control over the program.
Another reason we should move it to the Department of Health, I suppose.
I wouldn't agree with that.
No? Okay.
No.
All right. So well, probably there'd be conflicts there. I understand.
It has to be independent.
So, yeah, the idea of independence, I get it. I misspoke. Thank you. All right. I would love to learn more, Richard, about what you were talking about, the difference between profit and not-for-profit and the responses and what's happening from a profit motivation. But my time's up.
Yep.
So I will yield.
Unfortunately, you will have to, that you could always submit it in writing for Mr. Mala to respond in the future. Passing to the Senate, recognize Senator Metzger for 3 minutes.
Thank you. Thank you so much. Okay, first I have a question for Richard. Sorry, I'm trying to get my video on. Richard, you had mentioned that those for-profit nursing homes outcomes for residents fared worse than for those that were not for profit or state owned. Is that correct?
Mm-hmm.
One two questions. One is, do you have a study, like, is this data available that can be shared? That's one question. And secondly, what do you contribute, or what are the main factors? Is it staffing? Is it understaffing? Like, what are the main factors involved? I'm very concerned because there's actually, in my district, a county is considering selling its nursing home right now, which I have really major concerns about. And this data is important.
Thank you. Well, and those are really great questions. So we're embarking on a larger study to assess the data. As people before mentioned, there's federal data that's coming out, and of course the state data, which only provides data on deaths. There's now more robust federal reporting. In any case, so we, in anticipation of the hearing, we did some quick analyses, and those are the results of those analyses, and I could of course share those data. There are not a lot of the county-based nursing homes, but as I recall, when I looked at, and I haven't looked at them this the past 4 hours or so, but as I recall, the county-based nursing homes actually did even better than the not-for-profit / county-based overall. But there was a clear delineation, and that is probably true to the fact that the not-for-profit and county nursing homes tend to put more money into resident care and tend to have higher staffing levels. So there are good nursing homes on both ends.
County nursing.
County nursing homes and not-for-profits both put more money into resident care and into staffing, which, as someone mentioned earlier, was about 80% of the resident care costs anyway.
Yeah. Okay. Thanks. And do I have time to ask a question of Judy, Mr. Chair?
Wait, if you keep asking it until the time runs out.
All right. Judy, I just is there? I'm very concerned about the lack of visitation. This has come up as a theme constantly. Even for within the current guidance, I mean, I just don't understand the ban on outdoor visitation. It seems like that would be safer. And I mean, what do you think about that?
I think some facilities are doing that already. But I do think you're right. This issue of visitation has to be solved. We have to get our best minds together because it is impacting the mental health of residents and their families.
Okay.
Thank you so much, Judy. Thank you so much, Senator. Assembly?
Yes, next I recognize Co-Chair Assembly Member McDonald for 5 minutes.
Thank you, Harry and Judy and Richard. Thank you for being here. Judy, Harry already asked my question, so you're good. You're off the hook, I guess.
Okay.
Richard, you may have heard my question earlier with Dr. Zucker, and I understand you've got your ear to the ground. Psychotropic use with our residents in the long-term care facilities, what are you hearing? I'm hearing through the pharmacy community that it's up significantly, and I'm just curious what your reflections are.
Thanks. And this is one of our biggest advocacy issues is the inappropriate overuse of antipsychotics and other psychotropic medications. And that is what we are hearing. So the data we have for this time period right now, it's all anecdotal. I just want to be very careful because we do a lot of policy research on this using federal MDS data. So we don't have great data, but the reports I'm hearing over and over again is of residents being drugged, residents appearing drugged, residents being told that they need these drugs, essentially, rather than receiving appropriate care. And I just want to quickly mention that a lot of the rules have been relaxed for nursing homes over this time period, but the right to be free from unnecessary drugs, the right to be free from chemical restraints, and the right to be treated with dignity have not been relaxed. So nursing homes still have a responsibility to do that. I know we're not going to get everyone together for a game of bingo or whatever, but there's other things that they can be doing, which too often is not going on.
I've gotten a variety of emails from not only constituents here in the capital region, but throughout the state. And the impression I'm getting, which is you can understand why people feel isolated, is that they're barely able to leave their room. Is that true?
Yes, and it doesn't have to be that way. Again, nursing homes were never an appropriate setting to let steam off of the hospital situation. They just weren't. And that's why we brought in the SHIP. That's why we set up hospitals. That's why we still have units around the state. It's one of the most infuriating and appalling things to me in the 18 plus years I've been at the coalition, is to see residents essentially imprisoned in their facilities for month after month after month after month. Nursing homes are not a mass unit in a war zone. This is just completely inappropriate.
Yeah.
As everyone has said throughout the day, it is physically, clinically harmful for people to be out of touch, to be isolated, and to be neglected in this way.
Thank you both.
Thank you for raising that.
Thank you, Assemblymember. Now moving on to recognizing Senator Serino for 5 minutes.
Sorry about that. Just took me a second to get there. Thank you both so much for being here and for all of the hard work that you do. At the start of the pandemic, I immediately heard from my local ombudsman who was working overtime to help keep families connected to their loved ones. And we're so grateful for all of your services. She brought to my attention that many of our state's volunteers are seniors themselves, which you guys had spoken about, and would not have been able to safely enter these facilities, even if they were allowed to. So we immediately saw a dangerous gap that needed to be filled, and we can all agree upon that. So we came up with a proposal. I introduced legislation to create an emergency public health transparency and accountability council. That council would be charged with creating a direct 24/7 hotline, collecting and investigating reports of problems or COVID-19 guidelines not being followed in any facilities. The idea was that those who were allowed in could continue to be the confidential eyes and ears in these facilities. The bill expressly required the long-term care ombudsman to be a member of that commission, so their experience could be leveraged to best protect these residents. That proposal, like so many others, was completely ignored. We also know that the state has failed to provide enough resources to bolster the ombudsman program, and I also carry legislation to incentivize more there as well. But I'm wondering, what do you think we can do going forward to ensure that there is a patient advocate on the ground advocating for patients and their loved ones? It's for either one of you to answer.
Judy, do you want to?
Sure. I do think that the advocates and the resident representatives have to be part of any local emergency preparedness planning. I think after 9/11, we learned that, being prepared, you never know the pandemic. We didn't expect it to be as horrifying as it is. But I think if we're communicating with the emergency services and all the first responders and everyone that's going in to assist facilities, that we can communicate to the residents what's going on in their community. So I think and to their families, their loved ones, because they really want to know. They see things on the news and they panic and they're living in fear, but we can reassure them or we could share information, and that's really comforting.
I would just quickly add, and Senator Serino, you've been a strong supporter of this for many years. I know personally that we clearly need to be adding funding and support for the long-term care ombudsman program. And I thank you and Senator May for that support. Of course, others who are here as well. But it is so clear. We've been calling for this for several years. I did research on funding 6-7 years ago now that found that New York is one of the states that least funds their long-term care ombudsman program. The New York State Comptroller's Office did a similar study about 2 years ago, which found roughly the same thing. And this shows we really need to have professional staff because, as you mentioned, a lot of volunteers are seniors themselves, and it may be a long time before it's safe for them to be going into facilities. We need to have the professional staff there to answer questions and advocate.
Thank you, Richard. And I actually also introduced legislation that would provide grant funding to these facilities to hire staff solely dedicated to answering calls and answering questions from loved ones and ombudsmen, so that there was no logjam and there was no staff being pulled away, right? Because that happens from taking care of the patients. That proposal to date has been completely ignored as well. But thank you so much for your time today. Thank you.
Thank you.
Thank you, Senator. Assembly?
Yes, recognize Assemblymember Jake Ashby for 5 minutes.
Thank you, Mr. Chairman. Quick question for Richard. Earlier, when you were talking with Assemblyman McDonald, we were talking about how inactive some of the population in our nursing homes have become. And I'm wondering, have you seen this on kind of a larger scale in terms of their functional ability, and how has it impacted, or has it impacted their ability to be discharged? Some of the patients aren't necessarily there for long-term care, they're there for short-term rehab, or they get to the point where they can go home or should be able to, or leave the facility, maybe not go home, but go somewhere else to an alternative level of care. Do you feel like their functional ability has been impacted to where that's not happening?
Yes, and again, I want to be careful because everything I hear is either it's anecdotal. It's from hearing from ombudsman and hearing from family members, et cetera, over the last 5 months. So we don't have good data on this, which we are constantly calling for and urge you all to call for as well. For good data on what's going on in nursing homes, as you did earlier with the commissioner. But I think that's the kind of thing we hear. People that went into a facility for rehab services and they are confined to their bed, put in a double diaper. And so not only are they not getting the therapy services that they need and went in for, but they're losing their ability to be continent. The nursing home, refusing to even take them to the bathroom to maintain continence. Those, and of course, a lot of residents who we're seeing with malnourishment and dehydration. As I mentioned before, a lot of reports of widespread drugging of residents. And so all those things lead to a deterioration and a lack of ability to get out of the nursing home.
Yeah, I would be very curious to know, in terms of the patients or residents that went in for short-term rehab and were expected to go home and had a discharge plan in place, and then secondary to the sedentary lifestyle of now not being able to leave your room, right? Or if you are receiving rehab, are you able to go to the gym, the rehab gym in the facility? Or are you confined to your room for rehab services, and the impact of quality of services that's happening there? And then, on top of that, what counts as a safe discharge at this point? Can you do a home eval from a nursing home? Or is everybody, because of the restrictions, we're not able to get therapists, are not able to get into these people's homes and make sure that it's a safe discharge environment? I mean, there could be a lot going on here that's compounding problems for not only nursing homes, but for the families and residents as well.
Absolutely. Thank you.
Thank you.
All righty. Thank you. Some member now recognizing Senator Tom O'Mara for 5 minutes.
Thank you, Chairman. Thank you both for your testimony today, and much thanks for what you do as ombudsman and helping those programs operate on such limited budgets. I know in my region of the state that I represent, our ombudsman's program covers 5 counties. I think they have 1 paid staff person and rely on volunteers for the rest of it. It's just woeful. So it's very inadequate coverage on providing ombudsman. And when you can get a volunteer, it's likely related to somebody that is willing to do some extra work while they're visiting a facility where their own loved one is, and perhaps after that loved one is no longer passes away in the nursing home, is no longer a resident, they kind of lose interest and fall off the volunteer list for continuing those efforts. So I agree we need a lot more effort put into bolstering these programs to help with that. What is your sense, if you have one, in the areas that you represent? We've talked about there's a 20% vacancy rate, or down in occupancy, the census of our nursing homes. Probably a little less than half of that number are actual deaths that occurred in nursing homes. What is your sense of the breakdown of the other vacancies in the nursing homes that have been resulted. I assume there's some that were taken out, some residents taken out back to their homes where that was feasible. But there was also those that were transferred to hospitals with COVID that died there of COVID, and they're not in our counts, as well as probably those deaths that have occurred. And there just is a lack of sending a loved one to a nursing home right now because of the conditions under COVID, and people are dealing with that more at home, hopefully. But what's your sense on the breakdown of that those extra vacancies, as far as what you would consider were deaths that occurred in hospitals or individuals that were checked out of the nursing facility?
I don't, this is Richard. I don't think there's really any good way to, I mean, the department may have data, as was discussed, with the commissioner earlier, but that would be the only way, I think, to speak about those issues. They're important, but I think we should be careful and really expect the department to come out with that information to the best of its ability. We're still not getting a lot of information. We still don't know cases among staff. We still don't know suspected cases. As many have discussed, we still don't know who was sent to by ambulance to a hospital and died there when really they were sick and whatever. They were led to death's door by the nursing home, and then they went on to the hospital and died there.
Well, thank you for that. I'm not trying to.
Sorry.
I'm trying to not put you on the spot, but I was hoping you might have something anecdotally on that because of the lack of the Commissioner of Health being forthcoming in that information, despite having 2 weeks to prepare for this hearing and coming in with no numbers as far as deaths in hospitals. But let me ask you one thing. What do you see in the facilities, their ability to help with the residents, make that electronic or computerized contact with loved ones, since nobody can visit? Are you finding enough assistance, what you're hearing in the homes, on allowing or helping an individual get set up to do a Zoom teleconference of sorts with a family member?
It really varies across the state. So some nursing homes are really doing a good job. I heard of one nursing home that was actually, after the economy tanked in early April, they hired people who had worked in entertainment and to help residents so that they could do that safely and bring in staff that were not clinicians, but that could provide that kind of help. But we also hear, over and over again of nursing home residents being told that they can't get help with even turning on an iPhone, that the staff just utterly refuses, doesn't have time, whatever, that of phones and things being lost. It is the nursing home's responsibility to make sure that those things don't happen. They're the ones in total control of the situation. And then in respect to the money going out, that's actually something that we and other resident advocates had advocated for. That's federal money that the commissioner had mentioned. It's a federal civil money penalty funds that every state is getting to give out to nursing homes. So we're looking forward to that.
Very quickly, and my time is just about up, but do you have any thoughts on allowing a resident or family members to place a surveillance camera in the resident's room with the consent of the patient, obviously, since there is no access from either ombudsman or...
You could answer that question quickly?
Sure. So we support that very carefully and respectfully for the resident. So there's certain ways in which it has to be done. And then just very quickly, there are actually other equipment that we know of that allows, and it's actually, I know someone who's using it in New York, who allows you to communicate, the resident to communicate in a very easy way, a two-way with their family members.
Thank you, Mr. Mullins.
Thank you very much.
Thank you, Senator. Assembly?
Thank you, Senator. I next recognize Assembly Member Tom Abenati for 3 minutes.
Oh, I'm sorry. Well, okay.
You ready, Tom?
I think I'm next. Hold on. Yep, I'm here. Talk to you soon. Thank you. Yes, hi there. Thank you very much. I just want to emphasize one thing. Did you say that visitors are delayed from entering long-term care facilities because of an increase in COVID among staff? Am I hearing that correctly?
I didn't say that, but what the guidelines are, first of all, there are federal guidelines, And then within those federal guidelines, the states can have set up guidelines. And what the department did was they set up very, very conservative guidance within what the feds allowed. So essentially, because I think that, people are very, and you're of course very interested in this, is that the whole 28 days, et cetera, that was for internal visits under the federal rules. What the state has done, and we urge them not to do this, was to open it up more, but they did this for external and internal visits. So as Judy said, some facilities,
visitors, including you guys, are being penalized because the staff might be out partying or coming across people who have, or from other jobs or whatever. The staff is transmitting it to each other or whatever. Everybody else is being excluded forever. Am I understanding this correctly?
Yeah, well, I don't want to speak about whether the staff are out partying or something, but I think that, as I said from the start, we said before it got to such a disastrous proportion in New York State that it could be done safely. If staff could come in, as you're saying, that family members could come in also. Think about it. Family member only wants to visit his or her loved one. Staff go in and out of different rooms. They're providing care, et cetera. So now that it's, we've got it under control here, we think that it should be reopened safely, but we actually put together a blueprint for doing that. I know several people have.
Can you send that to us? Can you make sure it gets distributed to all of us?
Yeah.
Thank you. Secondly, what's the definition of long-term care that you guys represent? Do you include only the healthcare facilities, or do you also include things like places for people with disabilities, developmental disabilities, et cetera?
No. So we principally, originally we were the Nursing Home Community Coalition of New York State, and now we do both national work, and since more people are getting care in assisted living, adult care facilities, we have over the last 18 or so years added that under our umbrella. But my focus,
the same rules being applied to all of those facilities that are being applied to nursing homes?
Say it again. I'm sorry.
Are the same prohibition on visitors being applied to all of those facilities? We've been basically talking about nursing homes by and large, but are the same are visitors being prohibited?
I believe so. Just very quickly, the federal rules only go to nursing homes. Everything that happens in adult care facilities is up to you guys and the governor, because there are no federal rules for adult care facilities. It's only state rules. So DOH has whatever it wants to do, it can do in the adult care world.
Thank you, Mr. Mollett. Thank you, Assembly Member.
Yes, we have one last questioner, Assembly Member Missy Miller. You have 3 minutes.
Yes, hi. I would like to start by thanking you both for being here, and thank you for what you do for this population. I have 2 questions, very brief. One, you spoke about, the impact that, or the effect that it's having on the residents in the homes, isolation, they haven't seen their family members, they're not getting out and around. But there's also a population of children in children's facilities, long-term skilled care facilities, who haven't been able to see their parents in months, which, is unbelievably critical to somebody's rehabilitation, especially children. Have you heard much about that from families about that population?
Yes, we have, and just the concerns that you're raising, frankly, about those children who are at enormous risk and are very vulnerable, and who count on their family members, obviously, to visit them, to provide, just as with adults and the elderly, to provide often care and monitoring.
Right. And I know I've heard from one in particular that one of these facilities, a hospital for children, who's had absolutely 0 patients test positive, none. It's all just staff, and it's the 28-day limit that's, stopping anybody from moving forward. As far as the ombudsman, I, as a parent of a medically fragile child who spends lots of time in and out of hospitals, I am always a big advocate. And I tell people when I find that I get a lot of calls in my assembly office that I believe would have been helped by an ombudsman, but families still just don't know about them. So I think we have to do a better job of getting that word out. It somehow is missing. And then my last question is just philosophical. We all know we're advocating, we're fighting for the people who have the quietest voices here. Do you guys feel that you are getting heard by Department of Health, by the governor's office, by anybody that's making decisions?
No, to be perfectly blunt, I was kind of disturbed to hear early this morning that the provider industry, not only individual nursing homes, but the lobby associations, the lobbyists for the nursing homes meet with DOH regularly about these things. As I said, we have a blueprint. We have long represented residents in this state, and I have never received a phone call or request for even information. I think we provide some, valuable data as well as insights, and no, never.
Thank you.
Thank you, Assembly Member. Thank you, Mr. Mollett. I believe that is all the questioners that we have on both sides. You folks may go back to your normal days. Au revoir. We are moving on to panel 4. That will be Roxanne Tina Nelson, who is the interim president of the Continuing Care Leadership Council. Lisa Newcomb, who's the executive director of the Empire State Association of Assisted Living. And John Auerbach, hope I'm pronouncing that correctly, President and CEO of Trust for America's Health. Monsieur Gottfried, we cannot hear you.
Then, if they're all here, then I will ask them each, do you swear or affirm that the testimony you're about to give is true?
I do. I do.
Okay, fire away.
So I guess, Lisa, I can start. I'm Roxanne Tina Nelson, interim president of the Continuing Care Leadership Coalition, which represents exclusively the not-for-profit and public long-term care providers in the New York metropolitan area and beyond. Our members represent the full continuum of long-term care, including skilled nursing and post-acute care, and a variety of home and community-based services. We definitely appreciate the opportunity to provide testimony to the Senate and Assembly committees today. I am here to offer 3 points. 1, our mission-driven members saved lives, thousands of lives, at least 3,200, helping 74% of some of the sickest patients with COVID recover. It took dedication that started long before COVID-19 came to New York, and that resulted from tirelessly answering the call of their missions every single day. 2, our members are essential to preparing for what comes next. The virus disproportionately came after our patients and the people who care for them, and we must be a central part of any preparedness planning with the ability to share many best practices from our experience this spring. 3, we need your support to continue our commitment to taking care of older and disabled people. We must protect the financial and the psychosocial well-being of the long-term care community to stabilize our healthcare system and remain ready for the coming weeks and months. First, how did we save lives? We had a baseline of high performance. Long before the global community began detecting this novel virus, CCLC members have been focused on quality improvement with a very strong track record of high performance on federal and state quality measures, as seen in attachment 1 of my written testimony beginning on page 7. Another contribution of high performance is our members' investment in their workforce. In attachment 2, we show an example of CCLC's disproportionate commitment to highly qualified clinical staff, in this case, attending physicians, raising the bar for New York, a commitment that carries forward for the other staff categories listed in that attachment. Additionally, CCLC has been deeply committed to emergency preparedness and response in the region, serving as a long-term care lead for a wide range of preparedness education and exercises, which also contributed to the lives saved and what went right. Second, why are we essential to preparing for what comes next? We did not shy away from finding solutions to the biggest challenges. 3 examples of best practices include focusing on clinical excellence and testing to quickly create safe environments focused on infection prevention and on well-trained, committed staff. Building capacities to create safe, distinct units for those needing medically complex rehabilitation, including the provision of specialty care uniquely tied to COVID illness, such as ventilator support. Supporting creative solutions to engage staff in their communities with car parades, family video conferences, robotic solutions to check vitals or provide pet therapy, and virtual offerings of music, caregiver support, and religious services, to name a few. Finally, why do we need your support? Prior to the arrival of the virus, our members were already financially fragile, and the crisis has exacerbated these financial pressures due to decreased occupancy and increased expenses. Attachment 3 demonstrates this with regard to occupancy rates, which we've talked about a little bit in this hearing already, 22 percentage point decrease, looking at $2 million for many members, up to 5.6 for one from April through June. Additionally, members had a similar magnitude of millions of losses for the costs that we've been talking about on PPE and personnel and such. And as the pandemic carries on, the losses just continue to mount. Although the federal government has allocated some provider relief, the funds that have come to long-term care have been highly insufficient, particularly for providers largely caring for Medicaid beneficiaries. Also, our members have had to navigate massive regulatory burdens, as seen in attachment 4. Last but not least, a significant cost that has yet to be quantified is the mental health impact of our sector. We contend that we must meet these challenges head on in order to maintain a strong, compassionate, and high-performing long-term care community. We respectfully recommend prioritizing older and disabled people for decisions on PPE testing, vaccination strategies, and any related funding, to maintain strong provider and staff liability protections, and to thank the long-term care community for what they have done and what they do every day to care for our most vulnerable New Yorkers. Thank you.
Perfect timing. Thank you so much. I have either Lisa or
Yes.
Ms. Newcomb or Mr. Auerbach.
Good afternoon. Thank you for the opportunity to testify on behalf of the over 300 adult care facilities, ACFs, who are members of the Empire State Association of Assisted Living, and the more than 30,000 senior residents that they serve. Our members include both private pay communities whose residents use their own funds to pay, and low-income communities in which our members rely nearly entirely on a fixed SSI subsidy, which has largely been unchanged since 2007. It's not possible to read my entire testimony in the 5-minute limit. I will summarize here, but I implore you to read the testimony in entirety. First and foremost, I just want to give a shout out. The ACF providers and their staff are the truly unsung heroes in the fight to protect our residents. They deserve acknowledgement, gratitude, and government support. There are not enough words to sufficiently thank them. The assisted living model combines independence, choice, and privacy with personalized supportive care in a congregate residential setting. Assisted living residents generally require some assistance with activities of daily living, usually do not require round-the-clock skilled nursing care. ACF residents are generally healthier, more independent, active, and mobile than those in nursing homes. In normal times, they move freely throughout the inner and outer communities. COVID-19 data, as reported by the Department of Health, reflects that the virus has had a substantially greater impact on the nursing home population. There are far fewer COVID cases and deaths in licensed adult care facilities. The public data through July 28th is that there have been a total of 6,403 nursing home deaths and 175 ACF resident deaths. Unfortunately, as has frequently been the case, the unique features of the ACF population and the reimbursement we receive has not been fully appreciated and in many cases has been ignored. In virtually every instance, the assisted living industry is treated identical to the nursing home industry. This repeated linking of the two in written directives and general policy has caused confusion for everyone. It is important that state guidance be tailored specifically to ACFs based on the unique needs of residents and the unique features of the ACF industry, even if there are some parallels. Want to talk a little bit about funding. The lack of or thereof of funding support for ACFs must be rectified. ACFs have been largely left out of all state and federal funding available to nursing homes and other healthcare providers during this crisis. 2/3 of ACF providers have received no funding from government to help offset COVID, not even for that technology support that you were talking about. ACFs who serve our most financially vulnerable seniors on SSI operate on a limited budget that has remained at $41 a day for a decade. In that time, costs in every area of operation has skyrocketed, and now COVID costs threaten their very existence. This is unconscionable. Even providers and residents in private pay settings can absorb only so much additional cost before they find themselves in heightened financial distress that could ultimately put some out of business. So we ask for your support in securing funding for all ACF providers. A little bit about testing. It's critically important, testing our employees, but the average cost is $100 per test, and that equates to thousands of dollars per week for even a smaller ACF and tens of thousands per week for larger ones. With increased national testing, there is increasing delay in receiving results, 7 to 9 days sometimes, severely lessening the value of the information. To routinely incur such significant costs when it can be too late to effectively use the results is pointless and unsustainable. Due to the significantly lower incidence of cases and fatalities in ACFs, ESAL will make recommendations to the administration moving forward about reducing the testing of frequency for ACFs, especially that have not had any recent employee cases. One other thing about testing, ACF should only have to test and pay for their own employees, not those of vendors or other licensed providers who deliver services in their building. It is unfair to shift costs to the ACF who has received the least amount of funding. Distribution of PPE, our association our members struggled to obtain the critically needed PPE. I know I'm running out of time. ESAL desperately appealed to government during that process. Once it did become available in New York City, ESAL actually took the responsibility of securing pickup sites and manning.
Thank you so much, Ms. Newcomb. Your testimony will be included in the record in its entirety.
Thank you.
Thank you so much. Starbeck? You are on mute, sir.
Unmute.
There you go. Now you're good.
Great, thank you. Good afternoon. My name is John Auerbach, and I'm currently the president and CEO of Trust for America's Health. We're a 20-year-old nonprofit, nonpartisan, Washington, D.C.-based public health and prevention organization, and we deal with issues such as emergency preparedness and response and the health and well-being of older adults. I'm also a former city and state health commissioner and a former associate director of the CDC. Part of our work has been to examine how each state is doing with response to COVID-19. And we have been impressed by both the skill and the effectiveness of the New York State Department of Health. Its adoption of evidence-based practices and policies have contributed significantly to the decline in new cases in the state at the present time. Sound policy was difficult, particularly in the early days and weeks of COVID's arrival, because of the uniqueness of the virus and the limitations of the appropriate protective measures within most of the nation's and the state's nursing homes. And it appears that the lack of such procedures led to the unintentional introduction of the virus into nursing homes as a result of workers and our family members who are COVID positive with either asymptomatic or mild to moderate symptoms. Contributing to this early spread was the minimization of risk by the federal government and delays in test availability and restrictive federal guidelines, which meant that too few were tested and transmission was missed. I believe that the roots of this problem aren't state specific, but in fact are part of a series of problems, including the cuts to federal emergency preparedness funding, the general underfunding of public health when not in the midst of a crisis, and due as well to a general lack of attention to the health and well-being of older adults. Nursing homes receive insufficient reimbursement, and that contributes to inadequate pay for and training of their workers. And the current model of care makes it challenging to provide the highest quality of care when faced with a pandemic. As COVID spread in New York State, like other states, it was faced with rapidly increasing cases and rising hospital occupancy. And it was faced to make difficult decisions with how to best care for patients while they were ill and infectious, and later when they were no longer infectious and recovering. There are times when patients get stuck in acute care hospitals when they don't need hospital care because step down or other facilities are either unwilling or unable to care for them. And this is problematic because it means hospital beds aren't available for others who need them, as well as because it keeps patients in a setting that isn't particularly helpful or healthy for them. It seems that the decisions to return non-infectious post-COVID patients to the skilled nursing facilities and admit patients with suspect COVID to a nursing home, to nursing homes that were prepared to isolate them appropriately from other residents were reasonable ones, as long as the patients returned or admitted were cared for properly and the proper precautions were taken. Such a policy shouldn't offer any risk to other patients in nursing homes, and the data I've seen seems to reinforce that. We believe at Trust for America's Health that the best way to learn from the lessons of the last few months is to think critically about what we need to do in terms of improving long-term care and the health and well-being of older adults. We think that we should be examining the reconfiguring of long-term care and placing greater emphasis on older adults remaining at home and aging in place. When that isn't possible, more attention should be paid to aligning nursing homes with acute care facilities, perhaps functioning as extended or step-down wings of hospitals where infection procedures may be more routine. This reconfiguration would require a business model for nursing homes where reimbursement is more comparable to that of a hospital, and it would require reimbursement for more intensive home and community-based services and support for caregivers. It also requires examining our support for public health agencies and ensuring that they have the funds that are needed. These changes may seem big and like pipe dreams, but they're actually those in Washington, D.C. who are now beginning to have those discussions. A group was set up at CMS to begin such discussions. At the National Academy of Medicine, there also is a convening to look at these issues. The lessons of COVID-19 involve recognizing you can't reduce illnesses, injuries, and deaths without taking proactive, not reactive steps. And they can be accomplished by providing the funding, attention, prioritizing the lives and well-being of older adults, and demonstrating the willingness to make the necessary systemic changes when the models we have no longer meet the purpose. Thank you.
Thank you, sir. Recognize the assembly. Begin questions.
Yes, I recognize Assemblymember Kevin Byrne for 5 minutes.
Yes, thank you. I don't think I'm going to have to use the full 5 minutes, hopefully, famous last words. And I know you've mentioned that there was limited or apparently no state assistance for testing and PPE. I just wanted to make sure that was confirmed. I know there's more mandatory testing. And have you received any assistance from the state financially to offset those costs?
So one segment of our industry is Medicaid funded, so they had the ability to apply for funding under the CARES Act, but 2/3 of the industry has gotten no support whatsoever.
Okay, and now I know the state manufactured and disseminated a lot of PPE, hand sanitizer, all these different things more towards the height of the pandemic. A lot of it was distributed through our county health departments. Was any of that made available to your facilities as well, or was that really more for an urgent or emergency situation?
Well, it was emergent for us. They ultimately, we did get assistance for a period of time. I kind of ran out of time before, but, one of our asks is that assisted living, residents and providers should be higher on the priority list when it comes to that distribution.
No, understood. And so long as we're asking more of you, I feel like the state personally needs to do its part as well. This is a public health policy to ensure the safety of those folks that you care for. So thank you. I said I was going to be short, and oh my gosh, I got 3 minutes and 10 seconds left. Thank you. Unless you want to say anything else.
Can I have it? Can I have it? No.
Go ahead. Thank you.
Thank you, Assembly Member. To lead off in the Senate, Senator Rachel May, recognized for 5 minutes.
Thank you. And thank you all for your testimony. I wanted to direct one question to Roxanne, actually 2 questions to you. You mentioned virtual visitation. How practical do you think this is in nursing homes in terms of the availability of technology and of staff who can support residents in using it?
Our members have been extremely committed to making it work. I think one of our members, in speaking with them the other day, they did something like 4,000 video conferences with families just within their one organization over the past few months. And, we are all learning about how to do the virtual visits better and virtual communication. So, our members have been working really hard to make this kind of opportunity work. I think also some residents, for example, preferred telephone calls. So the video was disturbing or difficult. So a telephone call sometimes was even more effective for certain residents. And I think that's what's key about our members. They really focus in on the personalized way in which they communicate with their residents. Also on the home care side of things as well, working with caregivers together. Providing some resources to caregivers at home was really important on the virtual front as well.
Right. Okay. Thank you. And have you heard about an issue with the new managed long-term care policy changes that have gone into effect for people if they are in rehab in a nursing home for more than 90 days, they get dropped from their home care managed long-term care plans? Have you heard about this as a problem?
My understanding is it's not dropped. It is converting back to fee-for-service. What the state has learned in their experiment with managed long-term care for long-term care, people seeking long-term care and receiving those kinds of services, is that the way that the managed way of caring for people, for certain types of people, was really not the best way to do it. It turns out to be much more effective, or because the cost is so high to care for such sick people with multiple comorbidities. And so the state recognized, and to their credit, that managed long-term care in certain instances was not the way to go. In certain instances it may be, but in particular for those living in nursing facilities, the reverting back to the fee-for-service model made more sense, and that's our take on that.
Okay, thank you. And then I have one question for I've lost your name, the assisted living, Lisa.
Yes, Lisa.
All right. I've heard from assisted living administrators that the rules for nursing homes really shouldn't apply. Do you have any specific areas, like, is it testing, is it PPE, is it what are the most important areas where you would say there should be different criteria?
Well, I think, maybe even visitation. It gives me an opportunity to speak about visitation a little bit. Just because the prevalence is much lower based on the data that has been provided. Perhaps it's not the 28-day rule. I'll also point out, somebody earlier had mentioned that that rule is from CDC guidance, which it is, but when I looked at that was tied to phase 1 and phase 2. So I'm thinking that there are ways that the department could loosen and make visitations more flexible. You know, the other issue is that our staff, as long as they test negative, can return to work after having tested positive in 14 days. And in some cases, even less than that. So, you know, those would be more reasonable. But I think it's almost more like, you know, they put nursing home and ACF guidance together, and they're speaking kind of different languages to two very, very differently regulated entities. And it creates a lot of confusion and questions.
Okay, thank you very much.
Thank you, Senator. Assembly?
Yes, I recognize Chair Richard Gottfried for 5 minutes.
Thank you. Yeah, Mr. Auerbach, I have a couple of questions, mostly about you and the Trust for America's Health. I have to confess, I don't think I've ever heard of the Trust for America's Health. Can you tell me what it is, what it does, who funds it? Who does it have members? Are there people with whom or for whom it works? What might it have done recently that I should have known about?
Happy to do that. We are a 20-year-old nonprofit, nonpartisan group, as I mentioned earlier, based in Washington, D.C. We are entirely funded by foundations. More than a dozen foundations provide us with funding. We don't take government money and we don't take corporate money. We were established to be an independent voice for public health and prevention. We work to provide information about significant health issues, evidence-based policies and approaches. We develop a variety of different publications, and we are also involved in educating policy members of the legislature at the federal level of Congress and of the administration. And we also work closely with state public health departments and local public health departments. In terms of some of the things that we've done recently, we published several different reports this year, including a report evaluating each state's work on emergency preparedness, on the response to obesity. We're about to publish a report on climate change efforts at each state level. And we have worked, I think, effectively with both the administration and with Congress to promote certain policies that have been beneficial to states like New York in terms of receiving the resources necessary to both support public health and to combat the COVID pandemic.
Are any of the foundations that support you things that I might have heard of?
Sure. Robert Wood Johnson Foundation, Kellogg Foundation, Kaiser, Permanentes, Philanthropic Arm, Kresge Foundation, the John A. Hartford Foundation has a particular interest in healthy aging, so you might have heard of that organization. The CDC Foundation, the de Beaumont Foundation. So I hope you've heard of some of those. So.
Yep. Okay. Well, thank you.
You're welcome.
That's it.
All right. Thank you, Assembly Member. Moving on to the Senate, recognizing Senator Serino for 5 minutes.
Thank you, Chairman. And thank you all for being here today and all of the great work that you do. You care for some of the most vulnerable New Yorkers, but unfortunately, I think the assisted living industry especially has been an afterthought to the state for far too long, right? And that's only exacerbating the current problems you're facing now with this pandemic. I'm glad, Lisa, that you brought up the fact that the rate for these facilities hasn't changed since 2007. That's awful. As you know, I've carried the bill to increase that rate for some time now. And in 2018, It did pass in the Senate, but it failed to advance in the Assembly. I'd like to take this opportunity to urge my colleagues to make this initiative a top priority. These facilities, as you've heard today, can't afford to wait, and they will close, putting these vulnerable New Yorkers in an even more vulnerable position. Assemblyman Byrne touched on this as well. It is my understanding that the assisted living facilities are having tremendous difficulty covering testing costs to adhere to the state mandate. Is that right? And would you say being reimbursed for testing needs to be a top priority now?
Yes, yes. Thank you, Senator. Yes.
Thank you. And in addition to addressing this particular need, if you had to prioritize one other change to improve the state's response for this sector in particular, what would be at the top of your list? Maybe you all have some different idea or the same idea.
I think more collaboration with the association, with providers, when they're making policies. So for instance, when they were making their visitation policy, we weren't aware of, what the requirements, the rules were going to be. And, so then that came out there, and we've been fighting very hard for visitation for weeks. And finally comes out, only to find that there's like, a major obstacle. So I think the communication with us, while they're making the policy decisions rather than after.
That's true. Very good. Thank you. Anybody else have anything to add? Or
I would just support funding that is really prioritizes long-term care in a way that hasn't happened in New York State and federally, because folks, especially the not-for-profit and public community, is really extremely financially fragile, definitely before COVID. And COVID has just such a major impact on the not-for-profit and public community. So any way that the funding can be supportive of what we've been through and what we will probably go through during a time where there will be flu season, coastal storms, school reopening, all the testing costs and all of the costs that have incurred are tremendous. And the last thing we would want is for, the destruction of the organizations that are really focused on caring for older and disabled people, especially the ones that are so high performing.
If I could weigh in too, I think I would also speak to the needs of older adults who are still in their home, but have challenging times staying in their home because of social isolation, sometimes lack of food in the home, lack of other services. So I think in addition to the very important services that my colleagues on the panel are mentioning, paying attention to home-based services and supports so that we keep people as independent and as healthy as possible is critically important.
And that's very true, John. A lot of times that population gets left out of the equation as well. So thank you all so much again. A deep, heartfelt thank you for all that you do.
Thank you.
Thank you, Senator. Back to the Assembly.
Thank you. I now recognize Assembly Member Brian McDelow for 5 minutes.
Good. I want to see with Kara because I want to.
Brian, are you with us? Oh, he just,
I got it.
okay.
Thank you, Chairman. Lisa, just a couple of questions on finance. Our assisted living facilities, where do you see them in the scheme of things as far as financially secure?
Well, as I mentioned a little in my testimony, there's three segments of the industry when it comes to finances. The ones that lack the most resources are a straight SSI only building, which there aren't too many of them left. They're hanging by a thread. I mean, these additional unanticipated costs are just not sustainable for them. And even before this, we've seen them closing. You see, then we have some who also get Medicaid support on top of the SSI. That's called the Assisted Living Program, which is a wonderful program because it allows really nursing home eligible people to be able to age in place in the adult care facility. But you know, it is Medicaid. Our Medicaid rate is based on some strange formula that it's half of the nursing home rate from many, many years ago. And that's basically kind of a rate that hasn't changed either. So it keeps, you know, the SSI building afloat, but you know, they have their challenges too. And then in the private pay, we have lots of, you know, there are some for very, very wealthy people, but there are a lot, I'd say most in between are for, you know, seniors who are middle income. And, you know, they can only absorb so much additional cost, and the provider that, you know, that serves them can only absorb, you know, so much. So, you know, it does kind of run the gambit.
Okay, so I have a few assisted facilities in my district, and meeting with one of the owners, one of the issues they have is the unemployment situation right now. Right now, people can get unemployment pretty easy. They can apply for it, and the amount of money they're getting is more than the staff members are getting paid normally. Can you see a fix that we need to do from the state side there to help secure the workforce?
Well, I guess it goes back to funding again. I hate to sound like a broken record, but you know, I had an SSI provider who ended up closing. It was family owned, and they closed several buildings in the North Country. And you know, he always said, "Look, I want to pay my staff what they deserve. I want to pay them more than minimum wage or a little bit above minimum wage, but if you're only giving me $40 a day to take care of this frail elderly senior, you know, I can't do that." So, you know, I mean, I think that you know, if you have the resources, then you would be offering wages that would be beyond the 600 if you could.
Right. So when those facilities close, where do the seniors go then?
Nursing homes.
And are they able to take everyone at this point?
Well, yeah, I mean, I think that we talked about, you know, vacancies in nursing homes earlier on today. Yes, and it's just tragic because they don't really need to go to the nursing home. The assisted living is much more of an independent, you know, setting, very socially based, but they are frail elderly as well. And generally they can't really live alone. They sort of need somebody around on a 24-hour basis, you know, for supervision purposes. So the nursing home is the default.
Okay, thank you, Lisa. That's all I have.
Thank you. Assemblymember moving on to the Senate, recognizing Senator Boyle for 3 minutes.
Thank you. Thank you, Mr. Chairman. So I represent part of Long Island, and I can tell you that when this pandemic started, I had gotten a phone call from a constituent who told me that their father was in the nursing home down here, and that
we lost the senator.
Senator Boyle? Senator Boyle? All right, until we get him back, I got a couple. If we could put 5 on the clock, I won't take all of it, but thank you all for being here. One of the things that I wanted to ask about, because you've made reference to it a few times, but I think it's important to kind of really put it on the record. We can talk about all the stresses that the crisis has put on all of these facilities, but you have spoken about, and I want to give you an opportunity to kind of expand on that, on what the situation was before the crisis, that you were already put in very stressful positions. Because if there's requirements that are, if there's things that the state required of you for as institutions during a crisis time, and you had few resources to begin with, that makes it all the more difficult to be able to manage to hold on. So give us a view about that, and the rest of the time I'll give to you, but give us a view on that, and also to also give you an opportunity to tell us what are the things that would make best quality facilities be able to survive. If you could give us kind of a sense of that, I would appreciate it.
Sure. So I'm sorry, is that for Roxanne? Go ahead,
That
Roxanne.
is for anybody who wants to take it, but you can start, and Roxanne, start, you start, and then Ms. Newcomb. How about that?
Okay, so sorry, just wanted to respond that we were definitely financially fragile coming into COVID. Just so for nursing homes in our community, there was a 62-day daily shortfall in the Medicaid program. And also the margins were at negative 5.2%, all in my written testimony. For certified home health agencies, for example, on the community-based side of things, 78% of them were operating in the red. So it was a dire situation even before COVID hit. Now that we endured this spring, you add the occupancy rate, the losses due to occupancy fall, and then you add all of the expenses. And I talked a little bit about the magnitude of that in millions of dollars per facility.
Ms. Newcomb?
I would just add, I go back to where the most indigent, are living. Obviously, they were under strain before, especially the straight SSI, again, $40 a day to, provide a whole slew of services, to the residents. So they're going to go first, the ones that are left. The ones that have the Medicaid supplement and the private pays, they're all in different situations. Some, they've been absorbing it, but as each week pass and, a larger facility is going to, have thousands and thousands, maybe 10,000s, per week just for the testing. And, that's on top of the PPE and the cleaning supplies and all of that. So
You would say that to be able to have some of these facilities that provide good service, for them to be able to survive, as you talked about funding more than once, you would say that's kind of the baseline. They have to be better. The reimbursements need to be
sure.
to be
Yeah.
more.
Yes. For
Right.
those that serve people that are indigent. Yes.
Okay. Thank you so much to all of you. It seems that we have unfortunately lost Senator Boyle. We will move on to the next panel. We will make sure that whatever questions he had, we make available in writing to the panel. Thank you so much, folks. Moving on to panel 5. We just got 4 more to go, folks. Panel 5. We have Alexa Rivera, who is the co-founder of Voices for Seniors. We have, these are my cousins, by the way, lest you forget. Vivian Rivera Sayas, co-founder of Voices for Seniors. Grace Colucci, also from Voices for Seniors. Kathleen Webster, Neighbors to Save Rivington House. And Lenore Solowitz, who is a resident of Garnerville, New York. Senor Messier Gottfried, are you with us?
Yes, I am here. It just took a little doing to unmute myself. And now I'm unhidden as well. Do each of you swear or affirm that the testimony you're about to give is true?
I do.
I do.
Okay.
All right, in any order that you folks would like to continue.
You better pick.
All right, then I shall. Let's go with Alexa Rivera. She is in the car. So let's go with Vivian Rivera then. You're on mute, my friend. There you go.
Hi, good afternoon, greetings. Thank you for the opportunity.
to not only speak on behalf of my mother, but to also represent the families in the group Voices for Seniors, which is a group consisting of grieving and frustrated loved ones impacted directly by the COVID pandemic in our nursing homes. The seniors who reside in nursing homes are often there for long-term care as well as short-term care, resulting from sometimes just minor surgeries like knee surgery or neck surgery. My mother, Ana Martinez, was there for treatment for a minor wound and only expected to be there for 4 weeks. It is short-sighted for us to believe that in the future, we may also necessitate a visit at one of these very facilities. But having to do so with no family or to visit or advocate for us is truly unconscionable. Lonely and voiceless in a terrible situation and system. Every day I recount the days I could not be with my mother to advocate for her in a nursing home that stated they had taken every precaution in place to care for her, while our governor mandated they accept COVID positive patients. Many nursing homes are cited repeatedly for not having proper infectious disease protocols in place with no severe penalties. So mandating COVID positive patients to be accepted in light of this defies logic. The thought process of not discriminating against a few COVID positive patients at the expense of the COVID-free residents as a whole is dangerous and negligent. My mother and many others contracted the virus at the nursing home, and today I am still under the belief that she was unaware and uninformed as to what was happening to her. As someone who spoke limited English, it appears she was not informed as to her condition, and she never shared that information with us, who were always her best advocates. Since her unnecessary passing, I hear countless stories of others like me who are enduring the pain of not seeing their family and their loved ones and the uncertainty of their well-being. Hopeful to see them one week, and then the next week, the goalpost is moved once again with no end in sight. With the fall and winter approaching, are we really to ask families to be prepared to stay away from their loved ones for the foreseeable future? Unlike, and with all due respect, Commissioner Zucker and Governor Cuomo, who are more than likely able to see their own mothers and fathers. Elderly bewildered by the new sense of abandonment in a time they need their families the most. My mother was sad and homesick. It was the first surgery she ever had and her first visit to a nursing home. What was meant to be a 4-week stay ended up being a 2.5 months stay when the social worker and case manager failed to return our calls to finalize her discharge. When the pandemic became more prevalent and the facility did not offer us the option to discharge her before the facility closed its doors, our mother became ill, and when I detected something was terribly wrong, our mother was too ill to speak on the phone, and the staff continued to reassure us that she was fine. When we got a call that she was going home on Friday, March 27th, despite showing all the symptoms of COVID, except the fever, without telling us, and she was or telling us that she was suspected to have had COVID, they continued to reassure us and downplay her symptoms. And when she became gravely ill, they failed to escalate her care and send her to the hospital. COVID-19 has helped shed a light that while immunity is given to owners, the directors, and the staff, it is the resident, our vulnerable elderly population, that is not immune from abuse, from neglect, and from dismal care with no family or recourse. An unnecessary amount of death and carnage was inflicted on our seniors by the mandate to take COVID positive patients, to the inadequate levels of staffing and the infectious disease protocols that many facilities and time again have failed to put in place, were the true recipe for a disaster. If that weren't enough, families have been stripped of their rights to visit their loved ones and are often lied to and misled by the very leaders and staff charged with the duty to keep them safe. I'm here to ask that a true and sincere evaluation of our nursing homes take place, taking into the account the input and voices of families like my own, and that finally seniors will get the care that they are deserved, and that they no longer get the short end of the stick. Thank you so much.
Thank you. Thank you, Ms. Rivera Sayas. Alexa Rivera, I noticed that you were in a car earlier. I'm not sure if it is Quiet enough car? Ms. Rivera? All right, so we'll move on to Grace Colucci. Grace Colucci, I'm sorry. Grace Colucci.
Hi, how are you? Thank you so much for giving me the opportunity to be a voice for my father and for all the families that were affected by the COVID pandemic with people that were in the nursing homes. When the COVID-19 first appeared in the US, Governor Cuomo and Mayor de Blasio made light of the risks and encouraged people to go about their daily lives as all was well. We quickly found out that all was not well. Governor Cuomo was on TV daily making appeals for ventilators, PPE, and hospital beds. The president swiftly sent what was requested, converting the Javits Center, sending the Comfort, sending millions of tests, PPE, and more ventilators than were needed. On March 25th, under the directive of Governor Cuomo's mandate, nursing homes were not able to deny taking COVID patients, even though they housed the most vulnerable. The Javits Center and Comfort went virtually unused. Each day, the news reports were escalating numbers of new COVID cases, and the death count grew. The shortage was not hospital beds, but room at the funeral homes. Governor Cuomo stated that he wouldn't put his mother Matilda in a nursing home. I'd love to tell you about my dad, and I'm sure you can understand that he was a wonderful person who made many sacrifices for his family and his country, as well as everyone else that has been affected. My dad had suffered several heart attacks, had a valve replacement, several minor strokes that left him unable to properly cut his food or dress himself properly. He needed help. He was also developing dementia. My dad is not listed as one of the nursing home statistics because he wasn't tested until 4 days after his release. In February, he was hospitalized with aspirational pneumonia. While in the hospital, my mom was there every day to help my dad with his meal and other needs. March 19th, Dad was released and immediately sent to Gerwin Jewish Nursing and Rehabilitation Center for rehab. The COVID restrictions had just gone into place and Mom was not allowed to be there. Shortly after, she received a phone call that there was one patient and one employee who tested positive for COVID-19, but they assured her that they were in a different part of the facility and that my dad was not at risk. That turned out not to be the case. My dad was discharged April 8th, 13 pounds lighter and unable to eat after not being able to eat for so long. Dad was unable to walk. My brothers had to carry him into the car and then the house. A nurse from the nursing home came to the house twice over the next 4 days as follow-up. We found out afterwards that she was COVID positive, and who knows how many people were exposed from her entering the house. My mom and my brothers ended up a week later testing positive. On April 12th, my dad's BP plummeted. His temperature rose over 103 and his breathing was rapid and shallow. My brothers rushed him to the ER. He was given a rapid COVID test and was positive and admitted. After a long hospital stay, my dad was no longer exhibiting symptoms, but he was still testing positive. The doctors said because he couldn't eat, they recommended hospice care. We were allowed to bring him home for at-home hospice. Dad passed a week and a half later on May 24th. My mother is haunted by one of the things my dad said to her. You can eat, but I can't. If my mother was able to be with him and feed him, this may not have been a situation, and my father may not have been one of the ones that have passed. He was a very strong fighter. Every day I watched Governor Cuomo's press conferences. He went on and on how he was the one that was the benchmark on how to handle and stop the pandemic. At one press conference, he was asked, why did the nursing homes have to take the COVID patients? And he answered, because that was the rule. I think about all the families who are unable to be with their loved ones as they take their final breath, and all the families whose loved ones, not sick with COVID, but are also being deprived of seeing the people who love and sustain them. To hear Governor Cuomo turn his command that this was the rule into blaming the nursing homes, their employees, and even the families for the thousands of deaths while he went on his brother's TV show joking about COVID testing with the giant cotton swab and laughing on a late night TV show about his stage 0 dating life is a knife to my heart. We need accountability. Instead of protections being given to the nursing homes, and worse, to those who mandated the nursing homes take the COVID patients. Why did Governor Cuomo mandate that the nursing homes have to take the COVID patients when the CDC advised against that? I hope that as a result that we will be able to have a Bill of Rights for seniors, where families and seniors are given rights to be able to care for their loved ones. Pre-COVID, families were necessary in the care of their
Ma'am, if you could wrap up, your time is.
Sure. Okay.
If you
I
could
just
wrap
want to
up.
let you know that today my family is still waiting to be able to have a funeral mass and military service that my father deserves. We're not able to have my whole family, never mind friends, in attendance because of the restrictions that are still in place. Thank you for taking the time to listen to this, and I urge you to withdraw the power that you've given the governor to make these mandates all on his own and not be able to get approval from the Senate and the Assembly. Thank you.
Thank you, Ms. Colucci. Followed up by Ms. Kathleen Webster.
Thank you. First, my condolences to both Grace and Vivian. I'm Kay Webster with Neighbors to Save Rivington House. We fought to save the once largest skilled nursing home dedicated solely to those who were trying to survive AIDS. The year it opened, that mortality rate had reached an all-time high of almost 51,000 deaths. The state's dormitory authority had financed this state-of-the-art infectious disease site with $72 million in bonds. It was a nonprofit. Through a series of events, the Allure Group took it over in short order, but planned long before. They sold it for condos. Taxpayer-funded equipment was in a dumpster. Staff laid off. Patients transferred without the required 90-day notice or vetted plan. Despite this, New York State licensed the Allure Group to take over more nursing homes, one in Harlem. During the pandemic, at least 20 bodies in black bags were secretively carted out of that home, while reporting only 5 people had died of COVID. Media and staff reports from their other sites were no better. The demise of Rivington House was one of many warnings of the results of profit-focused operators and toothless oversight. The Department of Health's vetting arm is the Public Health and Health Planning Council, has 24 appointed members, many with expertise, and many have a very real potential conflict of interest. And there is but one consumer rep. There is a strong correlation of nursing home for-profit ownership and reduced quality of care, conditions that existed prior to the pandemic, shown in study after study to have exacerbated COVID-19 deaths. Over 90% of nursing homes in the US are now run for-profit. Along with those major changes in ownership structure and management, the degree of complexity has greatly increased with LLCs, et cetera. There are many ways to hide funding extracted from the care it was intended for. We need independent legal and financial experts to serve on or advise the FIPIC to develop competency and explain industry financials to the rest of us. Licensing should require financial transparency and mechanisms like medical loss ratios, empowered paid ombudsmen, et cetera. Private equity buyouts of nursing homes are linked with poor patient to nurse ratios, lower quality care, declines in patient health outcomes, and weaker performances on inspections, according to new research from the Wharton School, NYU Stern School, Chicago's Booth School of Business, and from other studies. In Connecticut, for sites with at least one confirmed case of COVID per resident day, every 20-minute increase in RN staffing was associated with 22% fewer confirmed cases of COVID. And in sites with at least one death from COVID, every 20-minute increase in RN staffing significantly predicted 26% fewer deaths. From Canada, government-owned facilities provided 61 more minutes of staffing per resident day than for-profit facilities. With the same public funding, for-profit operators failed to deliver 207,000 hours of funded care, while the not-for-profit sector delivered 80,000 more care hours than they were funded for. Facilities run on a for-profit basis had more extensive outbreaks and more COVID-related deaths than facilities run on a nonprofit basis. From California, in sites with RN staffing below the recommended minimum standard, COVID outbreaks occurred more often. They were twice as likely to have residents with COVID infections than adequately staffed facilities. Nursing homes conceal a shadowy world of concealed ownership, hedge fund operators, and private equity firms, yet they are staffed by some of the lowest paid workers in the country. This is the public's money, and we shouldn't continue to put up with secrecy. If requirements to fund adequate staffing levels hurt for-profits' profits, then it's time this care is turned over to truly nonprofit providers. Our state needs to face this reality and intervene on behalf of our most vulnerable. Too many seniors in nursing homes have no ability to fight for their lives. If they have them, their families have no strength left for advocacy. They and the best of our caregivers were left alone to handle a crisis of biblical proportion. Dr. Fauci said there were many, many, many nursing homes that got no infections. Just because you're a nursing home doesn't mean you're going to get an outbreak. It's how you have your staff and the actual structure and the standard operating procedures that have made certain nursing homes highly vulnerable. You got to fix that, and you got to fix it fast, or you don't get money. And I do want to say that the nursing homes I'm referring to were mostly peopled by Black and brown men. And I think that hasn't been said enough here, but in 5 minutes, that's what I got. But in my testimony of 13 pages, I devote some time to that. Thank you.
Thank you, Ms. Webster. Followed up by Ms. Lenore Solowitz. You're still muted, Ms. Solowitz. There you go.
Can you hear? Okay.
Yes, ma'am.
I just want to thank you today for looking into this problem. I brought my mother back to her facility on March 13th. We spoke every evening. On Tuesday, March 17th in the afternoon, my mother called me to tell me the facility was going to call me about something. They didn't tell her what it was about. I called the facility to see what was going on. They told me there was going to be a lockdown effective immediately due to COVID-19. My mother was 98 years old and completely mentally competent. She had a private room. Everyone had to stay in the room. She ate her meals in her room. And to the best of my knowledge, there was no COVID in the facility at this time. I thought she'd be safe. Little did I know the horror show that was about to unfold. The facility was completely unprepared to handle this situation. And once the COVID patients arrived, they really were in trouble. COVID patients were not separated from the residents. The facility did not have enough supplies. On a regular weekday basis, there were not enough aides to attend to the residents. Weekends were much worse. Areas were left unattended for long periods of time. When the COVID patients arrived, a lot of the staff refused to come to work. Some of the staff that stayed were catching COVID. There was a young nurse that had a miscarriage 1.5 years ago. She was 6 months pregnant. She came into work and she asked the director for a mask. And the director told her, "We don't have any masks. We're going to run out if we give you a mask." This is how unprepared they were. I visited my mother for a few times a week. Once they knew the residents had a family member coming in, they were a lot more careful. I was my mother's advocate, and I had to speak up on her behalf quite a few times. When the facility went on lockdown, they had full reign, and this is where my problems began. I called my mother to check up on her. She told me her hip hurt and nobody was taking care of her. Of course, they couldn't take care of her because they were extremely short-handed. I called and I got that settled. A few days later, she called and told me, I'm in my right mind and I know what I'm talking about. And I said to her, "Of course you are. What's the problem?" The aides didn't want to bother with her and her pain, so they told her she didn't know what she was talking about. This is what happens when you have no representation in these facilities. In addition, when I called the front desk to check on her that night, nobody answered the phone. I called at 9 p.m. and I kept calling and nobody answered till 2 a.m. Talk about stress and frustration. I called the next morning and I was told they were going to do a chest x-ray, which they did that evening. I called my mother in the afternoon to tell her about the chest x-ray. A nurse or aide answered the phone and I could hear my mother crying in the background. "It hurts, it hurts." These are the last words I heard from my mother. Our family doctor called me the next morning and told me my mother had pneumonia and she was exhibiting signs of COVID. The next morning, my doctor called to tell me my mother passed away. And her last words, "It hurts," will stay with me forever and haunt me. The residents trusted the facility to keep them safe. Here is a partial text my mother's friend sent to her. This lockdown won't be over anytime soon. They have to discover a vaccine for this virus, but at least we're safe here. Well, he got COVID. I wonder how many families would have made different arrangements for their loved ones if they had known what the Cuomo administration was going to do. This is my story. Who will be held accountable? Why wasn't I notified of COVID patients coming into the nursing home? I could have taken my mother home. Now the matriarch of our family is gone. We were 4 generations. My mother will not be here for the next family celebration. She will not get to meet her new great-grandchildren. A tremendous void was left in our lives. A very bad decision was made. How could you send COVID patients into a facility that was home to the elderly with pre-existing conditions, knowing if they got COVID, they would die? There were other facilities to send the COVID patients. There was the SS Comfort, there was the Javits Center, and there was a facility in Brooklyn that the mayor had. These facilities had room for COVID patients. Why weren't they sent there? The Cuomo administration has yet to admit any wrongdoing. They blame the workers, they blame the families of the residents, they blame the CDC, and they blame the federal government. The person to blame for the COVID deaths in the nursing home is Governor Cuomo. There was no law that said COVID patients had to be admitted to nursing homes. The governor of Florida did not allow COVID patients in nursing homes. Governor Cuomo did not follow sound science-based federal guidelines, and he made a grave mistake. In addition, he signed a bill to protect the owners of the nursing homes. Governor Cuomo said his father told him if he made a mistake, he should own up to it. Well, Governor Cuomo, own up to it. And thank you very much for your time. I appreciate it.
Thank you, Ms. Solowitz. We're going to, unfortunately, we lost Ms. Alexa Rivera. If she comes back onto the feed, we will allow her to testify. For the moment, we will move on to questions, which will be led off by the Senate, recognizing Senator Skoufis for 5 minutes.
Very much, Mr. Chairman, and to everyone who spoke, first and foremost, please accept my deepest condolences. The grief was palpable at times, and I can't imagine what you've all personally lived through, these nightmares. But I thank you, and I think we all thank you for your service, your public service in participating and sharing your stories and hopefully trying to right this ship. It's been my strong opinion for some time that the Department of Health doesn't adequately scrutinize nursing home transactions when they take place, and just as importantly, if not more importantly, doesn't adequately punish nursing homes with substantial violations. For many facilities, and I know this in working with family members and employees in the district I represent, which includes North Rockland, Orange, and part of Sullivan. Ms. Solowitz, you're a constituent. I've worked with many family members in fighting for some of these issues pre-COVID. I know that for many facilities, these fines are just the cost of doing business. And so first, Ms. Solowitz, let me actually, before I get to my question, make a statement, and that is I intend to follow up with you after this hearing. What you suggested and raised about what happened in the nursing home itself. COVID patients were not separated from the rest of the population. Complete lack of staffing, effectively taking the phone off the hook. I want to work with you to make sure that the nursing home, which I believe is the Willows in Suffern, is held accountable for the things that you described. But I want to ask you, it's my understanding that in just the past few years, that particular nursing home, the Willows, had 41 violations at their facility, including failing to have proper infection control procedures. Yet, from these 41 violations, exactly 0 enforcement actions by the Department of Health took place. In fact, the Department of Health didn't issue a single action over the past 10 years against the Willows. And so my question to you is, what would be your message in light of what you have now lived through, this nightmare? and what's happened at the nursing home, not just to you, but over these years. What would be your message to the Department of Health in better dealing with facilities like the Willows who have treated residents this way?
I think there has to be a closer relationship between the state and the nursing homes. The state comes in once a year. I've seen them, they're working in a room, they're doing paperwork, and I have not yet been approached by a state worker to ask me if anything was wrong. I'm always there. And I've seen horrible things going on. I've seen people crying and they ignore them and they walk through. If I wasn't there to speak for my mother would be laying in the bed. Nobody would come in. And there's so many different things. She rings the bell. You need an aide to come in. Okay. Another aide comes and turns the bell off. They don't want to be bothered. So you're laying there again. You try to ring your bell again. And they have a shortage of staff during the week. It's really very bad. On the weekends, it's absolutely terrible because there's like nobody there. They have a long hallway that it's supposed to be monitored. There is times there is nobody there. There's nobody outside, and you hear people screaming, "Help, help, nurse, nurse," and nobody is coming. Either they're in the lunchroom or they're someplace else. And as far as the phone goes, I cannot tell you how many times I have called and it rings and rings and rings and nobody answers. And I want to find out how my mother is. I just don't know. As I said, I started one night calling at 9 p.m. I didn't get through till 2 a.m. till somebody actually answered the phone. And I asked if I could speak to the nurse to check on her. And it's been a horror show the entire time that she's been in there. She also has allergies to food. She gets the food that has the allergies that she's allergic to, and the staff in the kitchen cannot read English. So you just get anything, and you don't even get the food you ordered because they just put anything on there. There is such a list of things that I can tell you that I just really can't go into now, but I do intend to speak to you after. And when I get all my thoughts together, I will tell you exactly all the problems that I've had while my mother was in the nursing home.
Great, thank you, and I look forward to that. I've run out of time, but I would just point out, Vivian, I know that your mother passed away in a nursing home that was cited 32 times over the past few years, and again, zero enforcement actions by the Department of Health. If at some point later in this hearing, my time is out, you find it appropriate to speak to that, please do. Thank you.
Thank you, Senator. We're Assembly.
Yes, we will recognize Assembly Member Kevin Byrne for a period of 5 minutes.
Thank you, and allow me to echo my colleagues' remarks, just extending our heartfelt condolences to all of your families for what you have gone through. I had a few other questions for our first witness I didn't get to because it was a little briefer than many of us would have liked. So I'm just going to pose some of those questions to you to see if you have any thoughts. I believe it was Mrs. Webster mentioned some of the issues at the facility where you lost your mother. Have you heard from nursing staff or any other residents or through your loved ones about the possibility of commingling of positive COVID patients with other residents?
Let me stop you there. While I did lose my mother in a nursing home quite some time ago, I don't think I'm the person you're trying to talk to. So
I might have mixed up the people that were speaking earlier. So I can ask that in generic. There was comments made about a nurse with masks not getting PPE. So have there been any other remarks from any from speaking with residents? No.
We had a nurse say that she was using her mask for the entire week, the same mask for the entire week.
Okay. All right, then I may have just misheard part of that testimony. Another question I have, most of you have been able to, were you able to follow the testimony earlier in this hearing from the health commissioner?
Yes.
Okay.
Yes.
Okay, well, Grace, I believe, hope you don't mind me calling Grace, Ms. Colucci.
That's fine.
I'd like to get your feedback on what you were able to hear from the commissioner as far as our state's involvement with the handling of the nursing homes. If you had any comments.
Well, I felt that he did not give you adequate answers to your questions while having several weeks to prepare for this hearing. I think that the nursing homes were brought with too many patients that they weren't expecting. And with the lack of having family there to be able to participate in the care of their loved ones, they were even at a further disadvantage. The nursing homes are used to having family members there to feed and take care of their loved ones. So I think he was evasive in a lot of answers and did not provide you with the tools that you will need to make a good investigation.
Oh, thank you. My hope is that somehow we get him to come to the next hearing on August 10th. But I appreciate your remarks, Grace, and all the witnesses in this round. And I will give the rest of my time to, I believe it's Vivian Rivera Zayas, to speak to the point that Senator Skoufis asked. You have my 2 minutes. He was talking about a personal story, so you can use. I think there was something that the senator mentioned. If there was time, you could use my time. If there's a personal story that affected you and your family that you'd like to share, you can use my time.
My mother was, I'm sorry, I'm hearing, I don't know if someone's trying to ask a question. My mother was in a nursing home, which was only supposed to be for a very short time. From what I understand, once she became ill, like one of the other women here said, all I heard was my mother's moans and groans of the pain and discomfort she was in. Yet every single time that I called on a daily basis, I was reassured that she was okay. I kept asking what was going on, why she couldn't talk, and they were telling me she doesn't have a fever, her vitals are okay. So when all of this happened, we were blown away by the fact that we didn't know she had contracted COVID. There's a record in her chart saying she had it. No one told us. So we were completely off guard. When on the day she was supposed to go home, we found out she can't even speak on the phone. They downplayed it to the point where they asked if she was a smoker. She was having trouble breathing. The director said he had no idea why she was having trouble breathing. She waited for about 4 hours for an x-ray when they didn't even put it in as an emergency. And several hours later, when they waited for the results, she went into respiratory distress. And she was basically on a ventilator by the evening. So we were wondering why they were going to discharge her if she was well enough to go home, according to them that morning, because we were arranging for her to go home, yet she was on a ventilator by the evening. So there's something really, really wrong here on how they were trying to discharge COVID positive patients in order for them not to have died on their watch and increase their tally. So it's criminal that you discharge a sick patient with COVID, no less, without telling the family.
Thank you, Vivian. I appreciate your remarks. And again, my condolences.
Thank you.
Thank you, Assembly Member. We will follow up by Senator May, recognized for 5 minutes.
Thank you. And my heart goes out to all of you who lost family members. It's just heartbreaking. I wanted to ask if any of you had contact with an ombudsperson in that nursing home, if you were aware of that program, if that was something that was available to you and it was helpful to you. Oh, you're muted.
Okay. I was not aware that there was such a program. I had absolutely no idea. I basically had to take care of everything myself. Whenever there was a problem, I would go in. I would talk to the nursing director, to the administrator. I basically was the advocate for my mother.
Sounds like you're kind of a de facto ombudsperson for other people too in that nursing.
Probably could be, but you know, there's so many things that have to be done with these nursing homes. I mean, an instance from my mother, there was one nurse that she was having a problem with. So my mother, as I said, she was 98, but she was totally with it. And she would count her pills. She knew if they gave her more or if they gave her less. And she would count them. There were 21 pills coming in the morning. And she said to this nurse, there's a pill missing here. She insisted there wasn't a pill missing. So there was a problem with that. Then she over-medicated her and gave her more pills. And she said, I'm not supposed to get this. I've already had this. The nurse insisted that she got that. This is like a child. Here you're taking care of somebody and you're playing around with the pills. So that's one thing that really bothered me. Then there was a nurse that wrote down that she gave the medicine and never gave the medicine.
So to me, you should be dismissed, you should be fired, is all they did was put her to the other side of the building. Whenever there was a complaint about somebody, and even if the state came in, they never fired the person. They went to the other side of the building. So here, there's incompetent people, whatever they did on the other side of the building, they're just going to do over there. So there was a lot of issues, really, and you really need to have somebody that was there to speak for you. Otherwise, you were really out of luck. You just laid in the bed. You could cry, you could scream. Nobody was coming in for you. And I've stood in my mother's room and heard so many people crying for help, and there was just nothing to do, and nobody came.
Thank you. Anybody else? Vivian, did you have an experience?
My mother had a call bell, but my sister and I went every single day to see my mother. I actually really blame the shutdowns as a contributing factor in her passing away, because she was of good health. She only had a knee surgery, went in there because she had an abscess in her thigh. Once they drained it and kept her on antibiotics at the hospital, she was transferred to Our Lady of Consolation in West Islip and was supposed to be there for extra therapy, and which we welcomed at the time. Yet when we were trying to get her out of there, I was not getting a call. They were not responding. Multiple voicemails later. I called the social worker. She would bounce me to the case manager. And I had to ask her, what is your role as a social worker if I call you and you keep transferring me to other people? Once we kept pressuring them and they saw my mother was terribly homesick, I believe that they were trying to get her out of there before she contracted the virus, but it was too late. She got it. She was transferred out. And when we found out, we were wondering why, if they've called me for minor issues, they did not call me when they knew, in fact, according to her charts, that she was exposed and that there was some kind of an exam, like a droplet precautions exam done on her. They've called me for sillier things, yet for this that was pretty deadly and very important, they did not call me.
Nobody ever told you you had the right to speak to an independent ombudsperson?
They never told me. And once my mother passed away, it seems like there's no follow-up from them. They wouldn't even give me any empathy. When I called to find out about my mother's belongings, they basically said, oh, you need housekeeping, transferred me immediately with no sense of empathy. And I was so hurt because I'm thinking, my mother was in your care for 3 months, 2 months more than what she was supposed to be. And you didn't even give me, and I'm sorry, or I'm sorry for your loss. It's a terrible system and it needs to be reformed.
Okay. Thank you so much. And I just want to thank Ms. Webster too for your written testimony. It's very helpful to know that there are not consumer advocates on the Department of Health's Public Health Council. We will look into that as well.
There's 1 and 2 on the way, but out of 24.
Right. Thank you.
Thank you, Senator. Assembly?
Yes, next we'll go to Chair Gottfried for 5 minutes, please.
Okay, thank you. Well, first of all, I want to join my colleagues in expressing our condolences to all of you who testified about the loss of your loved ones, of your family. It's just horrendous to think about. I think one thing that is clear, though, is that certainly based on some of the research that Mr. Skoufis did, that these facilities were bad news to begin with, long before the COVID virus even evolved. But I just want to say a couple of things to Ms. Webster. I want to thank you for your testimony, and the praise about ownership and dealings and for-profit, et cetera, are really important. And we've done some legislation in this area, and we intend to work on a lot more of it. I'm sure you heard Richard Mullet's testimony on that score. We'll be working with him, and we'd love to have your assistance in that as well. And just one more comment on coming off the family members who talked about never having been told about the existence of the long-term care ombudsman program. We've been calling on the department because of the lockdown on visitation and the long-term care ombudsman, people not being able to enter facilities, that facilities ought to be required to periodically, regularly notify every resident and every family member about the availability of the ombudsman program, what it does, and how to reach it. Because even in the best of times, it appears many people have little or no knowledge of it, and that's just an outrage. Whether it would have saved the lives of your family members, we can't know, but it could have made a difference. So that's all I wanted to say.
Thank you, Assembly Member. Follow up with Senator O'Mara, recognized for 5 minutes.
Thank you, Chairman. Thank you, ladies, for your courage and your fortitude in telling your stories here today. My deepest sympathies to each of you for your loss, and thank you for participating today. I wanted to follow up. I'm equally appalled about the lack of information regarding the Ombudsman program, that's not getting out to family members to help and keep track of what's going on in these homes, when certainly most family, cannot be there extensively enough to monitor day in and day out activities of what's going on. And the Ombudsman program, even though underfunded, does do some great work. Throughout this process, this is to any one of you or all of you actually, did you ever receive, you've got no notice on the Ombudsman, did you ever receive any information or see anything posted in any of the nursing homes on how to make a complaint to the Department of Health while you were visiting loved ones there? No one? I take it.
No, I don't recall seeing any information. No.
Neither
Okay.
did I.
Did any one of you ever reach out to the Department of Health or the governor's office to make a complaint?
After my mother passed, yes.
After she passed. And did you receive a response?
No.
Anyone else?
No, we did not reach out to the governor's office.
No, I did not reach out to the governor's office either.
Okay. I guess from your perspectives, what would you prioritize as the most important improvement that you would like to see in the nursing homes from what you've witnessed visiting your loved one up until the past?
If I started telling you everything that was there, we would be here until tomorrow morning. There are so many things that you see going on there that shouldn't be going on. It's with medicine. They don't order the medicine because the last person, if there's 5 pills, should order the medicine. They don't. They leave it for the next person. So what happens? You're due to get your medicine the next day and they don't have it. So now you go a day without your medicine. And luckily, if they come the next day, you get it. Otherwise, you're 2 days without your medicine. That's one of the things that really used to annoy me, that they just didn't have the pills. They just didn't want to be bothered. There was a lot of things they didn't want to be bothered with. And I forgot.
Yeah. Well, hi. If I could speak, I would think that a bit like I mentioned during my statement, a seniors bill of rights would be very helpful. It would be informative where families and patients could be given information on what they have as rights. The communication between the families and the nursing homes is especially important to improve. My family was discouraged from calling and asking about my father's care because they were understaffed. And this facility happens to be something with a very good reputation, but it didn't help.
I would say that in the future, we just cannot have the shutdowns that we have. I was my mother's caregiver. I knew her better than all of the nurses. And since I saw her, as soon as I saw anything wrong with my mother, I was able to address it and have it addressed. When the shutdown happened, then my eyes were removed. I was counting and relying fully on these nurses, but all they kept telling me was that my mother was fine. So they are the professionals. They're watching my mother. I'm thinking and believing wholeheartedly that they know what they're talking about. But I knew that something was really wrong. And when a previous occasion, when she actually had a UTI, I kept telling them, listen, something's wrong with my mother. Can we test her for UTI? And they said, no. The doctor refused an exam, a urine test, which I offered to pay for if I had to. And they told me no. I insisted. And 2 days later, they performed the test. And in fact, it was positive and they put her on an antibiotic. This is something that the eyes of the family members are extremely important on these loved ones. We know them best. We can advocate for them the best.
And I want to add that if we can suit up and go to the food store or a liquor store or anything like that, we should be able to take the same precautions to be with our loved one. It's not like they'll be going throughout the nursing home. We will be in the room with our family member and not spreading any kind of illness. And it's not like this has been the first time that there's been some kind of pandemic. There was the S1N1 and the flu every year, that the seniors are always the first to be the most vulnerable. And the nursing homes were totally unprepared.
May I just
Well,
say-
thank you all very much. Again, I'm out of time. I do want to credit Ranking Member Sue Serino for giving me the heads up on those specific questions as she had run out of time. So thank you, Chairman.
Thank you. Thank you, Senator. Assembly?
Yes, first, let me echo the sentiments of my colleagues and our condolences for the loss of your loved ones. I oftentimes tell constituents that it's so vitally important for us as policymakers to hear the real life stories. And as hard as it is for you to share those stories, I want you to know it's very important for us to hear the experiences that you've had and to hear what your recommendations are and us moving forward as we try to develop policies to prevent harm to our loved ones who are residents in nursing homes and other care facilities. So thank you very much. And Kathleen, thank you for your information on the issue of for-profit organizations. I look forward to reading that in more detail. We will now move to the next questioner, who is Assemblymember Ron Kim. We recognize Ron for 3 minutes.
Thank you, Chairman Bronson. So I believe this is perhaps one of the most important panel of the hearing. I'm a firm believer that when we design policies or solutions, we should center around all of it around the people who are hurting the most, who are mostly, impacted and traumatized in this time. And we haven't done that until this moment. So I thank the Assembly and the Senate colleagues for putting this forward. I think the previous speaker already asked this question, but I want to clarify. Has this administration or the Department of Health reached out to any of you to talk about solutions, policies, or how the state can do a better job at protecting and strengthening the rights of nursing home residents?
No, not at all. We have called several times, and people in the members of the Voices for Seniors group, Families Impacted, have called on multiple occasions. We get voicemail, we get tossed around here and there. And at the end, some have even claimed they'll take our number to call us back, and we have received no return, no callbacks.
Instead of handing out an early blanket legal immunity or get out of jail free cards for this nursing home CEOs or shareholders or the corporations behind them, do you think we would have had a different outcome if the state gave them an early blank check for PPE and staffing and held them legally accountable to save people's lives?
Many facilities lack the adequate infectious disease control protocols for several times. I think Mr. Scotus had asked me about this very issue. My mother's facility was cited 31 times in the period of 4 years, 2016 to 2020. The fact that they had been cited and obviously there was no punitive damages that made them change their behavior. And this includes not just COVID, it's Zika and the flu and any other infectious disease. They have to have a plan in place before these things come into their facilities. So they were inadequately prepared beforehand. Could it helped to have the additional supplies? Of course, but the reality is that this is something that they should already show that they lack beforehand.
Can I just add that, I just want to add that, the studies from Connecticut showed that if you had more registered nurses on staff, you had fewer deaths. That was the clear study. So, the fact that these conditions existed beforehand, I mean, I slept on a chair in my mother's room for 6 weeks to get her cured of a bad bed sore. And just in defense of the staff, I just do want to say that undertrained, underpaid, no sick days, no paid time off. What did we think was going to happen? So, if we could take the profits off of the CEO salary and put them more towards the staffing, might help.
Kathleen, my time is up. One question. Victims Compensation Fund. You think that's a good first step for retroactive justice? Yes or no? Thumbs up.
Yes.
Okay. Thank you.
Yes, definitely. Yes.
Thank you, Assembly Member.
Thank you. It looks like we have next up Assembly Member Doug Smith for 3 minutes.
Thank you so much, and thank you to the chairs for holding this, and thank you so much for the families for coming here to testify today. I think the families will probably join many of us in being a bit dismayed at what we heard from the health commissioner earlier today. In my opinion, really dodging and deflecting to a new level, and deeply concerned that we were not all able to ask him questions that many of us had concerning this. So I would ask at this time, and we'll start with Grace and then Vivian and go to everyone, because I'm greatly hopeful that after the fact that the commissioner left us, that he'll hopefully clear his schedule and join us on August 10th. I'd want to know, I have questions I would have liked to have asked him on behalf of the people I represent, but you represent families that have been directly impacted. What question would you ask Commissioner Zucker if you had the opportunity to the families?
Oh, where do I start? I would ask him how come they, delayed, I'm sorry. Hello, do you see me now? Okay. I would ask him why they delayed in using, actually, not even delayed, why they didn't use the comfort in the Javits Center and other facilities that were assembled to handle COVID patients. And why were the nursing homes actually, even though they weren't made to take the COVID patients, but they're hurting financially and they did need to take the patients.
Grace, sorry to cut you off. Would you agree though, because the commissioner actually said that, he said the state didn't force them to take COVID patients. However, the order said no resident shall be denied.
Correct.
So I mean, in a way, I would read that the nursing homes did say that they felt obligated to take these COVID positive patients.
I agree 100%. I feel that they felt that they had no choice.
Thank you.
And you're welcome.
And maybe Vivian, if you want to add to that, we only have about a minute.
I would ask Mr. Zucker about how well it is to make decisions for your own mother, whom I believe he mentioned his mother is at home and that they had made that decision. Yet families were denied the right to make decisions on our own parents' behalf. I was not given the option to discharge my mother before the shutdown. I was not given the opportunity to make decisions for her because I was not told what was going on. So, they took my rights away, yet he continues to have his and with his own mother.
Thank you so much. I don't know if you want to add.
Can I add one last thing? My mother had said that Had she had known that she would not be able to take care of my father and feed him, she would never have put him in the nursing home. She would have taken him home instead rather than have him do his rehab there.
Well, our thoughts and prayers are with you, and thank you for sharing your story with us. Thank you.
Thank you.
Thank you, Assembly Member. I think we have one more.
Thank you. I believe we have one last questioner, Assembly Member Missy Miller, for 3 minutes.
Yes, thank you. I want to thank all of you from the bottom of my heart for coming out here and sharing your stories. I'm kind of glad it took this long to get my question, so I had a chance to compose myself after hearing all your testimonies. I keep hearing, their rights, the patient's rights. You think that we need a senior's bill of rights. What we're overlooking is that we have a patient's bill of rights, and they were violated. And they were violated under this pandemic, that the governor's executive power during a pandemic, but he stripped you all of your rights and isolated residents in their rooms to be ignored and to be neglected, and didn't let not only the family members, but even the ombudsman, if one knew, to look or ask for one. So, it's just even more heartbreaking, the system of failure that went from step to step. And my biggest regret with Dr. Zucker leaving early today is that he does not hear these testimonies. He's not hearing what we just heard. And that is, I the other members, that's what makes policy change. Mr. Gottfried can attest to that. We did that years ago with medical marijuana. Seeing and talking to patients and talking to families and hearing what their lives are like, that's what makes us want to change policy. And that's what we need to get through to the Department of Health and to the governor's office. So thank you for sharing.
Well, thank you.
All righty. That is the last questioner, I believe. Okay, so we're gonna take a short break so that folks can actually get some coffee perhaps, since we got 5 more to go. I believe we can get this done. We'll give it 10 minutes. We'll come right back.
Thank you very much.
Thank you so much for all of your testimony. And please be in contact with the senators, particularly Senator Skoufis and others who have said that they would like to get some more of your stories so that they can really think through what we could do legislatively to respond to this concern.
Thank you. We will. I appreciate it.
Thank you. 10 minutes. Welcome back, folks. Hope that you had some nice coffee. We're going to power through right to the end. Next panel, we are joined by Judy Johnson, registered nurse and a member of the New York State Nurses Association, Mili Silva, Executive Vice President of 1199 SEIU Nursing Home Division, Eric Fogel, an 1199 member and activities aide at the Hollieswood Center, Tyrese Byers, 1199 member, certified nursing assistant at the Sarah Newman Nursing Home, and Nicole Whitaker, 1199 member, certified nursing assistant at the Berkshire Nursing and Rehab Facility. Monsieur Gottfried.
Do you all swear or affirm that the testimony you're about to give is true?
Yes.
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 Okay, fire away.
Hi. Hi, good evening to the Joint Assembly and Senate Legislative Hearing. This testimony is on behalf of the New York State Nurses Association. My name is Judy Johnson. I'm a registered nurse employed at Rutland Nursing Home, which is part of Kingsbrook Jewish Medical Center in Brooklyn. I am here today on behalf of the New York State Nurses Association to relay our concerns about the impact of COVID on long-term care facilities and problems that we observed during the first surge in March and April. Rutland Nursing Home has about 466 beds and includes the acute vent unit with 30 beds, an acute step-down unit with 34 beds, a pediatric unit, a rehab short-term unit, and several regular long-term care nursing units. During the March and April surge, our nursing home was hit particularly hard, and many residents and patients were sickened or died. In addition, many of the direct care staff, including nurses, were also exposed and sickened. In our experience, several long-standing issues in the long-term care sector made the impact of the COVID-19 pandemic much worse than they should have been. First, nursing homes have for many years been understaffed. We simply did not have enough RNs or LPNs and aides to provide high levels of care and address infection control problems that became acute during the surge period. I work on the most acute unit, caring for very sick people who are on chronic life support beds with 30 beds. Our unit used to be staffed with 5 RNs at all times, but the ratio was recently worsened with the RN staff mix now including 40% LPNs. A similar thing happened on the step-down units, which used to have 4 RNs for 34 beds, but also reduced the RNs by adding up to 40% LPNs. On the regular units, the situation was even worse, and there were no RNs assigned to direct patient care. The only RNs assigned to those units are the managers who don't do direct patient care. RNs and our LPN and aide colleagues all work hard, but reducing staff is not helpful for maintaining the quality of patient care. During the surge, this chronic understaffing caused atrocious situations in the nursing home. The short staffing became even worse when a large percentage of the staff themselves became ill and could not report to me. At Rutland, we finally got some help in the form of temporary nurses, but they did not arrive until May, long after the worst of the surge in April. A big problem in the spread of the virus among staff and patients was the shortage of PPE. We did not have enough N95 respirators and masks for the staff and were forced to reuse the equipment for days and days. We also did not have enough PPE for the residents and patients to use. I think this contributed to the spread of the virus throughout the facility. Another problem that made things worse was the constantly changing guidances and protocols for infection control and the use of PPE. The CDC kept on changing its recommendation and the state just followed suit. A lot of the changes were related to the shortage of PPE rather than best practices to protect patients and staff. The lack of staffing, the bad situation with PPE, and the constantly changing protocols are in many ways the legacy of the constant pressure to cut costs because of reduced reimbursements from government and private insurers. The nursing home industry is constantly being squeezed by these budget cuts. Pay is too low, and that causes a lot of staff turnover. If staffing has already had and fund was already bad and funding was short, it should be no surprise to anybody that the pandemic had a devastating impact on our nursing homes around the state. To prepare for the resurgence of the virus in the fall and for future pandemics, we need to properly fund our healthcare system, including our nursing homes. We need to pay people more so that we don't have constant turnover of new staff who have to be trained to provide patient care. As part of addressing the staffing shortage, the state should implement minimum staffing requirements in all nursing homes. This would allow more stability and give us a core staffing improvement that will better allow us to respond to future surges. Finally, the state needs to implement more stringent and uniform infection control standards and protocols that all long-term care facilities have to comply with. This will protect both the staff and the patients. Thank you for the opportunity to present our concerns, and our written testimony will be admitted for the record. Thank you.
Thank you, ma'am. I guess Ms. Millie Silva.
afternoon. My name is Millie Silva. I'm an Executive Vice President of 1199 SCIU, United Healthcare Workers East, directing our nursing home division, which represents over 50,000 nursing home workers downstate. Our union also represents an additional 15,000 nursing home workers in the Hudson Valley and upstate. I understand that you will hear from these members next Monday. Our members in nursing homes provide essential care to residents, helping them get in and out of bed, feeding, dressing, and bathing them. They do this work because they're committed to providing quality care for the residents who they get to know and love. They do it despite many challenges, including high rates of injury, frequent understaffing, and often inadequate pay and benefits. Our members in nursing homes continue to love and care for the residents, and they did it that much more so during this pandemic under extraordinarily difficult conditions. Many of us saw it on television, we read of it in the newspapers, but nursing home staff faced it up close and personal. They saw large numbers of residents' deaths, overwhelmed morgues, and up to a third of the workers becoming ill with resulting severe staffing shortages. As we know, workers died, and on behalf of 1199, we express our condolences to the family members who also lost loved ones during the pandemic at the nursing home. We want to thank the legislature for holding these hearings to examine what happens in nursing homes during this pandemic, and most importantly, to learn its lessons so that this tragedy is never repeated. The decisions that individuals made and the systems in place or lacking during the pandemic made a real difference in the safety of residents and staff. In a moment, I will discuss those decisions, both positive and negative, and you will have my testimony, written testimony as well for the record. I want to make one key point. The nursing home industry is not going to be the same after this pandemic. Resident census is lower, and it is unclear how quickly it will recover. Returning to the status quo pre-pandemic is impossible. More than that, it is morally unacceptable. New York ranked 31st in the nation for nursing home quality according to CMS surveys, and in the bottom 10 nationally for persistent pressure ulcers. Residents are only getting 2.38 hours of hands-on care per day, earning our state a D on the national scorecard. Nursing home caregivers are forced to work multiple jobs to make ends meet, leading to staff turnover and burnout. We can and we must do much, much better. We urge the administration and the legislature not to waste this moment when there is more attention faced on the experience of vulnerable residents in the nursing homes than any time in recent memory. You must listen to the voices of those who are on the front lines. You're going to hear from some of them as soon as I am done. And we're asking you to commit to a comprehensive plan to dramatically improve the quality of long-term care services in our state. 1199 SCIU members stand ready and willing to do the work with you. As such a plan is developed, we're going to ask you to take a look at testing and cohorting. Our members saw the difference between what happens when you cohorted residents and when you actually had workers moving from room to room, COVID and non-COVID residents. On personal protection equipment, it was real. We saw members who had to wear garbage bags. We saw members who were asked to put on raincoats as part of their PPE, instead of given full gear with masks, eye goggles, face shields, and gloves. We also want to make sure that you take a look at what happens with sick pay policies, where in some cases, let's be clear, 1 in 4 workers were infected by COVID-19, according to the State Department of Health. Some of those workers were workers who also had to make the choice of staying at home and recovering, or being asked by their employers to come back to work. That's an unconscionable question that should have been asked of workers, yet some workers were put in that untenable position. And on staffing, the pandemic revealed and exacerbated what already was, which is insufficient staffing in nursing homes. So we're going to ask you to take a look and to hear from the experience and to imagine what would it look like to make sure that nursing homes are ones where, as we prepare for this pandemic, we know that there is adequate full PPE gear for all of the workers, that there is adequate testing, that resources are prioritized for testing in the nursing homes, that we make sure that workers have access to sick pay, and that we also know that there's going to be appropriate staffing as we prepare for what could be the next surge, and certainly as we move into the flu season. And with that, I yield to our 1199 member leaders.
Perfect timing, Ms. Silva. Thank you. And let's start with Eric Fogel.
Good afternoon. How are y'all doing? First of all, I want to appreciate I would like to appreciate you giving me an opportunity to speak today on the COVID pandemic. My name is Eric Fogel. I worked at Holliswood Care Center. I worked at Holliswood Care Center for actually 25 years. The first thing I thought when this actually took place that it was unreal. It was so surreal when you actually see the situation that was at hand. My job is actually activities aid, so I do what you call therapeutic recreation. When you do therapeutic recreation, it's more of that you have such a closeness to the patients, to the residents. They're very close to you. You normally run a group, and the group will be 15 to 20 individuals, but because of social distancing and because of face masking, I was limited to actually eight in the group. And what happened with that, you could actually see the effect that it actually had on the residents on a daily basis, because they were so used to being with each other in a group and doing group programs, group activities such as arts and crafts, bingo, trivia, things of that nature. So what it was, when you actually, after you go to a point where you have a group of 15 to 20, and a lot of times you have to choose the ones that actually understand and respect what was going on that particular time. Because a lot of times when you deal with patients that suffer from Alzheimer's, or they suffer from dementia or ailments like that, they really don't understand the severity of what's going on. So they would constantly remove the mask. If not remove the mask, they wouldn't keep the mask. They wouldn't respect the social distance. So I had to be due diligent in choosing residents that could understand and would actually follow this. It was very difficult. Like me talking about it now, it's very difficult at times that you actually know a resident where a resident is like family to you. It's not like this resident don't know you. This resident think you their family because they see you all the time. And you see them on a Monday, and then when you come back on a Tuesday or Wednesday, they're gone. Or when you get a new resident that just came in that you had a connection with, and they came in on a Monday, and then before you know it, they had passed away, and it passed away the next day, and they was actually gone. That right there was very troubling, and you got to realize that it was more of a mental thing than so much physical, because mentally, you had to deal with this each and every day. So you're dealing with a virus each and every day that you see the toll it actually takes, and then you have to go home to your own family, which is a scary moment when you actually have an area that's nothing but COVID patients. And I used to do what you call video chats, because the situation is you couldn't have family members visit. So it was important for them to do video chats. Here I'm dressed in a hazmat suit, going to do a video chat with a resident. So the family member, a lot of times, are basically in tears. You could hear the quivering in their throat, because in me, in fact, they're scared. If you actually could just see me as if it was a sci-fi movie or something like that, I'm going in to visit their family members, and so they can check on their family members to see how their family members is doing. And I'm in a full hazmat suit. It got to the point where as I make a decision where I had to have some type of normalcy. So what I would actually do would actually put my face mask on and everything, but I would try not to actually go in with the hazmat suits. And a lot of times too, because the lack of supplies. One thing about the nursing home owners, it just seems like it was a lack of supplies. They was more concerned about the second wave than dealing with what was going on right then and there. So a lot of times when you go past the administrator's office, they would have supplies stacked on top of each other. But then you'll see CNAs with garbage bags on, LPNs with garbage bags on, people with hazmat suits with holes on it. They wouldn't have no face masks. There wouldn't be no N95. There wouldn't be no N95 mask and things of that nature right then and there. So it was always a constant thing that you actually seen and you had to deal with, and you had to keep the moral. You had to actually keep people's morality moral, because they were so nervous at times about dealing with this particular situation. We was one of the hardest hit nursing homes. We had close to 60 deaths. We actually had the freezer outside where actually I was helping put the bodies in the freezer. Now, could you imagine that you don't have the opportunity to say a farewell? You don't have an opportunity to have a viewing. You don't have an opportunity where they actually be able to bury the person, whatever it can be. So here is, we're carrying them into a truck, a freezer truck, a meat truck, or whatever you want to call it, and you actually placing these residents inside a truck like that. That was like devastating. Every time you come home, you traumatized just by the idea of that. We had over 20 to 30 workers that was actually affected. Some was affected more than one time they was actually affected. It was intense for 3 to 4 months, because what happened, the nursing homes had a lack of staffing anyway. And they did that. So the thing is, with the lack of staffing they already had, the ones that they did have, they was pushing them. So what happened, you had a lot of times where you have LPS that was working 6 or 7 days out the week. You have CNAs working 6 or 7 days out of the week. You couldn't take a day off. You couldn't call out, things like that. So it was always a situation where that you was always trying to comfort someone. We actually had a union member in the building that actually passed away from COVID, and that was really devastating to the department itself, because the department itself was a type of department that really didn't have much contact
Mr. Fogel?
with the
Mr.
residents.
Fogel?
Yes.
If you could wrap up since your time has expired.
Okay. So my thing is, what I would just like to say that when it comes down to this, we need to be more proactive than reactionary. Hopefully, from this particular situation, we will actually learn how to be able to deal with this and put leadership and put guidelines in place for us to be able to deal with this situation if it happens again. Thank you very much.
Thank you for your testimony, Mr. Fogel.
Thank you.
We will continue with Tyrese Byers. I hope that I pronounced your name correctly.
Yes, you pronounced it correctly. Good evening, everyone. My name is Tyrese Byers. I've been a member at Sarah Newman Nursing Home for the past 12 years. I'm 7 months pregnant, so I worked through the whole COVID situation pregnant. What I wanted to say is, when I think about the situation that we was in, for me, it was very scary. I was in fear at times. Not just me, but also my coworkers. It was just the fact that when we had got a bunch of COVID residents, Cynthia, to us, we was lacking PPE. On top of lacking PPE, we was lacking staff members and even nurses. And instead of them getting people from outside or getting hurt from outside, if we was lacking PPE and lacking residents and not residents, lacking in co-workers, they will take the co-workers that they set aside for us, that they told us before we got the COVID residents, they're going to clear one unit out. And when they clear one unit out, they're going to just make that unit the COVID unit. And we're going to have a certain amount of co-workers that's going to work on that unit. That's how it's going to be set, so we can not spread the COVID to other units on other floors. So we all thinking this is the plan when it came in. They already had their staff ready for who's going to work in that unit. But when the COVID residents came in, that wasn't the case. We had lack of short of short of staff members, and we had short members of nurses. When they didn't have enough nurse to cover the floor, they would pull the nurse off the COVID unit and have her come and work in a non-COVID unit to pass out meds. And we didn't understand that. And that's the part that got scary for myself and my coworker. Like, if we coming in working here at a unit and it's non-COVID, why would you want to bring somebody over that's been working the morning shift all day with COVID residents and move them over to the side with residents that's not COVID? And then they didn't have the proper PPE on. And then you working with our residents that's not sick, which contaminated and spread it throughout the facility. And they sit there and they say, the contamination came from the staff members. The staff members wasn't coming in there sick. The staff members got sick after working different shifts, different floors to cover the short staffing that we had. And it was scary. It hurts. It just hurts. I'm just expressing my feelings, how it hurts, how upsetting it was. And I just felt like our government, our healthcare and our government, it just let us down. It let us down. We sitting here, we taking care of our residents that we love. We grown to love, been taking care of them for years. Residents we had there for years. We treat them like our own family. Birthdays, holidays, occasions that came around, we did things with them. We had parties with them just to lose them because of the way how things went about with the COVID. And it hurts us, but it hurts our residents as well, because I'm looking at it like we feel like we didn't have no support, not even from our own administration or DOH that worked there. They stayed in their own little cubby. They wasn't even worrying about if we had enough PPE. Oh, you work on the floor that don't have COVID, so you don't need the PPE. You don't need to wear a mask. You don't need to wear this. How you figure? It spread like wildfire. We wanted to have coverage for ourselves and for our residents. It took for the state to come in. The state had to come into our facility for them to tell us, well, sit the residents apart, make them wear their masks, also have the staff wear their masks. But when we was suggesting this before it got as bad as it did at our nursing home, what we was telling them, they wasn't taking it as face value. It was just going one ear and out the other. And that hurts. That hurts because I've been working at this job for years. I knew I had wanted to be a nurse since I was in junior high school. And I would never think in my wildest life, as grown up and as an adult and as a pandemic that come along at a facility that I work at, that they wouldn't show the same love and respect and care to work together with us. Everything that we did there, we had to do on our own. Just like the last gentleman that made a statement, we had to wear plastic bags, come in there, buy our own gloves, buying our own masks. We came in there with our own supply, not being able to count on our facilities to give us what we needed. And then when they did get the stuff, it came late. When we finally did get PPE, it was later on.
Ms.
After we
Byers.
lost a whole lot of people.
Ms.
Yes.
Byers, if you could conclude since your time has expired.
I'm sorry.
No need to apologize. I just, want to make sure that we can hear from other members as well. But if you want to do one last statement, you certainly can.
I just want to say from this forward on, as a mother, as a family member, as a friend, as a person that loved my elderlies, as I was able to take care of them through my time life, that y'all find a better way and a better solution and come up with a better strategy than that came up, because it was horrible. It was horrible.
Thank you, Ms. Byers.
Mm-hmm.
Thank you, Ms. Byers. We will continue with Ms. Nicole Whitaker.
Good evening. Can everyone hear me?
Yes, ma'am.
Hi, good evening. My name is Nicole Whitaker. I am a certified nurse assistant at Berkshire Nursing and Rehab on Long Island. I have been working at Berkshire Nursing for 5 years. I work the 7 a.m. till 3 p.m. shift. My shift begins with serving and feeding breakfast, and then I move on to AM care. AM care includes bathing and dressing the residents, and also assisting in all activities of daily living. We as CNAs provide love and support daily through many activities. We also serve and feed lunch and assist residents to the bathroom throughout the day. In the beginning of March, there was an outbreak of pneumonia in my facility. Several residents had incredibly high fevers, shortness in breath, and some weren't eating. They were all seen by doctors and given chest x-rays, but COVID testing was not widely available, especially for their population. We, as staff, were watching the news daily and hearing about this novel coronavirus and began calling for proper PPE. But for weeks, we resorted to wearing garbage bags. N95 masks were finally issued to us, but were being worn for entirely too long. The staff was also getting sick, and testing was still scarce. We were also being told that we did not qualify for a 14-day quarantine, that we were to return to work once 48 hours fever-free. Unfortunately, many of us were asymptomatic and never had a fever or any symptoms of this virus at all. So we just continued to work daily, many of us pulling double shifts regularly. When it first came apparent that our residents were suffering COVID-19, they should have been isolated immediately. Instead, it took almost a month to institute proper infection controls. We lost a significant number of residents, and many of these deaths could have been prevented. All of the staff and residents should have been required to wear appropriate PPE at an earlier date. I personally have a 7 and 9-year-old, and I live with 2 people over the age of 60. I would come home after many 13-hour shifts and immediately disrobe and shower before being able to hug my children after being away from them for plus 13 hours. I would have to come home living in fear that I could potentially bring home this virus and in turn put my children and our families' lives at risk. We need to do better as a whole to protect ourselves and our residents against another viral outbreak of this capacity. Thank you. My name is Nicole Whitaker.
Thank you so much, Ms. Whitaker. And we will start off questions with the Assembly.
Thank you, Senator. First, we'll recognize Chair Gottfried for 5 minutes. Okay. Not hearing from.
Are you with us?
I think we lost him. We will track him down.
Okay. Then I'll go first then and asking a few questions. But first, let me make a comment. I said this to the family members who were testifying earlier about the importance of hearing their stories. And I say the same thing to all of you who are on the front line. You truly are the heroes that are out there putting yourselves and your family at risk, quite frankly, while you're caring for our loved ones. And so a heartfelt thank you, but also a recognition that hearing what you went through is vitally important for us as we try to develop policies that will make our systems better and provide more protection equipment, as well as guidelines and protocols that will keep you safe and keep those who you care for safe. With that, let me ask first to 1199, Ms. Millie Silva. I looked at your written testimony, and at the end it has several recommendations. One of them is adopt the Massachusetts model of an infection control audit, along with the availability of technical aid and other resources. Could you, just for the record, could you explain what the Massachusetts model is? I'm not that familiar with it.
Certainly. So one of the things that occurred in Massachusetts as a result of really figuring out how do we start to put a plan in place to address and to really fortify the nursing homes during the pandemic is that they instituted something called an infection control competency checklist. And it is a system where nursing homes are using the checklist in order to make sure that they are implementing best practices on infection control as a way to really mitigate what's happening with the spread of COVID-19. And so as a result of it, each nursing home was provided with this checklist. It includes under the topic of infection control, for example, pointing out that residents who are confirmed by testing to be infected with COVID-19 or who are recovering from COVID-19 would be separated from residents who are not infected and have an unknown status, cohorting as a point. It also speaks to facilities implementing a staffing plan where there is dedicated, consistent staffing teams who can interact directly with the residents who are positive or symptomatic for COVID, and limiting the movement between that staff and other staff who are caring for non-COVID patients. It also speaks to PPE, making sure that full PPE is going to be provided for staff, but also adding an additional piece, which I wasn't able to address in my comments, which are that staff, in addition to being provided personal protective equipment and the full complement of it, they actually also need to be trained on donning and doffing the PPE so that they're able to protect themselves. On the issue of staffing, it speaks to the facilities being able to demonstrate that they have an advanced plan in place for certainly for COVID, and also just as part of a general emergency preparedness plan, and that it will include what their plan is to either make access to staffing that might be available through volunteers, through a staffing portal that might be created. The checklist also speaks to clinical care. All of this we can certainly provide to the committee members following the hearings. That again requires the facilities to implement infection control policies, and also on communication. And it points out the importance of there being designated staff at the care facility whose role it is to make sure that there is constant communication across the care teams, the management teams, so that everything is in place in terms of implementing and executing the plan. With this infection control list, then the state is actually inspecting the nursing homes to see whether or not they have their competency plan in place, what it looks like, and if they are in fact implementing it. And then the state is providing additional technical aid to the facilities. And there's also some additional funding that's provided to those nursing homes, and nursing homes who fail to meet the requirements of the checklist are then held accountable by the state.
Thank you. And if you wouldn't mind providing that, that would be great. And if you could possibly get it to us so I could review it before our August 10th hearing, that would be very important to me.
Will do.
Thank you. And I don't have much time. I only have 20 seconds left. So Ms. Judy Johnson, thank you so much for your testimony, especially on the staffing. Many of us who are on this hearing are very supportive of that. And I just wanted to recognize that I think that we really need to look into the mandatory staffing. So thank you for your testimony. And with that, I will shift it.
Thank you. Thanks.
Thank you, Assembly Member. And to lead off the Senate questioning, Senator Rachel May is recognized for 5 minutes.
Thank you. And thank you for your testimony. And I could tell it was hard to tell these stories for some of you. So I really appreciate you sharing with us. I have a few questions, kind of general questions about working in a nursing home. So can any of you speak to how many of your colleagues are working multiple jobs? And what do you need in order to be able to work a single job? Is the most important is it regular hours? Is it childcare? Like what would be the most important thing to help people work just one job?
And a lot of people in my facility work at least 16 hours. Like they'll do an 8-hour shift at my facility, then they'll go to another facility and do another 8-hour shift. So, and a lot of times they doing that is because they don't make enough money at the facility to cover their bills. So that's why they pick up extra shift and extra time.
Oh, it's an issue. Okay, and is there a limit to like 8 hours is the most you can work at one facility?
And our facility is a 40-hour shift throughout the week. Sometimes they offer overtime if they have it.
Okay.
And a lot of times they try not to give overtime because they don't want to pay that extra money of overtime.
Right, sure. And then I had another question, which was, and I don't know if any of you can speak to this, but what are the special challenges of working with someone with dementia or with residents who have memory issues in the pandemic? Has that been a special challenge?
A lot of times they just didn't keep their mask on when we told them, and they like to wonder, like you can't keep a person who have dementia in one spot or tell them they got to stay isolated to one spot because they're not used to that. They're used to just wandering and going. And it's hard to just tell somebody who's not fully there to be like, to have dementia. Well, I'm sorry, you have to stay here. This for your own protection because they're not really understanding what we're trying to say.
Oh, and I'll open it up to other people too. Do you need more staff for?
Absolutely.
A lot, yeah.
And then just going through a bunch of questions I have. We've been talking a lot about the ban on visitation in nursing homes, and from the family's viewpoint, it's been really, really hard. But I'm wondering from the staff viewpoint, what?
As a staff member representing my residents, there has been some significant cognitive decline in our residents due to the loss of not being able to see their family members. A lot of their dementia has progressed. Even though with dementia, some of them don't know their family members, they have a slight idea of who they are. And they're really, really suffering because of their family members not being able to come and visit them.
And it's not the same even when we do live communication, because even myself, by having an iPhone and I keep in touch with a lot of my residents' family members, I will call them just to show them how they doing. We have conversations, but a lot of times they get it, and then a lot of times they just don't understand the device. They'd be happy to see their family members' faces and to talk to them, but they still don't understand why they not there or when will they be able to come see them, because they miss them. And they look through pictures more often. Like if they have a family album and stuff there, they look through it more frequently. It's telling us that they really miss their loved ones.
That was definitely one of the hardest things that we had to go through with not having the family members here. We did a really amazing job here, like assembling the recreation department to do FaceTime calls on a weekly basis. So we had like at least twice a week we would reach out to family members. And that was helpful, but it's not the same because, you know, we have family members who provide hands-on care when they're here. And that was really one of the hardest things that we had to go through. You know, family members not being able to be with their loved ones and passing, that was so hard. Very emotional, emotional roller coaster for the most part.
And one last question. I've been told by some nursing homes that they're not offering the opportunity for outdoor visits because they just don't have the staff to supervise that. Is that something you've experienced, or does that ring true to you?
Well, at my facility, they started curbside visits, where at the front entrance, they blocked it off where we used to have cars and stuff. They took the cars and stuff away. We're not allowed to park in that area. And they set up appointments so they can have curbside visits. And some of our volunteers or some of our recreation members will come get some of our residents, or we'll take them ourselves. And they have like maybe an hour or two visit curbside.
Thank you so much. Thank you so much, Ms. Byers. Thank you so much, Ms. Byers. Thank you so much, Senator May.
Thank you.
Assembly.
Yes, Assembly Member Dick Gottfried, your hand was raised. Do you still want to go? Okay, very good. 5 minutes, please.
Okay, thank you. So first of all, I just wanted to say, you know, hearing from previously from family members and now from workers is just terrific. I mean, not easy to listen to, but really important to hear from the people on the front lines. I have a couple of questions. I guess either maybe for Judy or Millie. Mitch Katz, the head of the New York City Health and Hospitals Corporation, the other day, we were on a program together, and he said that for nursing homes, well, at least for the city's nursing homes, the fact that their workforce is unionized made for, in this crisis, made for better morale, better, you know, a stronger workforce, worker retention, just all sorts of benefits, having a unionized workforce. This is sort of a softball question. Do you agree?
That is a softball question.
Yeah. Or it's too easy a question. Let's move on. I've been hearing some pretty shocking stories of nursing homes that, you know, like reported at one point having 13 deaths in the facility, and it turns out it was 98. Without mentioning the facility by name, you probably know the name. Does that happen a lot? And how does that go on?
During the pandemic, it was really bad. It's not on a daily basis. This was just during the pandemic, and again, because it was so, you know, this was unprecedented, uncharted waters we were in, you know, and it was just nothing we had ever seen before. And again, with staffing, it was, you know, a lot of our staff were out. So it was just really, really, it was bad. As again, I say, emotional roller coaster throughout.
One of the points that I would make is that in our experience, look, we were on our calls and in conversations with our leaders every day, and they were probably, in particular, March and April, some of the most difficult conversations that we've ever had to have with anybody. Just both because members were describing coworkers who were sick, and in some cases dying. And Eric actually shared a story about what that looked like and felt like at his facility, as well as also recognizing that, as Tyrese described, we had members who were taking care of someone and they would come into the facility the next day and that person wouldn't be there anymore because they had transitioned on throughout the night. One of the things that we were able to do in conversations with our members is to try to have as much of a sense of how many people were actually passing away at the facilities. And as Ms. Judy described, those numbers seem to grow fairly quickly, and in particular during that moment of time, and that there was a discrepancy we found between what the numbers were that had been reported to the state versus what our own members saw and knew what was happening inside the facilities. So I think looking forward, just really having having some expectations for nursing homes with regards to what the communication and transparency will be, both with the staff at the facility as well as with the state about what is actually happening in real time. I think that communication is a must. And in institutions where we saw that was occurring, there was much more of the teamwork that was required in order for people to be able to focus on how to give care and stay safe. At the places where there was a sense that there was PPE being locked in offices and that they didn't know what the counts were in terms of people who were sick, or that there wasn't adequate reporting about who was symptomatic for COVID. All that did was fed distrust, and that fed the fear that members then had to also work through. And it just made it that much more difficult.
Earlier, some of the consumer advocates who were testifying said that they were struck by the fact that the nursing home trade associations that had testified talked about how the health department was frequently consulting them and bringing them in to talk about what they should be doing and what they were experiencing and what the health department should do, et cetera. And the family representatives said, the department never invites us in to talk. To what extent does the union get consulted by the health department, and compared to the level of consultation that the trade associations of the owners were talking about?
And if you could answer that fairly quickly, since their time has expired. Ms. Silva?
Sure. Certainly on behalf of our members, we were advocating and in contact with the Department of Health to alert them when we were aware of situations. Also, we were doing the work coordinating both at the city level as well as the county level, helping to raise the flag when there were issues regarding a lack of PPE at institutions. During the period of time, we received requests from over 100 employers who at a certain time had less than 7 days of PPE available. And so once we were alerted to that, we then also used our voices to call attention to those institutions and to look to have supplies sent their way.
Thank you, Ms. Silva. Next, we have Senator Jim Skoufis, recognized for 5 minutes.
Thanks very much, Mr. Chairman. And I want to share my gratitude that some of my other colleagues have already shared. Pre-COVID, the word hero was thrown around a lot for a lot of reasons, and was diluted in some ways as a word. But I think we're all in agreement that you all on the front lines were heroes for what you've lived through, for taking care of others, for sacrificing your health, your family's health. And I think I could speak for everyone on the Zoom that, we are indebted to you, and our constituents are indebted to you. Thank you. So I really have just one question I'd like to ask of each of the witnesses. So I've personally heard from some 1199 members that a number of local nursing home administrators in my area were literally hoarding PPE under lock and key, leaving desperate, dangerously exposed staff to reuse masks and other equipment, all while fresh supplies existed literally on site. One of those facilities was Sapphire here in Orange County, where I represent. They were alleged to have done this. Clearly, securing PPE was an enormously difficult task in the early weeks and months, and that ought to be considered as part of this conversation. But in your estimation, 1199, NISNA, how much of the PPE crisis in nursing homes was driven by a genuine shortage versus driven by improper distribution by administrators?
On behalf of NISNA here and Rutland Nursing Home, I would say it was the supply, because I was privy to the supplies coming in and what was being distributed, and it definitely was a supply issue.
Okay.
We did pause, every day we would do pause, and we would have to do a calculation as to how much, which floor we had designated floors which were high priority for the supply chain. But it was definitely, I didn't see hoarding here. We distributed according to the need for sure, but it was definitely a shortage on the supply chain.
Okay, thank you.
Me speaking for Hollis Wood Care Center, I would not say it was a supply issue. It was an issue where they was worried about the second wave. If you went into the administrator office has so many supplies in the office. When you walk past, it was actually a fire hazard. He had that many supplies in the office. And when you would actually have people that would look for the N95 mask or whatever the case may be, they would often tell them to wear the other mask, and they could wear the other mask, and they could wear more than one day. And the mask, that blue mask, that you cannot wear more than, it's only good for maybe about an hour, maybe less than that. Or if they're upstairs, they're using garbage bags, or they leave face guards or face shield. And there's a situation with face guards and face shields. There was this incident where I had to step in among union members and deal with them a certain way, because they was actually grabbing supplies because they were so worried about they wouldn't get supplies the next day, that they would actually grab supplies and hide supplies from one another, because they was worried about the mere fact that every time they come in to ask for supplies, there was always a song and dance or an excuse. So I used to see the trucks come in with supplies on top of supplies, and it should never be a reason why that you come to work and you don't have enough supplies. If you're a police officer, they're not going to give you only 6 bullets for your gun if you're a police officer. If you have a job to do and you need those supplies, you should have those supplies. They shouldn't worry about the next day. Let's get through the day, and then we worry about tomorrow. And from what I've seen, they actually hoarded a lot of stuff.
Okay, thank you.
If I could, our assessment is that it's a little bit of both, right? No question, let's go back to where we were in February and March. It was a global pandemic. There was a crisis in terms of both the production of PPE as well as then distribution. That is real. At the same time, we also know, as Eric described, that there were some employers who, in fact, based on our members' reports, were stockpiling PPE and not distributing it to their staff. On the other hand, there were some institutions who actually did do the right thing. I want to give you—
May I ask, sorry, because my time is running out. In those cases where there was hoarding, were there any repercussions from that, Ms. Silva, by the Department of Health, or were they simply allowed to do that?
When I'm aware that when members understood that there were PPE supplies available, they then organized and went to management and demanded that management release the PPE supplies to the staff, and they were able, for the most part, to resolve the issue at that level.
Got it. Thank you.
Thank you. Assembly?
Yes, next we'll go to Chair John McDonald, recognized for 5 minutes.
Thank you, Harry, and to everybody, thank you for joining us. To Therese and Eric, thank you, Nicole. Thank you for your real-time testimony. We've heard this, we've seen it on the news, but to hear what you said, and Judy as well, and to hear exactly not only your frustration, but your concern for your patients. It's a constant reminder to us that why we're doing these hearings. We want to understand where things came up short. Obviously with PPE, we need to continue to find ways to make it here in New York State to make sure we've got enough to provide for everybody in the state. And I'm sure you've heard this throughout the course of the day, and you'll hear it again next Monday. We're committed to doing that, among other things. Harry touched on this a little bit, and Millie, I'll probably push to you a little bit on this, or Judy. I had asked earlier in a couple other panels about infection control and the committees, and I was assured that there are systems in place, but it sounds like, Millie, we have room for improvement. Would you agree with that?
Yes, sir.
What's interesting, and I'm looking at my other computer over here while I'm doing this, the Massachusetts model, I hope that you do share that with Harry, because I think there is some important aspects. And Millie, because SEIU and NISNA too plays in both the for-profit and not-for-profit world, I'm going to be very blunt. Do you see a difference in approach in the for-profit and non-profit world in regards to long-term care, but also, because I know you also are in the hospitals, do you see a different approach between hospitals and nursing homes in regards to the approach for infection control?
I will speak directly to the nursing homes in that, in our experience, when it came to the issue of workers who were exposed to COVID and who needed and were confirmed in some cases to be positive for COVID and needed care, we had a very difficult time, and it was actually quite outrageous dealing with for-profit owners of nursing homes who made it incredibly difficult for workers to be able to access the emergency paid sick leave benefits that those workers were entitled to. So that was something that really got our attention in that moment. Certainly, I think that as the pandemic was occurring, it is something that we saw across the board, for-profit, not-for-profit, there was transmission. I do want to point out that there's one institution that I think is a story of doing it exactly right. An institution in Long Island, San Simeon by the Sound, where one of the things that they did is from day one, they gave all of their staff full PPE gear. They quarantined any staff who reported that they had been exposed for 2 weeks with pay. I'm ready. The institution to make sure that there was no possibility of that person then bringing COVID into the nursing home. There was constant communication between the caregivers, the management team at all levels. And the reality is that the director of nursing and the 1199 members at that institution, through those measures, were actually able to maintain the facility COVID-free. I think that we should look to places who were able to do that, but also acknowledge that there are other institutions, some of which were mentioned earlier, that did the wrong thing and didn't provide PPE, were distrustful of the staff, didn't invite them to be a part of resolving the situation. And in some cases, those did happen to be for-profits.
Other question. Oh, go ahead.
Nope.
Okay. Last question on one of your bullets. Talks about setting up a system to recruit and deploy emergency staff for nursing homes. During this pandemic, the governor was basically begging retired nurses, retired doctors to come back to practice. We were taking graduates of colleges and putting them into practice. Is that what that references, or is that what's the meaning behind that?
I think certainly looking at all avenues that would create an opportunity to bring on more direct care staff is going to be essential to be prepared for either another stage of COVID or whatever the next pandemic might be. Another piece that we would offer is that the 1199 SEIU Training and Employment Fund actually also offered and assisted nursing homes with being able to provide staff who were available and willing to work at their facilities. And so I think really looking at all stakeholders who have an opportunity to either provide fast tracking on learning and licensing to then also offering placement support to nursing homes is critical.
Thanks to all of you for your meaningful testimony. Chair?
Thank you. Thank you, Assembly Member. We will now move on to, and Ms. Whitaker, if you could actually mute yourself while you're not speaking, we can hear the birds all over the place. So just so you know. Thank you. We are now moving to Senator Serino, recognized for 5 minutes.
Okay, thank you very much, Mr. Chairman. And I have to say, Eric, your 25 years, Tyrese, both of you, your passion is just amazing. Thank you so much for everything you do. Nicole, your story is so relatable too, having children and loved ones at home and being terrified of bringing this COVID. It's a story, it's so familiar to us, but thank you. Millie, I would love to talk to you about the PPE training. I probably won't get to it because I have 5 questions, and as you can tell, I'm going to rip through them really quick so I can get them all in, but I'd like to follow up with you later. My first question is for Judy, because you mentioned the major staffing shortage that we all know that we have, and you mentioned that you were able to get some temporary nurses, but they didn't arrive until May. So can you tell me the process that you used to access the temporary nurses? Was it the volunteer staff portal or another avenue?
It was a Hava. It was actually a agency. I think it's a city agency. I think it's a city agency that brought in these nurses like from out of state and CNAs and stuff like that. So they supplemented the staff during that from me.
Okay, thank you, because I've heard horror stories about that portal. It did not work, contrary to what we're hearing. So as you know, I've been a co-sponsor of the Safe Staffing Bill for years, and I believe the state needs to do all it can to increase staffing in these facilities.
Absolutely.
I put forward a number of proposals that would fund the hiring and training for additional staff. One proposal that would utilize unused federal funding the state currently has to bolster staffing. Do you believe the state should provide direct assistance to the facilities to help bolster staffing exclusively?
Absolutely. No question about it.
Good.
Absolutely.
Thank you. And as for the PPE shortage, this is a story we've heard over and over again, and this should never have happened. These staffers are true heroes for continuing to power through and do their jobs. Has the Nurses Association or SEIU put together any data on how many units of PPE we would need in the event of a second wave to ensure that all of your members have access to the PPE they would need to stay safe at work?
Yeah, they actually sent out surveys for us to do, for nurses to do, so they can collect that data. So I'm sure they are, putting that data together so that we'll be able, if there's a second wave or when there's a second wave, to safely, for our nurses and aides and everyone to safely do our duty, which is what we revel in doing. We want to save lives. We want to be alive to save lives.
Oh, absolutely. We want to protect you. So we want to make sure that there is that data available and that we're working on it. And also, I noticed from your testimony, some workers were given hazmat suits, others were wearing garbage bags and raincoats. Can any of you speak to that discrepancy? And do you know how the PPE was issued by the state? And do you have suggestions to ensure that the PPE gets to where it's needed most and is distributed equitably? Sorry, I'm trying to speed it up. Does anybody?
Well, I just wanted to say, as far as the PPE is concerned, that I felt like it shouldn't just be on just the nurses unit when this COVID gets around pretty fast. I figured everybody should have had it. Non-COVID floors and COVID floors. And even our residents should have been able to wear masks to protect themselves. We do it now, but it took a while for it to happen, for them to do it both ways, for us and for the residents. When we were saying this from the very beginning, before it got as bad as it did at our facility. And I just feel like when you give care to a resident, we go in a room, we give care, we in there for at least 20 minutes, giving care longer. By the time you wash, clean, and do everything you have to do, and then you got to take everything off and move into the next room, they need to provide enough PPE, because you don't want to take what you already have on. You just finished giving care to one resident to move into another room and still have to wear the same thing to give care to another resident.
Right, and that was probably part of the problem. And
right.
That's why one of our recommendations is that nursing homes be required to have a 90-day supply of PPE calculated at the peak burn rate from this past year. It's what's required of the hospitals, and we believe that the same should happen in the nursing homes.
Absolutely, yes.
Agreed, thank you. And I really want to follow up with you, Millie, about that PPE training, because you brought up an excellent point. I think a lot of us would like to hear that too. Thank you. Thank you. I got all 5 questions. Thanks, guys.
Right on time, Senator Serino. Excellent work. We will now continue with the assembly.
Thank you. Nice job, Senator Serino. We will next go to Assembly Member Kevin Byrne, and we will give you 5 minutes, please.
Thank you, Chairman. I want to thank all the speakers in this group. It's been said, and it's like beating a dead horse a little bit here, but you truly are all frontline heroes, and we need more of you. We need more nurses. I think that's part of the much larger issue. Before COVID, after COVID, we need more of you. And I did want to ask, before I got into my questions, one of the speakers, was it Tyree, Sarah Newman? Is that the Sarah Newman Nursing Facility in Mamaroneck?
Yes.
Right. In another life, when I used to work as an EMT right out of college, I used to take plenty of patients to nursing facilities. That was one of them. And I think Walters is right outside. So
yes,
familiar with that place. And I want to thank you all again, but you do a tremendous job. And one of the things that was shocking to me reading the Department of Health's report that we were discussing earlier with the commissioner, and I think it's been referenced a little bit again since then, is about the number of exposure with staff at our nursing facilities. And it's about almost a quarter of our workforce in nursing facilities were tested positive through the antibody testing to show that there was some sort of exposure. I was very surprised by that. Maybe I shouldn't have been, because I remember during the governor's press conferences earlier in the year, there was antibody testing, and it was, I think it was more geared towards the hospital setting, and it was much lower. Now, I have to think maybe that's because of the hospital setting having more PPE, and I think there's probably multiple factors involved. Your testimony shared a lot about the need for personal protective equipment. I think it was mentioned that a lot of the staff at these facilities may work multiple jobs at multiple facilities. I wonder if that's part of it. If it's part of it's delayed access to testing at the facilities. And I wanted to see if that was, if you had any comments to speak. What, why the disparity between having these positive cases in staff at nursing facilities versus maybe another traditional hospital setting? If you had any comments or thoughts for any of you.
I work at Berkshire Nursing and Rehab on Long Island, and from my perspective, it was that the hospitals were more important to get PPE as opposed to the nursing facilities, even though it was to be known that our population was the most at risk.
So the largest portion of that is PPE, and it's not really a surprise, but I wanted to ask that question still. Another question that I had was, sometimes we hear anecdotal information and it's not necessarily verified, so I'm very careful when I share this, but I just want to ask if you had any issues, or heard any issues from your members about having trouble accessing information about patients if they were positive COVID. There's always, once in a while you hear a story about a nurse was caring for a patient and then they didn't know they may not have known because the person wasn't tested, but they may not have known because it was in their patient record and the staff just didn't know, and then they may have inadvertently just spread it. Have there been challenges with some of your members getting the correct access to information about patients?
Well, we had times when we was taking care of a resident and we will let our supervisor know, or nurse in charge, well, we've been giving care to Mrs. Davis, and for the past couple of days, she haven't had no fever, but she been having a cold. She haven't been able to eat and stuff like that. And some of the supervisors say to her, well, she's not running a fever. It's not, a fever ain't always the symptom. It's always other symptoms, and we bringing it to your attention so you can test the resident. And a day or two will go by before they do the testing, because now Mrs. Davis done got worse in the last 2 days. And it took Mrs. Davis to get worse in the last 2 days before you did the testing. And then when her test came back positive, we done been around Mrs. Davis all this time. We've been asking, can she get tested? Because we look after her. We see her daily. We know her routines and her behavior. And we telling you something is wrong.
And I can understand and I can understand you always want to wear the PPE, but the reality is when you know a patient is going to have an infectious disease, you're going to treat that patient differently, whether it's isolation or what have you. One other question I had, it was talked about PPE and supplies, and just generic question. I'm not sure if the answer would be no. Early on in a pandemic, when people were hoarding, not just in hospitals and healthcare facilities,
Remember
but
that.
the private sector as
Question
well.
in the next
private
15.
systems.
Ask your question.
15 seconds.
Yeah.
Have you heard anything about people actually stealing PPE? Not your members, but just people in general.
No, as soon as we found out that this outbreak was happening in my facility, we used to stay stacked with gloves. We used to have our cart with our gowns and everything in it. When they made this known, one day I came into work, the supply closet was empty. That stayed stacked, it was empty. And now they was disputing it manually. Like you had to go through the supervisor to get a gloves. And then she'll give you one pack of gloves. And we like, but Mrs. Frank don't have gloves in his room either. We need more than one. We usually keep gloves in every room.
I feel terrible, Ms. Byers, because it seems that I'm always interrupting you, and I
It's
apologize.
okay. It's okay.
But I want to make sure that we can get everybody needs to ask questions. Thank you, Assemblymember. Next, we have Senator Tom O'Mara recognized for 5 minutes.
Thank you, Chair. And I want to thank each and every one of you for your service, for your being on the front lines, and not just yourselves, but all of your colleagues across New York that have done outstanding work throughout this pandemic that we've had, putting yourself at grave risk, the family members you return to home with in the evening at risk as well. So thank you for that you've persevered throughout this. You know, we were hoping to get some information today from our Health Commissioner, Howard Zucker, on how many nursing home residents that were sent to the hospital with COVID ultimately succumbed to COVID in the hospital and therefore are not counted in the nursing home data that the Department of Health reports. I'd like to ask each of you if you have any thoughts or any comments on an estimate of, from your facilities where you work, what extent did you see residents sent to hospitals never to return?
Yes, absolutely, yes. And
Yes.
one of the things, again, is testing. Testing was not being done. These residents were being sent over, never to return. And the other thing that we have to also remember, during this time, the funeral homes were allowed to come in, claim the bodies, and a lot of these residents were cremated, so we would never know. Tests weren't done on them, they died, and then the bodies were gone, they were cremated. A lot of people got cremated during this time. So again, the data would never be reflected correctly because the tests weren't available. And that was one of the biggest problems. Tests weren't available. So even though residents or patients or whoever were displaying symptoms, signs and symptoms, no tests were available to be done. They transferred over or died right here, and the tests were never done.
Thank you, Judy. Others want to comment on that issue?
Yes, I seen a lot of loved ones leave, and some of them didn't come back, or a lot of loved ones died there at the nursing home that been there with us for years.
Anyone else care to comment on that? With regards to, move on, with regards to the PPE shortage, and you know, aside from the hoarding at some facilities, but mainly the lack of PPEs at a lot of the facilities, at what point do you feel that your facility got caught up with appropriate PPEs, if they have even to date, or what shortages still exist in your facilities of what type of PPE you need?
Right now, our facilities, we get masks, and the way that they doing it now is they give us an N95 mask. We sign for it. At the end of the day, we supposed to turn in our N95 mask so they can stick it in a brown paper bag, and when you come in tomorrow, you get the same N95 mask right back to give to you to work again. To today, and we do this for 3 days. And I had to let them know I'm not returning in my N95 mask. I'd rather take it home, spray it, clean it, let it air dry, and then wear it the next day. Makes no sense for me to wear my N95 mask that I use to take care of my 13 residents to come back here to give you my N95 mask to stick in a brown paper bag to give right back to me tomorrow. And it wasn't even clean or sanitized.
Thank you. Anyone else?
She's actually fortunate enough, like I say, Eric from Holliswood Care Center, she's actually fortunate enough to get in the N95 mask because in the facility I'm in, they're rare. Like N95 masks are basically like dinosaurs. They just that difficult to actually get. The mask that you always have, even when you come at the front desk, they have the new mask that you actually tie in the back. They have those masks. And I have a mask here sitting on the table with me right now. It's basically the blue mask. So that's a mask that they always seem to have in abundance. When it comes out as an N95 mask itself, like I sit there and say, like a dinosaur, or clips, some every 4 years or whatever the case may be. I don't know what the situation is or whatever. Before, they used to hand the N95 mask out. But I guess because they feel like even though it's still social distancing, still mask wearing, I don't know if they feel that they're out of the woods as of yet. So maybe that's the reason why they're not supplying them. But even when we was at the height of it, when we was really overwhelmed, N95 masks was still difficult to come by, and they still are now.
Are gowns available today for each of you?
Gowns are actually available when you actually when you're doing direct care, whatever the case may be. They will able to actually have gowns, but what you do notice a lot of times, nurses will actually put gowns on the floor and try to hold on to the gowns on the floor for when the gowns are actually really needed.
Thank
But
you.
yeah.
Thank you so much, Mr. Fogel. Thank
Right.
you.
Thank you all.
Senator, thank you, Senator O'Mara. And back to the Assembly.
Thank you. Next, we'll go to Assembly Member Jake Ashby, recognized for 5 minutes.
Thank you, Mr. Chairman. Earlier, I think it was Mrs. Whitaker who spoke kind of this collective cognitive decline that she noticed in her residents secondary to isolation that they've been experiencing. And I'm wondering if you've also seen kind of a physical decline along with that because of isolation as well.
Absolutely. I mean, in the height of the pandemic, we were very short-staffed. It was to the point where we had 3 aides on a 7-aide unit, and our charge nurse was our med nurse and our supervisor. So it was very difficult for us to give these people, our residents, the attention that they needed to help them, get up and out of bed. And a lot of them are on nursing floor ambulation, and we did not have the time to be able to get that done.
And do you feel like the people that have declined, are some of them starting to bounce back, or have they plateaued, or are they continuing to decline as we speak?
With the increase of our staffing, I believe that it has wholeheartedly made a difference. But these people are really missing their families and, seeing their faces over a teleconference or having someone banging at their window is not helping. They need to have their families back in their lives.
And I don't imagine this is just exclusive to Ms. Whitaker's, but I'm sure Ms. Byers and Mr. Fogel and Ms. Johnson, this is all going on in your facilities as well, correct?
Mm-hmm. Yes.
Yes, it is.
So if you were able to, if you wanted to improve the functional ability of your residents, because I don't imagine that it's going to get easier over the next couple months to really see a collective improvement throughout all of these facilities. What would you do to improve functionality? Because I don't know if many people can understand, like it's one thing if someone needs a little bit more help eating, now and then cutting their food, but when someone goes from, a min assist to a 2-person assist to get on and off the toilet.
Right.
Also that they probably need more help actually doing toileting too.
Right, I would say that. I would say
as
they
one
need a little
person,
bit more help.
if that's happening with one person, that happens with 60 people,
Right.
cascades with staffing and what
More
you
staffing, yeah.
need. So if you had the ability to change things and improve, have your residents improve collectively, what would it be?
More
I
staffing
would, more staffing.
and their family members
you
back
can
in their
give
lives.
more time to your residents. You can give more of you to your residents if you have more staffing. You'll be able to give them that extra 20 or 30 minutes that they want from you. Instead of saying, can you give me a few minutes? You can only do the essentials and then you got to come back because you still got 10 or 12 other residents of your own, not within a facility of your own that you still have to give care to. And they all want the same attention. And it's hard. It's hard when they all want the same attention.
I would like to also add that during the height of the pandemic, we lost therapeutic recreation. So there was no more bingo. There was no more coffee hour. There was no more movie time, things that these residents look for every day. I have specific residents that every single day that bingo is offered, they're there. 10 o'clock coffee hour, they're the first waiting at the door to be opened. And they lost all of that as well.
Mr. Fogel, anything to add?
Yes, well, she's absolutely right, because I do the therapeutic recreation. And what you try to do is have normalcy. You know things are not normal, but what you try to do is make it as normal as possible, close to normal as possible that you possibly can. But because you do have the social distancing, you do have the mask, you have to limit the size of the program. But what I normally do and what we continue to do, we continue to provide programs for them. So we try to make it seem like, okay, this is what a normal day would be like. They just don't see a large group as they would normally see, but they enjoy bingo. They enjoy coffee chat. They enjoy arts and crafts. They enjoy trivia. They enjoy these type of things that you provide for them on a daily basis. And they look forward to it. And then the whole thing with the socialization, which is also within a group, which is kind of difficult at times because you're so limited. So what you try to do is put them 6 feet apart, but have it where they can actually have a conversation, or they can sit there with each other and just read a magazine or look through a book or whatever it can be. But normalcy is what I try to always provide every day.
Thank you. Thank you, Mr. Chairman.
All right, thank you. We don't have currently any questions from the Senate. Going back to the Assembly.
Okay, we will next go to Assembly Member Ron Kim, recognized for 3 minutes.
Hey, thank you. First, I want to just join my colleagues in thanking the workers for enduring so much trauma and challenge some of the worst situations one could imagine. I want to share one bit of good news. The governor signed our legislation to narrow the scope of the corporate immunity that was handed out early. Now, the administration framed this issue as a pro-worker thing, but because of how it was so broad, it actually limited workers' rights to file lawsuits if they found that the employers weren't providing a safe workplace. So I think this is a step toward restoring the rights for the workers to make sure that we can hold these facilities accountable for preventing the spread of COVID-19 and also for making sure they're arranging the care properly and moving forward. But I want to redirect my question to how Governor Cuomo and his administration, starting in early May, began to put blame and shifted the responsibility, shifted the spreading of the infection toward workers. On May 18th, on one of his briefings, he explicitly started to blame the workers in nursing home facilities for spreading COVID-19. Yet we all know that more than 6,000 COVID positive patients were transferred back to nursing homes in the last 3 months. And I know that the commissioner has submitted testimony that despite that massive number of people coming back in, it didn't have an impact. It was mostly the families and workers that are responsible for spreading COVID-19. As the workers on the ground, can you let us know if, first of all, are nursing homes hospitals? Are they even equipped, to take in these, patients? And what kind of an impact did that have on these facilities last couple of months?
Before you answer that question, Mr. Kim, we'd feel a lot better if you pulled over. Driving while the Zoom is happening doesn't make us feel too safe for you, but I'm sorry.
I'm not looking at my phone.
Yes, you were. Yes, you were.
Okay.
The workers, go ahead and answer. I just concerned about you. Please answer. I'm sorry. And I'll give you 30 seconds extra. I just would prefer that you be safe.
Okay.
Workers, go ahead and answer.
Thank you, Chairman.
Me personally, I agree with you 100%. As you notice with the hospitals are more equipped to actually handle the COVID virus. Nursing homes are not. And sometimes when you would actually watch them bring new residents in that was COVID positive, you could almost look at that resident yourself and you would sit there and say, if that resident made it through the week, it was a miracle that it made it through the week. So I could never understand why we took or we was getting so much of the blame when you actually had hospitals that couldn't even handle it themselves. Hospitals are way more equipped to actually deal with situations like that. And from what you understand, they was having people's passed away in the hospital. But for some strange reason, the blame was shifted on it was shifted on the nursing home workers, which I could never really understand and wrap my head around, because a nursing home is not a hospital. We're not equipped to deal with a pandemic like a hospital is actually equipped to deal with a pandemic. Even when it comes down to isolation with a nursing home, sometimes they will take a COVID positive resident and we'll put a COVID positive resident in a room with a resident that wasn't COVID positive at all or had no symptoms of being COVID, just because of the placement and because they had not enough area, enough space for it. So how we got the blame is beyond me. How they actually narrow it down and say we was a lot that had a lot to do with it is beyond me too, because I used to see them bring patients in, and when it was bringing patients within the building, you could see that patient was not, just physically looking at that patient was not in good shape at all.
Thank you, Mr. Fogel. Thank you, Mr. Fogel. That was a good 35 seconds extra. I hope that you continue to drive safely. Assemblymember Kim, back to the assembly.
Yes, for our last questioner, we will go to Assemblymember Tom Abenati, recognized for 3 minutes.
Okay, thank you very much. As the last speaker, I guess I'll be the last one to say thank you to all of you. We really appreciate the efforts that you and your colleagues have put in over these very, very trying times. And I really mean that. I got a text from somebody over at SEIU, a comment I made earlier today seemed to have offended some people, and I really did not intend to offend anyone with my comment. I really do appreciate all of the work that you all do. You truly are our heroes. I also appreciate your standing up for the family. You who are on the job understand the importance of having others come in and work with or visit with their family members. I was just wondering, I have two questions basically. One, are there any plans that you could help devise to get family members in safely? Has anybody worked with any of you yet? Have they asked for the nurses' input or the union's input as to how we could get family members back in the same way? It seems that the health department is signed for that. And the second thing is, we've talked about safe staffing. We've even passed a bill dealing with safe nursing staff. I was wondering, what are the staffing levels necessary or mandated now for nursing homes? And is there a way that we can have a similar type of legislation if the health department can't do something to make sure that you have enough staff at each location so that you all feel comfortable in doing the jobs that you have to do? Whoever wants to.
So all right. First, I want to say,
okay. May I?
Okay, go ahead. Go ahead.
Okay.
Yes.
So on the staffing piece, would want to point out that right now in New York, what we have is 2.3 hours per day for direct care for nursing home residents. What has actually been recommended by health advocacy and policy experts is something that is closer to 4.0 hours. That's one. The second is that we think that the conversation regarding staffing really warrants a careful conversation around what it looks like in terms of direct care staff, as well as the professional caregivers who work at the facilities. And then I think on the question, but New York also does not have a state minimum hours requirement. And I think that it is, one of 12 or one of 15 states that remain in that category. The other, with regards to the question around family members, we would encourage that home operators actually invite the caregiving staff along with the family members to come together and have a discussion around what are the things that we can currently put in place to be able to have the residents get access to their family as quickly as possible. It's that kind of communication, bringing all the stakeholders to the table that's necessary, because the reality is that the men and women who are on this call who provide are experts as well, heard on the earlier panel.
Okay.
Thank you.
Silva, thank you so much. So that brings this panel to an end, and I know that Councilmember Abenanti said that he was going to be the last one, but I will be the last one to say thank you for all the work that you have done to make sure that we keep people healthy, and we look forward to working along with all of you as we consider what policies we might need to change going forward to better protect and better protect our residents in nursing homes all across the state. So thank you
You're
so much
welcome.
for
Thank
all your
you.
service.
Thank you.
You may go
Thank
back
you.
to your
Bye-bye.
normal day. While
Okay,
we
thanks.
soldier on to panel 7, and that will be Pat Tercey, Chief Executive Officer for the Elizabeth Seton Children's Center, Rachel Amar, parent of patient at the Elizabeth Seton Children's Center, Dr. Edwin Simpson, I'm hoping that I pronounced your name correctly, President and CEO at St. Mary's Healthcare System for Children. Monsieur Gottfried, if you are with us still.
Am I unmuted?
You are now.
Okay, do you all swear or affirm that the testimony you're about to give is true?
Yes.
Yes, I affirm.
Okay.
All righty, let's start with Pat Tercey, please.
Thank you. Thank you, Chairperson Godfrey, Chairperson Rivera, members of the Assembly and Senate for organizing this important hearing. I'm Pat Tercey, CEO of Elizabeth Seton Children's Center and School in Yonkers. COVID-19 has had a profound and unanticipated impact on our cherished children and young adults with complex medical needs who have not hugged nor kissed their parents in over 4 months. I'd like to focus my testimony today on the trauma that this is caused by the current nursing home visitation restrictions. This trauma can quite literally take years off our children's already life-limited lives. Elizabeth Seton Children's is the largest licensed pediatric nursing home in the country. It was built in 2011 to hospital standards with HEPA filters and UV lights to safely care for 169 residents, of which 67 are dependent on ventilators, oxygen, and medical technology to live. This requires a highly qualified staff of pediatricians, RNs, palliative care specialists, rehabilitation and respiratory therapists, and educators and more to provide a quality of life that's second to none. And of course, their families. Starting in late February, our leadership recognized the distinct and deadly threat this virus would pose on our compromised children.
Ms. Tercey, I'm sorry to interrupt you. Could you start your video, please?
Oh,
Yes, we want to make sure that you are, there you go. We want to make sure that you are for posterity since it is being recorded. Please continue.
sorry. I lost where I was. Oh my God. Okay, so distinct and deadly threat this virus posed to our compromised children. We began implementing strict infection prevention protocols that led to our success. I'm overjoyed to share that no child has tested positive for coronavirus throughout this pandemic. In fact, there have been 0 viral infections since March 17th. The 28-day ban of visitation of a staff member test positive for COVID-19 will indefinitely prevent visitation by our parents. Additionally, it's costing approximately $200,000 a month to test our over 600 staff members weekly. Our staff positivity measure is 0.64%, representing all asymptomatic cases, and which is far below the state average. If you took a look into the faces of our beloved children every day, wiping away their tears because they're missing their parents, unable to communicate through technology, and further can't understand why their families can't come see them, you would do anything to change this policy. The simple solution is to treat pediatric nursing homes the same way you treat pediatric hospitals for visitation. On May 20th, DOH issued guidance that permits 2 support persons at bedside at children's hospitals. We ask that you offer our children and families the same rights. We understand the need to protect public health, and we are doing our part to protect the most vulnerable amongst us. I ask that you do everything within your power to reunite our families. Let's not let another day go by where a child cannot receive the love they need from their parents. Now I'd like to give the rest of my time to Rachel Amar, who will share the toll this separation has taken on her and her son, Max.
Hi, my name is Rachel Amar, and I want to thank you for hearing my story about how difficult my life has been. the
Well,
past-
actually, I'm gonna stop you for 1 second, Ms. Amar. Please give Ms. Amar the whole 5 minutes. Thank you. Please continue.
Oh, thank you. Okay, I'm going to start again. Hi, my name is Rachel Amar, and I want to thank you for hearing my story about how difficult my life has been the past 4.5 months not being able to visit my son, Max. My hope is for all of you to understand how detrimental this is and how it has affected the well-being of my son and my family. Max is 18 years of age and has been a resident at the center for 14 years. Max was born with a small brainstem, and therefore he cannot breathe, move, swallow, or speak. However, he is fully cognizant of his surroundings, caretakers, and most of all, my presence. As an active parent in my son's daily life and delivery of care, it has been an atrocity to not be able to be there and provide the love and support that he depends on from me every day. Never in his lifetime has he gone without seeing me. Consequently, this has negatively impacted his emotional behavior. As a result, he has regressed with a deep decline in his behavior towards the staff. He prevents the ventilator from giving him breaths, turning blue, and coding. This is Max's way of acting out when he is angry or upset. Knowing what Max is going through emotionally, I tried FaceTiming with him, but all he would do is cry, and it made the situation worse for him. The nurses advised me that he rarely smiles, which is very unlike his character. Max's birthday was July 12th, and I was hopeful in seeing him, based on the governor's ordinance and lifting the ban on visitation, to celebrate with him and commend the staff for their amazing job in keeping Max and the other residents safe and virus-free. Unfortunately, I was informed of the restrictions and stipulations that again prevented me from seeing Max. The only other alternative was to visit him through a tall, dark fence. I tried calling out his name, but he wouldn't even look at me. I can't imagine what he was feeling, the feeling of being heartbroken and abandoned by his mother. This cannot continue any longer. I'm pleading with all of you as a parent, which I hope you can personally understand. Max needs me to be there with him physically, to read, kiss, hug, laugh, and sing together so that his emotional well-being thrives. I can't imagine how the other families and children are coping with this unbearable separation, which is a detriment to the livelihood and overall well-being of our children. I trust that you understand the severity of the situation that requires your immediate action in resolving this crisis. Your attention to this matter is greatly appreciated. And I just wanted to show you a couple of pictures, Max and I, so you understand how much enjoyment he gets from my daily visits. So this is just every day I come into bed with him and we kiss and hug, and all he does is smile like this. He laughs. We read all day after school, and he just is so happy sitting and laughing together. And here's a picture last year of his birthday, celebrating with all the staff. Everybody's involved in his care as well as me. I come every day and visit him every day and spend from 11 o'clock in the morning, approximately. I meet him in school and I stay till about 6 p.m. and I haven't been able to be there. It's been almost 4.5 months, and this is really devastating to me. So I really please hope that you reconsider the visitation policy. Thank you.
Thank you so much, Ms. Amar. Next, we'll hear from Dr. Edwin Simpson.
Thank you very much. Good evening. I'm Dr. Eddie Simpson, a pediatrician and president and CEO of St. Mary's Healthcare System for Children. Thank you for giving me the opportunity to speak on behalf of New York's most vulnerable children and families. St. Mary's Healthcare System for Children is a national leader in providing specialized care to critically ill children and young adults. We are dedicated to providing inpatient care, day health care, home care, and education services to children and young adults following acute care hospitalization due to premature birth, illness, injury, or other critical health conditions. We're the largest post-acute provider of our kind in New York State, with a continuum of care that supports a sick child throughout their lifetime, from our inpatient facility to home and community settings. With a highly trained and dedicated pediatric workforce, St. Mary's is committed to improving the health and quality of life for children and young adults with special needs and their families. I'm here today to talk about our experiences with the pandemic and in particular, a pressing issue on visitation in our pediatric skilled nursing facility. First, some background. For many years prior to the pandemic, we've been a leader in infection control measures, establishing an exemplary track record of protecting our very vulnerable children from the spread of infectious disease, including regular viral testing of all symptomatic and at-risk children. Any encounter with an infectious disease, from a simple respiratory infection to the novel coronavirus, can be devastating for a medically complex child. Since the outbreak of COVID-19, we've expanded these measures, and our efforts have been extremely successful. Just like at Elizabeth Seton, to date, 0 children in our facility have tested positive for COVID-19, and we've had no outbreaks of any other respiratory infections. This success has taken place against a backdrop full of extraordinary challenges. Precautionary regulations have forced us to close a number of critical programs that serve children in the community, depriving the children and their families of much needed support, while compounding the extreme financial pressure our system is currently under. When you add the burden of COVID to the recent Medicaid cuts, we're under great duress. Since the DOH prohibited visitation to nursing homes, we have parents who, just like Pat mentioned, have not hugged their children for months. The parents of a child in a pediatric skilled nursing facility are never visitors. They're critical partners in the care and well-being of their children. Hear the plea from one of our parents who cries to our staff in pain and frustration, "I'm not a visitor, I'm his mother." Many of our patients are newborn babies transitioning from a neonatal intensive care unit right into our facility. Under the current visitation restrictions, parents would be forced to separate from their newborn upon arrival at St. Mary's, leaving many to refuse admission and forcing many children to languish in acute care settings while they await resolution. We have facilitated virtual visits for our parents, but these fall far short of the necessary connection between a parent and a child. Testing our staff for COVID-19 has proven itself a flawed mechanism for preventing the spread of COVID in our facility and as a criterion for staff quarantine or visitation, as I'll outline. As of now, we can't envision a scenario where any large pediatric facility meets the current Department of Health criteria for having 28 consecutive days without a positive case of COVID amongst our dedicated staff. At our campus, we're testing over 600 clinical and support team members once a week. If 1% of the population is positive for COVID, we're going to have 5 or 6 positive cases a week. And it takes up to 2 weeks sometimes to get results. We can easily imagine a staff member who's positive but asymptomatic and working until we receive the results of their test at a time where their infection and their infectivity has already passed. The important point is the continued success of our infection control practices to prevent the spread of the virus, even before we were testing all of our staff. Our parents are at the end of their rope. They're devastated and need us to act immediately. In a time of extraordinary hardship, we can imagine few greater hardships than the pain of a parent separated from their child in need. We believe that our proven expertise in infection control and our exemplary track record warrants due consideration. Children's nursing homes are unique within the broader nursing home industry. Our children need their parents to be with them, and we would welcome a dialogue with state leadership to help unite parents with their children today. Thank you very much.
Thank you so much for being with us today. It's a very important conversation to be having. We'll start off with Senator Skoufis, recognized for 5 minutes.
Thank you. And I don't expect to need 5 minutes. And I want to begin by really just expressing my gratitude for the work that you and your staffs have done over these months. Both Elizabeth Seton and St. Mary's sound like some really exceptional places. And again, it sounds like you have a lot to be proud of. I do want to ask, so obviously visitation policy now on August 3rd is very different than visitation restrictions in March or April or May when the virus was at its peak or otherwise ravaging our state, right? So I want to ask, were you supportive of the visitation restrictions then? and you've since changed your mind now that the virus numbers have decreased. And if that's the case, with an eye towards the next public health crisis, I think it's important to hear from you as to what you think that threshold ought to be by which we ease restrictions. If you did support it then when the virus was more rampant than now on August 3rd. I don't know who would like to speak first to that.
Want to go, Eddie?
Sure. So thank you for that question. So we have a practice during outbreaks within the community, such as flu or other viral outbreaks, to begin limiting visitation well before this coronavirus pandemic. So in fact, this year in January, when the flu was pandemic or epidemic, we actually limited visitation, but not to zero. We just limited the number of people that came in. We made them wear PPEs and we protected our children. We certainly agreed during the height of this pandemic that we needed to restrict visitation altogether. But as you pointed out, August is not March. 1% of the community is positive, not 10 and 15% of the community. And we've learned a lot about how to utilize PPEs to protect our kids. And we believe that we can safely protect our kids, limiting visitation to single individuals, doing as much outdoors as possible. A lot of what's already been proposed by the Department of Health. The problem we have is that we can't get 28 days of negative staff with this many staff being tested every week. And we just feel that that criterion doesn't work for us, and that our track record, Seton's track record of not having any children positive, despite the fact that staff are positive, speaks to the fact that we should be allowed to have visitation without those restrictions.
And I'd just like to add that during the pandemic, Eddie and I talk a lot about this back and forth always. So we also want to look to the CMS guideline that DOH didn't recognize for comfort care. Because even during the pandemic, it was only 24 to 48 hours of a imminent death. All of our kids have life-limiting conditions. Sometimes we don't even know when that's going to happen. And parents, understand all our infection protocols. They live by them, like Eddie said. We do have outbreaks other times. So, to me, I think the definition of comfort care that would be greater even in the pandemic should be allowed, because we had many parents that were sleeping in the building when we got the restriction, and 4 parents decided to stay. I know Eddie had many more than we had, and they stayed for a very long time, and till they couldn't take it any longer. And one actually would have lost her job and is, in a situation where that couldn't be. So I just, the pain and anguish that we've dealt with our parents is indescribable. I can't even begin to tell you how awful.
Thank you both.
Thank you, Senator. Assembly?
Yes, to recognize Chair Gottfried for 5 minutes.
Yeah, on the question of visitation, well, one is I think it would be useful if you had written down for us what you think the visitation policy should be. And maybe that's in your testimony, but rather than just saying what the department does is too restrictive, if you could recommend something that would be useful.
So, Senator Gottfried, we actually submitted a pilot visitation plan to the Department of Health and had a meeting with members of the Department of Health to discuss that pilot plan weeks ago, and we'll be happy to share it with you.
Yeah.
Okay, and they have not responded, I assume.
Correct.
And the other question I have is, what's the likelihood that if we adopt your proposal, that 3 months from now we'll be at a hearing, and instead of family members like the ones we heard earlier talking about how terrible it was that the health department led to the death of their grandparents by letting in all those COVID-19 patients into the nursing home that the department thought were no longer contagious, but oh my God, look what happened. will we instead have parents coming in saying that terrible health department relaxed these visiting restrictions, and a couple of people were visiting at St. Mary's, and before you knew it, 6 of our children were dead?
So we partner with our parents all the time. And we have a family advisory council. I've had Zoom meetings with the family advisory council. They're ready to partner with us, wear full PPEs, get tested before they come in, whatever restrictions we want to put in place. Also, both us and Seton have a lot of experience, as I mentioned before, in controlling outbreaks. And we're confident that even if we were to get a child with COVID-19, that we would be able to contain an outbreak and not have the kind of outcomes that you've seen in geriatric nursing homes. We have a long track record of protecting our children from flu and many other infections, and we are confident that we'll do well. We're not cocky, but we are confident that we'll do well, and we believe in partnering with our families. When we showed our families a graph of the decrease of infections within our facility, they all said, that speaks volumes of how we have to act post-COVID, not just during COVID. So we really believe that a partnership with families will protect our kids.
Okay, thank you. And if you can unmute for a second, I've, as you probably know, I've worked with St. Mary's and Blythedale and Elizabeth Seton off and on for years on a variety of issues, and sometimes with success, sometimes not. But everything all my colleagues said about how amazing you folks are is certainly true.
Thank you.
Ditto on that. Now to the Senate, recognizing Senator O'Mara for 5 minutes.
Thank you, Chairman. And thank you, Pat, Rachel, and Eddie, if I may be informal with you for your testimony and for the great work that you do at your facilities for our children with disabilities. And it just truly is God's work. And I want to thank you for that. And Rachel, to you, God bless you and your family. I can't imagine going that length of time without being able to see my children.
Hard.
Just it's heart-wrenching to even think about. But to Eddie and Pat, if you could just briefly, again, I may have missed it, run through what the protocols are right now for your staff to be able to come to work.
Go ahead, Pat.
I don't know, you're gonna go ahead or you want me to? It's the same.
Go ahead.
So they,
Yeah.
when they come in, they have to, fill out their survey. They have to have, they have to attest that they have no signs and symptoms of any kind of illness. Also, we're being very strict about where staff are traveling. So we're monitoring that as well. So if anybody travels, we go above the CDC requirements and we're making everyone stay home for 14 days. We are paying staff for all their unlimited sick time so that people don't have to worry about not having it. But in that case, we said we're not going to pay. If you decide to go travel someplace, that's, you're going to have to just stay home. They have to wash their hands, and we have plenty of Purell, and then they mask. And then they also, during the pandemic, we just restricted it a few weeks ago. We were having our staff come in their street clothes and then change into their uniforms. But now that we're not in the peak of the pandemic, we've let that go.
Are there testing requirements for your staff?
Once a week.
Once a week.
We're doing the same thing, over 600. I think this week we did 646. So we're like in the mid 600s every week.
Okay. And how many patients do you have at your facility?
169.
169 patients and over 600 employees?
Yes.
We have 124 patients.
And how many employees?
Also over 600.
Okay. Now, Rachel, if I can ask you, would those requirements that were just laid out for staff be acceptable to you to be able to see your son?
100%. I would feel comfortable if the parents, put on masks. We also get our temperature taken and get the test taken. I would be 100% fine with that.
I would think so. And it's just unconscionable to me that you're allowing over 600 employees into a facility, yet 150 parents can't come in and see their children. That is unconscionable, and that needs to change. Thank you all very much.
Thank you.
Thank you, Senator. Now back to the Assembly.
Yes, I will go next. First of all, Ms. Amar, thank you so much for sharing your personal story. And I can't even imagine what you and your family and certainly your son are going through. First, I'm just going to request, Mr. Simpson, I believe you said that you submitted a pilot plan
Yes,
to the Department of Health. When was that submitted?
3 weeks ago.
Okay. Would you be willing to share that with us so that we could take a look at it as we develop policy?
Absolutely.
All right. And then the other thing, and I apologize, this may be naive, but listening to your family story and listening to some of the other families we heard earlier, we use the word visitation, but I'm not sure that fits. Sure, you're a mom visiting your child, but you're also a mom that is 100% engaged in caregiving for your child. And I'm just throwing it out there, whether or not there's a distinction we can make between, visitation versus being a necessary component of the care of your child, or when we're talking about nursing homes, a necessary component of the care of a parent or a grandparent. That being said, we've recognized, and you brought it up, the feeling of isolation, or you actually referred to it as abandonment of your mom. So I don't know where we can make that demarcation, but I'm throwing it out to you if you have an answer today. But if not, help us work around that, because I think that's a balancing that we need to do with care that's given by the professionals in the facility that is supplemented and augmented by family care. So if you have a response to that, that's fine. If you don't, I'd like you to think about that a little bit.
Well, what I'd like to say is that I do come every day and I know all his care. So I also give his medical care. I help and I assist the nurses. So when they're busy and they can't change him or suction him or any type of care that he needs, I'm able to give it to him. Unfortunately, I can't take him home and take care of him myself because he is very challenged medically. He's 100% dependent on a ventilator, so he's very fragile. But I'm able to assist in his medical care, and I occupy him all day when I go to school with him. I assist in his schooling. We do arts and crafts projects. There's music, there's gym. I go with him all day. I'm all with him in school. And then when we come up, we get into bed, cuddle, kiss. And I mean, he's the happiest kid ever. I show you pictures smiling, happy. And when I don't come, he's devastated. I call in the morning I call the 2 different shifts, and they tell me he's upset, he's angry. He really feels the lack of my presence there. And I mean, I could definitely say that in his medical care, I'm part of his medicine. He needs me.
Thank you.
There's a provision in the visitation restrictions on medical necessity and allowing visitation for medical necessity. And I guess that's open to interpretation. We have had parents visit for medical necessity when we're transitioning children home. We discharged 35 children over the course of this pandemic to their homes. And those parents obviously had to come in so they could learn how to care for their children. I would think there's an opportunity to interpret medical necessity for pediatric nursing homes the same way, as Pat pointed out, medical necessity has been interpreted for pediatric hospitals and allowing parents to be there for pediatric hospitals way back in May.
They also have the DOH guidance talks about the support person. And the support person they have for both, persons of intellectual disabilities as well as the medical complex. And that already is in the DOH guidance and it's already spelled out. Now, Eddie and I both agree that there needs to be, some maybe other things that we would want to do and add into that visitation policy for hospitals, but it was very strict during COVID. So, the strictness doesn't bother us. We have to get the parents connected to their children again.
Okay, thank you. I think that gives us some stuff to work with. Thank you.
Thank you, Assemblymember. We don't have any further questions from the Senate at this time.
Okay, then next we will go to Chair McDonald for 5 minutes.
Thank you. And to Pat and to Eddie, thank you for your testimony. To Rachel, the expression, a picture is worth 1,000 words. This was worth about 100,000 words. I don't think there wasn't anybody here who wasn't moved. We've been moved all day long in many aspects. Heart-wrenching stories, and mostly have been focused in the gerontology part of people's lives, but this hits homes too. We know the great work that both Elizabeth Seton and St. Mary's has done for, well, probably longer than Dick Gottfried's been around. That's been a long damn time. So we know what great work you do. Eddie, in your letter or your testimony, you mentioned about how, you've had zero positives of any of the children during this whole time, which is remarkable when you really think about it. And you mentioned that your organization has been nationally recognized. Is that through some kind of accrediting body or what is that?
So there happens to be an association of children's nursing homes throughout the country. And we did a number of studies working with epidemiologists at Columbia. Actually, Seton was involved in some of those studies as well. And we then presented those studies nationally and actually brought our infection control practices that we have here in New York to facilities around the country. And that's why we use the term nationally recognized.
Well, it's interesting. Member Gottfried raised a good point. If the pendulum swings in another direction in 3 months, is everyone going to be, pointing finger at the legislature to state and say, why did you let this happen? But I think it's very clear. And I think, Rachel, you would agree with me because I work very closely with the intellectual development disability community. Max and many other children, they don't have a way to understand what's going on. They just don't know. Their daily lives are interrupted and they don't understand it. They think that this is the part that really bothers me. They almost feel like you've abandoned them. And we know that's not the case. So, we appreciate this testimony. I know if you were around when we started about 9 or 10 hours ago, whenever it was, many of these members brought this up to the commissioner. I know that many members of the Department of Health are monitoring this right now. Your visit was not for naught, and I want to thank you for your testimony.
Thank you so much.
And I assure you it was longer than 5 hours, Assembly. So much so that I missed one of my colleagues who was online to ask questions. So my apologies. Next will be 5 minutes for Senator Sue Serino.
Thank you, Mr. Chairman. I appreciate that. And Rachel, Eddie, Pat, thank you so much for being here today. Oh my God, you touched all of our hearts as you've heard everybody say. But I just have a couple questions. Throughout this time, have any of you reached out to the governor's office or DOH directly? And did you receive a response? I know, Eddie, you had said about the plan, but.
So we have had 2 meetings with senior members of the Department of Health. One that we had individually and one that our representatives have had with senior members of the Department of Health. We've asked for a meeting with the commissioner. We've had our representatives have had numbers of conversations with members of the second floor. I think everybody's compassionate and aware. I think everybody's afraid, as Chairman Godfrey pointed out. I think the commissioner and the Department of Health are very anxious. And the problem is that we're regulated and considered a nursing home, whereas our kids are not like the residents in the geriatric nursing homes, and our staffing and our approach to care is just different. And we ought to be treated differently. And that's the argument we're trying to make. I understand they're frightened, and we were anxious, frankly, coming forward and being so public and making these statements. But our parents are at our wits' end, and we're at our wits' end because of that.
Well, we had 6 surveyors show up today and did a second infection control survey that we just flew through. So, you know, I know that, you know, everyone's concerned, but we're doing a great job, and they commended us today for it. And I also think that parents coming in with admissions, like Eddie said, we've had, you know, they come from Blythedale. It's one of our major referrals here. We're very close to Blythedale, and they're able to visit there. And then they had to leave a 2-year-old at the door with complete strangers. And we admitted a child like 4 weeks ago and another one 2 weeks ago. And parents aren't able to come in with their child. I just don't know. It just doesn't seem, it's not right.
I can't even imagine, like Rachel, watching you with your son. It's just absolutely beautiful and just touched my heart. So to not get any response is absolutely horrific. That, you know, and I can understand people are nervous, absolutely, but at least respond, you know, talk it through. That's all anybody is asking about through this pandemic, no matter what area we're speaking about. And Rachel, did you yourself reach out or to the governor's office at all?
I reached out twice to the governor's office. One time I was able to speak to somebody who connected me to somebody else, who gave me another number, who connected me to somebody else. And at the end, they called me back, and I filled out like this this form in regards to filing a complaint. And they said that it wasn't in their jurisdiction. And then I called Department of Health, who said that there was nothing that they could do. So.
Yeah, so who are you supposed to go to, right?
Right.
That is absolutely
always a fight. It really is.
And in the event of a second wave, what would be at the top of your priority list? I understand visiting that you would want to for the state to do differently.
I mean, I think that if the parents are tested just like the employees, and we limit the amount of parents that come in, I think it's the same thing. What's the difference of a parent coming in or an employee coming in? You don't know what the employees are doing during the day. If everybody's getting tested, wearing the same PPE, take the same safety precautions, it's the same thing.
And I can tell you that I've had countless parents that have called me about this very subject. So I'm asking questions on their behalf as well. My heart goes out to all of you, and thank you for all of the hard work that you do. And God bless you, Rachel.
Thank you. Thank you.
Thank you, Senator. And again, apologies for not seeing your name earlier. Back to the Assembly.
Next, we're going to go to Assembly Member Missy Miller for 3 minutes.
Thank you. I also want to thank the 3 of you, Rachel. I'm a mom of a medically fragile child. I have him at home with me. I cannot even imagine what you're going through. I won't get through a sentence if I try to imagine it. So just know that I am thinking of you. In full disclosure, I've known Eddie for far too many years that I won't age us both. But a very important point has been brought up that I think Department of Health and the governor's office really, really needs to hear here is that the parents who keep saying they're not visitors, they are a very, very important part of the care team. They are part of this child's team. And by keeping them out, they're keeping a part of that child's care team away from them. And it's one of the most important parts of that care team. You know, years and years I've been doing this. I trained pediatric residents on how to deliver chronic care. And I fully believe that the Department of Health has missed this entirely. They just aren't equipped to understand this. And so this really needs to bring a light to this, that, and the points of, a staff member, 600 staff members can go in and out every day and go home and ride public transportation. I can guarantee you that parents are taking more precautions. They are not, they're going to make sure that they are not the ones bringing in any kind of virus, and would happily submit to testing every day if necessary. I think also there was a point that was brought up earlier, even on other segments, that the testing that's required, what good is that testing if it takes 5, 6, 7 days to get a result, and then it throws you back all the way back to the beginning of your 28 days all over again? It's really just unacceptable. So thank you for being here. Thank you for voicing these concerns. I think it's disgusting that the Department of Health has waited 3+ weeks now, even with their anxieties about what would happen if somebody were to get sick. I think a 0% positive of patients is a pretty significant, impressive, note to pay attention to. It should earn their respect, and it should get their attention at the very least. I myself have been doing my part by badgering them to answer this, and I will continue to do so. So thank you.
Thank you.
Thank you so much. We don't have any other further questions from the Senate at this time.
We will then go next to Assembly Member Brian Manctillo, and Brian will have 5 minutes.
Thank you, Chairman. I'll keep it short. Doctor, just a quick question for you. Earlier on, you had said something about there's a lot of room or some room for interpretation on the order. Can you expound on that just a little bit for me?
Well, the terminology is medical necessity. There are 2 words in the visitation restrictions. One is that would allow people to come in. One is compassionate care, and the other is medical necessity. Compassionate care, the DOH seems to interpret as end-of-life care. And as Pat pointed out, sometimes that's very challenging for us to know when a child is going to go down. We actually had a baby whose parents didn't see him for 3 months, who got sick and in 24 hours died. We got them in before he died, and they got to hold him, but they missed 3 months of his life because it's hard to know, and we're nervous about breaking the rules at the same time. The same with medical necessity. What's medical necessity? How do you interpret medical necessity? And I'm ready to argue, and I'm happy to have the argument with the commissioner, frankly, that parents are medically necessary to be at the child's bedside. But that's not how we've interpreted it up until now, except for children who we're planning on discharging.
You said you're afraid to break the rules or have something. What would happen if you broke the rules? Or what do you think would happen?
We are certifying every week. Our administrator is certifying every week that we are following all of the governor's executive orders and all of the DOH directives. We are subject to fines. Our administrator could be subject to losing her license. So, we're anxious about not following the rules and interpreting things differently than how they've been interpreted throughout the industry.
All right, thank you, Doctor. Rachel, could I ask you a question really quick, please?
Sure.
And thank you for your words about your son. And I want to talk a lot because I'll start crying. So, in your eyes right now, what's the hardest thing right now at this point in your son's life that's going on today that you feel is the hardest thing for him?
I mean, the hardest thing is that he doesn't see me. I mean, he's used to seeing me. I come like 7 days a week, every single day. And for him, that's all he knows. He doesn't like change. He likes me to be there. Like I said, I sit in bed with him. He doesn't even like when people come, because, obviously people come over to the bedside. They want to talk with me. He gets so angry that he starts turning blue, and they already know, okay, Max, sorry, we won't talk to mommy. He, 24 hours a day, 7 days a week, he's living in this facility. And when I'm there, he wants my time and he wants me. and it's understandable, and he deserves it.
So as a parent, you're willing to take the risk of opening up the doors and allowing you as a mother into his room?
I mean, obviously, I'm very scared, but I have been sitting home the past 4.5 months. I go out maybe once a week to go to the supermarket. I don't go anywhere. I don't have anybody in my house. I'm like sitting, waiting, like on call to get the call that I'm going to be able to go and visit him. So I haven't been doing anything. And I mean, obviously, if I will be allowed in, I will take even stricter precautions because I mean, you know, but the fact that employees are coming in, I mean, I don't think they're going to be doing anything different than I'm going to be doing. So I think that things should be okay. And I know he really needs me. So especially when I FaceTime him and he's so sad and he's crying, and I mean, it just breaks my heart.
Absolutely. I can't imagine not speaking with my kids. So thank you all for your testimony. And I think our job as legislators is to make sure we take your testimony, and let's not wait 2 weeks, 3 weeks, 4 weeks. Let's make sure something happens sooner. We need to get you back to see your children. We need to open these things up. And I feel the safety part is there from you and the staff members. And I will be pushing for that from the assembly side for sure. So thank you all for your testimony.
Thank you.
Thank you.
Thank you, Assembly Member. You got one last question, I believe.
I do. Assembly Member Tom Abenati, 3 minutes.
There we go. Thank you. I guess again, maybe I'll be the last, except for the chair, I'll be the last one. But Eddie and Pat, I want to thank you for coming in and possibly risking the wrath of the health department. And Rachel, thank you for having the courage to come forward and talk. Like Missy Miller, I have a child with a disability. My child, fortunately, is running around. He's got autism, and I can see if I'm just away in Albany for a few days, he very much misses me because we've changed the style. I can't imagine what your son is going through. I agree with your comments, Eddie and Pat, that you should be able to have the same rules as Blythedale, which is in my district. You know, I've been hearing from a lot of people about all types of congregate care, where parents have been deprived of being able to see their children have been deprived of being able to see their parents. We're struggling with what is this concept? Is it visiting, whatever? From my point of view, it's parenting. As you said, you're part of the care team. I think this is a discrimination against people with disabilities, because people with disabilities are being deprived of the right to have part of their care team there because they're related to the care team. And I find it ironic. I tried to get for one of the parents additional Medicaid payment because she was a nurse and she was taking care of her son when she couldn't get other nurses who were, and she had approval under Medicaid for this service. But the response was, well, she's a parent. Why should she get paid to take care of her son? This is just parenting. And now on the other side, you're trying to go parent your child and you're being told you can't because you're a parent, because he's in this institution and you can't go there. So it's just, it makes no sense. And I'm very, very disappointed that the health department doesn't understand people with disabilities. And the governor today, the governor was really paying attention to what we were doing. I was just checking the news. What did the governor do today? Well, he announced that he was signing the New York Child Victims Act. Very important. But this hearing is as important also. He could have waited until tomorrow to sign that. And he spoke about openings. It wasn't opening your institutions, it was opening schools. That's going to happen in September. And then he legalized frozen desserts, which were infused with liqueur. He did everything possible to divert attention from this hearing today because he knows that his administration is not doing the right thing. So I appreciate all of you coming forward. We're all together on this. I join my colleagues. We're going to push real hard because this is insane. This is inhuman. This is a mistake by this administration, and it's got to change. Thank you for coming forward.
Thank you.
Thank you, Assemblymember. And on behalf of all of us, we again, thank you for your testimony here today. And I assure you that this has not fallen on deaf ears. There's things that are already moving. I've already gotten a couple of messages about plans that are moving around and what have you. So thank you so much for being here, and have a great, wonderful evening.
Thank you very much.
Thank you so much.
Moving on to panel number 8. I see the glimmer at the end of the tunnel. Let's keep powering through. We have Beth Finkel, the New York State Director of AARP, and Judith Grimaldi, a member of the New York State Bar Association's Elder Law Section Task Force.
And do you both swear or affirm that the testimony you're about to give is true?
1 second, Assemblyman. They're transferring over with their cameras.
Yes. Make sure you turn on your cameras, both of you folks. All right. Yep, there's Ms. Finkel.
Hi.
Okay.
Okay, do you both swear or affirm that the testimony you're about to give is true?
Yes, I do. Yes, I do.
Okay.
Thank you. Ms. Finkel.
Okay. Thank you very much. I want to thank you all for all the work that you have all done during this pandemic to help New Yorkers put forward in these unprecedented times. I know that we are all concerned about a possible second wave on the horizon. We can never let this tragedy happen again. 6,300 deaths occurring in adult long-term care facilities. Clearly, the state's focus on the onset of the pandemic was really focused on hospitals, not on adult residential facilities, communities, and even though the virus's first strike was a nursing home in Washington State. So it's not like we didn't know that this was going to be coming. Building hospital bed capacity and securing ventilators was critical, but our focus and planning should have included nursing homes and long-term care facilities, which house some of society's most vulnerable, many of whom have pre-existing conditions. And I know that all of you know this so well, and I know that you've all been working in the Assembly and in the Senate so hard to try to help people in long-term care. AARP joined with the Urban League, Asian American Federation, NAACP, and the Hispanic Federation, and 1199 SEIU to ask Governor Cuomo to create a long-term care COVID task force working with consumers, long-term care providers, home care agencies, and unions. It would be modeled on the successful approach the governor took to coordinate New York's public and private hospital systems. We need real planning and real coordination. We also asked the governor to ensure that long-term care system received adequate supplies of PPE. The governor did not establish such a task force or release a coordinated plan for the long-term care system to thwart future pandemics or a second wave of the COVID pandemic. That's why we're supporting Senator Mays and Assemblywoman Cruz's bill to establish a long-term care task force to examine the state of long-term care, both home-based and facility-based, and to consider potential models for improvement. We believe this task force should certainly look at current staffing levels, as we heard so much today in all the testimony that came before me, and any possible supply chain issues for PPE in the future. This bill passed the Senate 2 weeks ago and awaits action in the Assembly. AARP strongly believes that family caregivers should be a part of this task force since they play such an integral role in our long-term care system. While AARP fully recognizes the necessity of shutting down nursing homes to visitation by families, we also understand the devastating impact that this has had both on the families and their loved ones in nursing homes, since family members often carefully monitor their loved one's health status and are often the first line of defense in identifying key areas of concern to the facility staff. Not being able to visit a loved one in person and then not being able to communicate with them during this time has been one of the most frequent complaints that we have heard from our AARP membership. And I know you all know this, but we have over 2.5 million members in New York State. So we've been hearing from a lot of them, and they're really upset. Many facilities failed to provide regular and effective opportunities for virtual visitation. We even heard stories that the only communication that a family received was that their loved one had died of COVID. We are grateful that the legislature passed and the governor signed into law legislation requiring communication protocols for nursing homes, including virtual visitation in the future. But while the governor dedicated $1 million for technology necessary to implement the virtual visitation program, media reports indicate that very few nursing homes are actually opening up for visits. And this issue certainly needs more attention by the legislature and the state to make sure families can see their loved ones as soon as possible. ARP strongly recommends that the long-term care ombudsman program be improved by hiring more professional staff to be trained and sent to more nursing homes throughout the state. We certainly heard a lot about the ombudsman program. Currently, the program relies on volunteers. I want to thank you all for the steps forward by repealing certain legal immunity for nursing homes, but repealing nursing home and long-term care facility immunity must be full and retroactive. ARP is very concerned that the 6,300 families who lost loved ones do not have access to courts and therefore not hold the nursing home accountable.
Thank you, Ms. Finkel. Now, Ms. Judith Grimaldi.
I'm looking at my notes and I noticed I started it off with good morning. So I have to change it to good evening or maybe even good night. I was optimistic.
Positive view of life.
I'm not going to go, I could just say ditto to everything that Beth just said. So I'm going to skip quite a bit, but I want to tell you one graphic story. I'm an elder law attorney and I work in Brooklyn. I'm actually on my local communities, age friendly, but I wear many hats, having been a past chair of the elder law section of the state bar and the past chair of the city bar and the past chairs of many things. But I'm going to get right down to the story of the Ling family. You would enjoy meeting the Ling family. They're warm, they're kind, they're capable, and they lost their mother. They're 3 professional children whose mother, Linda Ling, who lived independently, completely fine on her own in her lower Manhattan apartment. And she fell, broke her pelvis, wow, and ended up in, right in your district, Chairman Gottfried, she ended up in Gouverneur Hospital, Health and Hospital Corporation's 295-bed facility, and right down in 227 Madison Street. She lived in Lower Manhattan as well, right at the start of the outbreak. She entered the facility on March 16th. She died on April 23rd. She was admitted to the home with a broken pelvis. She was fine. She was optimistic. I'm going to get through rehab and I'm going home. Unfortunately, it was downhill from day one. Mrs. Ling used to speak to her daughter every day. It was their touchstone. It was how they kept in touch with how she stayed alert and happy and connected. During this period, she talked to her daughter 12 times. During these weeks, the family attempted to contact her with the social workers, with the nursing staff, with the administration. It all fell for nothing. They kept saying, I need to speak to her. I need to see her. What's going on? They said, oh, she's fine. She's fine. Yet when she did speak to her mother, all her mother would say is, they don't care here. They don't care. They don't care if I have pain. They don't care anything. This proved to be true. The daughter asked for a psychological evaluation for her mother, an assessment of why her mother was failing to thrive, failing to eat, and the treatment of her mother's overall depression. They said, we'll do that. But on April 3rd, 3 weeks after her mother's admission to the home, the family learned that her mother wasn't participating in any physical therapy, that she had lost her ability to walk and transfer. This was a shock to the family. In addition, she was losing weight and she needed 2 persons to assist her with all forms of transfer. This is a woman that was fine until she fell. Their mother was wasting away and they could do nothing to stop it. They would have been willing, as we heard from other people, to move heaven and earth to help their mother, but the system blocked. They asked, could we hire someone to bring someone in to make sure that she's connected because she can't use the FaceTime. She couldn't get to us. The family said were refused. And then on April 7th, they learned that she was going to go home. They got a discharge notice. They were thrilled. And when the daughter called on April 8th to say, well, what's going on? I'll take my mother home. They learned no, there was no social worker on staff. She was out sick. There was a substitute social worker who didn't know her mother. There was a substitute nurse that was know her mother. The psychological evaluation had never happened because there was no longer a psychologist on staff. The physical therapy was discontinued. And all they were going to concentrate now on was her mother's failure to eat and worsening bed sores. There was no rehabilitation. It was just maintenance. And they were just completely frustrated. And then they got a call, finally, on April 21st, that their mother was being rushed to the hospital. Her condition was worsening. She was admitted to New York Presbyterian Lower Manhattan for blood work, testing, and suspected COVID. And on April 24th, she died, not of COVID, but an untreated urinary tract infection. The reason for Mrs. Ling's death gives evidence to something we've known all along. As an elder law attorney, people would ask me, what nursing home would you recommend, Judy? And sadly, my answer was always none, because I couldn't feel confident that anyone was really going to give the kind of care that I would have wanted for my mother. So this story tells you the story of the home's failure to give not COVID treatment, but primary care, the core reason that they were there. It was the isolation, poor care, lack of health monitoring, overstressed and inadequate systems, and a staff in a nursing home that was overworked. That's what killed Mrs. Ling. And there's just one.
Wrap up since your time has expired.
Yes. The one thing that hurt the family more than anything, when they collected her belongings, they were shaken and angered to find that the small album they had left her and all the mail they had sent her had never been delivered to Mrs. Ling. She never saw any of those things, the things that would have given her the ability to get home. So we as an elder law community are ready to roll up our sleeves and work with you.
Thank you so much. Thank you so much, Ms. Ramon.
Okay, thank you.
Thank you so much. Assembly leads off the question this time.
Yes, I recognize Chair Gottfried for 5 minutes.
Yeah, at the risk of jumping the gun on what I assume would be Assemblymember Ron Kim's question, if Mrs. Ling's family felt that she was given substandard care and that somebody ought to be liable for giving her substandard care below the standard of care of the community, thanks to Article 30-D of the public health law that was enacted as part of this year's budget, unless they could prove gross negligence or intentional misconduct, they'd be locked out of court.
Correct.
And even if they wanted to allege that the nursing home had violated departmental regulations, the nursing home would be off the hook unless the department could prove intentional misconduct or gross negligence. Do I have that right? And is there something that should be done about that?
If it's being directed to me, yes, you have that right. And that's one of the efforts that the New York State Bar has formed a task force, and we're going to be working on, and maybe with you, Assembly Member, on legislation to undo some of that budgetary, I think, oversight of what was done. I don't know why it was done. The nursing home representatives who spoke this morning said they didn't ask for it, they didn't lobby for it, so who is lobbying for it? Who made that happen? and can it be undone? So we're, as the State Bar, we're looking to work with you and see if we can undo that legislation or that budgetary regulation.
Yeah, thank you. That's it for me.
Thank you so much. Some member questions lead off in the Senate by Senator May. Recognized for 5 minutes.
Thank you. And it's great to see you both. Hi. Thank you for the shout out for my bill about the long-term care task force. I hope that Harry Bronson was listening and can bring that up in his committee in the assembly. I also wanted to mention I have a nursing home virtual visitation bill that you might take a look at, but I wanted to use that to jump off as a question about family caregivers. You probably heard the discussion earlier about the issues about family members and visiting and some potential designation of a family caregiver. Do you have thoughts about that, of what we could and should do?
I think the whole visitation thing is very troubling. We know what a health risk isolation is, and we're already talking about the most vulnerable. And so isolation for them is absolutely even more staggering. I think, one of the things, I know you've asked for the long-term care task force, and we're very anxious to get that, but we need a real in-depth analysis of the whole visitation isolation piece. And at the same time, I think we need an overarching examination of what happened with the nursing homes this time out. We need experts from a broad base of disciplines to come forward and really do some good digging here to figure out what happened and have a full formal report on it.
Okay. And for Judith, I actually have a different question for you. So on the Department of Health website, there is a list of rights of nursing home residents you're probably familiar with. And the Ombudsman handbook says state and federal regulations require nursing homes to have written policies covering the rights of residents. I feel like we've been hearing a lot of cases where at least the family members feel the rights haven't been observed. What more do we need in order?
I think community education, and that's one of the efforts that we're going to be working on. If you go into most nursing homes, posted probably by an elevator in a frame, indiscreet, is a listing of patient rights. I've seen it because I look for it every time I go into a nursing home, and it's there, but it's not well publicized or well demonstrated, and you have to kind of know about it. The Nursing Home Reform Act goes back to 1987, and it was revised again in the 2000s, but it's not talked about. It's not that, and I think you heard from Richard Moloff this morning. He's got it all worked out. We don't have to reinvent the wheel. That the long-term care task force is really, that organization has laid things out very, very well. I mean, we can take a page from that and maybe build on it, but there's a lot of groundwork that's been done both there and nationally. I'm a member of the National Academy of Elder Law Attorneys, and across the nation it's happening. The groups of Elder Justice and Empire Justice in New York State has worked on it. There's a lot of resources that are there, and we can pull on it, and we're prepared to work on that. We're working on a white paper for review as well.
Thank you so much.
Mm-hmm.
Great, thank you, Senator. Now to the Assembly.
Thank you, and I'll go next, and I'll be brief. And yes, Senator May, I heard you loud and clear. I will help Assemblymember Cruz with her bill, and hopefully we can move that forward. But in line with that, Beth, nice seeing you, by the way. You talked about reaching out to the governor and requesting a task force, one that would be made up of all the stakeholders, consumers, long-term care providers, home care agencies, and unions, and really coordinate a statewide effort. Did you get a response from the governor's office at all on that request?
We've had conversations, but we haven't heard anything moving forward.
Okay. Are those conversations still ongoing?
Not as of very recent, but yes.
Okay. So, I mean, certainly sounds like I mean, that's the whole idea of these hearings, is to hear from all stakeholders. And that's all you were asking from a administrative process. Let's get the stakeholders together and develop a good plan. And I'll just end with this. Judith, you ended your last response to Senator May. I know you're all ready, willing, and you're able, and you have the expertise, you have the knowledge. We really need to try to encourage the governor to involve all of the stakeholders in this, so that the difficult things that we were just talking about with the family on the panel right before you, with caregivers of young children. I mean, how do we work this out? Because it's not working right now. So I just wanted to thank each of you for coming in, and look forward to working with you as we move forward.
Thanks, Solomon.
Thank you.
Thank you. I'll take the next round. It'll be quick. I just have one question. So if a family member, because we heard a lot of stories today about family members who were concerned because they had lack of information, they didn't know the state of health of their family member. So if they want to actually have somebody discharged, it is my understanding the home could actually prevent that from happening, correct? If they want to have their family member discharged?
We've been working on discharges. It has to be a safe discharge. And the difficulty has been that with the lockdown, the agent, so you have to have a home care setting that's safe, and assessments. So the discharge has been slow because assessments have to be done by Zoom or phone, have doctors prepare medical treatment plans, and then the hiring of home care workers the families often can't do the care at home. So it's been slow because the coordination pieces have been slow. Everybody's in the same lockdown. So I have not seen homes say, no, you can't take them home. But what they say is, do you have a safe discharge? And if the family is not as coordinated or savvy enough to pull a discharge together, then it doesn't happen. And they're frustrated because they don't have the tools to do so.
All right. Thank you both. I think that is the extent of our questions for this panel. And yes, it is. Thank you so much, both of you, for coming.
Thank you.
We've got just a couple more folks who are hanging around. Panel number 9 will be Susan Duha. I hope that I'm pronouncing that name correctly. Executive Director, Center for Independence of the Disabled. Brian O'Malley, Executive Director of CDPAANYS. A lot of acronym there. Feiji Horowitz, again, I hope that I pronounced that correctly, Director of Marketing and Communication for the Caring Professionals Incorporated, and Claire Altman, President of Altman Strategies, LLC. And Monsieur Gottfried. Can't hear you.
Oh.
There you go. Now you're good.
Okay. Do all of you swear or affirm that the testimony you're about to give is true?
I affirm. I affirm.
Okay.
All right, let's start with Susan Duha, please.
First, thank you so much for allowing us to appear before you. I want to thank the nursing facility staff who appeared before. I want to thank the family members of residents of nursing facilities. And of course, Richard Malott and Beth Finkel. What can I say? Terrific work. I want to speak to you about our work. About half of our 70+ center staff assist individuals who want to secure care at home and in the community, or another more integrated setting, so that they can avoid nursing facility placement. I would agree with Judith. The only safe nursing facility actually is the one that you can be at all the time. These staff also help people leave nursing facilities for their homes in the community. And our staff protect the rights of nursing facility residents and their families. Our helplines have been open throughout the pandemic and have fielded many desperate calls from nursing home residents and their families, from staff of nursing facilities. And we've been managing complaints, appeals, desperate cries to exit facilities Residents have called Sydney desperate to get out. Often our staff calls to facilities about them are not returned for days at a time. Our Open Doors program helps individuals who want to leave facilities. And we've been able to get 27 individuals out of nursing facilities in New York City, the epicenter of the pandemic in New York State, and one of the epicenters across the nation. However, 136 people that my staff were working with died before they could exit the facility, and they were in the process of transition. And we mourn them, and our staff are grieving for them and their families. I could speak with you about any number of issues that have been covered today, and I think add important issues to what you've already heard. I would be remiss if I didn't mention and speak briefly to the issue of racial and ethnic disparities, because nursing facilities are especially dangerous for people who are Black or brown. The New York Times observed that facilities primarily serving Black and Latinx residents had cases of COVID at twice the rate of facilities serving white incidents. We've also observed this, and we want to know where is the focus on resources on eradicating disparities in treatment and care in nursing facilities? Where is the public awareness of what's happening in these facilities? Where's the racial, ethnic, demographic data? Where is the where's the disparities prevention and eradication task force for people in congregate facilities? And does emergency planning being done by nursing facilities include a focus on how they will address populations at much higher risk? I could address all kinds of other issues. I want to touch briefly on involuntary discharges because no one has mentioned that. It is important that you know that individuals are being discharged from nursing facilities to very unsafe places, to homeless shelters in New York City, which are not even as equipped as nursing facilities to do infection control, to provide PPE, and to have other prerequisites of safety. We believe there should be a moratorium on such discharges at this time. You've already heard enough about many of the other issues, but it's imperative that I speak with you about the egregious and chronic underfunding of the long-term care ombudsman program. The governor called the long-term care ombudsman program a watchdog. And I want you to hear about the condition of the watchdog. We've worked daily to provide assistance and to be the eyes and ears of family members and the eyes and ears of the state, of the Department of Health, and provide a resource for families. During the recent period, we have participated in hearings and appeals. We've addressed 350 complaints and requests for information, and much more. We have a staff of 5 certified ombudsmen who are able to go into facilities, and they are serving more than 50,000 residents of nursing facilities, as well as residents of other facilities. And
If you could wrap up since your time has expired.
they are in no way adequately able. There's one ombuds for every 8,650 nursing home residents. The standard is 1 for 2,000.
Thank you so
We've
much.
asked
Thank
for
you so much, Ms.
$3
Tuha.
million for the LICOP program, and we hope you hear our plea.
Thank you so much, Ms. Tuha. Mr. Brian O'Malley.
Good evening. Thank you for having me. These hearings are critical. The victims of this crisis and their families deserve justice. But I want to be clear, the problems that we're talking about aren't new and they can't be fixed. To make sure this never happens again, we have to use this tragedy as an opportunity to reimagine our long-term care system and focus on improving services like home care and consumer-directed personal assistance that exist in our communities. These services not only prevent the rapid spread of pandemics, they provide better care and address health disparities that plague our healthcare system. What I'm going to say isn't without precedent. In 1972, when the country learned of the horrors at Willowbrook, It led to New York become synonymous with the word deinstitutionalization. And as an epileptic, even I've benefited from this movement. Much of the last century would have seen me at a colony for epileptics in Soraya, New York, instead of before you here today. This is important because if we're lucky enough to reach old age, we will need assistance. And while the ability to age in place is a civil right, it's contingent on being able to receive the services you need. But nobody wants to go to a nursing home. And I guarantee you, folks like Michael Bloomberg never will. The research is clear. Nursing homes are for those without resources and primarily those on Medicaid, even though a nursing home costs over 4 times as much as the average person in consumer directed. Thus, it should also not be a surprise that nursing homes with the higher numbers of Black and Brown residents were disproportionately impacted by this virus. The wealth and resource gap that means Black and Brown folks disproportionately live in poverty also makes them more likely to go to a nursing home. It means they're more likely to be in worse health, have less resources when they get to one, meaning they're more likely to die. Meanwhile, CDPA addresses many of the health disparities that much of the healthcare system struggles with. When the person receiving services is hiring, they can guarantee their staff will speak their language. They don't have to worry about whether or not the staff will understand or respect their cultural needs. And concerns about institutional racism in the healthcare system, such as that which stems from Tuskegee, Henrietta Lacks, eugenics, and countless others, are mitigated when people actually control their own services. As I've said, the problems of COVID aren't new. Nursing homes, like all congregate settings, inherently pose a safety issue for residents, and this isn't the first instance of a contagious disease disproportionately impacting these institutions. The flu, Legionnaire's disease, and even the common cold ravage nursing homes every year. Natural disasters like Superstorm Sandy also always come with stories of horror about their impact on these populations. But an examination of policies shows a bias towards institutional care, despite community-based care's multiple advantages. This year, the state enacted a look-back period for home care and CDPA before they can even receive services, a process that often takes 6 months or more, and which in a nursing home is provided while the look-back is taking place. And I'll acknowledge Senator Rivera and Assemblymember Godfrey's legislation that would fix this bill. We do not know the impact of COVID on those in CDPA or home care because the state didn't collect the data. But we know several realities, not the least of which is that while one nursing home worker can infect hundreds in an institution, in CDPA, that person typically only works with 1, maybe 2 consumers, immediately limiting any potential spread. In a survey CDPA has conducted, every region of the state saw between 70 and 90% of respondents acknowledged they were more likely to die if they caught COVID, and between 50 and 90% worried that they would become infected. But what most feared, even more than the virus itself, was institutionalization. On top of this, consumers who had historically received gloves, rubbing alcohol, and other critical PPE and medical supplies from Medicaid were suddenly unable to do so. When they could, they were forced to buy them themselves at dramatically marked up prices. Despite these problems, it's clear that home care, and in particular CDPA, was substantially less dangerous than an institution. But that didn't stop the governor from saying to Chuck Todd on June 29th, Meet the Press, in the face of all evidence to the contrary, that you could argue that a senior citizen in a nursing home are safer than a senior citizen at home. COVID-19 provides us with a unique moment to analyze our policies, the impact they have, and what we can do to improve them into the future. I'm reminded of an old truism about smoking. Public health experts noted that while the healthcare costs for smokers are substantially higher for a brief period of time, they actually saved the system money because they died decades before their non-smoking counterparts. If we don't use COVID-19 as an opportunity to change our policies around nursing homes and long-term care, we're in essence saying that unlike smoking, we're going to continue to promote institutionalization.
Thank you so much, Mr. O'Malley. If you could wrap up, please.
But people die sooner.
Okay. Thank you so much, Mr. O'Malley. Next, Faggy Horowitz. I hope that I pronounced your name correctly, and I'm sorry if I did not.
You did fine, Chairman. My name is Faggy Horowitz. I work for Caring Professionals, a licensed home care agency and fiscal intermediary for CDPA, based in New York City, which serves over 5,000 individuals. I come out of a management career in social services. I'm an executive board member of an OPWDD agency for over 20 years, and I'm a founder of a shelter for runaway and homeless youth in Brooklyn. I serve on the Parks Committee in the Long Island Village where I reside. Today, I am testifying out of a sense of moral obligation. My 89-year-old father died of COVID-19 on April 7th. He succumbed peacefully in his own bed without requiring outside caregiving and was active until his last day. It was a dignified passing. In my work, we provide caregivers to those much less healthy, less active, and much more vulnerable than my late father. During the early months of the pandemic, our coordinators heard from frightened, frail patients and consumers who realize they are at high risk and must stay in quarantine to avoid life-threatening exposure. It was the job of our coordinators to reassure patients and family members that our home health aides would use PPE to protect them and would continue their caregiving jobs. And continue they did, leaving family members at home and traveling on public transportation to care for their charges, despite the fact that their jobs pay just above minimum wage and could be life-threatening. They work nonetheless, often doing overtime without pay. In Spanish, Russian, Cantonese, Creole, and Mandarin, our staff heard fear of removal to nursing homes if there would be no available caregivers. I will die there, a woman in Sheepshead Bay told Marina Kay. And if I am destined to die now, I would rather die in my own apartment. The fear is also true of people using CDPA, as documented by Brian's organization, the Consumer Directed Personal Assistance Association of New York State, in a survey conducted during COVID. It is abundantly clear from numerous studies that aging in place is safer and healthier than institutionalization and is the preferred choice of seniors. However, the history of long-term care for people with disabilities and seniors in this state has gone from pioneering choice and expansion of access to restriction of choice and barriers to enrollment in Medicaid during the past few months. Additionally, a 25% cut to wages and benefits for home care workers was put in place as recommended by the Medicaid Redesign Team 2 earlier this year. This was done despite a study showing that low wages were one of the chief obstacles to both recruitment and retention of New York home care workers. Currently, I am seeing advertisements warning people to be aware of the looming changes in Medicaid rules beginning October 1st. I'm hearing from frantic families in the communities who are afraid their seniors might become seriously debilitated very quickly from COVID and will need assistance that their current moderate income cannot cover. I can urge them to hurry up and put their affairs in order and apply to Medicaid in time, and I do. However, I must warn them that when they will need long-term care, the current contradictory and vague regulations will seek to keep them from accessing it. Furthermore, I will tell them that the MLTCs are instructed to promote congregate care and take away home care under the new regulations if the hours become too numerous. Frankly, I'm in the position of substantiating their fears of institutionalization. The rest of the country and the federal government have learned the importance of home care during Corona and are implementing policies to support this healthy, safe choice more broadly. In New York State, however, the situation is the reverse. The ethically responsible approach is continuing to be undermined despite the current lessons of Corona deaths in congregate care. Beyond the moral obligation to the vulnerable, it will be good for New York State's economic recovery to invest now in home care and its thousands of jobs. It's up to our lawmakers to push back against current policies, wage cutbacks, and restrictions, and do the right thing to reform home care here. We already have the solution to the problem of unsafe congregate care facilities. CDPA, which has family members take care of family members at home at a lower cost than traditional home care. It's the safer and socially responsible option already in place. So let's expand it.
Ms. Horowitz, was that the end?
The end. That was my call to action.
Thank you so much, Ms. Horowitz. Perfect timing. Next, Claire Altman, please.
Thank you, Mr. Chairman, Chair Lady, and Chairman, and members of the Senate and the Assembly. Thank you for this opportunity to share some ideas myself and my colleagues have with regard to improving policies and practices in long-term care. As the president of Altman Strategies, I do a lot of consulting around healthcare, low-income housing, and community development. The ideas here today have been developed by myself, Dr. David Katz, who is a well-known physician and public health advocate, president of True Health Initiative, and the founding director of Prevention Research Center at Yale University Griffin Hospital, and Jack Gold, a real estate colleague who has done a lot of work in developing long-term care facilities. As a lawyer by training, I've spent the last 35 years developing housing for low-income individuals and families and for persons with special needs, primarily in New York City. In my portfolio of over 3,500 units are 2 skilled nursing facilities for individuals and families with HIV and AIDS, which I developed in the 1990s, and for one of which I served as the chairman of the board for 17 years. We learned a great deal about infection control back then with some of the lessons learned applicable to the current pandemic, particularly the high risk of spreading infectious diseases through central air handling systems. We have believed from the beginning that the only way to really protect residents in nursing homes from this pandemic is what we have termed a closed loop isolation system. Now, 6 months into this epidemic, our experience has borne out this belief. For example, one 40-bed skilled nursing facility in Upper Manhattan has had no COVID-19 deaths. What differentiates this facility from many others are several key factors. Almost all of the rooms are individual rooms. There is no central air conditioning system. They use room air conditioners. Many staff only work at this facility. Food is prepared on site. And given the size, there are a limited number of outside vendors and therapists coming into the facility. In a closed loop isolation system, as we are proposing, residential healthcare facility management would set up an isolation arrangement, creating what we call a clean facility. This would begin with what is done now, at least weekly testing of staff and residents, hopefully with immediate results. That would be the first step in ensuring that COVID-19 free residents are protected by closing off all sources of virus to them. Other features of this approach would include residents only going to clean medical facilities for services such as dialysis and cancer care, only traveling in vehicles that are clean vehicles, receiving hospital care only in clean hospitals, having fewer no visitors, at least for a time. In addition, jurisdictions could create one or more temporary nursing or assisted living facilities so that people who are about to enter a nursing home would be entering there and be there for 14 to 30 days to ensure that they are COVID-free. We recognize that there are advocates for an approach referred to, and it's been talked about today, called cohorting. That is the approach supported in the Senate and House bills in Congress with that includes a $20 billion appropriation for nursing home relief measures. The danger is that COVID-19 would still be present in the building when you just set aside one wing for COVID people and one not. Simply put, COVID-19 has proven from the beginning that it is extremely cunning and has outsmarted every attempt to eliminate it once it's in the building. We believe the only way to prevent COVID-19 from spreading is to keep it out of the facility altogether. Now that scientific results are emerging suggesting that COVID-19 can be spread through airborne transmission, there is another compelling reason to create closed loop isolation systems with separate facilities for non-COVID positive residents and for COVID positive residents. As long as COVID negative and COVID positive residents share the same air handling system, the virus is likely to spread. We recognize that this closed loop isolation system would create additional costs in the short run, but we believe the longer term benefits more than outweigh these short term costs. lives would be saved. You all know the desperate statistics on saving lives. Major reduction in hospital costs would be achieved, as healthcare providers would spend less time treating COVID patients. This would permit the safer opening of the rest of our healthcare system, and we would importantly protect healthcare workers. I realize that my time is up, so
You could actually just wrap up, please.
sure, I just want to close with saying that we should also pay attention to home care, as the speaker before me talked about, because the next wave is going to be dealing with that. And a similar situation could be dealt with home care residents. Thank you for your time and the opportunity to testify.
Thank you so much. Leading off questions will be the Senate. Senator May, recognized for 5 minutes.
Thank you. And thank you all for your testimony. I wanted to give Susan a chance, although Figgy also talked about this, about the, I know you wrote a letter about the managed long-term care changes and how that was stranding people in nursing homes who no longer had access to home care. Can you talk a little bit about that problem and what you see as the solutions, what we should be doing about it?
There are a number of things that have resulted in people being stranded in nursing facilities. One, some of them I've already described to you, but it's some of the limitations on care in the community and the barriers to care in the community that also have us very worried. We would want to see resources restored for the consumer-directed personal assistance program. Managed long-term care changes have resulted in a lot of cuts of hours of home care for individuals. And this month, over 20,000 individual residents of nursing facilities are being disenrolled from their managed long-term care plans due to a determination that they are now permanently placed. This has reduced their ability to get out. It has resulted in problems that will make it much more difficult to change their coding, to get their income reestablished. All kinds of things are about to be much more difficult for many. And we would call for a moratorium on the rollout of this, at least until the pandemic is over. We think that it's imperative that additional changes that can lock people into nursing facilities not be made at this time.
Okay, thank you. And my other question is for anyone who wants to field it, but it's about just the home care field. So I have spent a huge amount of time advocating for better pay and various ways to attract people into doing home care as the workforce shortage is becoming more and more acute. But it seems like now there is additional demands for PPE and other protections, and no doubt difficulties of people who were maybe going into 2 different homes and they can't do that anymore. What are the biggest barriers to the actual logistics of home care right now?
Lack of PPE is a tremendous problem. We are seeing individuals living in the community who are terrified to let in their home care workers because they are at higher risk. Like our staff, like residents of facilities, they're at much higher risk and they can't control the environment that home care workers are working in, or how many people that they're seeing, or how much PPE do they have, and whether they have enough PPE to use unique sets of PPE for every setting. I have yet to see that home care workers or long-term care ombudsman workers have been designated as essential workers in the health system and have had testing allocated, the adequacy of PPE assessed, all of the things that we believe need to happen. So these are really terrible problems that have yet to be tackled. Nonetheless, people would prefer to take their chances with care at home and in the community than they would be to be locked into nursing facilities right now.
Okay, I'm going to break in and let somebody else take a shot at this while we have.
And I would just I would just agree with everything Susan said, and our survey bore out a lot of that, particularly with access to PPE. But I would also highlight that the staffing shortages you talked about, Senator, have just been exacerbated in many instances by COVID. Many people have gotten infected with the disease. Many workers have had to quit to take care of children who are out of school. Many workers just are themselves compromised and scared to go out in public and are quarantining themselves. So realistically, staffing has gotten shorter, and plans in many instances are using, the high unemployment rates to say, oh, we'll cut your hours because, well, your brother is now home and he can just provide the services uncompensated. So, we're seeing a range of issues around staffing and informal supports. Well, put informal in quotes.
Thank you.
Thank you.
I'd like to jump in with,
Actually, look, we have to move on to the next person. Assembly, please.
Next up, we have Chair McDonald for 5 minutes.
Thank you, Harry, and thanks to all those who provided testimony this evening. I'm going to be brief. Claire, when I read your report, it reminded us that it's the environment we need to be focused on, and the closed loop system does sound like a stretch in some aspects, but on the other hand, you know what? With everything else that's been failing, we got to look for solutions. I have to ask this naive question, because I think almost every nursing home I know of relies on a central air system. The cost would have to be kind of expensive to retrofit, I would think. And then the other question is, what are the ongoing costs compared to the central air system with just having room air conditioners?
Well, I think we helped build that nursing home 25 years ago, but today there's more sophisticated technology, and I'm not a builder, but I oversee a lot of buildings and developments. PTAC systems, which is a unit you see often in motels, which is a combined heating and air conditioning system controlled individually, and it doesn't circulate the air throughout the building. The air circulates in that room and with an outside source. So those systems are not actually that expensive and to buy, and they're frankly not that expensive to operate either. We've made a lot of strides. Now, it would mean not using a central system if it's there. And, depends on, I'm not saying it could be done overnight, but I'm saying we need to look forward to something. I think we ought to have in place a plan, as many people have said today, so that if we do have a second wave or there's another pandemic, that we have a more serious system, if you would, that we could put in place, like they're trying to do with floods, so that it's on the shelf, it's a policy, we can implement it right away. So it's expensive, but on the other hand, we've lost at least 6,400 lives, maybe more, as you all have talked about today, and untold grief for families and loved ones. So that I think, and in most buildings after 20 years, they do a lot of updating anyway. So
What about energy consumption or utilization?
not that, I actually know in the residential setting that people were worried when they moved into a building with PTAC systems that their energy costs would go up. Their Con Ed bill would go through the roof, and that hasn't been the case, but you would need engineers to do an assessment. I'm not an engineer, so I can't give you a full answer, but I think it's something that is worth looking at. We need to do some planning.
Okay, thank you. That's it. Thank you, Harry.
Thank you so much. We'll move to Senator Skoufis, recognized for 5 minutes.
Thank you, Mr. Chairman. My question is actually for Brian O'Malley. If I can direct one to you. You mentioned that the state is not tracking infection rates among the consumer-directed program. But can you give a sense of, even if it's anecdotally, what have infections been pervasive? Obviously, you noted, and it stands to reason, these are primarily one-on-one interactions versus, hundreds of people potentially being in a facility in a nursing home. And so the environment is very different. But can you speak to what has been happening these past 5 months vis-a-vis COVID in the consumer-directed program? And similarly, have you all had sufficient PPE? Speak to some of these major themes and issues that we've heard a lot about today in the hearing, please.
Definitely, thank you. From what we can gather, certainly, people have been impacted by COVID. The workers oftentimes, in the city, riding the subway, taking taxis, using public transportation to get to and from their cases. We heard stories of workers changing 2, 3, 4 times a day to, the same stories that you hear from nurses and hospitals and the like. But by and large, a lot of the worst cases seem to come at the beginning. Many consumers actually moved in with, or many PAs actually moved in with the consumers. And, overall, anecdotally, we have begun to hear some information from some plans that, in fact, their members with CDPA have fared by far the best throughout this COVID pandemic as a group. That said, we are experiencing problems with PPE, just as everyone is. But consumers, FIs, the agencies don't get reimbursement. They've never had to provide any of the PPE. They don't have channels to actually obtain the supplies in many instances. And consumers relied on Medicaid, and Medicaid stopped sending it. They stopped making it available. So, that was really something that became very problematic for people, was just access to things like gloves, rubbing alcohol, and other materials, PPE and materials that just protect general safety in the home. We're dealing with people who are getting shots, getting catheters and the like, and these supplies are critical.
What about cleaning homes? Did folks have the proper supplies to make sure that, whether it's spray or whatever it is that's available in nursing home facilities, hospitals, to cleanse, where they're working? Did they have that sort of equipment?
Right, and we asked that as well in our survey, and access to any kind of cleaning materials, disinfectants, bleach, hand sanitizer. People were buying it at grocery stores, just like you and me, and there was none to be had, and there was no way for them to get it. So, realistically, the people were doing the best they could.
Got it. But so we have to do a lot better, is the long story short. Got it. Thank you.
Thank you.
All right. Thank you, Senator. And thank you, Brian. Back to the Assembly.
Next, we have Chair Godfrey for 5 minutes.
Yes, thank you. For Brian O'Malley, you just said, I think you just said that Medicaid stopped making it available. And I think you were referring to things like gloves. Could you clarify that?
What we heard was that people who had traditionally purchased gloves, and Medicaid would allot 1 box of gloves per month, could no longer get gloves. And, I think part of the problem was there was dramatically increased use, but part of the problem was there was a shortage of gloves and people could not find gloves to purchase. So while Medicaid used to allot that, there were no gloves to be had. Gloves were, all PPE was being diverted to hospitals. At one point, I tried to go on and just do a bulk order for our member FIs so they could send things out to consumers. And if you weren't a hospital, you could not buy PPE. You could not buy gloves, masks, any type of protective equipment.
But apart from that, or before that, if you were a Medicaid recipient and needed to buy gloves, et cetera, Medicaid would pay for that?
Medicaid would provide 1 box of gloves per month, was always my understanding.
Uh-huh. Okay, just in general, I want to thank those of you who talked about the CDPA program. I think you've helped all of us have a better understanding of that program and of a lot of its value, perhaps beyond some of what we've thought about it. I mean, frankly, I think the whole CDPA program has, and I'm happy to say this, really blossomed into a lot more than we thought it might be back in the late 90s when it was created.
We thank you for creating it.
Okay, thanks.
Thank you, Assembly Member. And now we're going to go back to the Senate. Recognize Senator O'Mara for 5 minutes.
Thank you, Chairman, and thank you to all of our speakers here this evening. Now, I can smell my dinner coming from the kitchen, so I think we're near the end here. I thank everybody for hanging in there. I have one question for Claire Altman. In your remarks, you mentioned the usefulness of when we have, I guess, what we call rapid tests or tests with a quick response. Do you have a sense of where we are in that progress on that now?
I don't have any better information than my fellow witnesses today. I'm in touch with some nursing homes. I think it is challenging to get the results back quickly. I think it's it goes up and down. I also think that the last I understood, and I hope that I'm wrong about this, is that nursing home staff are to bill their health insurance for the COVID test, and many health insurers are saying these are not medically necessary, and so there's a conundrum there. That's the cost. So I think in addition to the cost and budgetary problems that a lot of nursing home operators have testified about today, the cost of doing regular testing is mounting up, and I'm not sure they're going to be reimbursed.
Yes, it is. Yeah. Well, thank you. I want to thank you all again, and just a couple closing remarks, since this is the last panel.
No, sir, it is not.
It's
We
not
have
the last
one-
panel?
We
Oh,
have
got
one more panel, sir. So your
Oh,
dinner
then-
is going to have to wait, or just bring
Then
it,
I'll have to. Then I'll
bring
have
it
to
beside
wait.
you, bro. Bring it beside
Thank
you.
you, Chairman. Yeah.
You done though?
Yes, I am. Thank you.
All righty. Assembly.
I do not see any other speakers from the Assembly.
Okay, then we've got Senator Serino to recognize for 5 minutes.
Thank you again, Mr. Chairman, and thank you everybody for your testimony today. I've heard the same stories about the gloves and alcohol pad shortages, and it's clear that this particular program was really an afterthought throughout this, and we have to do better going forward. But have you, Brian, with regard to you, have you ever reached out to the governor or the Department of Health to ask why they weren't collecting data on how many individuals receiving CDPA became infected with COVID-19? Did you ever reach out to the governor's office or Department of Health?
We did not reach out on that, largely because, when factoring one hazard of
Almost
being,
done.
you can capture, you can acquire COVID any number of different ways, from family, from your worker, from any number of people. So I don't, the value and the difficulty in just obtaining that would have been extremely hard.
I was just thinking that if you had a number, it might have been a little easier to be able to have the PPE, the amount that you might need, right? And then I also want to say thank you for bringing up the testing reimbursement issue. So thank you. I'm good. Thank you, Chairman.
Thank you, Senator. I'm just going to ask a quick question. Ms. Duha, at the beginning, during your testimony, you talked about some of the racial disparities in nursing homes that you're concerned about, as well as inappropriate discharges. And these were areas that I would have liked to bring up with the commissioner, but I had a limited time. Could you tell us a little bit about the concern that you have about these two areas so they could be on the record, please?
Absolutely. We are seeing within our staff, our board, members of our community, much higher rate of infection among the people who are Black and Latino. We've got this replicated in facilities And although we don't have the ability to look across all of the facilities, many of which don't have an ombudsman assigned to them, we do anecdotally think that there is really a lack of planning and thought about this issue. And it really needs to be a focus. It needs to be a focus of planning for any pandemic. It needs to be a focus of planning for nursing facilities. I don't know, we haven't been able to see what kinds of emergency plans are in place at facilities, but I would wager that they don't include particular planning for their residents who are Black or Latino, and that the Department of Health, I haven't heard anything about them inquiring about facilities where the death rates are highest among those who are Black and Latinx. And yet this is a story that's been in the New York Times, it's been in other media, and it's one that really requires an investigation and further attention. And I really commend it to you, Mr. Chairman, if you could please encourage a focus on this issue. It's just unconscionable that this is going on in this day and age. And there's no prevention plan for the eradication of disparities in nursing facilities, for example. So these are really serious issues. We've also been seeing a lot of people ending up in discharged to homeless shelters, and we don't believe this is a safe discharge under any circumstance.
Yep.
However, during the pandemic, it's especially alarming. We work with people who are homeless. We have members of our board, of our staff who've been homeless. We have a lot of clients, people we serve who are homeless. And the reports that we get from them about homeless shelters suggest that there's nothing like safety. Beds are ganged up together in congregate facilities. Staff don't have PPE. There's nothing like infection control, congregate bathrooms and shower areas, nothing like cleanliness. This is a really serious issue. There are a lot of congregate environments that are not being looked at and that really must be looked at, because these also are places where I would expect that there are a lot of deaths occurring, but they're under the radar screen. And I strongly encourage a focus on these discharges that are occurring, that are unsafe discharges, in my view.
Okay. Thank you, Ms. Dua. And we have no further questions from the Assembly or Senate. So I thank you all for your patience and for being with us. And now, Senator O'Mara, we are moving to our last panel, which is the following. We are joined by Daniel Roth, Staff Attorney at Mobilization for Justice Legal, Dr. Dara Cortez, a clinical professor at NYU and Executive Director of the Hartford Institute for Geriatric Nursing, and Jeff Lieberman, Executive Director, Coalition of Institutionalized, Aged, and Disabled. I believe that these folks are here. Okay. There is at least one of them. Okay, there's Dr. Cortez. Okay. Monsieur Gottfried. For the last time during the day.
So, who all do we have?
We have Daniel Ross, Tara Cortez, Dr. Dara Cortez, and Tara Cortez and Jeff Lieberman.
Everybody. Okay, last but not least, by far, do you all swear or affirm that the testimony you're about to give is true?
I do.
Affirm.
Okay.
Start off with Daniel Ross, please.
Let me just note, I pitched a perfect game. Everybody said yes.
Well, good evening. My name is Daniel A. Ross. I'm a senior staff attorney at Mobilization for Justice. For more than 25 years, Mobilization for Justice has advised and represented adult home residents in individual matters and impact litigation. And for almost 10 years, we've provided similar services to residents of nursing homes in New York City. Although the situation in the state's nursing homes is dire, as we've heard all day, I'm going to focus my testimony on the less known situation in adult care facilities, which have roughly 50,000 seniors and people with disabilities across New York State. Adult care facilities vary in the accommodations and services they provide. Most ACFs are either adult homes or enriched housing programs, which generally provide room and board and case management in either more private apartment style housing in EHPs or dorm-like accommodations in adult homes. Some facilities house low-income residents who pay the facility with their income from SSI and the state supplement program, while other facilities charge over $100,000 a year for luxury accommodations. Many also provide assisted living services such as personal care and nursing services. MFJ concentrates our work advocating for and advising residents of transitional adult homes. These are homes in which 25% or sometimes almost all residents have mental health disabilities. For decades, these institutions, which are mostly run for profit, have warehoused people being deinstitutionalized from state psychiatric hospitals. The poor conditions have been the subject of numerous government reports and media accounts, including the New York Times' Pulitzer-winning Broken Home series in 2001. The pandemic response has followed a familiar pattern in these homes. The DOH issued COVID-related guidance to adult care facilities beginning in the second week of March. But then, consistent with its history of promulgating useful regulations and failing to adequately enforce basic standards, the DOH suspended in-person oversight, including complaint investigations. Residents at some ACFs told us how their facilities quickly complied with DOH guidance. But we also heard from residents of other facilities, particularly transitional adult homes, about the lack of social distancing, staff cohorting, or resident quarantining that DOH guidance prescribed. We began reporting these concerns to the DOH in late March as deaths were mounting. For several more weeks, some facilities continued serving meals in large dining rooms with no social distancing precautions. Some facilities continued dispersing medications centrally, forcing residents to come down in crowded elevators and stand on line next to people from other parts of the building. And sick residents were not quarantined, and masks and other PPE were minimal or absent. Weeks after the April 4 guidance on communicating with residents and families about COVID, and even after that guidance became mandatory 2 weeks later, many residents told us that their facility hadn't told them about COVID cases or deaths, although they knew some residents had died and others were sick. Eventually, in late April, the department started unannounced visits, forced facilities to end congregate meals and end centralized medication disbursement, and provided testing of residents in these facilities. But there's no indication that the department has planned adequately for the expected second wave. Even knowing the scope of the problem is purposefully obscured, as we talked about earlier today, by DOH policy that excludes from public reporting deaths in ACF and nursing homes, of ACF and nursing home residents if they were first transferred to a hospital. DOH has not adopted for ACFs the same COVID transparency requirements that CMS demands of nursing homes. This leaves residents and their families in the dark about the risks to their health and prevents policymakers from assessing appropriate resource allocation. Low-income residents are often cash-strapped, finding it difficult to buy adequate clothing, food, and toiletries, let alone recreational expenses, as they face unprecedented social isolation without group activities or visits from family and friends. Economic impact payments from the federal government could have helped them buy technology to keep them connected to loved ones, or simply find entertainment to pass the time during the pandemic stay-at-home order. In April, we warned the DOH that some facilities would try to keep resident stimulus checks for themselves. And in May and June, that's exactly what happened. Operators at some facilities informed residents of newfound rent arrears, or told residents that they weren't eligible for payments. DOH has still failed to adequately combat facilities misappropriating of residents' economic impact payments. Stronger enforcement and stronger enforcement tools are needed to finally fix the problems residents have endured for decades. The state has awarded many chronically underperforming facilities with lucrative Medicaid-assisted living program certifications, but taken no steps to ensure transparency and accountability for the quality of services provided to vulnerable residents. We urge the legislature to enact A4416C and S3460A, which would empower the Department of Health to fine facilities for purposeful violations of residents' rights, financial abuse as described above, or repeated violations of the same regulatory provision within a 12-month period.
Mr. Ross, if you could actually wrap it up since your time expired.
It's common sense legislation that I think many people would be surprised to learn is not actually existing law. Thank you.
Thank you so much, Mr. Ross. How about Dr. Tara Cortez?
Thank you very much. Good evening, committee chairs and all members of the legislature present, and thank you for your stamina for listening and being so attentive all day. My name is Dr. Tara Cortez, and I'm Executive Director of the Hartford Institute for Geriatric Nursing, the geriatric arm of NYU Broward-Myers College of Nursing. Although residential long-term care is usually thought of as being simply custodial, the care needed in these settings is actually some of the most complex care delivered across the healthcare continuum. Most residents have multiple chronic diseases and very often have dementia as well. With the increase in the number of people living to 85 and beyond and the increase in complexity of those living in residential long-term care, the need for quality nursing homes that provide the right care at the right time by the right staff is more acute than ever. There is a historical neglect of long-term care, and nursing homes have been marginalized, even siloed, and denied a seat at the healthcare table for policy and reimbursement issues. The increasing complexity of caring for people in long-term care has never been recognized, resulting in chronic understaffing, low pay, and inadequate resources. The current state of nursing homes, coupled with the virulence of COVID-19, has created the perfect storm that has led to so many deaths. While the vast majority of nursing staff have strived to provide the best possible care, we're now witness to the impact of the shocking lack of resources and reporting that severely hampered the ability to pivot from everyday care to effective infection prevention and crisis management. It is disheartening to see the virus ravage even the most excellent nursing homes and see blame cast upon them when they had exhausted all the efforts to procure personal protective equipment and adequately manage COVID patients transferred from the hospitals. Many of the issues contributing to the perfect storm are long-standing and will necessitate both immediate response and a long-term strategy. One of the first issues that needs to be addressed is to ensure that providers of long-term care services are at the table as full partners with hospitals when setting policy and reimbursement rates. There should be a partnership formed between these two entities as equal partners, and not one bigger than the other, to ensure collaboration and coordination of care as well as equitable distribution of dollars. Our society has long been hospital-centric, with community-based care a second thought. Throughout the months of March, April, and even May, hospitals received the lion's share of personal protective equipment, while nursing home administrators went to parking lots in New Jersey or anywhere to find whatever medical supplies they could in order to protect their staff. In the meantime, staff often had to use garbage bags as gowns and handkerchiefs as masks. When the CARES Act was passed in July, it allocated $175 billion for hospitals, less than $5 billion for nursing homes affected by COVID-19. Nursing homes are now experiencing a dwindling census as people are afraid to put their loved ones into the nursing homes, and fewer elective surgeries are resulting in fewer admissions for rehabilitation at the Medicare rate. With nursing homes relying on mostly Medicaid-only payments because of the long-term care payments structured system we have, nursing homes are in financial distress. Layoffs and decreased capacity could be in their immediate future unless healthcare dollars are distributed in a way that recognizes the value and need for quality care with older people for whom home is no longer a viable option. The second issue that needs to be addressed immediately is the workforce in long-term care. Ensuring quality and cost-effective care at any time, but especially in the time of crisis, requires a professional staff that bases decisions and practice on evidence as a critical solution to increase quality while decreasing costs to the overall system. A study done by CMS found that nursing homes with greater RN staff numbers had significantly fewer hospital admissions. Another study mentioned earlier, done in Connecticut on the 215 nursing homes, found those with higher RN staffing and quality ratings had better control of the coronavirus. None of this evidence, however, has ever been considered in setting policy. In fact, CMS requires only 1 RN for 8 hours a day in a nursing home. In addition, a lower pay scale in long-term care as compared to hospitals means it's harder to recruit not just RNs, but also direct caregivers. Direct caregivers are the eyes and ears of the residents, yet turnover is very high because the pay and the pay is low and the difficult workload they have. There must be a staff with an appropriate number of professionals and direct caregivers to navigate through crises. Many of us have had a loved one in long-term care, and if you have not, you will. We need our nursing homes to have the resources and ability to not just be regulated and meet regulations, but also to provide the best care to keep people functioning at their own best level, address what matters to them, and allow each one a peaceful and dignified death. Thank you so much.
Thank you so much, Dr. Cortez. Last but certainly not least, Mr. Lieberman.
Well, thank you very much. Thank you all for waiting for me. I really appreciate it.
We were all
So,
we were all holding to be like, let's make sure that Lieberman's got to be in it. Go ahead.
Well, good evening. I am Jeff Lieberman, Executive Director of the Coalition of Institutionalized Aged and Disabled, an advocacy organization serving adult home residents in New York City. New York State's response to the COVID-19 pandemic in adult homes was to issue guidance that the state expected facilities to follow in the absence for far too long of testing, adequate PPE for residents and staff, and on-site monitoring and inspections by the New York State Department of Health. Since mid-March, CIAD has fielded and made phone calls to residents and stayed in constant touch with resident council officers and other residents. They have provided us with a significant amount of information about conditions in the homes during the crisis. This is contrasted with the health department's reliance on communications with adult home administrators to monitor what was happening. The information we collected includes the numbers of resident deaths in the homes and how well facilities were carrying out the New York State Department of Health's guidance on social distancing and cohorting to prevent the spread of infection. Based upon information we have received from residents, we have tallied approximately 250 resident deaths from 28 homes in New York City. To confirm those numbers as best we could, we were able to identify about 156 of those residents by name. There are 8 homes where reports indicate at least 20 resident deaths from COVID-19. These numbers contrast with the significantly lower numbers publicly reported on the health department's website. As of July 28th, 2020, DOH reports 53 confirmed or presumed deaths from 18 homes in the 5 boroughs of New York City. Only 5 homes on our compiled list have reported fatalities to the health department. The misleading and inadequate data collected by the DOH is based upon self-reported numbers from the adult homes and the practice of only counting deaths if they occurred in the adult home, rather than counting residents who died in the hospital. To this day, we do not know the full extent of the terrible impact the pandemic has had on adult home residents. We also found some adult homes slow to initiate appropriate social distancing measures. It took weeks for homes to end congregate meal service in their dining rooms. It took even longer for most to deliver medications to residents' rooms. Before this practice was instituted, residents were crowding on elevators and waiting on long lines to receive their medications. Residents were not supervised to keep 6 feet apart on these lines. Residents also told us of the inadequate measures facilities took to cohort and quarantine residents who were suspected or confirmed to have COVID-19. Residents who were showing symptoms or were known to be infected freely wandered the building and facility grounds in the absence of adult home resident staff supervision. Working in close collaboration with Mobilization for Justice, we informed the governor and the health department of these increasingly alarming conditions and numbers of deaths residents were reporting to us as early as March 27th. In mid-April, we, along with MFJ, NIAPRIS, Mahaney's, and SCAA, made 4 demands New York State had to meet to ensure the health and safety of residents. These demands are as important and relevant now as they were then. They are testing for all residents and staff to identify hotspots and inform staffing and cohorting measures to reduce the spread of infection. Ensure compliance by unannounced in-person inspections by the Department of Health. Number 3, relocating residents to hotels or motels to reduce density in the adult homes. And number 4, deploy additional staff and medical personnel where needed to ensure social distancing, cohorting, and services and care. especially for infected residents. We make several other additional recommendations. Along with MFJ and Dan, we urge the state legislature to pass A 4416C and Senate Bill 3460A, legislation that will protect residents by strengthening the enforcement of the state's adult home regulations. As Dan has mentioned, we also would ask DOH to revise its guidance of adult homes regarding economic impact payments to residents. Finally, we would recommend that the state consider funding the purchase of tablets and laptops for adult home resident use. Not enough attention has been focused on the increased isolation adult home residents have suffered because of COVID-19, contributing to increased loneliness, stress, and severe reduction in the access of residents have to family, friends, and community. Thanks very much.
Thank you so much, Mr. Lieberman. And for this last round, we will be leading off with the Assembly.
And I do not see any Assembly members who have raised their hand. Mr. Godfrey?
And I guess it's not so much a question, but just to say that this group of witnesses and many that we have heard all day today are just extraordinary assets and heroes for New York. And as I've listened to a lot of their testimony, and I say to myself, why does all this still need to be said? Why isn't it being done? And I keep thinking of what the author Upton Sinclair said a long time ago, which is that it is difficult to persuade a man of something when his salary depends on him not being persuaded of it. That's it.
It's what happens when 9 o'clock. See, I've been with this gentleman with enough hearings that went long to know that by 9 p.m. he gets mad poetic. So expect a couple of more couplets before we're done. But for now, we have on the Senate side, Senator May, recognized for 5 minutes.
Thank you. Thank you. And I also just want to compliment you and everybody we've heard from today with so much expertise and so much passion. It's been really inspiring. I have an actual question, though, for Dr. Cortez, that I feel like in the course of the day, we've heard two really different stories about nursing home finances. And I would appreciate it if you would help me make sense of that. Now, I used to teach Russian literature, so I can handle paradox, but this one is bothering me. So on the one hand, the nursing homes are in all this financial trouble, as you detailed. On the other hand, we're hearing that it's a boondoggle for hedge funds and things like that in the for-profit ones. And both arguments have been persuasive. So I'd like to hear from you, sort of how do you balance those?
And I'm speaking more on behalf of the not-for-profit nursing homes. And we have where the dependence on the Medicare funding from rehabilitation patients has been very, very high. Now that elective surgeries have gone down and continue to be down, people are not going to hospitals now to get elective surgery. So they've continued to be down. And the fact that, yes, we've lost patients through death, but patients are not being admitted. People are afraid to put their loved ones into nursing homes because of all of the terrible media that's been going on. So they're running at 60-70% capacity, and Medicaid payments coming for 60 to 70% of the capacity just don't do it. And it's why they can't have adequate staffing. They can't have they can't have an adequate number of professional nurses on board. You just don't have enough money, and salaries do run lower. They run around $10,000 less for a starting nurse in a nursing home than in a hospital. So nurses won't go to nursing homes. So I'll go to the hospital and I get a pay raise faster and I get reimbursement on my tuition without making some adjustments in the structure of payment for long-term care. Our long-term care industry, I think in the long run, is in trouble. To really get quality staff, it's far more complex today in nursing homes than it was 5 years, 10 years ago. Even last year, it's becoming more complex. And when you take dementia, you superimpose it on tops of patients with multiple chronic conditions, you've got complex patients. So we just need to find, I think, a payment structure that allows nursing homes to have the right kind of staff so they can give the right kind of care. And our patients, our residents can live in a dignified manner and die a dignified death.
And should we be worried about the other side of the story and money being
for profit?
Yeah.
I think we should be. I think you're right. I think we should be. I think we should be looking very carefully at how they are allocating their resources and what they're, not what they're meeting, whether or not they're meeting the regulations, but what are their quality outcomes? What are the outcomes that their residents actually have that reflect person-centered care and good values? I think that we're not looking at the right things if we're just looking at, well, what are the regulations and do they meet those?
Okay.
I think we need to be more specific on what are resident outcomes that reflect quality care.
Thank you. Yeah, I have been wondering about the way nursing homes are rated. There's a rating system, and I read that even in highly rated nursing homes, the racial disparities are very stark, even worse in some of the more highly rated nursing homes. And it made me start wondering, what are these ratings based on? And it seems like it's inputs based and not outcomes based. And so
I think you're right. Absolutely.
that's, I gather, at a federal level, but if there's a way we can rethink that, that might be a great move.
Yes.
For state level. Okay, thank you very much.
Thank you.
You have a poem for us, Dick? If you don't, or you do.
Well, I'm muted. Oh, okay.
No, you're not muted.
I can just correct the Upton Sinclair quote. It is difficult to get a man to understand something when his salary depends upon his not understanding it.
Told you he gets like that.
Words to live by.
Back to the assembly.
Yes, we have up next Assemblymember Tom Avenatti for 3 minutes.
Yes, I'd like to join everyone else and thank all of you for staying with us so long and adding a different perspective. We heard a lot about nursing homes. Somewhere during the day, I mentioned that there were other long-term care, congregate care facilities, and I wanted to hear about them. So I appreciate your highlighting those. I'm not going to ask too much other than, what do we do differently in the future? Are there plans out there? Is there conversation going on with the health department? And finally, is the health department overwhelmed, and should control of the facilities you're talking about be somewhere else? Is the health department trying to do too much at this time?
I think so. Adult care facilities used to be under the auspices of the oversight of the Department of Social Services. And when that department was dismantled, it got moved to health. And I think that probably makes sense as more and more adult care facilities become assisted living programs and receive Medicaid funding, or become assisted living residences and have licensed home care services agencies personnel or CHA personnel on site. And so I think that's probably fine. You're probably right that they're overwhelmed to some degree. There have probably been slashed budgets, so there are fewer people to enforce the regulations, which leads to a problem. And I indicated one action item that the legislature can take up, and I know the bill passed recently out of the Assembly Health Committee, but something else that's concerning to address a question that came up earlier, I think from Senator May, is right now, the Department of Health doesn't collect demographic data, racial data about residents of nursing homes or adult care facilities. That information is available from the federal government through the MDS, the minimum data set, which all nursing homes have to report to the federal government. But DOH doesn't have racial data, demographic data that would be really helpful to kind of analyzing what's going on. What are those disparities? What are the causes of those disparities? And digging down and trying to correct those.
I would quickly add, you asked if the health department, if we were engaged in any discussions with them regarding the future. And unfortunately, we're not quite sure that there are any specific plans that the New York State Health Department has to ameliorate the impact of a second wave that would strike adult home residents and assisted living residents. And we're quite concerned about it. As I mentioned in my testimony, we think that the demands that we've made over the last couple of months are still incredibly important. And although the terrible instances of death and what happened to nursing home residents, rightfully took center stage.
If you could wrap up, Mr. Levin, please.
I'm just afraid that adult home residents are in the shadows in this regard.
Thank you. Hey, Dick, I got one for you. Roses are red, violets are blue. Oh, how I wish Cuomo would actually listen to you. Next, we've got Senator Tom O'Mara. Recognize him for 5 minutes, please.
Yes, we all do get a little bit giddy at this time of night. Thank you for that one, Chairman Rivera. I wish that Commissioner Zucker would listen to you all as well. I want to echo Senator May's comments that we've heard a lot of great expert testimony with some great ideas here today, and thank you for all of that. I think we came up short with the executive branch of government today on this hearing with the testimony from the Health Commissioner, Howard Zucker, that consisted of little more than his own self-serving CYA PowerPoint presentation, coming in with an implausible response that they don't have any figures on how many nursing home patients that were transferred to hospitals died there, which has been probably the biggest topic of concern that has been in the media and the public arena surrounding the governor's March 24th order that nursing homes accept COVID positive patients. I find it further implausible that the Commissioner of Health was not aware of the opinion and statement from the American Medical Directors Association Society for Long-Term Care Medicine that was issued the day after the governor and Commissioner Zucker came out with their mandate, saying how flawed it was and what a wrong-headed policy it was. In fact, 2 days or 3 days after that initial statement, the American Medical Directors Association and the Society for Long-Term Care Medicine was joined in a follow-up statement with the American Healthcare Association and the National Center for Assisted Living, again, with concerns over the wrong-headed policy that had been directed. The fact that Commissioner Zucker claims he's unaware of those positions from the leading associations in the country is totally implausible. I request of the chairs of this hearing, since we in the minority have no subpoena power, we have no ability to call witnesses ourselves other than make requests. And I would note that the witness list for today, we received about this time last night. Not much fairness there, and we deserve better. I ask that you recall Zucker to be a witness at the next round of this hearing on August 10th, and further that you call the executive director of the American Medical Directors Association Society for Long-Term Care Medicine, Chris Laxton, to come and testify about their opinion and concerns over this and how that was directly transmitted to Commissioner Zucker and the governor's office. We deserve answers in the legislature from this administration. We clearly did not get them today. I hope we make some progress next Monday, August 10th, or continue these hearings thereafter. Thank you, Chairman.
Thank you, Senator O'Mara. Back to the Assembly.
And I believe it's coming right back to you, Mr. Chair.
All right. Last but not least, cleaning up, Senator Sue Serino. Recognize the lady for 5 minutes, please.
Thank you, Mr. Chairman. And Dr. Cortez, I'd like to just say I really appreciate your comments about the facilities need to be considered equal partners, the hospitals and the nursing homes. And that's something that I believe that we need to create more partnerships, and I really take to heart. So thank you very much for that. And I think it's very fitting that we're ending the day with this panel because you all really drove the main points home. The reporting is clearly flawed. These facilities are not getting the resources they need to really ensure real quality care. And we need to do better to ensure these vulnerable New Yorkers are protected and those who care for them are absolutely supported. And I want to echo with Senator O'Mara's point too. I really wish DOH, the Department of Health, came prepared with more than the governor's establishment talking points. But I really hope that at next week's hearing, we can dive even deeper because New Yorkers deserve answers. And I think today we should be doing all we can to send a message to residents and that there's a bipartisan commitment to get them. So thank you very much, everybody. This was a great panel today. Thank you.
Thank you, Senator Serino. Assemblymember Godfrey, did you have any closing words that you'd like to share with us? Maybe a poem or two?
No, I think I'm all poemed out for tonight. I'll see if I can come up with a couple of choice lines for next week.
Gotcha. Thank you all on the panel. Was that?
I think this has been a really terrific hearing, both in terms of the witnesses who've testified and the real elements of social justice understanding that a lot of them have injected into the discussion, and the questions from our colleagues as well.
I agree. I think it was it was the beginning of the process. I think, and that I certainly agree with you, Senator O'Mara. We have much more digging to do, but I thank each and every single one of the people who testified today. We have much more information to go on, but certainly deeper to dig. Thank you, everyone, for continuing to tune in. Thank you for the staff that is in the background doing all the work to make sure that this functions. I applaud all of you. I know Stanley certainly, but everybody else who's back there whose name I might not know or remember, thank you for it. And we will see you again. Probably they're working tomorrow. We might not be. We're going to be here next week for the next hearing on this. But thank you, everybody, for tuning in. And with that, I am signing off. Have a good night, folks.